We are live now. Ooh.
Hi all, I think we are waiting for the keynote lectures to get over. It will get over in another 2 to 3 minutes and then we can start here.
तो जरा भाव जब ये नहीं बचे तो इसको
I told where is faculty login. Huh? Hello. Good morning, everyone. Hall B. Can anybody hear me? Yeah.
Yes. Hi, morning.
Hi. Good morning. Good morning. So unfortunately, Dr. Ketan is traveling because he had traveled to Bangalore for a life surgery, and he's on his flight as of now, so he couldn't be there. And Dr. Malcolm Pestanji is, as we all know, he is down due to some personal issues. So, Dr. Sandeep, are you around? Dr. Pramod?
Yeah, hi, I'm there.
Sandeep, can you, I request you to kindly take over and moderate the particular session. Is it okay for you?
Yeah, that's fine. That's fine.
Yeah, thank you very much, Sandeep. So I think I'll hand over the mic to Sandeep. Sandeep is going to start the session in Hall B, and this today is going to be an exciting session in Hall B. Lot of case discussions, lots of important debates that is coming out throughout the day, along with a lunch symposium in the middle. As well as a quick bit session on minimizing complications and how to perform a safe surgery. So please remain logged in Hall B. So Dr. Sandeep, the session is all yours. Kindly take over and you can start the process.
Thank you, Umesh. So after a very exciting session in Hall A on didactic lectures, we'll now move on to this session. We are slightly running behind schedule. So this is a session on surgical videos of application of MIS in various settings. So may I invite the first speaker, Dr. Ajit Nayak, to give his talk on MIS relief in a case of prior laminectomy. So I assume we have the pre-recorded videos with us, the AV team. Hello.
Yeah, I have already. We have the pre-recorded videos.
Yeah. So can you play the first video, please?
Yeah.
Dr. Ajit Nayak's video.
It's not possible from my side to. I have sent it to the organizers.
Yeah. So the organizing team. Can we have the first video by Dr. Ajit Nayak?
Hi friends, I am Dr. Ajit from Toronto. Today I am going to demonstrate missed TRIF in a patient who underwent laminectomy and discectomy previously. 3 points I want to highlight. Microscope is used to cannulate the pedicle because radiological landmass won't be visible as in a new case. Full-length full-spine standing X-ray is taken to assess the PALL mismatch, plumb line, and type of bag to decide regarding the type of surgery. Always do lateral to medial exposure of Campbell's triangle because we work through virgin to fibrosed area and can avoid neural complications. Operative video is on a 50-year-old male patient who presented with a radiculopathy and axial mechanical pain, back pain. He underwent a minimally invasive laminectomy and discectomy 7 years back. His MRI showed L5S1 disc prolapse with a facetal hypertrophy. And this patient has severe back pain more than the radicular pain, and full length full spine X-ray shows type 1 or 2 back with SS less than 35 and a low PI, and he has got a gross sagittal imbalance with the plumb line anterior to bifemoral axis. We have exposed the transverse process after docking over it, and now facet transverse process junction for the insertion of pedicle screw identified, and the cortex is broken, and you can see the hole, and this hole is expanded using an owl, rotating an owl, and the pedicle is probed, and the area to insert screw is prepared. This whole procedure can be viewed through the microscope, and after that a probe is inserted to see where there is any breach to palpate around the hole. And now it is tapped, and tapping is also done under microscopic vision, and you can do this as if you do freehand technique in an open technique. Then after removing the tap, also then again the probe is inserted and palpated all around to see there is no inferior or a medial breach. And after doing this, we will insert the K-wire. K-wire is inserted and it is kept in position. And an X-ray CM image intensifier view is taken to make sure it is in the right position. This procedure, only 2 CM exposures are done, one identifying the level and also after putting the K-wire. Then for the final thing, pedicle decompression, the tube is docked over the facet joint, and we have drilled facet joint a little from the lateral side. Then slowly with the Kyson punches and high-speed drill, the pedicle to pedicle decompression is achieved. And after doing, you will come across the ligament flavum, which is intact ligament flavum, and it's a virgin plane also, easy to remove without any problems. You can see very well the ligament flavum is exposed between the pedicles, and as you go medially, you can see the fibrosed area and the traversing route. One important thing here, you have the ligament flavum. One important thing regarding this is, as if in a new case, the traversing and exiting route cannot be easily mobilized in a redo case. So you have to do extensive fibrous tissue release. Now the discectomy is being done. You can see the disc is very narrow because of old discectomy. There may be lipping and osteophyte formation that has to also remove to put the adequate size cage. Then the bed is prepared, removing the tough fibrous annulus and disc which is attached to the disc space, curating and removing it. Now I am inserting a expansile trial, which is almost 11 centimeter in height, 11 millimeter in height, and it can be expanded up to 15 to 17 millimeter. This procedure is being done by the time before we have put screws on the rods on the other side, and they are loose, and after inserting it and checking its position on the C-arm, we slowly expand the trial, and the trial will be expanded to between 15 and 16 millimeter. After expanding it, the screws and rods on the opposite sides are tightened, and after this the trial is removed. You can see the expanded position is expanded to 15 millimeter. Then after preparing the bed and putting the graft on the other side, the definite expansive cage is inserted, and cage also filled with graft, lot of graft. A lot of graft can be put on the rear side of the cage also. This cage is inserted, the position is checked with the image intensifier, and it is slowly expanded to the required 15 millimeter. It is a lordotic cage which can correct little of the plumb line, because the lordotic cage after compression it will give a angulation there. About 10 to 8 to 10 degree correction can be obtained. You can see the previous and after expansion of the cages. Now the cage is in the AP view. This is a procedure, and thank you.
So thank you, Dr. Ajit. So till we have the next talk loaded on the screen, I'll just check whether we have any questions. So may I ask a question, Dr. Ajit? What is the difference between a sort of a virgin case and a case which has got a prior laminectomy? How different do you approach it in the planning, and what is the care that you additionally take? So do we have Dr. Ajit Nair here? Dr. Nair, please. Okay, I think we are not able to hear him. So we'll move on to the next talk by Dr. Vishal Kunnani, that is minimally invasive transarticular screw fixation. Dr. Vishal's talk, please.
Yeah, hi Sandeep. Very good morning, everyone. The talk is already sent, but in case if they have any technical glitch, I can play from here as well.
So the AV team, are we having the talk over here?
Sir. Yeah. 1 second. I'm playing his talk.
Yeah. Thank you.
Welcome to the MSS Surgical Symposium, and greetings from City of Mumbai. Transarticular screw is one of the strongest stabilization modality in patients with C1, C2 instabilities, and it has served the test of time by providing not only immediate and absolute stability, but also proving to give 100% fusion rates with patients of C1, C2 dislocation. It has proved its test of time, and it has stood the test of time with good results in patients with unfavorable anatomy of odontoid fractures, and also in patients with reducible AAD due to tuberculosis, syndromic, inflammatory, or infective pathologies, showing the wide applicability of transarticular screw. Now the question is, why minimal invasive application to the conventional transarticular screw? Because conventional transarticular screw has shown its own problems, which are often related to access or due to poor planning, including big incisions, more blood loss, more mobility of muscle. To adding to the compound of this, wiring related issue, which is often a part of standard conventional transarticular screw, has shown problems. Unplanned OC2 or OC3 fusion and C2, C3 adjacent segment degeneration is also known. And also graft side morbidity because of use of conventional Magnell technique using a bone block has resulted into a defame to the conventional transarticular screw. And this has also led to resurgence of segmental C1, C2 fixation options as more favorable compared to the more stable transarticular screw ones. So the answer why MSS is because minimal invasive standalone transarticular screw is not only more precise, giving more stability, the same advantage of transarticular screw, but also reducing the minimal access reducing the access related morbidity in patients with conventional transarticular screw. So you get the same advantage of TAS with less morbidity and more precision, and also with the advantages of more stability, immediate stability with 100% fusion rate without the disadvantage of conventional transarticular. Yes, this preserves more soft tissue, and that's why it is minimal invasive transarticular screw. The emphasis of preoperative planning cannot be overemphasized, but in this particular case, where 90% of success of MIS tasks relies completely on the preoperative planning. And of course, meticulous surgical technique is also something that is very, very important. However, 90% success still lies on preoperative planning, which can be broken down into simpler steps. Ascertain the feasibility, plan the trajectory, position the patient well, reduce it well so that you get a better hold of C1, C2 screw, and keep your implant ready. And then comes your surgery, which actually is, of course, a meticulous requirement is important. However, it still takes a second precedence over the pre-op planning. Coming to feasibility, always rule out all the contraindications. Just because it's a minimal energy technique doesn't increases its applicability in patients with conventional contraindications, and that's why the most important thing is rule out if you have a irreducible AAD or a bony chunk. Having said that, let me bring to you that almost all AADs which do not have a bony black to make it irreducible are reducible by various techniques of reduction that I'm going to just highlight in a small while. Once you have ascertained the feasibility, now comes the surgical planning. When you know that this patient you're going to do a surgical transarticular screw, in those patients, ascertain that your transarticular screw, which is minimum 3 millimeter, should be able to have a bony purchase all around. And for that, the minimum requirement is the minimum pars diameter should be at 3 millimeter or more. Anything less can result into a dorsal burst out of the screw, resulting in poor purchase. And that's why preoperative CT scan is absolutely worth it and should be done in all cases to ascertain that the minimum pars diameter is more than 3 millimeters. Now, we differ from the conventional Magrel's technique where the entry point is fixed. In our technique, what I recommend is that during preoperative planning, always get your exit point. So make a fixed exit point. That is one thing that is first thing that you should see on CM after a patient is positioned. That your screw tip should go and lie in zone 1 and zone 2. And that's when intraoperatively you expose the dorsal and medial surface of the pars, which should be intact, making your retrograde trajectory. And wherever the exit point and the retrograde trajectory falls on lamina becomes your entry point, which is never fixed. In fact, it is the most tailor-made and variable point, and giving a lateral deviation of 10 degrees to get a good exit point through the trajectory as you have planned. And this is something that is different from the conventional technique. And if you follow this, believe me, in last 400 cases, we have not had a single vertebral artery injury just by following these basic principles in there, making it far more reproducible than C1C2 techniques. Planning is extremely important. Always have a military tuck position where you allow the neck to fall back, allowing the C1 to translate over C2 to get a reducible C1-C2 dislocation. But as I mentioned, if it seems that it is a irreducible, try all these maneuvers. Push C2 ahead, pull C1 back, go and do distraction in the C1-C2, do arthrolysis, and you will be surprised that 99% of those which look to be irreducible will actually get reduced. And I have tried all these, and all these really work wonders. In irreducible AADs, they are never irreducible. All of them can be reduced unless there is a bony block to prevent reduction there. Always drape wide, keep the T1 to T2 to T3 spinous process open, because that's where your percutaneous implants will come in, because your surgical incision is only 2 centimeters where you actually going to see the pars visualizing in front of you to get the good trajectory, but the actual implants come far distant from T1, T2 area, and that's why wide draping is important. Now keep your implants ready. Now, the implants available in market are not more than not less than 3.5 millimeters. So keeping Herbert's screw, we have got a specially designed screw which is 3 millimeters in diameter. It's very, very important to keep it ready with you on table. The surgical technique involves a midline incision centered over C2 spinous process. That's as you can see here. There's the head side, the foot side, the right and left. You continue your Murray to get dissection in the C1, C2 area. Expose the whole of C1, C2 area. However, do not disturb the C2-3 capsule and do not disturb the soft tissue on the superior aspect of posterior C1 arch, because unplanned C1-C2 fusions and OC fusions can happen. Dissect it with the help of your Bovai cautery and bipolar, and blunt dissection with patties will help you to dissect right inside the pars, giving you entry into the C1-C2 joint. That's very, very important. Once you've dissected the whole parts, that's where your retrograde trajectory comes into picture. You portray and draw a line all the way from the joint on the dorsal surface of the parts, falling back on the lamina, giving you a right entry point. So you have exactly seen the exit point on C-arm. You have seen the whole trajectory in front of you, and where it falls gives you the entry point, which is tailor-made in all cases. Like in this case, where you burr it, and that's where your guide wire drops in. And under C-arm guidance, you can exactly see where your guide wire is heading, as you can see on the C-arm pictures here. You burr the entry point with the help of your guide wires going in. You can exactly follow it up, and that's when it continues happening around there. And then once your guide wire is in, that's when your screws just walk in there, and all this is seen under C-arm guidance, as we just saw. Once your screw is in, comes the time for fusion. What we use is the allograft. No wiring is used in our cases, reducing the wire and graft related morbidity. We use allograft, morselized one, and lay down there, giving a solid fusion in almost 100% cases. None of our cases we have ever had any pseudoarthrosis chances there. Some case examples: reverse oblique odontoid fracture, failed odontoid screw treated with the transarticular screw minimal invasive, less than 2 centimeter incision, less than 50 ml blood loss in a patient with transverse ligament injury, again an unfavorable anatomy of odontoid, very small fragment of odontoid unavailable to odontoid anterior screw, solid fusion achieved, less than 2 centimeter incision, patient walks home the next day. Odontoid fracture, again in a comminuted fracture, a C1C2, see the solid fusion there with the help of morselized graft without use of any wires there. In pediatric and inflammatory arthropathies, the exposure is kept minimal because of MSS, and that prevents any inadvertent OC2 fusion. In pediatric cases, far better precision use of smaller implants comes very, very handy, preventing any unplanned OC fusion in these patients, giving a precise trajectory with no misplacement. Even in syndromic AAD with HRVA, with the help of navigation, we have been able to get the same results as in conventional transarticular screws. So to summarize, MSS is the gold standard of posterior C1C2 fixation. And as I mentioned, preoperative planning takes the precedence over the surgical technique. However, meticulous soft tissue dissection with percutaneous implants definitely reduces the morbidity and enhances precision. Thank you so much.
So thank you, Vishal. Thank you very much. And I would request the AV team to load the next talk by Dr. Fanikiran on balloon kyphoplasty. In the meanwhile, we'll take questions for Dr. Vishal Kundnani, if any. So let me ask you, Vishal, one of the concerns, obviously, you have a very huge series of MIS transarticular screws. One of the concerns is which doesn't convince us is the fusion rate. So because you don't formally graft it like we do in an open transarticular screw, or you don't put a tricortical graft there. So what is your take on that, and what are your results on that?
Very interesting question, Sandeep. In fact, a couple of times the same question has earlier also arisen, that what happens to fusion with the morselized graft? Is it as good as the conventional Magrenil technique? So we have analyzed this in many of our papers earlier also, that use of morselized grafts gives you as good a fusion as a tricortical graft. And sans, I mean, you can minus the problems of graft migration, the K-wire migration, and the mobile sublaminar wires that you put in from the morselized graft, because we never use a supplemental wiring into this. Now, it is interesting to note that in many of our cases, we also got worried at the end of 6 months, 9 months follow-up X-rays that the posterior onlay graft between C1 and C2 spinous process was not seen. In those patients, we went ahead and did a CT scan, and to our surprise, what we saw was that despite not having a solid bony bar formation between C1 and C2 spinous process, intra-articular fusion in at least one of the joint was always seen. So not a single case we have seen where intra-articular fusion between C1 lateral mass and C2 joint has not happened. So it's 100% cases where C1, C2 joint will always use. And we went ahead to study this, and we saw it in retrospect with all the other cases where segmental C1, C2 is done, where they don't put a block graft inside there. They just go and burr it there, which is a normal process while putting in wires there. So a wire goes in there, our drill goes in there, our screw goes in there, resulting into intra-articular hemorrhage. And also we onlay graft in the joint area also, and posterior morselized graft in the C1, C2 spinous process area also, which has almost always, never, not a single case in last more than 500 plus cases we have had in pseudoarthrosis or not seen a bridging fusion in C1, C2 joint. So it always happens without any concerns now.
Okay, thank you, Vishal. Thank you very much. We now move on to the next talk by Dr. Fanikiran on balloon kyphoplasty for osteoporotic vertebral compression fracture.
Hello all. Good morning. I am here to present the technique of balloon kyphoplasty for osteoporotic vertebral compression fractures. It is a cement augmentation technique for vertebral compression fractures, where a balloon tamp is passed into the vertebral body and inflated to restore the height of the vertebral body, correct the kyphosis, and create a cavity so that the cement can go in easily. It can be done either through the transpedicular approach or extrapedicular approach, depending on the level that is being done. Usually the dorsal spine needs an extrapedicular approach. One must plan the trajectory of the needle so that, based on the fracture pattern, so that it is not very close to the end plate. And the first and foremost step is to have an end-on view of the index vertebra that is being injected. One must have a proper view with the spinous process well centered and pedicles equidistant from the midline, and end-on view of the end plate. And most of these procedures are performed under local anesthesia and a proper good infiltration at at the entry point on the skin as well as on the bone is done, and a small stab incision is required to enable the Jamshidi needle to pass in easily through the fascia, and the Jamshidi needle is inserted again under C-arm control. One must keep seeing the AP and lateral view as required. And here it is very important to know that as the needle approaches the posterior border of the body on the lateral view, the tip of the needle should be lateral to the medial border of the pedicle on the AP view. This will ensure that the needle is not going to enter into the spinal canal. And once the Jamshidi needle is into the posterior part of the body, a guide wire is passed further ahead into the vertebral body, and the Jamshidi needle is removed, and then a thicker working channel is passed over the same guide wire, is inserted gently again with gentle tapping or rotation into the posterior part of the vertebral body, making sure that the guide wire is not advancing further ahead, which can happen in osteoporotic bone. And once the working channel is in position, the guide wire is removed, and the drill bit is used to create the path for insertion of the balloon tam. The guide wire has markings on it, and when it is at 0, the tip of the guide wire is at the tip of the working channel, and the usual length of the balloon that is used is either 15 or 20 millimeters. So that is the length of the track that needs to be created by advancing the drill bit up to that length, checking on the C-arm. This drill bit also brings out some bone pieces which can be sent for biopsy. That's how the track is created in the vertebral body for adequate length. And the balloon tamp is prepared. The device has a pressure monitor. Contrast is filled in it. And the functioning of the balloon is checked. And it is inserted in so that both the markings on the balloon are outside the working channel into the vertebral body, and then the inflation is performed so that the end points of the inflation are if the vertebral body height is restored, or the pressure is reaching the maximum, or there is no further increase in the balloon size with dilatation, or the balloon is reaching too close to the end plates. And then the once the cavity is created, cement is prepared, and the cement filling devices are filled with the cement. There are 4 of them in the set, and once the cement reaches appropriate viscosity, the filling devices are passed into the cavity under C-arm, and the cement is injected. One must make sure, keep checking that the cement is not leaking outside the vertebral body or too posterior, closer to the canal. And once the cement is set, the needles are removed, and this is how it looks. So that's it. Thank you.
So thank you, Dr. Panikiran. So till we load the next talk by Dr. Jayesh Sardara on posterior cervical decompression with the Descandu technique, let me ask you a question. The literature currently is in a gray zone as far as the results between vertebroplasty and a kyphoplasty is concerned. So what is your aim of using a balloon in this case? Is it only to sort of compact the surrounding cancellous bone and create a gap, or do you really try to restore the height to the normal? Where do you achieve the balance between them?
Yes, that's always a question that is there for each case when it's a gray zone. And I actually do more of vertebroplasties than balloon kyphoplasty. So this is a balloon kyphoplasty is I do it selectively where there has been an acute rapid collapse and kyphosis, segmental kyphosis. But even in those, many times I see that once the patient is put prone, it does open up, and we may feel that even a vertebroplasty would suffice. So if there is a significant segmental kyphosis, in localized kyphosis in that vertebral body itself, that's where it is not the fracture is not very close to the end plate. That's when I would try and do a balloon kyphoplasty, so that there is some. It is not basically. I don't feel there is difference in the amount of the chances of leakage if it is done with proper care between a balloon kyphoplasty and vertebroplasty. So it's mainly to address the local kyphosis.
And what is the time duration? When do you prefer a kyphoplasty vis-a-vis a vertebroplasty? Any time difference between the two, particular time?
That I don't think there is any difference in the time between the two. The decision to go ahead with the procedure, that itself depends on how long it's been, and how, usually we wait for initial 3-4 weeks, or if the patient is completely bedridden even in those initial few weeks and not able to get out of bed, that's when I decide to go ahead with either one of these procedures. But whether it is balloon kyphoplasty or vertebroplasty, I don't think there is any difference in timing. But if it's an older fracture where there is some sort of feeling, but still there is a pain, persistent pain, then probably balloon kyphoplasty is preferable.
Thank you very much. So we will move ahead and go on to the next talk. That is the posterior cervical decompression by the Descanso technique. Can we have the talk, please?
Good afternoon, everyone. Posterior endoscopic cervical decompression. Descanso technique is indicated in the lateral and foraminal cervical disc herniation or the spur using a laminophoracotomy. Sometimes a multiple level cord compression due to stenosis can be achieved with a single small incision.
Hello, Dr. Sandeep.
Can we have the video, please? Can we have the video, please, and restart it?
1 centimeter related to the midline at the end.
The AV team, can we restart with the video? We will not able to see the video, please.
We are restarting the video once again.
Yeah, thank you so much.
Good afternoon, everyone. Posterior endoscopic cervical decompression. Descanso technique is indicated in the lateral and foraminal cervical disc herniation.
I don't think we have the video. At least I'm not able to see on the screen.
Sometimes a multiple level cord compression due to stenosis can be achieved with a single small incision.
Hello. Is there any issue with the video, or Dr. Jayesh, do you have the video on your side where we can play it?
So we are just... No, 1 second, sir. We have the video.
Okay.
Can we start, please? I have the video, Dr. Sandeep, but it's better that...
Fine. Let's wait.
You have the visuals now?
No, we don't have it.
I would like to request the AV team that start from pre-recorded there. Yes.
Right. Thank you.
Should I start, sir?
Yes, please.
Good morning. Anish from MSS. MSS. Next is
Posterior endoscopic cervical decompression. Descanso technique is indicated in the lateral and foraminal cervical disc herniation or the spur using a laminophoracotomy. Sometimes a multiple level cord compression due to stenosis can be achieved with a single small incision. Patient is need to take in the prone position. 2 to 3 centimeter small incision is given 1 centimeter later to the midline and it should be centered at the maximum level of compression for 3 level. For the more than 3 level, you need an additional single extra incision. After incision, a subperiosteal dissection along the spinous process to be done in the lamina. Once you confirm the lamina, a distal set is inserted at the lamina-facet junction. Once you confirm the level, the outer cannula is removed and the inner cannula is replaced with the scope. We need to understand the important bone landmark, that is the V point. V point is basically apex is situated towards the facet joint. And the idea is to convert the V into U. For that, you need to drill the medial 1/3 of the facet joint. For 2-level decompression, you need a 1.5 laminotomy. For 3-level decompression, you need a 1 full and adjacent half of the laminotomy in order to decompress the cervical as well as cord as well as nerve root. Once you insert the scope, your distal set should be exactly docked at this V point, the level of maximum compression. So this is the cranial lamina, caudal lamina, and the apex is toward the facet joint. Now, the plan is to drill the lower half of the lamina, upper and the upper half of the lower lamina. And this is the exposure of the ligament of flavum. Ligament of flavum should be gently dissected from the underlying dura. Usually there will be adhesion at the center part. And once it should be freed from the underlying dura, then using a 90-degree Carrison punch, you can undercut the lamina very gently to avoid the dural tear. So we can see the very pearly shaped dura using a bipolar to control the ligament of flavum bleeding. In order to do a foraminotomy, you have to drill medial 1/3 of the facet joint, not more than that. And that will expose you to this cervical nerve root. And always remember that in compared to lumbar one, in which a root is lying vertically, in cervical root, it's always lying horizontally. And all the soft tissue or the osteophytes will be found just beneath the nerve root. It should be excised without retraction of the cord or any nerve root. That is the main difference. Finally, we can see the freely pulsatile thecal sac and this nerve root for the single level of foraminotomy. With the 2-level, this is another patient with a 2-level compression which anteriorly already fused came with the adjacent segment disease. The difference in the procedure is that the distal set is docked over the lamina, not on the V point. And the idea is to drill the complete half of lamina and adjacent half of the superior lamina. Drilling should be started at the base of the spinous process and the lamina junction, and it should be thin adequately. Once a ligament of flavum is exposed, it will be preserved till the end. We see the mobility of the distal set, and this will allow us, this free mobility allow us a 3-level of decompression from the single incision. Once you make your lamina very thin, with the help of 90-degree Carrison punch, it should be gently excised. How you control the venous plexus bleeding? And it will be a big issues. For that, you just put a small gel foam, piece of gel foam between the facet joint and the thecal sac. And 90% of case, it will be enough. Never try to coagulate it. Still it bleed, you can use a flow cell or you can remove the outer cannula, and with a microscope, you can continue the hemostasis, and then after that, you reset your further endoscopic procedure. Now, once ipsilateral decompression is kind of clear, the contralateral decompression, you need to drill base of the part of the base of spinous process. For that, with the help of dissector, the dura should be separate from the base of the spinous process. There must be some adhesion there. And the part of the base of spinous process to be exercised with the help of thin Carrison punch. Always use number 1 or number 2 upcut, not more than that. And see the degree of bony decompression and the well pulsatile thecal sac and this nerve root of the 2-level decompression. Now, this is a elderly morbid patient with 3-level, 4-level OPL and plant address from behind. And look at the bony decompression, one full laminotomy and adjacent half laminotomy and the full ipsilateral and contralateral thecal sac, well adequate decompression with the help of a single incision. So the postoperative CT suggests us the degree of bone removal in a 1-level, 2-level, and this 3-level decompression, and with a comparable and good clinical outcome with rapid recovery without any additional bony requirement or bony fusion. So thank you very much for your attention.
Thank you, Dr. Jayesh, for this excellent demonstration. So since we don't have any questions in the chat box, just one question. In cases where you do a complete laminectomy, unlike the lumbar spine, where when we go over the top, you have to retract the cord a bit. In the cervical spine, the cord suddenly falls back. So how do you manage to decompress the contralateral root or complete the laminectomy in these cases where the cord suddenly falls back?
Exactly. So, Dr. Sandeep, very nice question. Compared to lumbar one, where you have more space, the cervical, the problem is, of course, the space is narrow. But the thing is, when you do a hemilaminectomy, and you will have a base of the, similar to lumbar spine, you have a base of the spinous process in front of you. What you have to do, you just drill a 2 mm base to the spinous process and you do a thin cutting. You can do a thin bony drilling of the contralateral lamina, especially proximal part, and that will definitely give you a full, complete, control over the contralateral, as I have seen in the video also. Second thing, a full complete decompression is required contralateral sides when patient have a radiculopathy associated with the compressive myelopathy symptoms. If patient have a compressive myelopathy symptoms, then you just need to give a 6 or 7 mm space. That would be enough to control all the symptoms. And if patient have a ipsilateral radiculopathy, then you go to the same side, right side or left side, and then you require ipsilateral foraminotomy. For that, you need to drill the facet. Otherwise, hemilaminectomy and drilling of the base of the spinous fluid will be enough for to cure. I hope you get.
Thank you very much. So we move on to the next talk by Dr. Sachin Borkar on MIS ressection of intradural tumor. Can we load the talk, please? Okay, I think there's some issue, so we can have that talk later on. Is it okay, the AV team? We move on to the next talk by Dr. Dhruvin Patel on OLIF for degenerative scoliosis.
Yeah, sir, we are playing Dr. Dhruvin Patel's video.
Right, please go on. Thank you.
My surgical video is on only for degenerative spondylolisthesis as per case availability. Patient is a 45-year-old female with bilateral back pain. Claudication pain is significant, not improving conservative management. The preoperative action shows a
Can you just load the video and then start it?
Can I start now?
Yeah, please. No, but we can't see the video screen.
Video folder.
My surgical video.
You're able to see. You're able to see the screen.
No, just wait for the video to load and then you can start it. Just wait for the video to come on the screen. Then start it.
You can start now?
No, we are not able to see it.
Give us a second, sir.
Sir, if you're able to see the video.
Now we can see. Now start. Yes, we can now. Please go on.
My surgical video is on only for degenerative spondylolisthesis as per case availability. Patient is a 45-year-old female with bilateral pain. Claudication pain is significant, not improving conservative management. Her preoperative X-ray shows a little bit of a scoliotic curvature, but primarily it's a grade 1 degenerative spondylolisthesis at L4, L5 level. MRI shows significant stenosis at L4, L5 level. Important thing is to visualize the space between the psoas muscle and the abdominal vessels. Many times the MRI may not be able to show it, but once you should ask your radiologist for the smaller sizes. Also, one can extrapolate from L3, L4 level. However, the anatomy can change even from L3, 4 to L4, L5 level. But important to visualize the space between the psoas and the vessels in preoperative axial MRI. Positioning starts with keeping the patient in the lateral decubitus position. It is important to secure the patient adequately with weights. Pad the pressure points adequately. Keep the table straight. There is no need to take the table as in X3 for a delete procedure. Keep a pillow between the two legs. One can keep the upper leg a little bit flat or even straight also. Level marking. The disc space should be marked on the skin adequately. I draw a line along the anterior and the inferior end plate of the disc space and along the middle of the disc space also. Marking the disc space on the disc gives the idea regarding the trajectory of the disc space so that you can work in the line of the disc space. The usual site of incision is approximately 5 to 6 cm from the middle of the disc space. The length of incision can be approximately 5 cm. More of a mini open kind of technique. Skin incision starts in a usual fashion. The point comes regarding the subcutaneous dissections. Important thing is to split the abdominal muscles and not to use a monopolar quarter during dissection, as that can now injure the nerves which are lying between the muscles. Important thing is just to split the muscles. Do not use a monopolar quarter while dissecting between the abdominal wall muscles. Here one can see the splitting of the internal oblique muscles. Once you remove it, once you split the transversus abdominis, use your fingers to dissect the peritoneal content away from the beneath the abdominal wall muscles. That will give you adequate space to work with. Retroperitoneal dissection is very, very important. One can dissect the psoas muscle with the fingers also, but I generally prefer to dissect it with the pin dissectors. Dissecting the loose areolar tissue between the psoas belly and the abdominal vessels. Use a pin dissector to push the psoas posteriorly. Many times the psoas fibers are attached to the disc space itself. So it is important to erase the psoas fibers from the surface of the disc space. It may take a while, but then you should take your time to retract the psoas muscle posteriorly. Retractor placement is important. The guide wire is inserted along the anterior third and the posterior third of the disc space. Once we are satisfied with the guide wire placement, dilators are inserted over the guide wire and the retractor is placed accordingly. One can even use a holding pin to keep the retractor in place. Once you expand your retractor a little bit, there will be some encroachment of the psoas fibers within the retractor space. You can either use a bipolar quarter to remove those fibers, but the important thing is basically to know the posterior margin of your incision cut for the MRS one. Discectomy starts with a shaver. Use shaver very wisely. Sometimes it can plunge into the input of the whole vertebra. So use shaver very, very carefully. Try to perforate the contralateral annulus by visualizing in the TV view under a C-arm. That contralateral perforation is always going to be under C-arm only. Discectomy starts with various curates, angled and a cob elevator and the rasp. Be careful when you use curettes and rasp. Important thing is to preserve the end plate. Use your disc forceps in a reverse fashion. That's much more easier to remove the disc space in case of an olive. Once the adequate discectomy is done, one can go for a trial placement. Use adequate size of a trial. You don't have to over-distract the disc space. Important thing is physically to go in an orthogonal direction when you finally put your trial. Bone graft packing is generally I use autogenous bone graft. Sometimes I use beta tricalcium phosphate which is mineralized bone matrix, which is thickening bone marrow aspirate. It's good to cover your cage with this flange, otherwise your graft may fall when you insert your cage. One needs to use a dissector when you put your cage because sometimes this psoas belly can obstruct your view. Thing is basically to go as orthogonal as possible when you insert your cage. One way is to hold them, insert them equally by pushing it backward so that you remain in orthogonal direction. Very, very important not to damage the contralateral nerve opening ganglion. Once you can see that both the end plates are engaged in an AP view, one can stop it. There is an endoscopy view of the final cage placement. One can see the psoas belly on one corner. Hemostasis is very, very important. That will prevent the psoas hematoma and the subsequent nerve damage. So make sure that there is adequate hemostasis in your area. Close your muscles layer by layer, closing all three muscles. Transversus abdominis, internal oblique, external oblique. Final skin incision can be approximately 5 to 6 cm in length. The final CMMS shows adequate restoration of the disc height as well as good lordotic alignment. AP view shows both the end plates are adequately engaged. Thank you.
So thank you very much, Dhruvin, for that excellent demonstration. I think we are running short of time over here. So are we sorted out with the talk by Dr. Sachin Borkar, the organizing team and the AV team here? Hello? Is Dr. Sachin around here?
Yeah, I am there. I think
we have Sachin's video. Just give me 20 seconds, I'll play the video.
Fine. Thank you so much.
If there is a problem, I can share my screen and we can start.
Great.
Is it visible?
Yes, it is. Yes.
Okay. Good morning, everyone. I'm Dr. Sachin Borkar, neurosurgeon working at All India Institute of Medical Sciences, New Delhi, and I shall be talking about minimally invasive spine surgery for intratumoral tumor. What are the good cases for minimally invasive IDM excision? The tumor should preferably be located posteriorly or posterolaterally, preferably a neurofibroma. A dorsolumbar spine is the preferred location. The vertical extent of the tumor should not be more than 1.5 vertebral levels. Though with experience you can attempt bigger tumors, but to start with it may be advisable to start with smaller cases which do not span more than 1.5 vertebral levels. Also, there should not be much lateral extension of the tumor in the foramen or in the extraforaminal compartment. She is a 56-year-old female diagnosed with L1, L2 neurofibroma. After the standard dilators and the tubes, we can now see that the cranial and the caudal lamina with an AMAT attachment of the metacerex slit, we are thinning out the lamina by gradual drilling. As the lamina is getting thin, ligamentum flavum starts appearing. We may also remove a part of the lamina on the opposite side, like an over-the-top decompression to make more space. Once the ligamentum flavum is in picture, using a small dissector, we are making space between the dura and the ligamentum flavum. Gradually, ligamentum flavum. This will be the exposure after removal of the ligamentum flavum. Now, using the number 15 blade, we are opening the dura. The next step is taking the dural tacums 2 sutures with either silk or 4 PDS. As the tumor is soft in this case, it can be removed with suction. At times, you may also require an ultrasonic aspirator to remove the tumor. As you can see, the tumor, the lower pole of the tumor is being delivered down by gradual debulking, and now you can see the roots below. This is the last portion of the tumor being coagulated and cut. The more important part is the dural closure. So it is also the most difficult part. That is why many surgeons do not attempt it the MIS way. However, with good instruments and good microsurgical technique, it can be done successfully. As you can see, the depth at which we are working, I have deliberately zoomed it out to show the depth at which we are working. And with a specialized nerve instrument which we use for nerve repair, we are closing the dura using 6-0 Proline. So as you can see, if the proper instruments are there and microsurgical technique, you can do an efficient dural closure as fast as you do it in open surgery. This is the before the final suture, we are irrigating inside to remove the debris, if any, and the final stitch is being taken and the knot is being pushed down to have proper closure. Hemostasis is achieved. We usually perform a Valsalva manual to check for the adequacy of the dural closure. And this is the final picture of the dural closure. Another case, a 60-year-old female with a D11D well ID, now starting from as you can see in number 9, we are opening the dura. The next step will be take the dural tacum sutures. I am gradually dissecting the roots of the tumor, and this is the neurofibromine picture with gentle coagulation of the capsule of the tumor. Tumor is opened, and this tumor is not as soft as the first case. So this is being debulked using an ultrasonic aspirator. Though it's very tempting to pull this tumor in single piece, we should not attempt it because it is damaging the already compromised cord. So gradually debulk it so that it will fall off from the surface of the cord. As you can see, the cord is in the picture and it is sufficiently to be rolled out. The closure proceeds in similar fashion. So to conclude, minimally invasive tumor excisions using tubular retractors is another less invasive way of dealing with carefully selected patients. The advantages definitely are small incision, patient comfort, and early return to work. In places with a long waiting list like ours, some of these cases can be done at a daycare or an extended daycare surgery, saving crucial hospital bed occupancy. It does not replace conventional open surgical approach. It is another good way of dealing the same pathology. I thank you for your kind attention. Thank you.
Thank you, Dr. Sachin. Thank you very much for that excellent demonstration of a very difficult procedure. I think we are way past the time. So, Dr. Luana, you wanted to say something?
Sachin, excellent talk. Just wanted to know some tips about dural closure. That is the most difficult part.
Yeah. So obviously, the dural closure, I usually use the nerve instruments which for the brachial plexus repair. So these are pretty handy and very low profile. So it can go through the and as you have seen in the video, it has a curved tip. So that also helps in grabbing the needle very well. And the isoprolene needle is such that it perfectly suits the space available. So this has been done after many trials and error, and finally this is the best I thought is the way of doing the dural closure, and it is working pretty well in my hands doing this. And you can do a really fast closure.
Sandeep Sone session.
Thank you.
Thank you very much, Sachin. And I think we need to conclude this session. I thank all my speakers over here, Dr. Ajit Nair, Vishal Kundnani, Dr. Pani Kiran, Dr. Jay Sadara, Dr. Sachin Borkar, and Dr. Dhruvin Patel. Thanks a lot. It was quite a learning experience, learning from the experts. And we hand over the proceedings to the hall in charge for the next session. Thank you all.
Thank you, Dr. Sandeep Sone. Thank you, speakers and moderators. Thank you for an exciting session. We'll be moving on to the next session now.
Thank you.
ಎಲ್ಲರೂ ಬಂದಿದ್ದಾರಾ?
Dr. Jacob Matthews, sir, over to you.
Right. Thank you very much. It was a very fantastic session. Beautiful surgical videos that we saw, and from the experts in the field. Now we have a very unique format coming up. That is, we are discussing some difficult topics. We have a set of experts, and we have the young Turks. I don't see the young Turks here. I hope they have joined in. But we have our faculty here, Dr. Shekhar Kurupa, Dr. Bai, Dr. Anand Naik, and Dr. Ajay Krishnan. They're all here. And I hope that Dr. Yadu and the other young Turks will join in. So our topic right now, what we have is about discogenic pain. And it's a very controversial topic. When we see a patient with a black disc with unremitting back pain, our first instinct is not to sharpen our knives and go ahead and do the surgery. And I try to stay as far away from it as possible until and unless I am forced to do something. And it's a very tough thing to diagnose, first of all, and also to decide on the correct treatment available, because there are so much of alternative treatments available. And we are surgeons, and when do we come to the surgical part, and what surgery do we use even if we come to the surgery? So first of all, let me just start with a small case which I've had, and we can take it from there. So I hope you can see my screen. I hope people can see my screen. Yeah. Anand? Okay. All right. So this is a patient who presented me. It's a 35-year-old young man who had back pain for 5 years. and he could not sit in his office. He was really in distress. Or pain was exacerbated by any kind of movement, even lying down and changing position in the bed was difficult. Examination was within normal limits. He had tried everything from back school, weight reduction, physio, and this is over a period of 4 or 5 years. He had some temporary relief with foraminal injections, and so this is some kind of a typical presentation. And I would like to ask one of the young Turks, how would you go about it before I go on to the expert panel? Dr. Yadu, is she there? Are you there?
Yeah.
Hi, Dr. Yadu.
Hi.
Yes.
So basically, with whatever case history Dr. Jacob has presented, this is a basic history what we get in a case of back pain. What is it and how does it change? So from here point of view, basically we try with a course of physiotherapy and we get the imaging done.
Right. So, so what is your first impression, or how do you go about this this kind of a case?
So since we know it is an sort of mechanical component there, we first go with the course of physiotherapy. But we usually see in these cases, patient again come back to us with same complaint saying that I'm not doing better.
Right. Hello.
So I would want Dr. Shekhar Kurpat to tell us how do we take from here. Once the patient has come, we have tried a course of physiotherapy. We then from what next to be done in these cases? So how do we take it from here? How do we manage from here? Dr. Shekhar Kurpat, please.
I think you're not able to. Dr. Bai, are you there? Dr. Bai? Hello.
Yes.
Yes, Dr. Bai. This is a difficult topic. So we'd like your inputs as to how you would deal with a case like this.
So the patients is complaining of recurrent and chronic back pain. So in that case, after we fail the conservative treatment, we need like MRI and the CT scan. And we also need to understand the dynamics of the pathology.
So this is the flexion extension views, as you can see here. And there is not much instability. And you can see the T1, T2 views here. As you can see here, there is some, it's more like a modic type 3 changes. You can see there is some hyperintensity both on T1 and T2 on the adjacent end plates and with a black disc. Dr. Bay, I think he can't, maybe he can't hear. Dr. Anand, are you there? Dr. Anand?
Yeah, before giving any comments, where are our young Turks? Dr. Yadu, Dr. Bharat Patel, Dr. Amandeep Gujral, Dr. Kamlesh Rangari, where are all of them?
So Dr. Yadu is here.
Yeah, and where are rest of the 3 guys? So nobody is participating.
Okay, Dr. Yadu.
Sir, Doctor, I am Dr. Here, sir. Kamlesh.
Yeah,
hi, Dr. Kamlesh.
Turn on your videos and participate in the discussions, please.
Yes, we are waiting to hear from you, the young Turks, as your experience with these kind of cases, especially the investigations. Would you like to comment on these, the MRIs and the CTs? You can see there's some sclerosis on the adjacent end plate sclerosis is there. So would you let us know your views, because we would like to hear from you, the young Turks, our future heroes. So if you guys are not speaking up, then I'll ask Dr. Anand. So, Dr. Anand, would you like to comment on how we would go about this? Like, you have a good practice with regard to discogenic pain, and we've seen you present at multiple forums. You have a very good experience with this, and we'd like to hear your views on how you would go about it.
Okay, before that, Dr. Kamlesh is there, right?
Yes,
Yeah.
sir. Yes, sir.
Yeah. So, Kamlesh, how will you proceed about this case? Like Jacob has presented pure axial back pain, not getting any relief with conservative management for so many years, and he's still having back pain. He came to you. You have exhausted with all conservative management. How will you proceed?
Sir, we will even after giving all the conservative management, if patient is not improving,
Yeah,
then we consider this. Hello.
It's not improving. That's why we are discussing. So next.
Yes. If not improving, we generally consider this patient for facetal block or joint block. If there is any pathology, we will in detail evaluate the MRI. If there is a facetal joint effusion or something like that, if there is loss of lumbar lordosis with erector spinae muscle weakening, so that we can advise the patient regarding the back muscle strengthening exercise. And particularly, this kind of patient will improve on facetal block, because in most of the patients have facetal joint effusion. And particularly regarding the discogenic pain, mostly we can collaborate with the pain clinic, our team member, and after detailed evaluation, we generally consider this patient for joint block.
Yeah. So, Dr. Kamlesh, you said that you will directly go ahead with the blocks. But do you consider any investigations in between before ending up with a block? And how do you decide that you are going to do a block for this patient?
Okay, before we go discuss that, I just want to say that, Dr. Kamlesh, one of the history which I said was like he has got more pain on bending forward, and it's so. Would you consider a facetal block in this case when you have like a increased problem with the flexion? And
no. As I said, even only after detailed evaluation on MRI, if there is facetal joint diffusion or something like that, then only we will consider the patient. If the patient is having only discogenic pain, not improving on conservative management, then we will look for whether there is what is the cause exactly, whether there is any infective cause or something like that. We will go with CRP, ASR, and to rule out any pathologies, infective pathologies, so that we can give antibiotics. Because in our institute, if patient is generally in Indian population, tubercular infection or other infections are most common, and with the antibiotic, most of the patients improve on. So, yes, CRP and investigation, we will go for further plan of treatment.
Dr. Yadu, how will you go forward for this patient? How will you investigate? He just came to you with pure axial back pain. You have tried all conservative managements. You are exhausted with the conservative management. Now the patient is with you. How will you proceed? How will you investigate further? How will you identify the source of pain?
Would give a pain intervention in the form of caudal block first. So that would be a first point of intervention from my side. See how does he respond. If he responds well, would after the caudal block, we would again get back to him with a course of again physiotherapy for a duration.
So, Dr. Jacob has said that the patient is getting pain whenever he is bending forward and backward. Okay, and after X-rays, initially he has shown us the dynamic X-rays, flexion and extension. So, would you get any further investigations before jumping into blocks? No, after seeing patients, getting an X-ray, dynamic flexion extension, and then you will straight away forward with the blocks, right? Yeah, you don't want any MRI scans or anything?
Yeah, of course. Before going for a epidural, whatever pain intervention, MRI is necessary for one of the investigation of choice for to get before proceeding.
So we have Dr. Junsuk Bey as well. So how will you proceed about these kind of patients in your country?
So I think for this patient, our next choice will be the epidural injections, because I'm seeing the patients need physiotherapy and intensive exercise. So in clinic, my usual routine is 2 or 3 times injection, and we further exercise. Then we have to see how it's going on, because he's still a relatively young patient.
Okay, Jacob, how will
Yeah,
you?
so I think Anand, so all this patient particularly has
I would
had all these interventions, that is multiple epidural injections, and he's had a good course of physiotherapy back school, all that. He has gone through that, and he's been doing that for the last 4 or 5 years. Still, there is no benefit. Now, how would you go about this particular case? Because it is, I realize it is always a problem when it is in our own clinical practice. You don't want to go and jump ahead and do something which may or may not be useful, because it can be a painful disc can be a pain for your practice your entire life. So in this particular case, Anand, what is your take? Like, how do you go about it? You're like probably one of the person with a lot of experience in this field. So can you enlighten us on your way of handling this?
Yeah. So what I do, apart from all these conservative managements, clinical examination, and you have the dynamic access with you, uh, I would not go ahead with a facet block or epidural block in first go, but I would further investigate. I would get an MRI scan done. We'll see whether what all levels are involved. Like you have shown that L5S1 is badly involved, and patient is having a purely discogenic back pain. Most of the times, we don't see a neurocompressive lesion. The incidence of getting a neurocompressive lesion and a radiculopathy is around 15%. 85% of the people, they have either a white disc or a badly degenerated black disc. So the next step for me would be to get further investigations like electrodiagnostic test, EMGs and NCV studies. We'll do the EMGs are much better, and we'll do the paraspinal sampling as well. And then second set of investigation is a CT discogram. I need to identify the pain generator. So I do a discogram under local anesthesia, obviously, and do the scoring system accordingly, and do a fine cut CT when I inject the dye, so that I get an orientation about the facet joints as well. If the disc is a pain generator, you will get your answers, and then you can treat accordingly. If you still don't get any answer, then probably, like Dr. Kamlesh has said, go for the facet blocks. And Dr. Yadu and Dr. Jinsik had said, I'll go for the epidural blocks. So we need to try and test multiple blocks. If I don't get any answers with CT discogram. Another block is sacroiliac joint, because sacroiliac joint block and L5S1, the bottom level, they almost present same. So you investigate by doing all these blocks and all these tests, and then you decide. For me, the decision criteria for surgical would be modified Dallas discogram pain score, in which we evaluate the back pain, the leg pain, and also the facet joints at the back, and see how the dye is running through. And that's how I proceed with these cases.
So I think before we go into the surgical treatment, I would like to ask Dr. The senior consultants about the surgical management. But before that, I'd just like to have your opinion, Dr. Bay and Dr. Naik. Are there any specific criteria that you look for on the MRI? Like, for example, they talk about internal disc disruption or mode exchanges or high intensity zones. Like, is there something that you particularly look for on these kind of cases?
Yeah, so there can be two clinical situations. One where you get a black disc And the number two would be the white disc. The disc may look absolutely normal, but it can be the culprit. So that is the catch there. If I do a discogram in a perfectly normal disc, then probably I am challenging that disc to further degeneration.
Right.
But if it is an internal disc disruption, you can get indirect evidence by looking at how the gel is there based on the axial cuts. You can see any end plate changes are present, modic changes and all. You see that. So that gives you an idea what exactly is happening over there.
Right. So MRI does give some idea about what is happening here, and so you're talking about discogram. So before we go into the surgical treatment, may I ask you about the discogram? Do you always do a control injection? So you have a black disc. Do you always do a control injection to see that there is no pain at the adjacent disc?
For me, the indications is if it is a normal, perfectly looking disc on MRI, and if there are no changes in L3, for example, adjacent segment, we do an EMG. If there are no changes in the paraspinal muscles, then probably I will not intervene. I will not take a control. Those discs which are grossly degenerated, you don't have to do a discogram because it's already obvious that is one of the pain generators. So, so I don't do a test level. I don't do a test. It's just to identify because all these modalities, they have to match with the pathology. So you need to really identify where exactly that pain generator is.
So, Dr. Bay, I would like to ask your opinion on how do you select these like very select cases for a surgical procedure? For example, you want to move into a surgical procedure, and how would you select those kind of cases?
The important thing is the presence of instability for the patient. So as you look at the MRI and X-ray, you notice that there is a moderate decrease of disc height at a 5S1 level, and there is a partial tear of annulus on the posterior at the same level. So I think we have to suspect that F5S1 has significant degenerations. Of course, there is some degree of a body change as well. So I presume that by image study, I can say that F5S1 is the main pathology for the patients. I agree that we should do the discography for the patient. I presume that F5S1 definitely has posterior tier of the annulus, which can be the main pain generator due to the ingrowth of sinovertebral nerve into the posterior annulus. So our next choice should be some injection after, and if we find the revival zone is the main pathology, we should think about the IDP or the annuloplasty for the patient. But I think the surgical option should be the last one after all kinds of the interventional procedure.
So Dr. Ajay has joined us. Thank you, Dr. Ajay. He had a session in the hall, the other hall before he came in here. So we were talking about this particular patient who's basically presented for a 5-year history of mainly axial back pain, which is worse on bending. And none of the interventions have worked for him. And, as you can see, the MRI shows evidence of a black disc with high intensity zone, modic changes. So what is your take on this, Dr. Ajay? How would you decide if this case requires a fusion or not? Let's say he's exhausted everything else.
See, first of all, we need to prove that it is matching with the symptoms. As you said that there is a bending pain, so there is some mechanical nature to that pain. Second is that it is old custom and our training also, don't treat the backache. For patients of backache, you should not make an intervention on the first go until and unless you have ruled out all means that this is really pathological. So that is the second thing. Now, image does not guide in all cases of a backache. Like the case what you are discussing, I have not seen the MRI. Still, I would be suggesting that we have to pinpoint that this is a source of pain. And for a case with no other features which is suggestive of a guidance towards this pathology, I would go in for a disco block. Even if I'm not able to do a discography proper, I would do a disco block, and the patient reports to me that he has got relieved, and I'll definitely go in for fusion with a history of 5 years. That's what, for this case, what you have just shared me. I've not seen the images, but this is what I would do. But it would be I would try to definitely avoid the surgery in good number. If he is sticking to me and if he has understood me, then only I will take up this case, because even Rashikran sir, don't operate backache. This has to be remembered. So we have to have good evidence on clinical presentation, on your examination, a very good history, and you have to have some intervention. Needling is the only thing which can definitely prove that this is the reason of the pain.
Right. Dr. Ajay, you have a good experience with endoscopy. So what there is this school of thought which actually treats these kind of patients with transforaminal endoscopy, removing the centralized high intensity zone, and then giving a platelet plug there. Like, so what is your take on that? Would you be?
I have not used any platelet plug ever. I have done good number of cases wherein a backache is there, the patient is not fitting into the category of fusion, and you want to grade the treatment. Say you are offering an endoscopy, you are not doing any damage to the patient, you are still not burning the bridge. So you can definitely go in and offer surgeries to this group of patients. And here also, I am successful only in 50% of cases. So I may give them a fusion again. So it is not the complete solution as to doing a say annuloplasty and getting out of the plane completely. So the lifestyle modification always comes into play in all these group of patients, and those females, those laborers who are not ready to accept this, don't try to go in with an intervention like endoscopy, wherein you know that this is the source of pain and you want an intermediate procedure, because they will not modify the lifestyle. So they have to accept that this is an intermediate procedure before we take up the fusion.
So I think all the faculty is kind of the same impression that they would be very loath to go in for a direct surgical intervention, in spite of, let's say, a good clinical diagnostic criteria, that is a centralized pain and the MRI criteria plus a positive discography. Then they might consider surgical intervention. So I would like your opinion, Dr. Ajay, Dr. Naik, Dr. Bay, on what kind of surgical intervention do you do? Because there is a mechanical pain. Would you like go for a fusion? Would you go for a disc replacement or some other surgical technique? Because there is still a very controversial topic, and the results are difficult to.
For me, if we are considering fusion, so it would be a posterior fusion or an OLIF. This is what I am trained for, or I can do it. I would like to explore the possibilities of a disc replacement, which I'm still very.
Dr. Bay, would you like to add?
If I have to choose a surgical option, I would go for the disc replacement. There is normal disc at the C4 and 4-5 other levels. The only degeneration at the 5S1. So 5S1 is the best level for the disc replacement. So I will do the total disc replacement for the patient.
Dr. Anand, the champion.
For me, if I have to go for a surgical intervention, then I have two options available with me. One is a lumbar disc replacement. The second one is an anterior lumbar interbody fusion. But I have a criteria for, I do a patient selection for my lumbar disc replacements. Earlier, we were doing those mechanical discs, ProDisc L and all. I'm not sure about Dr. Junsuk Bey. Are you guys using the monoblock viscoelastic disc? ESPs or M6?
Unfortunately, we don't have only a lot of options in Korea. We only have one implant systems. I don't have M6.
Okay, so I'm using ESPs in our country. These are viscoelastic discs, and that completely changes the topic of discussion from fusions and all. So I have two options: either the viscoelastic disc replacement device or an anterior lumbar interbody fusion. And to reach to that criteria, I have some patient criterias. One of the most important, and normally I tell everyone, match the technology with the pathology. If the nerve damage is so severe that if you place a device there and the dorsal root ganglion is inflamed, irritated, then probably lumbar disc replacement is not going to help the patient. But with this viscoelastic disc, there is no fixed center of rotation, so you can balance easily, and you can use ESPs or M6 in these patients. So for me, two options: disc replacement or a anterior lumbar interbody fusion.
So Dr. Anand is one of the foremost experts for ALIF, for disc replacements, and he's got good results in his hands. This particular patient was treated with MIS TLIF, and now it's 4 years down the line. He's still got very good relief. I don't really normally touch these kind of patients, but they have the few patients I have done with these very, very strict criteria. I thankfully have got relief in this particular patient. I've been asked to end this session by 10:55, and may I ask some last words from the stalwarts in the field, Ajay, Anand, Dr. Baye.
So
I would like to be with Anand.
So can I speak?
Yes, doctor.
Yeah. So for me, we have a treatment option available for the purely axial back pain, and they're really awesome, and you will get results. So those are old school thoughts. Don't touch the patient. Don't do anything for purely axial back pains. That is an old school of thought. There is no scientific evidence beyond that. In fact, there is a lot of evidence-based medicine which is coming on for particularly for axial back pain treatment. It's there in our scientific journals, and it's there in our textbooks. So somebody teaching someone, don't touch a patient with a back pain, just go ahead with the conservative management. There are criteria. So you just follow those simple criteria. If they fall into this conservative management or the surgical management, you will get the results.
Dr. Yadu, the Young Turk. So would you like to add something, like maybe you guys have an experience with your team has an experience with this kind of discogenic pains? Like, what has been your experience?
Now, for me, for any patient who has been
I think I can't. I'm not able to hear.
So, shall I speak?
Yes,
Jacob.
Yes, Ajay, can hear you.
Yeah. So, for me, a correctly identified cause of discogenic back pain is an indication for fusion, and I would like to mature to the level of what Anand has matured. I would like to go in for an anterior fusion or anterior replacement, but definitely I will try and not give a fusion disease associated backache which is new to the patient. So whenever you are handling this group of patients, because if you are handling this group of patients, there is in all probability there can be something which ends up with fusion and relieve his complete backache and give a new type of symptoms. It is worrisome. So I would go by Anand.
Yep. Thank you very much, everyone. It was a very interesting but difficult topic, and it's still controversial, and there's a lot of work ahead for us. So I end this session right now. Thank you, everyone. Thank you for the experts, and thank you for the Young Turks who joined in.
Thank you.
And may I hand the floor over to the hall in charge. Thank you.
Thank you, Dr. Jacob, Dr. Anand Naik, Dr. Ajay Krishnan, Dr. Jensen Bay. of your expert comments on managing discogenic back pain. Thank you, Engtux also. Good morning, Dr. Vishal.
Hi, good morning. Very good morning.
So this is one of the interesting case discussions here. Minimal invasive or open in this case, why and how? So we have an exciting list of expert panel, Dr. Praveen Munin, Sabin Kulkarni, Dr. Niraj Vaswada, Dr. Sukumar Sura and Engtux. So let's start going. Over to you, Dr. Vishal.
नहीं 10-15 मिनट रुको. Hi everyone, welcome. So I have prepared some cases for this particular session where the session theme in itself is so appropriate to talk about whether to miss it or to do a miss in it. And I'm going to just bring out some cases. Since yesterday we have all seen cases where most of us would have understood that the gold standard for single level PIVD, single level LCS, and single level listhesis, MIS is the way to go. We have spoken about the principles, we have spoken about the basics, we have spoken about the technique, we have spoken about the salvage problems, and I'm sure with all this understanding, there is absolutely no doubt that don't miss the MISS in single level PIVD, LCS, and listhesis. And I'm sure we all agree on this front, and this is what we are not going to be talking about today. We have a wide range of panelists with us. We have the young guys to tell us about cases where miss should be missed or should be continued with. And it is not about PIVD single level, LCS single level, or listhesis single level. We are going to be talking about cases which are challenging enough, where the controversy ripes in and grows bigger, like multi-level developmental stenosis, multi-level listhesis, high-grade listhesis, degenerative and deformity cases of lumbar spine, and patients where severe bilateral facet hypertrophy is present with listhesis, where we should miss the miss or continue with the miss. And let me bring in my first case scenario to you. A 21-year-old male with mechanical low back pain, 7 on 10 on VAS, with left leg pain disturbing his activity of daily living, no obvious neurology, no neurological deficit, and that's the kind of imaging here. So may I call upon our panelists? So we have Arvind here. Arvind,
we can't see the slides. I'm not sure about the others.
Can we all see this? Can all of us see the slides so far?
No, Dr. Vishal, I think you should do a full screen now. You should go to the slideshow.
Okay.
We were not able to see the full screen properly.
Is it seen now?
Yeah. Just do a slideshow. That's it. Yeah. Perfect.
Okay. So here we are. Here we are with the first case scenario, a young guy with a dysplastic high-grade listhesis. Arvind, since you are here and I'm sure you have done so many of these cases, let me hear from you what this case is to you like, and then how would you proceed with such cases in future?
So in such a case, I wouldn't do an open surgery, because I have several factors to support MIS here. One is this is a high-grade listhesis, and even if you reduce it with difficulty or reduce it easily, there's going to be a high stress on the segment, on the implants. So with MIS, I can get my screws in the right position because the entry point would be far lateral, unlike an open exposure wherein we really need to pull the paraspinal muscles far apart, strip them apart at L5, S1 region to get your trajectory.
Right.
So that is one. Second is I would depend on navigation here. So, the pedicles at L5, see, when you do open L5, S1, the most difficult part of the entire surgery for me is putting the L5 screw, because the entry point is quite deep down in the hole there, and you might get wrong. So here it is generally, you can do open image guided, but that is not the tendency. So you have an open, you have a navigated approach to get into the small pedicle. So you should, as you marked out, you are hinting that these pedicles are atrophic. They are small in diameter. So within the confines of that small diameter, you want to put as big a screw as possible. So that is possible with navigation, which can be taken, assistance of. And here probably you'll need to do some degree of dome osteotomy at S1. Again, that can be guided very well with the navigation. So these are all the factors. And the trajectory of the tube you always know where the trajectory of the tube is to land in your cage as central as possible. So these are few of the reasons why I would do minimal axis. And secondly is when you do a open, I usually don't use a microscope. Here, since it comes with the package, the minimal axis, the MIS TLIF procedure, I'll be able to see the exiting route, not damage it, etc.
Right. So I think Arvind has highlighted all the problems that one can come across in MIS, and he's already given some tips and tricks to it, to how to get the right implant into place, how to get the obliquity of the tube, and how much exposure. So Neeraj, any difference in opinion you would have? Would you miss the MIS here and do open, or you would take up the challenge of MIS surgery in this?
No, I guess for me, this still can be managed minimal invasively. Navigation is one thing. Yes, I would be prepared even to do a dome osteotomy and put a sacro-L5 screw also through MIS. I have done a few cases with like that. So I think, this. Yes, I think I would not think of open for this case right away.
Right. We also have Vishal Peshetiwar. Is Vishal here? Vishal Peshetiwar. You have a high series of high-grade degenerative patients here. Vishal, are you around to take up the question?
Yeah, I'm around.
Yeah. So would you please highlight the challenges that one can come across? Like we have young Turks here. I'm going to soon move on to the young Turks with their challenges on what they face across. But can you please highlight about the challenges that you have faced while dealing with high-grade listhesis in MIS way?
So typically, if it's a long-standing high-grade listhesis with osteoporotic situation, getting a reduction becomes a problem. In this case, that to get, like Arvind said, you need to do a dome osteotomy. Navigation really helps. I mean, we have done a few without navigation, but majority have been with the worm on. So that in that situation, it makes it safer. If you haven't done enough, I don't think this is a case to be tried MIS. However, it's going to be equally difficult if you do it open. So MIS in my hands is an easier option than an open surgery for this. For the simple reason, the screws have to go through other incisions. So I can focus my TLIF part of it to a different, more medial to the screw fixation. The screws, actually in this case, we would put very, very lateral. And the S1 screw, the entry would be way, inferior, just skirting the lower border of S1 screw, so that I get a long tricortical screw. I think Arvind has also spoken about this screw in the past. And he also does it similarly. So you get a nice reduction. And I mean, so far, most of them have been able to get, including grade 4 listhesis, fairly well.
Right. So how do you reduce these, Vishal? I mean, you've been reducing all of them.
So,
Is there any stepwise
reduction, I had a lecture yesterday about it. So I'll just enumerate the points to it. The reduction has to be by a release and not on screws. Majority of reductions which last on, which people use screws for, are very perilous. They are going to fail if the unit doesn't happen in time. You have to do a complete distal release. If not, then you have to go down, go over the top, do a medial facetal release. If that does not reduce, dock a tube on the other side, remove the facet, again do a discectomy from that side, put your paddle shifters from there, and then get the disc in. This reduces. If this does not reduce, then this is not going to reduce, come what may. You do open or whatever you want. Then the only way to probably release is to go anterior, release it, flip the patient in and do it from behind. That I don't think that's a pre-op planning that you would do that. But here, once these releases are done, if it doesn't fall back, then it is better to then fuse this in situ and then put a delta screw that goes from S1 into L5 body and another screw that holds L5 and holds the fixation.
Right. Now, Mihir, are you around? Let me catch you also, Mihir. We'll quickly have a word from Mihir Bapat, who's here, who's had a big series of high-grade spondylolisthesis, and he's also a pioneer of doing the MIS in a hybrid way. Dr. Mihir, there are instances where we have to use a L4 screw to get our L5 back, where the reduction is implant guided rather than release guided. Do you think that is also a possibility when you do it MIS, or no? In MIS, you have to totally depend on release in toto.
No, actually, what Arvind said is very, very pertinent, because these pedicles are extremely atrophic, and whether you do it the MIS way or the open way, you still have to have a pull-out force on the L5 atrophic pedicles. And you need to study these very well on a preoperative CT scan, because some of them are really not capable of holding anything more than 4.5 or, precariously 5.5. So the thing is that these screws tend to migrate when you start pulling them out. And it is quite sort of wise to take an additional hold on the L4 if required. So there is nothing wrong in taking a hold on the L4.
Right. And what challenges do you think a young guy like me would have while dealing with this in MIS way?
Well, you should have given some other example than you. But anyway, so I think most of them have been highlighted. See, the greatest challenge is to protect your L5 root here, because as the vertebrae topples over, it's really overhanging your disc. And as you start negotiating your kyphosis, you have to be very, very worried that your intradiscal shavers do not hit your L5. So your decompression of the L5 has to be far lateral. That is one, to protect it. And second is to reduce the stress when you are pulling it out. Second is negotiating the kyphosis. So if you do not negotiate, that means if you do not complete your sacral dome osteotomy really well, then you are likely to perforate the end plate of L5, because your intradiscal shaver tends to angle superiorly. So that is the second point. And the third point is that whenever you reduce these, do not use an unilateral implant. Try to use sequential tighteners and use, if probably, bilateral implants to get a uniform pull-out force. Otherwise, the L5 screw may pull out. And when you lose the L5, then it's, if you are in an MIS situation, it's like a terrible problem to have.
Okay, thank you, Mihir. I think now I have another guy, Dr. Sukumar Sura, who will probably deal with this in a little more different manner. Sukumar, your word on that. How would you deal with such cases? Miss it or not to miss it? Sukumar.
Yeah. Good morning, Vishal.
Hi.
So I do more endoscopically for grade 1, grade 2, but in this case, it is very difficult to reduce without dealing the facets. So I will do more MIS way rather than endoscopically. I would not rather do open in this case. So I would go in MIS way, as Dr. Anand has already told in detail. So I think I'll go in MIS bilaterally rather than open or endoscopically in this case.
Right. Venkat, now let me just go on to the young guys. I'm sure you all have heard the challenges of MIS where this case has come to you today in your clinic. You have already attended a MSS surgical symposium. You have heard the masters. Tomorrow you have to do this case. Would you do it in an open manner or you would miss it? Venkat.
I am still more skeptical about MIS in this case. Probably I will try open first, do few cases of open, then I may shift to, because I have done only one case of this and that was open, and that was very difficult to reduce also. So I may consider in future, maybe after 5 or 10 cases of open.
Right. Venkat, I really acknowledge your concerns and really appreciate openly sharing your concerns on this. And this is the key that we all must take home from here, that please don't get overridden by your ego that you have to do it MIS unless you really can challenge it by your surgical skills, which takes a certain amount of learning curve and time to it. All these masters who are speaking here about MIS, they are all guys who have done at least thousands of open surgeries and more than thousands of surgeries in MIS way on the simpler cases, rather than taking up this as the primary challenge. And we as young guys, Akash, Venkat, we all must understand the concerns, whether we can really tackle the challenges and achieve the principles of surgery in this in MIS way or not, because the end game is to achieve the basic principles done instead of the basic of open and MIS. Akash, so how would you deal with it? Venkat has already mentioned his concerns about going it MIS way. You have heard the tips of the leaders here. What is your take on it tomorrow if this case comes to you?
So similarly, I think as Dr. Venkat said that I've not done many cases, so MIS would be preferable. But since I've not done, I'll try to go in by an open approach first, and then probably after 5 to 10 cases go to an MIS approach.
Right.
The cases that I've assisted of these grade 4 listhesis, I've seen challenges both in open and MIS. I'm not very particularly I'm not very sure that the open helps much more than what an MIS surgery can. So probably after 5 to 10 cases, I will decide.
Yeah, interesting. And do we have Gautam here? Gautam, are you around? Gautam? If not, we will move on to the next case scenario. So these kind of cases, these are the challenging cases. Again, as I mentioned, it is not a single level LCS, single level disc, or a single level listhesis or a low grade listhesis, for which already a gold standard has been established that MIS is the way to go, be it a tubular or a endofusion. But that's the way to go. However, in these cases, the house is still open, and the concerns of the senior leaders are genuine to take forward, no matter how good you are. But the primary principles of decompression of both the exiting nerve roots, good amount of reduction, and achieving a solid fusion with good hold on the implant without putting them under stress is the basic principle. And if that can be achieved in MIS way, don't miss the MIS way. However, if you really feel that the learning curve is yet to be achieved, you would not want to compromise the surgical principles, and you would want to do it in the way you did. This was a case where we did it in 2014, and I at that time was not so confident, and I even today, anything more than grade 3, I am little more concerned about my ability to do bilateral decompression of the exiting nerve roots. So this is the way what we did in this particular case scenario, using navigation and getting our screws right in place, tricortical almost at the sacrum, bicortical at both the other levels, and getting the screws in, and then removing the upper screw and getting the final L5S1 reduction in there. So this was done open, but now today, with all the leaders who have mentioned all the concerns and the tips and tricks, I also think we must try to miss it and then not miss the MIS benefits for the patient. Let me bring in the case 2 for my panelist here. Now, this is a completely different ball game, where an elderly patient with multi-level lumbar canal stenosis comes to you with no obvious instability. However, a flat back kind of scenario in a patient who's got primary claudication and leg pain, both right and left, thigh and calf both, which is primarily affecting the ADL. So of course there is back pain involved. However, primarily the patient's complaints are related to leg and claudication in a 78-year-old, otherwise fit, retired army personnel. This is the MRI. Let me call upon my young guys here. Venkat, let me take the start from you. Multi-level canal stenosis with a lumbar flat back. What is your take on this? And what is the surgical plan for you? Forget about the open and MIS part. Would you want to do only decompression multi-level, or would you want to do a decompression plus fusion in this patient? Venkat.
This case, sir, this patient has, as you said, he is an army personnel. That means he should be fit surgically. And there is a loss of lumbar lordosis also. And there is also scoliosis, degenerative scoliosis. And disc space is narrowed in multiple spaces. So a simple decompression may cause further progression of the deformity. So this must be fused. If the patient is fit surgically, I would go for fusion.
So multi-level decompression and multi-level fusion. What would your levels be, Venkat? A quick answer to this.
1, 2, 3, 4, 5, at least 5, sir.
L1 to L5 or L1 to S1?
S1, L5, L4.
Okay, we have the anterior guys here.
L1 to S1.
Any difference in your surgical plan? Whether open or MIS will be discussed later. Anand Nayak, can you hear us? So your surgical plan, would you agree with multi-level decompression plus fusion, or you will only limit yourself to multi-level decompression? Open or MIS is different. Where the surgical plan, let's define the principles of
multi-level fusion and decompression.
Multi-level fusion and multi-level decompression. Let me have Dr. Neeraj. Neeraj, your plan, surgical plan in this patient who's got leg pain and claudication is primary thing. And what's your surgical?
Vishal, I will be the black sheep here. 78-year-old gentleman, primarily, as you're stressing repeatedly, that primarily complaint is claudication and radiating pain. Back pain is there, but see, these are the cases which we can lead to discuss in detail with patient that what entails about multi-level fusion and what entails about multi-level decompression only. MIS open, that's probably the next discussion. So I guess, I'll talk in detail with the patient that, even if whatever I do, some amount of back pain is likely to remain. So I think, my focus would be to convince patient for only decompression. Deformity is not so much collapsing here. So do a foraminotomy, multi-level, minimal invasive decompression would be my choice, and explaining the patient that, your back pain may improve to an extent, but may not go completely. I would not want to, venture into multi-level decompression, fixation, correcting of deformity. However tempting it looks to me, I would want to restrain myself from that.
Okay, I think I have someone who's now even more wiser than what he was a couple of years earlier, who's chosen the middle path between the MIS and the open way, and also he's not the very aggressive anterior guy. Arvind, I'm referring to you, the wisest of all the MIS guys here. How would you plan surgery in your case? What is your surgical plan and your approach, open or MIS?
So that makes me another black sheep with regards to this particular case. I come what may, I'm not going to able to fix this patient's back pain. The thing is, there are two issues about back pain. One is usually it is the buttock pain many a times that they gets interpreted as back pain, and that is a root pain. So that should be taken care of by decompression alone. And if it is still genuine back pain, even if you do a multi-level OLIF, whatever you do, give his good sagittal balance, etc., it is so rocky, the whole spine. I don't think he'll get, he can be assured with regards to his back pain. So I would go with Neeraj do multi-level decompression. That will be, I think, 3, 4, and 4, 5. I have not seen the axials at 2, 3, but not at 5, 1.
3, 4, 4, 5, 5 S1.
Yeah. Not much impressed by a 5, 1. So 4, 5, and 3, 4.
So 2-level decompression.
Yeah.
Dr. Mihir, what's your way of dealing with it? Is it tubular? Is it interlaminar or a frank laminectomy in this particular patient with a almost stable spine? Dr. Mihir.
I seriously feel that a simple laminectomy for this patient is going to work the same way as a minimally invasive surgery. So if you are really confident of doing a multi-level surgery in a relatively lesser period of time, he's 78-year-old. You have to consider him as a whole with all his medical problems and his age and his anesthesia risks and everything put together. Give him a good surgery which offers good bilateral decompression, whether it's a laminectomy or minimally invasive, doesn't matter in this particular patient.
Right. Let me take upon the endoscopy team here. Sukumar, can you help us about your surgical plan? Is MIS endoscopic technique good for these patients with stable spine, almost fusing discs there, multi-level canal stenosis? Your take on that.
Yeah, these patients are the very good patients for endoscopic decompression. I fully agree with Dr. Arvind. I would go for 3, 4, 4, 5 and 5, 1 on the right side with a stenotic decompression and over the top doing bilaterally. So such a 70 plus individual, I think I'll 78 with already nature has fused and it's a stiff spine. So I'll just go with a multi-level decompression endoscopically. And these patients do very well. We do regularly now. So I have more than 30 patients of 75-year plus people. So they are doing very well, and the back pain eventually also comes down. Most of the time it is because of
right.
Rather than the discogenic pain. Yeah. So I will go for endoscopic multi-level decompression.
But Sukumar, are you concerned about the surgical time and the surgeon's fatigue coming into play as you do from one level to another level? I'm sure you are a master, but the message that is being driven home is for a lot of young guys who are entering into MIS. So for these particular cases, I'm sure you would do it endoscopically. But say 10 years ago, when you were starting your endoscopy in MIS, would you still be the one to choose these cases for endoscopy, or you would worry about certain concerns in your MIS technique?
Yeah, here when you do interlaminar, radiation is not a problem because hardly you take 3 or 4 shots for each level. But as you said, the fatigue on your shoulders and the forearms is a big concern initially for any beginner. So, for example, if you start a endoscopic single level stenotic decompression, a beginner might take 2.5 hours doing bilateral decompression. So as your learning curve decreases and you learn and you do, let's say 30-40 cases, so you can do 2 levels in 2 hours time. So definitely yes, the learning curve is it kills your shoulders and your forearms. But as you progress, so this is a very good case for endoscopic stenotic decompression.
Right. Do we have Sai Krishna Gade here? Sai Krishna with us? Dr. Sai Krishna? Sai Krishna? Okay, I think Sai is missing here. Akash, now you have heard the mentors with their concerns and restrictions. Akash, how would you take up this challenge in your case if you're doing this case tomorrow?
So I could not hear the question. Background noise.
Vishal, I just want to add one more point. So regarding this fatigue of surgery, so there are a few patients where I have done under epidural anesthesia catheter, two levels at a time, and I think and do the other 2 levels. I've done 4 levels like in 2 days like that with epidural catheter.
Very, very important point. I think the anesthesia part, the patient lying prone for a long period of time, particularly in patients where you are doing under regional or local anesthesia, that is something that becomes a major concern as well. Akash, now having heard all the concerns, what's your take on this? How are you going to deal with this patient tomorrow?
Yes, I did hear. So I actually had a concern of my own I wanted to ask everyone.
Yes, please.
So looking at the spine, the sagittal balance will be a bit in disarray. So if we plan to treat the patient surgically instead of going conservative, and decompression has to be achieved, how much can an OLIF, a standalone OLIF, do both the things, that is achieve sagittal balance and achieve decompression?
So let me have this question directed to Anand Nayak. Anand, can you please take up this question? Standalone OLIFs in these settling discs for decompression and achievement of sagittal rebalance. You're mute, Anand, you're mute.
You can perform an OLIF at multiple level in this patient. You can achieve a balance, but I will not never ever recommend standalone OLIF at all.
So I think that gives a very clear message there. Standalone OLIFs are not something that you are recommended, not in the settling disc, because the chance of subsidence and the loss of lordosis happening that your reconstituted intraop is very high. And that's why if you are doing an OLIF, go the whole hog, do it from back, and then also stabilize it from the back and compress it from the back. Anand.
No matter whatever the bone quality is, if you're doing an OLIF or XLIF, it always has to be supported with the instrumentation at the back. Standalone OLIFs in any quality of bone is not suggested at all. You see a lot of subsidence in standalone OLIF.
Right. I think the house still remains divided. Open is also a word. Dr. Mihir just mentioned about it. The concerns among young guys are very true. That dealing with them can have their own problems in a multiple level way. And tubular surgeries can have their own challenges, like surgeon fatigue, surgical time. And this is something that we all must keep in mind before we venture into these cases. As MIS is said, that patient selection becomes even more stringent when you are doing MIS as compared to open, and your surgical skills come into play, and you have to really rely upon a lot of things like surgical time, surgical factor, and of course the patient positioning also has also matters. So Arvind, one last quick liner about your concerns whenever you're doing a multi-level decompression for such cases. What are your surgical tips and what are your surgical concerns for these patients? Blood loss, positioning, tube positioning, mattering them, and in rotation of the spine. Can you please highlight some of them?
Yeah, a few things. See, L5, S1 and L4, 5, the trajectory is one line if you draw the disc space backwards. So there you can do 2 levels with 1 incision, but if the disc space are parallel, it is difficult unless the patient is extremely obese and you can rotate your tubes up and down. Second is the patient has some degree of convex scoliosis. So if you put the tube on the concave side for that particular segment, the concave lamina, the concave pars, the concave facet, they will have all undergone attrition over a period of time. They'll be smaller in morphometry compared to the convex side, while the convex side is wide and large. So, and then I would go from the convex side. So because that gives a bigger platform, bigger playground to play with. And you should also make sure that there is no exiting level stenosis, and clinically that should correlate well. If there is an exiting level decompression, compression, and if it is that is symptomatic, especially at alpha S1, etc., I'm not sure whether you can do a decompression there. You probably will end up doing a TILIF at that particular level.
Right. And surgeon fatigue, surgeon.
Yeah. So that is there. So I think you should have to, if you do if you have to do more than 2 levels, I think you should take a coffee break in between.
Yeah. Very interesting. I think these are all points. These are very, very pertinent points. Choosing the right side of getting a tube docking, taking attention, the facet atrophy and atrial subluxation, and all these things will come into play while you are doing a MIS way into these. Fusion has its own challenges. The open surgery would give some results. However, you have to be really, really very well counseled in yourself, and your patient should be extremely well counseled about the failing degeneration which may set in tomorrow, if not today. And these patients can actually be coming back to you again and again, no matter what you do. And that is why choosing the right technique, choosing the right patient and counseling them the way you really feel is the key to these surgeries. And the challenges of open and MIS lie in there. My last case scenario before we end up this session, and this time it is about multi-level fusion in patients with multi-level listhesis. Let's not question the credential or the indications of surgery, because this patient has worsening claudication, mechanical low back pain. And I'm going to present 2 case scenarios: L4-5-5S1 listhesis, and another case scenario very similar, L4-5-5S1 listhesis with more than 2-level canal stenosis. So these are 2 different case scenarios. Arvind, let me catch you again on this. What's your plan on these patients? A middle-aged 64 female osteoporotic. Would you do only decompression in stable spines, or you would go and do fusions? And if yes, other than all the other concerns of multi-level decompression, multi-level fusion is now a challenge.
So these patients should be very careful. One is you to in detail evaluate these patients, do the axial, see the axial films, see for the facets, the alignment of the facets. If there is if they are very well placed coronally and there is no much movement in flexion extension, if the disc height is not very tall, there is an option of doing a decompression alone. But I think 9 out of 10 times in such cases, I would do a TILIF at 2 levels.
TILIF 2 level. So, Dr. Vishal Peshetiwar, Dr. Vishal, are you around? Or maybe Neeraj. Neeraj, what are your technical concerns when you're dealing with doing multi-level MIS TILIFs? What are the surgical tips and concerns that you face? You're muted, Neeraj. Neeraj, unmute, please.
Okay, I'm sorry. Yeah. So, I think, this is pretty straightforward MIS TILIF, the first case. Second case is little, we really need to think about slightly more, because, it's a collapsing lumbar spine. If you look at 4-5-5, and there is significant low doses. So I would be a little concerned about, the overall sagittal balance of this patient, because PI is quite high. And if sometimes you just do 4-5-5 TILIF, lumbar spine starts collapsing above that, So I think, this would be a challenging case to restore proper sagittal alignment. Second case. First case, I think I don't foresee that, there would be many challenges. Here, I think I would want a full length X-ray, whole spine X-ray, and then take from there that what I would want to do, how many levels, whether I would want to fuse or not. What many levels we want to fuse.
Let me catch Venkat, Akash. What's your take on these cases? Venkat and Akash.
As Sir has rightly mentioned, I think the first case can easily be dealt with MIS TILIF. Second case, I don't know. And of course, whole spine X-rays are important.
Right. Unfortunately, I have not kept full spine X-rays, but yeah. So it's important to see full spine X-rays. But let me tell you, this is very, very high PI, 2-level listhesis. They are very minimal instability or mobility on dynamic X-rays, and they are not moving on dynamic X-rays. However, the facets are very sagittally oriented. So I think fusion is surely on the cards here. So Anand, what's your take on these cases? I'm sure you are thinking going anterior or Olif way. Considering the high iliac crest there, what's your take on such cases?
So anterior is preferable. If you remember, Vishal, we tried one anterior approach in one of the spine surgery meetings in Mumbai. And
Yes.
unfortunately, I didn't have those angled instruments and the pelvic ring was causing trouble. So we had to abandon the live surgery. We had to abandon that and had to do the posterior MIS stuff with Ranjit. So now I have got all my angled curettes and instruments available with me. I can go ahead with the anterior surgery. But if those kind of specialized instruments are not there, then go from behind and do an MIS relief at both levels.
Right. Rakesh is here sitting and watching like a lion out there. Rakesh Luhana, can I have your opinion on this? You are master of OLIF, MIS, TLIF and both. What's your take on such case scenarios where two-level listhesis, multi-level fusion has to be added to these patients? Rakesh.
Yes. Okay. So here I would also like to see DEXA scan and see whether osteoporotic component is there or not.
Minus 2.5 DEXA. I have got it done.
I would see clinically how much component of back pain is there as well as how much mobile on dynamics. Otherwise, we may
Significant component of back pain, but dynamic mobility doesn't show too much mobility. It is just moving by few millimeters, not even like from grade 1 to grade 2 it is not, but it is slightly
okay.
mobile.
And if you have foraminal views, if there is no foraminal stenosis, then we can just do MIS decompression and avoid fixation fusion.
So this is case 1 where the disc is tall, facets are sagittally oriented, and there is foraminal compression also.
Yeah.
And case 2 where there is settled in the pelvis.
Right.
வெளியில எக்ஸ்ரே எடுத்தீங்களா? வெளியில எக்ஸ்ரே எடுத்தீங்களா?
So the first case, two-level MIS TLIF, just MIS decompression.
Okay. And second case only MIS decompression.
MIS decompression, yes.
Wonderful, wonderful. And Dr. Mihir, what's your take on such cases? Would you do something different than what has been spoken so far?
No, I just love doing MIS in these because you know me. I like to instrument long using percutaneous screws, and the way the hybrid technique works nowadays, we do over the top using a microdiscectomy approach on one side, and you decompress the roots on the other side. So these things come out very, very well with MIS. And I think this whole assessment of stability goes for a toss when you put this patient under anesthesia and in the prone position, and you feel that the discs are opening up with a lot of vacuum. So these are unstable, and doing only decompressions will cause a deterioration over a period of time. It's better to stabilize those listhetic segments.
Right. Let me just go the last hog of the MIS way. Endofusion. Can I have Dr. Sukumar on endofusion technique? Would you like to do endofusion in this, or you would do tubular, or you would do an open technique in these cases? Sukumar Sura. Dr. Sukumar?
I think he just left. He left a message that he is to go.
Okay. We have Dr. Kim from Seoul. Dr. Kim, can we have your opinion on such cases? Dr. Kim, can we have you on board?
Yeah.
Last comment from you.
Yes. Can I give the comment?
Yes, please, Dr. Kim. We are waiting for your word.
Yes. In this case, is the endoscopic lumen intervallic fusion is a good indication. A reduction can be, and also fusion also can take sufficiently. Because of that, I will choose the endoscopic fusion for these cases.
Right. And your concerns for multi-level fusion technique? Are you not?
Yes. Yes. This patient have a L4-5 and L5S degenerative release. I will choose the two-level endoscopic fusion.
Right. I think that sums it up all. So do we have any more time here? I have one last case scenario to come up, or we can just sum it up.
Okay. Yeah, sir, actually we are running pretty late.
Okay. I think I will sum it up. Thank you, Professor Kim, for your wonderful comment there. Dr. Mihi, Dr. Arvind, Dr. Sukumar Sura, Vishal Peshattiwar, Rakesh, Neeraj, Akash and Venkat, you have been really contributing very well, and I'm sure the concerns that you guys have raised are soon going to be taken care of. So we need to understand that MIS is the way to go. Yes, there are challenges that one can pose, one can come across while dealing with these challenging case scenarios of multi-level decompressions, multi-level listhesis, or even high-grade listhesis. But what was true 5 years ago is no more a fear today, and you can all deal with, as you have heard all the stalwarts talking about, how do they deal with these problems? And the young guys brought forward the challenges that they face. I'm sure there is a middle path into it where the concerns of the young guys with the tips and suggestions from the senior guys can come together, and we can all walk towards the miss way. The answer to this is don't miss it, do a miss to it. Thank you so much. Over to you, Hall in charge. Thank you, guys.
Thank you, Vishal sir. Thank you, Dr. Thank you, Dr. Neeraj. Thank you, Dr. Vishal Peshetiwar. We'll be logging off and moving on to the next session now.
Hi, can I?
Good morning, Dr. Vishal Peshetiwar. So this is the direct lecture session, MIS in degenerative spondylolisthesis. We welcome the panelists, Dr. Meher Bapa, Dr. Jacob, Dr. Satyan Matthew. Over to Dr. Vishal Peshetiwar.
Hi, good morning. We are way behind our time, so I invite the first talk by Dr. Nitin Garg. MIS decompression in stable degen spondylolisthesis, tip to prevent iatrogenic progression. Can you start with your talk, sir? Dr. Nitin, are you here with us?
Do I need to play here?
Sir, I am
because I've already
we'll play
shared the video. Yeah.
Yeah, we'll play the video.
Okay. I shall be presenting on MIS decompression in stable degen spondylolisthesis, tips to prevent iatrogenic progression. As we know that stable degenerative spondylolisthesis is a distinct subgroup in the spectrum of degen spondylolisthesis. And these patients behave more like lumbar canal stenosis, wherein they have predominant lower limb symptoms, no mechanical back pain, and dynamic X-rays showing no significant instability. Identifying this subgroup of patients, especially in the elderly patients with osteoporotic spine, is important because it helps to avoid fixations in these patients, as it is now well established that simple decompression is adequate to relieve the symptoms. So how to reduce the post-operative instability? The most important way is by adopting minimal invasive methods to decompress the spinal canal. It has now been proven biomechanically as also by clinical studies that MIS laminotomy significantly results in less post-operative instability compared to open laminectomy. This can be done by a midline approach, or it can be done by a unilateral laminotomy and a bilateral decompression, also more commonly known as over-the-top decompression. And these can be used for single-level or multi-level stenosis. In addition, it is important to preserve the posterior tension band or the osteoligamentous structures which comprise the lamina, the spinous process, the interspinous ligaments, and paraspinal muscles, of which multifidus is one of the important muscles. Important adjuncts to use during the surgery is the use of high-speed drills, and secondly, to undercut the facets, thereby preserving the integrity of the remaining facet. So I shall be describing about the tubular unilateral laminotomy and bilateral decompression. Once the tube is docked, this is the amount of bony decompression which is done, part of the lamina, the medial facet, and the spinolaminar junction. The tube is docked on the right side, and the ipsilateral and the contralateral bones are exposed. And once the bony work is done, the ligamentum flavum is exposed. Now it is important to angulate the tube so as to get access to the opposite side. Some surgeons angulate the patient rather than the tube. Once adequate bony work is done, the ligamentum flavum is removed, and the thecal sac and the opposite lateral recess and roots are decompressed. A brief mention about multifidus muscle, which is an important paraspinal muscle, and it is a key stabilizer of the spine, responsible for short and powerful movements. It is saved by splitting the muscles as in tubular discectomy rather than by stripping the muscle as in the midline method. As Lee has shown in 2005 that there is significant preservation of the trunk extension strength when using paramedian approaches compared to standard midline approach. A small video presentation. So this is a patient with L4-5, the patient with L4-5 stable listhesis with significant stenosis at the level. As we know, in these patients, the compression is predominantly due to the soft tissue structures, that is the ligamentum flavum predominantly, some component of the disc, and some component of the facets, hypertrophied facets medially, which encroach on the lateral recess. Importantly, the lamina, the spinous process, the interspinous ligaments, and the paraspinal muscles do not cause any neural compromise whatsoever. So therefore, comes the question whether it is justified to remove these posterior osteoligamentous structures which are important in stabilizing the spine, when we can achieve adequate neural decompression by using minimal invasive methods and thereby also preserving the spinous process, lamina, and the paraspinal muscles and the ligaments. So I'll be presenting a brief video with some important steps. The most important step is docking the port and confirming the level. And this is at the L4-5. This is the cranial level. This is the caudal. This is the medial, and this is the lateral. And the surgeon stands on the lateral side. Once the level is confirmed, the bony anatomy is exposed. And as we can see, the inferior part of the L4 lamina, the spinolaminar junction, and the superior part of the facet joint. The tube we are using here is an 18 mm diameter tube. And with smaller diameter tubes, the entire surgical field may not be exposed, and therefore we may have to angulate the tube caudally or cranially, depending on the area of dissection. This is the L5 lamina, the spinolaminar junction, and the inferior part of the L4-5 facet. This is an important step to expose. Now, for want of time, I am not showing the drilling of the lamina, but this is the drilling of the medial part of the L4-5 facet. Now, drills are an important part. They help to remove the bone from outside in. They help us to avoid putting large footplate carisons, such as 3 mm or 4 mm carisons in the canal, which is already compromised. And thereby, it helps to reduce the incidence of neural injury. In addition, when we drill the facet thin by these drills, we also preserve the integrity of the remaining facet joint, which is very essential to avoid further progression of the instability. So the bone is thinned out, the medial facet is thinned out gradually using the drill, and subsequently once it is thinned out, we can then use 1 mm carison as shown here to remove the thinned out medial facet. So this helps to avoid neural injury and also to preserve the integrity of the remaining facet. Now, once the lamina is drilled, L5 and also the L4, the attention is towards the spinolaminar junction. Now, it is important to remember that the spinolaminar junction is like a pyramid, which has an apex and a base. Now, to begin with, we as beginners tend to drill the apex more often than the base, but it is important to drill the base so as to gain access to the opposite side. Unless the base is drilled adequately, we will not be able to reach the opposite side. So here we are drilling the apex of the L4 spinolaminar junction, and the bone is drilled out, thinned out till the cortical bone is reached. And now we are drilling on the opposite side. This is the ipsilateral ligamentum flavum exposed. This is the midline, and the spinolaminar junction has been drilled. And now we have entered the contralateral lamina. We are entering the lamina and drilling it inside out. So the thin cortical layer will be remaining, and that will then be removed by using a Carison ronger. The same step is repeated at the L5 spinolaminar junction. And again, as we know, this is like a pyramid, and we have to drill the base as also the apex of the pyramid. Adequate bony removal is very essential so as to gain access to the opposite side. It is also important to keep the ligamentum flavum preserved till the entire bony work is done, because the flavum acts as a safeguard to the dura while the drilling is being done. Once the bony work is done, the flavum is removed piecemeal, and then we go to the contralateral side. Now, contralateral side, the flavum is being removed, and gradually the lateral end of the thecal sac will be visible. And as we see here, the probe is onto the opposite side using from the ipsilateral side. This is the MRI, which shows adequate decompression of the thecal sac and both the lateral recesses by unilateral approach. Another important aspect to see is the preservation of the anatomy and morphology of the multifidus muscle. The similar procedure can also be done using midline retractors. The entire procedure remains the same. The amount of bony work is also the same. It is just the access and the retractor which we use separate in this case. And again, the same steps, and we can see the opposite end of the thecal sac adequately. The thecal sac is retracted gently by a suction, which also keeps the field dry. And all this ligament is removed piecemeal. Now, again, a postoperative MRI, which shows adequate decompression of the canal as also the lateral recess. Now, this midline approach can be used for 2-level and also for 3-level decompressions, wherein we use a midline approach and then expose respective levels and do the decompression separately at each level from one side. It preserves the intervening lamina and also the spinous process and the interspinous ligaments. So to summarize, iatrogenic instability following conventional laminectomy is significantly higher compared to using MIS decompression methods. And the main ways of reducing instability is by using MIS decompression methods, preferring a tubular approach, and preserving the posterior osteoligamentous structures. In addition, high-speed drills are very important, and opposite facets can be undercut by this approach, thereby preserving the integrity of the remaining facet. Thank you.
Thank you, Dr. Garg, for that excellent talk. Can we now call the second speaker, Dr. Mahesha K? Can we put up his talk now?
Sir, we are putting up his talk.
Yeah, Dr. K. Mahesha will speak on can full endoscopic lateral recess decompression make incidence of listhesis progression less. I mean, in a lot of cases, we see lateral recess stenosis as the primary symptom generator. And I think this is a very useful procedure in that, though I'm not an expert in endoscopy. Dr. Mahesha's talk, can we have it up? While the talk is coming up, can I ask the panel, so Jacob, do you do endoscopy? Oh, the talk is up. We'll have the question later then. Okay, can we start with the talk?
Yes, sir, I'm starting the talk.
Can full endoscopic lateral recess decompression reduce the incidence of listhesis progression? We all know the definition of spine stability and spine instability. Kirkcaldy-Willis in 1982 classified disc degeneration into 3 stages: stage of degeneration, stage of instability, stage of stabilization. Spinal stabilizing system consists of spinal muscles, spinal column, and control unit. Unfortunately, many of our colleagues are focused only on spinal column. What does the literature say? Laminectomy versus fusion. Fusion gives better results. This is because laminectomy is a destabilizing procedure. It destroys the spinous process, the ligaments, the paraspinal muscles, and sometimes even facet joints. However, fusion comes with its own baggage. Perioperative complications of multiple level fusion in patients above 60 years is as high as 62%. And also there are neurologic complications, blood loss, hardware complication, and adjacent segment degeneration. Ram and Hall in 49 patients of fusion at 5 years reported adjacent segment degeneration of 35%. Another paper by Gary Giselli in 215 patients, 27.4 patients required additional procedures for adjacent segment degeneration. For a long time, adjacent segment degeneration was buried as part of natural degeneration. This is wrong. Just to show you one case, this is a patient, a 71-year-old patient with the degenerative listhesis L45, treated by me with the fusion L45. You see what happens at 3 years. Patient develops instability and severe canal stenosis at L3-4 level, which was absolutely normal before, except for little bit degeneration. Why fusion is bad? Jiang and Lee have reported a very good paper. They demonstrated range of movement, nucleus pressure, annulus fibrosis pressure increased at L3-4 level after a fusion at L4-5 level. Fusion is unphysiologic, and discs are there for a purpose, and they are not there for you to fuse. Another paper by Enos, who did a randomized control study between decompression and fusion, and decompression and dynamic stabilization in 85 patients, and results were same at the end of 1 and 5 years, but fusion group had more complication and increased hospital stay. Another paper by Hayashi, who reported same clinical outcomes between minimal invasive decompression and fusion in 64 patients. There's another paper by Koenig et al. Who did a meta-analysis of decompression and fusion, and there was no difference in outcome, but fusion group had more blood loss, more complications. Another paper by Minamide et al. Who did the tubular endoscopic decompression in 242 patients, and they reported that 35% patients with instability showed re-stabilization of the spine. Just to show you one example, 50-year-old patient with left L5 radiculopathy, no back pain. This patient had degenerative listhesis, degenerative scoliosis, canal stenosis at L4-5 level. So this requires only a decompression at L4-5 level and no fusion is required. This patient was treated with stenoscopic decompression, L4-5, extruded fragments are removed, central canal was decompressed, and patient had complete relief from pain. Another patient, 74-year-old patient with right S1 radiculopathy, there is degenerative listhesis at L4-5, alpha S1 level, disc extrusion at alpha S1 level, canal stenosis, central canal stenosis at L4-5 level. And this was treated with transfemoral endoscopic surgery. Decompression was done at both levels. You can see the video here. This is the post-operative MRI scan. Patient had complete relief of pain, and at 3-year follow-up, there is no sciatica. Patient had come with episode of back pain twice. There is no worsening of listhesis. There is no adjacent segment degeneration, and patient did not require any further additional procedures for any level. Another patient, 76-year-old patient with bilateral claudication, no neurologic deficit. Patient was advised fusion. MRI shows severe canal stenosis at L4-5 level. This required only stenoscopic decompression. No fusion was done. You can see the post-operative MRI shows good decompression and facets are well preserved. And patient was very happy with the outcome. Coming to take-home message, ligaments, spinal process, muscles, facet joints are all important factors in spinal stability. Minimally invasive decompression avoids collateral damage and instability, and there is no evidence that fusion is better, and endoscopic decompression is the way forward. Thank you.
Dr. Mahesha, a question to you. Would you still do a transforaminal or an interlaminar decompression in an obviously dynamic listhesis? And not in a case where the listhesis is stable, but in an unstable listhesis?
In unstable listhesis, I will not do a decompression. I will go for a fusion.
My question to the panel, Dr. Mihir, a very experienced spine surgeon. In our first talk, there were interestingly both tubular as well as midline access was shown. Mihir is a proponent of the contained midline decompression with percutaneous screws fixation. So Mihir, do you fix all your listhesis, or do you selectively fix them, and unstable listhesis just decompress them?
Well, thanks. Because what's happening here is that when we see a listhesis, we see it only in one frame of time. We do not know how that listhesis is going to progress over a period of time. That is one. And second is that when we call it stable, the patient has already come to you with a symptom of nerve compression. Now, what we are trying to do, whether it is a microscopic or a tubular or an endoscopic, is just release the nerve. Now, I can accept that you don't need to take down the midline structures. That's a correct theory. But whether all these techniques can really halt the progression of the listhesis, that's not in the view of this discussion, because that's a natural phenomenon. The listhesis has happened even without us intervening. So the listhesis will progress over a period of time.
Sorry, Meet. Sorry to interrupt. My question is, in which cases would you not even think of doing just a decompression, just fuse? And in which cases you may think of decompressing and not fusing a listhesis?
I have a very low threshold of decompression. And I really feel, to answer your question, is that if you have a very, very mild listhesis, that is about maybe 2 millimeters, which doesn't shift at all, the facets are good, they look pristinely clear, not arthritic, not effused, and the disc height is fairly maintained, then in such cases, you end up doing only a decompression.
Okay. So Jacob, do you also fuse most of your listhesis, I'll put it here that I fuse most of my listhesis. I rarely decompress, except if it's a very highly comorbid old patient where mobility is not very great. I would just do a decompression. But fusion, I'm very trigger happy as it comes to that. I agree with Mihir on that. So Jacob, what is your take on this? Do we have Jacob with us? Okay, while we get Jacob on, Satyen, is Satyen here?
Yeah, I'm here.
Yeah, Satyen, your take on this. Do you fuse all your listhesis or do you conserve some of them? If you do, what is your criteria of just decompressing? What are the cases you select where you would just decompress rather than fuse a patient?
Yeah, so I understand that this is a gray area in many cases. The safest option obviously would be to fuse them to avoid the chances of progression of listhesis. So I tend more towards fusing these patients, especially in older elderly patients. The cases where I may consider only decompressing is that I have to see a few points here. Number one is the disc height. If the disc height is quite low, if it is less than 6 or 5 millimeters, then there is, it is kind of auto-stabilizing. So there is a chance that I may not fuse them. The second is the facet. If there is a lot of facet effusion, then you should not be looking at, I don't see any non-fusion technique. I operate and fuse these because they are quite unstable. The third thing is your facet orientation. So if your facet orientation is sagittally oriented by more than 60 degrees, again, that indicates that this is going to progress further. So I would tend towards fusing these patients. So, it's not just, okay, just operate on, just blindly fuse all or not fuse all. You've got to see radiological parameters and you've got to take every patient and every case separately. Other factors like maybe obesity, would also come into picture. Where a lot of low back pain also would come into picture that you would tend towards fusing these patients.
Thanks, Satyen. Thanks for that. Now, what does the evidence say about this? Ranjit, can we have Dr. Ranjit's talk up and going?
I'm putting his talk, sir.
So Dr. Ranjit Unikrishnan, my colleague from the same medical school that I passed out from, an expert in both open as well as MIS. Let's have his talk and take on this.
Very good morning to all. Thanks at the outset for this invite to MSAP. The topic is degenerative spondylolisthesis, choosing fusion levels. When we face a patient like this, which are low-grade degenerative listhesis, the most common problems we try to treat are claudication, plus or minus back pain, plus or minus neurodeficit, plus or minus a deformity, and all comprises treatment of the disability. Now, when we see these two grades of listhesis, we know that they are a different animal. One on the right is a high-grade spondy, which is essentially a deformity surgery, not a degen surgery. When you try to look at the evidences, there's umpteen number of papers comparing A-leaf with a O-leaf, with a T-leaf, with open P-leaf, and the jury is out as what is better over the rest. Whenever we treat, we are very clear about the surgical goals which we have to achieve, that is decompression of the central and foraminal stenosis, plus or minus extraforaminal stenosis, treatment of the sagittal deformity, as well as correction of any scoliosis if present. Now, this is very important when we make a decision regarding treatment of listhesis, the PI minus LL balance. We will not go into the details. So this has been demonstrated that sagittal balance has to be an independent predictor of the surgical result in adult deformity cases in short or long fusions. Now, also in patients with smaller pelvic incidents tend to have a high restoration of lumbar lordosis, and patients with higher pelvic incidents tend to be restored to lower lumbar lordosis. So for patients with normal sagittal balance, outcome is not correlated with the restoration of lumbar lordosis. So a vast majority of our patients come into the third category. So please keep this in mind when you make your surgical decisions. Now, when we come to these patients with a high-grade listhesis, we come to these two types demonstrated by Resco et al., a balanced and an unbalanced pelvis. Now, if you have an unbalanced pelvis and you decide to do a decompression alone, along with in situ fixation, a choice of fusion lesson does not happen. We have got enough number of papers citing that they are better than the rest. Now, the question arises when we see a low grade or a low dysplastic variety, what should be your fusion level? When do you want to go to L4 in the case of L5S1 listhesis? And next is the distal level. When do you want to go to the ileum in case of an L5S1 listhesis? Now, umpteen number of papers coming out which supports the restoration of the PI minus LL imbalance. Also, this is more important than selection of fusion level, where you get the lordosis correction. Is it in the lower two-third or is it in the upper two-third? We have enough number of papers which say that if the lordosis is not restored in the L4 to S1, where we have two-thirds of the lordosis, we don't get a harmonious PI minus LL restoration, and that leads to increased PGK on pure HRQL levels. This leaves us with four subsets: a short segment for L4 to L5 floating fusion, or a L5 to sacrum fixation, or a L4-5 S1 sacrum S1 fixation, plus all the above with an IDA fixation. Now, please pay attention to these factors. Than deciding the fusion levels, a restoration of the sagittal profile is most important with respect to long-term results, which amounts to posterior column osteotomies. They can be MIS or open, rod contouring, lordotic cages, anterior cage placement, etc. So this is what we follow. We make sure that we restore the balance appropriately, even if it is an MIS technique. Now, when should we go distally? So this is a classic paper in the Spine Journal, wherein we have go to S1, more valid for adolescent for adult scoliosis. You have to go into S1 when there's a previous laminectomy or there is stenosis or oblique takeoff. And also he recommends that when you have more than 3-level fixations, it's ideal to support the L5S1 with interbody fixation as well as going into the ileum. So a demonstrated case, 40-year-old female who came to us with degen symptoms, even though she had a high dysplastic listhesis, imbalanced pelvis. We went ahead, did a VCR or an osteotomy of the sacrum and corrected her and restored the balance. And obviously in this case, we had to have 2-level fixation. We went ahead. These are the pre and post-op images showing that we could restore the balance. The spot study outcome, which says that fusion or no fusion, the outcomes are almost the same. So the take home is that spondylolisthesis is a spinopelvic dissociation. The pelvic incident determines the sagittal profile as well as the fusion levels. Reduction is ideal in high-grade listhesis with unbalanced pelvis. Restoration of spinopelvic harmony is essential in maintaining the HRQLs, and the MIS techniques are very powerful to achieve this. Thank you for your patient listening.
So the next talk, can we have the next talk? Choosing between direct decompression MIS sleeve versus indirect decompression.
10 seconds, I load the talk.
Yeah. So while the talk has been loaded, Ranjit,
yes,
we had a talk about endoscopic foraminotomies. So, and here the author of this, the speaker also agrees that in unstable he will fuse. But if it is a stable listhesis, what is your threshold for fusion?
Stable listhesis, meaning there is no back pain. Patient only has got leg pain. I will not fuse. I will do minimal invasive decompression, endoscopic or open based upon the anatomy and feasibility. I will not fuse it at all. Because, and I always tell them that if your future you become painful, we'll go and fuse.
Vishal sir, the talk is ready.
Yeah. So can we play the next talk, please?
Good afternoon. I have slightly changed my topic from tips to avoid complication to tips for smooth tubular surgeries. I'm going to give you some practical tips.
Vishal, this is another talk. This is not the same talk.
There are three types of tube. One is a
Sir, sorry.
This is yesterday's talk. This is not today's talk.
Okay, 1 second.
We have to have is choosing between direct decompression, MIS CLIF versus indirect decompression of ULIF.
Okay, 1 second.
Are there criteria?
They're saying.
In the meantime, Dr. Vishal, can I ask a question?
Sure.
In your experience and Dr. Meer's experience, because both of you are suggesting that fusion, most of the times you do fusion. In your own experience, have you come across patients wherein you did only decompression to begin with, and they landed up after some years with fusion, say after 5 years or 7 years?
Yes,
Can
they
you,
have.
I mean, what would be the percentage of such patients?
So I won't
Just
be
a
able to
brief.
give you an exact ballpark figure, but yes, we have a rare patient coming back to us who was, in fact, even when they were not initially unstable, and after having done proper tubular decompression, we have few of them coming back to us say, with instability developing.
Okay, because for want of time, actually, the topic was MIS decompression tips. But actually, there are a lot of studies now, and I can share with you wherein they have actually even a Cochrane analysis in 2015, wherein they have compared laminotomy versus laminectomy and compared instability in patients with stable listhesis. And actually, they have found that in a unilateral or bilateral laminotomy, the instability is hardly anything, maybe 1 to 2%. So, but then of course, all these things have to be also corroborated with the personal experiences. And like in my own experience over last 10 years, I have not fused any patient who had a stable listhesis. Of course, we have to define stable listhesis, like as Dr. Anjit said, clinically also and radiologically, both the parameters have to be met. But if a patient is chosen in this criteria, I have not required the need to go ahead with for fuse, but it may vary from your practice and Dr. Meer's practice.
So basically what happens in India, unlike abroad, is whenever you have an adverse problem, and in India, if you develop instability after a certain years, it is still considered an adverse event. He usually never goes to the same surgeon. So if I have done a decompression and he's developed instability, the most likelihood is going to end up with me go to him for what to do now. So I think Mir would be better positioned to answer that question. And Mihir has a larger experience. So Mir, your take on patients coming back after decompression only to you in your practice?
No, I think
Wherein pain is incorporated.
Further on that, see, when we compare laminectomies to laminotomies, it's an heterogeneous group. We should not compare these two techniques because they're entirely different. Second is that when you are comparing laminotomies, what we have to understand is that laminotomy per se does not guarantee against listhesis progression. That's an entirely different issue. It's a natural progression that we are trying to halt with a laminotomy. So unless you are pretty sure that your group is 99% secure against natural progression, then you offer a laminotomy. The problem is, how do you secure this group? There are no strict parameters as to which listhesis will progress, which will not progress. And whatever we eyeball is only whether there is minimum listhesis, the facets are good, the facets are pristine, the disc is good, the disc is settled, there is auto stability. All those are vague parameters. They are never foolproof. And that is why there is always an element of progression in listhesis. And as Vishal pointed out, it is considered as a failure of your surgery.
So it's actually natural progression of disease. I mean, when there was a normal disc, it popped out. And when there was a normal disc you're born with, but it degenerates. So it's a part of aging. So the whole idea of treatment is while you're rectifying it to do minimal damage. And that's where we evolved from open surgeons to doing it minimally invasive. Do we have the next talk of Dr. Neeraj up?
Vishal?
Yeah, Ranjit.
Yeah, don't you think so? It is because of the the question which Dr. Nitin asked. In your experience, how often do you have to go ahead and fuse your or your colleagues' cases of listhesis which you decompressed? Don't you think so? It is because of the difference in the way it is decompressed today that they don't end up in fusion?
So Ranjit, you have just added one more parameter to what I have just said. It is also the difference in the surgeon technique that also results in progression.
Yes.
So it is just too many factors when it comes to the disease progression, which actually is not in our hands.
Very true, sir. Sir, like what Vishal and you mentioned, thankfully to me, most of my
Sir?
complications come back to me myself. And
So very
when I
sorry, the
go and-
talk is ready.
Yeah, when I go and see why it happened, it is my what do you call so-called Vishal's barbaric surgery which did to the listhesis progression. It is not the disease only getting progress. I go knock off sort of tissues. So it is my own mistake which has led to the progression added to the natural history.
Absolutely. So while we have some more time for discussion later, can we start with the talk now?
Yes, sir.
Good morning, friends. Let us talk about direct versus indirect decompression, that is MIS TLIF versus OLIF. Ideal surgical technique is which gives better or comparable results with gold standard. There is no unsurmountable learning curve, reproducible results, acceptable complication profile, and affordable. At the most, these days, lumbar lordosis is important, so technique should give an optimal lumbar lordosis. Let us take Professor Luke Kim's paper to compare. They have two cohorts. They have matched head-to-head for both the cohorts. The operative time was much lesser with OLIF. Estimated blood loss is much lesser with OLIF as compared to MIS TLIF, while the hospital stay remains same. ODI, right from pre-op, post-op to almost till the last follow-up remains same with both the techniques. So in disability improvement, both the techniques are same. Back pain and leg pain also improved similarly in both the technique. The disc height was significantly higher with OLIF, while the foraminal height remains same in both the technique. Overall lordotic angle more or less was better with OLIF, and the segmental lordosis was also better with the OLIF. Fusion earlier in OLIF at 6 months, you can see the statistically significant fusion earlier with OLIF cases, while when if you go further, there is no difference in fusion rate between the group. So early fusion happens with OLIF, and which is advantageous in deformity to prevent implant related or a fusion related complications. So more or less both techniques are equal in regard to clinical results, no unsurmountable learning curve, both gives reproducible result, affordable. And let's look at the complication profile for OLIF. We already know about MIS TLIF. Before we go for that, let us understand the advantage. It's a minimal access muscle sparing approach. We can use avascular retroperitoneal space, so very, very minimal blood loss. It's a direct access to this space, leads to better release, larger cage, indirect decompression and nerve sparing, and it gives a better lordosis. If you can see, the largest amount of cage which can be inserted is either in ALIF, XLIF of OLIF as compared to MIS TLIF. There are n number of complications which can happen with this anterior surgeries, and most significant would be vascular injury, ureter or bowel injury, neurologic injury, or subsidence. Osteoporosis is an enemy for anterior surgeries. If your patient is having less than -2.5 DEXA scan, don't use anterior surgery or optimize your patient. You should have a proper corridor to perform this surgery. If this corridor is not present, you cannot do OLIF, and you will have to recite for XLIF, and iliac crest may come in way in doing XLIF. In those cases, you will have to go from the back. There are certain cases like, this patient has a left-sided facet cyst. These patients are not good for anterior surgeries, as facet cyst would have adhesion and may not get decompressed properly with anterior surgery. So if you are doing an indirect decompression, thus osteophytic compression also may pose a trouble, and you would want to use a posterior approaches rather than the anterior approaches. There are approach-related complications with the anterior surgery. If you damage subcutaneous nerves like iliohypogastric, ilioinguinal nerve, that means if you are careless in handling this nerve, your patient may wake up with pseudohernia. If you are doing an XLIF surgery, you should know the anatomy of lumbar plexus, use neuromonitoring to be away from the femoral nerve or any nerve stimulant, especially at L4-5 level. Otherwise, patient may wake up with femoral nerve palsy. Even in OLIF cases, when you retract psoas muscle too much, it may end up having a neuropraxia or neuropalsy in your patient. Most of them recover eventually. So more or less, both technique head-on-head compare equally with each other. and even in complication profile are acceptable. The most dreaded complication for anterior approaches would be subsidence, because we are banking upon a jacking open of a disc space. So any subsidence would lead to further compression. A minimal subsidence is very well tolerated as per recent studies, but a significant subsidence should be avoided. So don't use this technique in osteoporotic bone. Don't use a sharp instrument. Always try to place cage at the cortical rim rather than the cancellous bone. Use appropriate size cage. Oversized cage may lead to further subsidence. So on and all, anterior surgeries give better lordosis, better deformity correction, while other things remain same. So disc height is better and lordotic angles are better with the anterior cage. So which technique should be used for which level? So recommendation says for alpha S1, LF is superior than other technique. At L4-5, either LF only for X-sleep can be used. At L2, 3, 3, 4, LF is not possible because you will have to retract vascular structure too much. You will have to mobilize major vessels. So better to use either X-sleep or O-lip, or go for a posterior approach. And if you go higher than that, generally either direct X-sleep approach for L1-2, or for higher than that, generally you should prefer a posterior approach for this patient. When you are doing multi-level, try to combine both the approaches. As I said, anterior approach gives better release, better deformity correction. So for deformity, try to go use anterior surgeries. I'm sorry to rush through the talk because of short of the time. This is an extensive talk, cannot be covered in this limited time. I have tried to do my best. Thank you so much.
Neeraj, thank you for that crisp and quick talk. Can you now enumerate what is your criteria to choose to do an OLIF? If money was not an issue and technology was not an issue, where would you do an OLIF and where would you prefer a TLIF? Do you believe in the concept of indirect decompression? Because OLIF, usually you are able to put a 14-16 size cage. So do you think in your hands, how many times have you gone back from behind to do a decompression after having put in an OLIF cage from the front and percutaneous screws from behind? Did you ever have to revise it, or do you always do a posterior decompression after OLIF?
Vishal, I guess, in my hands, I'm very selective and very choosy about doing OLIF. I'm not, left and right an OLIF guy. I still mix my surgeries with MIS TLIF. I think, when I'm dealing with deformity surgeries, adult deformity surgeries, my inclination towards anterior is slightly more because, I can do less from less incision and a very speed time. If I'm trying to do MIS TLIF for deformity surgeries, I think it takes a lot of time, and anterior is 2-3 cages you can put in 1 hour and just come back and you can do the things. If there is probably, I would look at the bony stenosis. If patient is having bony stenosis, patient's disc height is quite maintained, where, there is no scope of further jacking the height. In those cases, I prefer to do TLIF. Otherwise, I think, I don't remember a case where I had to go for posterior decompression once case was out of the OT. So there were cases where, the decompressions were already planned, and I showed some of the cases where there was osteophyte, trefoil shaped canal. All those cases, I prefer to do posterior decompression as well. Otherwise, in deformity cases, I do explain my patient that, I'm going to do this much, and if need be, I might, come back for decompression. But I think so far I haven't burned my hand, but I'm looking for a case where I will burn my hand soon.
Okay, I hope you never get that burn your hands case. But Ranjit is also fairly active in doing OLIFs as well as MIS TLIF. So Ranjit, do you have a criteria to which to do what when?
Yeah, Vishal, to answer the question in one word, if it is a single level fusion required, I still do MIS TLIF. It's more easy for me because no positioning, it's more less theater time with respect to change of position, etc. If it is up to or above, I try to do OLIF with the percut posterior because it makes less mobility. Again, apart from all the criteria mentioned by the Dr. Neeraj, wherein if you don't have an oblique window, I used to try and make a window, retract the psoas or slightly impale the psoas. But I feel that it has its own price. Patient post-op does have a bit of thigh paresthesia, etc. when you do all that. But anything about 2, I always try and do, if possible, OLIF. Again, a patient where there is a congenital stenosis, there is front back stenosis, the short pedicle, I don't always go with an OLIF. If it is SHISA grade 6 or 7, I go do a direct decompression of the posterior canal. Single level, I seldom or rarely do a OLIF with a percut posterior. It's MIS TLIF.
Thanks, Ranjit. Satyen, your views on this? Satin?
Yeah, Vishal. I've been seeing OLIF surgeries being done, and I don't do them myself. This concept of indirect decompression is something which is again, I'm really worried about. We will, as conventional surgeons, we want to see the dura and the roots being decompressed, and make sure that you take out the excessive phlegm and the excessive hypertrophied facets. So I think you got to be very, very careful when you suggest this to a patient.
Okay, so Mihir, we are already started behind schedule. So any winding up comments from your side, and what are your criteria for choosing this?
No, I think Neeraj and Satyen have said most of the things. The problem is that when you are jacking up a disc and you have an arthritic facet, the concerns are always fractures and the concerns are always subsidence. And in fact, those are the highest complications of an OLIF. So maybe people who do OLIFs are very, very good with it. But I have my own reservations about this whole thing of indirect decompression when you have a subsidence happening. You tend to lose a lot of this if you have not secured it from behind.
Okay.
So Vishal, just a quick comment. I mean, as Mihir rightly said, probably the idea is, you have to be choosy about patient. You cannot deal every cases with one technique. So osteoporosis, where you don't try to put too longer cage, because when you are trying to do an indirect decompression with a fear back of your mind that you are not jacking up enough, you tend to put larger and larger cages, and that temptation everybody has to avoid. And secondly, the osteoporosis. I think, I'm very skeptical about doing this OLIF and osteoporotic.
All your complications of OLIF will be in osteoporotic spines.
Exactly. I totally agree.
So I guess we should wind up because we are already 20 minutes over the time. But then in our defense, we started 5 minutes after our session was supposed to end. Thank you very much, the speakers and the panelists, for a very good discussion. Thank you. Over to the in charge.
Thank you, Vishal sir. Thank you, panelists. We'll be moving on to the next session.
Yeah, hi.
Good morning, Dr. Amrit sir.
Good morning.
Session will be a dedicated lecture session on lumbar canal stenosis, simple yet controversial. I would invite the panelists, Dr. Rakesh Lohana, Dr. Panikiran, Dr. Sandeep Sone. Over to you, sir.
Yeah, thank you very much, and a warm welcome to one and all. Welcome the panelists, Dr. Rakesh Lohana, Dr. Pani. Want of time, let's go on dive into the session. The topic is simple yet controversial. Now that's kind of summarizes the whole discussion. Over to you, Dr. Nikhil Arbatti.
Doctor, I'm putting up his talk.
Dr. Nikhil, you're there? Yeah. Hi.
Yeah, Amrit, I'm here. Hi. Hello, everyone. I'm Dr.
One of those, one of the bare essentials that one has to know to execute a good.
Is my talk on?
No, not yet. So as we are waiting for your talk,
Hello, everyone. I'm Dr. Nikhil Arbatti, and today's topic is going to be over-the-top decompression for simple lumbar canal stenosis. As you know, lumbar canal stenosis, the various compressive elements are ligamentum flavum hypertrophy, a central and lateral disc bulge, a fascicular arthropathy. Apart from that, instability due to coronal imbalance and striatal imbalance also causes stenosis. A surgical plan for a...
We are not seeing the video.
Yes.
1 second, sir.
I'm Dr. Nikhil Arbati, and today's topic is going to be over-the-top decompression for simple lumbar canal stenosis. As you know, lumbar canal stenosis, the various compressive elements are ligamentum flavum hypertrophy, a central and lateral disc bulge, a fascicular arthropathy. Apart from that, instability due to coronal imbalance and sagittal imbalance also causes stenosis. A surgical planning for a lumbar canal stenosis preferably involves decompression if there is no instability and only claudication symptoms. The decompression can be done of various types. It is an open laminectomy, microscopic decompression, endoscopic decompression, or tubular decompression. Today's talk is going to be upon tubular decompression with over the top, that is a unilateral approach with bilateral decompression. It is done where there is a bilateral equal compression. The benefit of this approach is that it minimizes soft tissue damage of the opposite side. You can achieve a very good decompression of both the traversing and exiting routes of both the sides. And in the higher lumbar levels, in fact, it's much easier because there is a very small interlaminar window or very less interpedicular distance. The requirements for the procedure are: in the armature, you require a tubular system, a rigid tubular system is better, require a burr system with bent handles and all sizes of cutting drill bits, table which can be tilted very easily on the opposite side, and a microscope with an adequate working length. This is the tubular system, Pitker system, which I use. Technique is I use a rigid tubular system, usually of an 18 or 19 mm diameter. I dock the tube on the side which has more compression or which is more dominant, the tube. Once I dock the tube, then I start doing the laminotomy on the ipsilateral side. After doing the laminotomy on the ipsilateral side, then I tilt the tube on the contralateral side and finish the laminotomy on the contralateral side. Once this laminotomy is done, then you can do the flavectomy and the decompression for technical video. So to demonstrate how it is done, this is how we dock the tube. After putting the dilators, then you pass the retractor of the axillary. And you can see how it is on the top on the ipsilateral side with a little bit of medial animation. So once we bring in the microscope and start the laminotomy. If you see the laminotomy, this is the left-hand corner is the cranial side. With the help of the burr from the medial part of the spinal laminar junction, I start using the burr to thin out the lamina. The burr should be used in a circular fashion. It should not be focused at one point so that it does not suddenly give way. With the continuous moving of the burr, you can thin out the lamina up to the desired level. Once the lamina is adequately thinned out, then the remaining part of the lamina can be taken out with the kerosene punch. Usually a 2 mm kerosene punch is more than sufficient. As you start finishing off the bony work on the ipsilateral side with the help of the kerosene punches, the upper end of what you want to go on the ipsilateral side is up to where the flavum is attached. Once you reach the upper end and you see the junction where the flavum is detached from the lamina and where you see the epidural vessel, that is your upper limit of the flavectomy. Once your middle side flavectomy is done, then you start going to the more lateral part and do the lateral part of the laminotomy. The lateral part of the laminotomy, you can progress up to the medial edge of the facet. Once you reach up to the medial edge of the facet on the ipsilateral side, that is where you start, that is where the laminotomy part is done. Usually a 2 mm or a 3 mm kerosene punches are more than sufficient. Once the laminotomy is done, then you put the dilator and you tilt the tube on the opposite side. Once the tube is tilted on the opposite side, you can ask the anesthetist to tilt the table more towards your side, and you can see how the tube is angulated on the opposite side. Then with the help of a long tip cautery, you can take out the soft tissue on the opposite side, and then again with the burr you start thinning out the lamina on the contralateral side. Start from the opposite side, just above ahead of the spinous process, and go more laterally. You can go up to the inferior articular process, up to the facet joint on the opposite side. And once the lamina is thinned out on the contralateral side, same process will repeat, and you, with the help of a 2 or 3 mm kerosene punch, take out the remaining part of the lamina, complete the laminotomy. The lamina on the opposite side, same, you can reach up to the medial end of the facet on the contralateral side, and you can detach the flavum from the contralateral side. The lamina being adequately burred out with the drill, it gives you very easy to take care of the kerosene punches. Now, once the flavum needs to be attached, I use a ball tip angle probe and pass it below the flavum and make a plane between the flavum and the dura. The benefit of this is that you don't inadvertently cause any dural damage and you don't cause a lot of epidural bleeding. Then once the plane is made between the flavum and the dura, you can just put in a 2 mm or a 3 mm kerosene punch and strip off the flavum. Usually, if you're doing it in a L4 or L5 similar, you can do the contralateral flavectomy and remove the flavum over the traversing route. And if you want to do the decompression of the exiting route, you can finish that. And then you can come to the ipsilateral side and finish the ipsilateral side. Because for the lower levels, after tilting the tube on the contralateral side, you may need to tilt the tube a little bit on the ipsilateral side to get a good decompression on this side. While in upper levels, you don't need to tilt the tube that much because of the small interlaminar window. So as you see, we are finishing off the decompression on the contralateral side. We are going more lateral where the traversing route is present and making sure that the traversing route is free. On the ipsilateral side also at the same time, you can finish off the phlebectomy by removing the adherences on the more lateral side. Then with the ball tip probe, you can just pass it over the route, traversing route, and see whether it is completely free or not. Similarly, you can pass the route over the contralateral side and make sure that it is free. If you feel that any adherence or any adhesions are still remaining, then with the 2 mm kerosene punch, you can finish it. The ipsilateral nerve root is free, traversing. You can just coagulate the vessels, arterial vessels, and make the nerve root free completely. And to finish off, if you feel any more tissues or any more phlegm needs to be removed, you can just put a patty over the dura, and with the help of a 2 mm 3 mm kerosene punch, you can just see it on the medial edge of the facet where it is. So this is how the root is free on the ipsilateral side. You get a good full bleed when the decompression is done, and similarly on the contralateral side. So that is how we finish the decompression. When the decompression is done, you can just give a good wash, put a gel foam, and just finish off the decompression part. Thank you.
Thank you for the presentation, Dr. Nikhil. Any tips on avoiding complications? Have you come across, do you have a problem of nipping the root on the opposite side, on the contralateral side, in the initial stages of your learning curve? Did you have any situation like that where?
No, I haven't had, luckily till now, any such complication. See, if you have a very good microscope and you are able to see, once you tilt the table and you're able to see the far lateral part of the contralateral side, chances of you getting any inadvertent nerve root injury are very minimal. Main thing what I do is, once you start removing the phlegm after doing the complete laminotomy on the opposite side, once you have taken out the phlegm with the help of the ball tip probe, and then you start taking out with the kerosene punches, I put in a patty over that nerve root on that side, and then slowly make a plane and then take off the remaining phlegm on the far lateral side. So with a good microscope and with this kind of technique, the chances of having any inadvertent nerve root injury is very less. Actually, I haven't had any of that. Okay. The only thing I sometimes fear is that sometimes I may not have done a very thorough bony decompression on the contralateral side. Okay. The soft tissue you can do it very well, but the bony sometimes you may feel that you may need to burr out more. So that is the only thing that you may fear. But otherwise, having a nerve root injury is not there. Okay.
Dr. Pani, in your experience, any difficulties that you face in the initial stages?
So this procedure, I do the same with Destando endoscope. It's exactly the same with the burr, and the only difficulty I find is when you have to do a superior laminotomy of the caudal lamina on the contralateral side. Probably Dr. Nikhil can enlighten on how he does it. When you have to do a foraminotomy on the opposite side, go down a little inferior.
Okay, so
that is where I find it.
Foraminotomy.
Sorry?
The question
contralateral.
When you want to do a contralateral extended foraminotomy, when you want to go a little more deeper than usually, there's a facet hypertrophy.
So you want to ask how to do it? I didn't get the question. Sorry.
It's quite difficult. I mean, this one as you go along the.
So let me rephrase that. Do you, at any point, have you felt like going after doing over the top decompression? Have you thought the contralateral side doing a direct
decompression?
Yeah.
You mean putting the tube on the opposite side if you feel that it's
on the contralateral side? Yeah.
No, I haven't. I mean, I feel that once you have seen the root and it properly. Ideally, I do decompression when there is a lumbar canal stenosis. If it's root and it's on the other side also, then ideally I would do both sides little decompression. Do on one side, do a little bit contralateral decompression, then go to the other side, pop the tube, and then do it. If it's a stenosis with a phlegm hypertrophy and facetal, then doing over the top is sufficient, because once you the lateral part of the root and you're able to do it, then you can.
Sir, actually, we are ready with the next talk. Next talk is loaded.
Okay, perfect. Thank you, Doctor. We'll move on to the next speaker, and that's Dr. Sumit. I request him to start in cases with severe facet hypertrophy, indications and tips. To be over to you.
Good afternoon, friends. I am Dr. Subir Javeri, spine surgeon from Ahmedabad, and I would like to share my thoughts on standalone decompression in patients with severe facetal hypertrophy. So, all those patients who present with significantly severe degenerative conditions tend to have facial hypertrophy, and they are the ones who we are going to be discussing today. All patients with excess bone growth, such as those presenting with dish, fluorosis, patients who undertake heavy manual labor, they all tend to have facial hypertrophy. And even patients with long-standing multi-level degenerations, they have significant facial hypertrophy, which leads to certain pathologies. So the commonest problem is the medial overgrowth of these facets, which tends to compromise the lateral and the foraminal zone of the spinal canal, leading to compression over the neural structures. The overgrowth of the superior articular process tends to be responsible for this neural compression in most of the cases. However, it is the inferior articular process which is responsible in patients of degenerative listhesis. There is usually an associated ligamentum flavum thickening, which causes further compromise in the neural space, and also patients having a constitutionally narrow canal. They already have a constricted narrow canal, and which leads to symptoms very early on. So these patients typically present with symptoms related to spinal canal stenosis, and usually there is a multi-level involvement. It is usually these patients have an inherently stable spine, and the instrumentation is commonly not required in these cases. However, one must be very careful to check the facet joint orientation, without which there can be some trouble. So if you take a look at this gentleman having a significant multi-level degeneration with symptoms of claudication and stenosis, you can see that he has got the last all four lumbar levels are significantly compromised. L1, 2, L2, 3, 3, 4, and 4, 5 are having a significantly narrow canal, and there is stenosis. If we tend to do an MIS at the upper two levels, then one would definitely take out the facet inadvertently, leading to instability. The lower two lumbar levels are still amenable to an MIS decompression with spatial care. Another patient, middle-aged 58-year-old, presenting with double level stenosis, almost similar kind of an axial, which you can see here at the last two levels. In these patients, undertaking an MIS would be quite challenging at the L4-5 level, especially with a heavy overgrowth, as it would be quite However, in my opinion, if you tend to consider these patients, I would probably prefer to take open surgery, where I would be able to do the spinous process and undertake a vasectomy at both the levels without any significant. This patient, on the other hand, presents with a single level compression at these L4-5 level, and she has canal with stenosis that can be very well managed with factor or decompression, ligamentum flavum removal, and she would be having a perfect outcome. This patient presented with degenerative scoliosis along with unilateral facial hypertrophy on the left side at the L5S level, leading to symptoms suggestive of the lateral canal release stenosis, which eventually would be taken care of with the tube very well. You can do a decompression and the lateral canal release along with foraminotomy, and the patient has an excellent outcome. This patient has got multi-level involvement, significant central stenosis at L4-5, requiring over-the-top decompression at lateral canal release at the L5S one on the left side, and a discectomy at the L1-2 level on the left side. So if you take a look at the cases that we went through, most of them had a narrow canal along with a hypertrophic facet, leading to a significant symptoms, and it can be they can all be very well managed with the MIS tubular system. High-speed burr is virtually indispensable in all these cases, and the undercutting of the spinous process and medial facet resection forms an integral part of all these patients' surgeries. You must ensure that the patient has an adequate lateral recess decompression, there is adequate foraminotomy and neural decompression, and make sure that you remove all the bony spurs. You must select your cases judicially, and remember that everything cannot be handled by MIS. You must have an open mind. Thank you.
Thank you, Dr. Subir, for your excellent talk. From your lecture, it is very obvious that most of the cases can be dealt with by pure decompression only, without any fusion requirement. But what would be your absolute? What would you really watch out for? You did mention about facet orientation. Other than facet orientation, what would be your absolute indication for not doing just decompression but also fusing?
You can look for osteophytes. If there are anterior osteophytes or even lateral osteophytes, that is an inherently stable spine. And if there's a stable spine, there is no need to unnecessarily go in and do fusions for a patient who is already having a stable spine. So many of them have already got ankylosing or this type of syndrome, where they just all they need is a decompression in relief of their radicular symptoms. So MIS decompressions are able to achieve that goal very well. Rarely, when just as I showed those couple of cases where one has to have an kind of an open mind, in the sense that you may require to do open surgery in cases. So don't think that everything needs MIS. At times you may have to use the open techniques and give the best outcome to the patient. What we had a good discussion yesterday was that doing the best for your patient means having optimal endpoints. So trying to do the whole thing by MIS and giving suboptimal endpoints is not the goal of surgery. So that is what I actually wanted to show in these cases, which are very, very narrow, and we have an extreme difficulty in managing. So earlier patients who are, whoever surgeons are embarking upon this technique in their early period, they should at least start with regular canals and then proceed on to narrow canal cases. That's my suggestion.
Right, absolutely. So we'll, for want of time, let's go to the next speaker.
Sure.
I call upon Dr. Salman Sharif, going to enlighten us on defining indications for fusion in LCS, traditional concepts and emerging trends. Over to you, sir.
Dear friends, good morning. My name is Salman Sharif. I'm the president of the World Spinal Column Society and co-chair of the WFNS Spine Committee. I'm grateful for giving the opportunity to speak to the audience, the amazing audience that you have of MISS AB Surgical Symposium. My topic for today is indications for fusion in lumbar spinal stenosis. Pathology, stenosis of canal and lateral recess associated with facet hypertrophy, ligaments hypertrophy, collapsed disc, and combination of all producing symptoms. Rationale to intervene, decompress, and improve function. And there's question is, do we need to restore the sagittal balance, address listhesis, or do you want beautiful pictures? So do you want to have decompression or fusion or not? So we did look at this 5 RCT included in this systemic review, in which there are studies from 90s, and there are 2 new studies, one from Gogawala and one from Frost from 2016, published in the same journal. These RCTs had a large number of patients, and the follow-up was significantly large too. And they looked at different outcomes as shown here. And these RCTs involving 438 patients showed that there was no significant difference between the 2 surgical procedures in terms of functional ODI scores at baseline and at 2 years follow-up respectively. So these 2 surgical procedures are fusion and decompression alone. There's low quality of evidence of meta-analysis because of the heterogeneity of the various studies over a large period of time. So that is over 2.5 decades. Factors not studied are risk factors selecting patients who may have failure following decompression alone. We've got facet angle more than 50 degrees associated with 40% rate of reoperation. Disc height more than 6.5 millimeter was associated with 45% rate of reoperation. And motion of spondylolisthesis of more than 1.25 centimeter were associated with nearly half reoperation. There are more than 3 risk factors. If you have all the risk factors, you're still looking at a 75% rate of reoperation. Patients with no risk factor for instability at a 0% rate of reoperation. So this is a brilliant study that showed all these, and it's important for us to understand these factors well. What about the facet joint orientation and tropism? Studies with very low quality evidence have suggested that increased sagittal orientation of facet is associated with stenosis. While sagittally oriented facets have been associated with stenosis, their role in the development of the disease and stability of the disease is very controversial. So if you look at this, you've got this stabilized signs with disc height loss, stable slip one on top of the other, and on top of it, lack of facet joint diffusion. So you could grade accordingly and decide is this significant or not. There is a linear correlation with degree of instability at the segment with facet joint diffusion. Several proposals are there, and there are several ways of calculating facet joint fluid diffusion. But the problem is it's very low to a very low quality of evidence. Presence of facet joint diffusion, best seen on spinal axial MRI images, appear to have linear correlation with instability. What about re-stabilization signs? There is no firm agreement on what parameters indicate a re-stabilization segment, but osteophyte formation, vertebral end plate sclerosis, and ligament ossification have been implicated with low quality evidence. So this type 3 unstable stenosis shows translation along with large facet diffusions and MRI and subtle re-stabilization time as well. Facet joint diffusion, very low to low quality evidence available for that. But this was a very good study which showed that type 1 stable, type 2 potentially unstable, and type 3 is unstable. And the suggestion was with stable, you decompress, potentially unstable, you decompress and fuse, and unstable, you decompress and fuse. Again, the quality of evidence is low here over here. And same fusion algorithm by Andrew Simmons in this study. Questions that need answering. Patients with stenosis, no signs, symptoms, instability, and predominant leg pain. Decompression alone is recommended, moderate to high evidence. Patients with stenosis and stable spondylolisthesis with re-stabilization seen. Fusion will not help. Decompression alone is suggested. Available literature, moderate. Do we have an answer? Yes. Unstable spondylolisthesis with symptoms. If you have these, they may require fusion. Again, the evidence, unfortunately, is low. Probably it will help. Chief complaints of mechanical lower back pain with listhesis. Available literature low. Fusion is controversial. Stable listhesis with deformity, loss of balance. If symptomatic, may need correction of underlying deformity with decompression and instrumentation. Again, fusion is controversial, evidence is low. Facet joint effusion, is it significant? Available literature, low to medium, fusion recommended, controversial. Lastly, facet joint effusion alone is not proven to correlate with instability. Fusion not recommended. So according to these, there is no difference if you fuse or not to fuse. So majority of the time, the decision is clinical instead of looking at x-rays. Thank you.
Thank you very much, Dr. Salman. From your talk, I beg to ask the question as to, in your personal private practice, which are the indications for you to fuse? Dr. Salman? Dr. Rakesh Luhana?
Yes.
In your
excellent talk, Professor Sarif and Dr. Subir Bhai. So, Subir Bhai, in your practice, what are the difficulties in the very narrow canal? What are the challenges in MWD?
I got a garbled message. You're trying to ask me regarding indications of fusion or decompression?
What are the what are the tips to negotiate the difficulties faced in your narrow canal decompression?
The biggest problem is when there is facetal overgrowth and there is virtually no space between the overgrown facet and the spinous process. So first, when you dock, you are sitting right on the facet. You have to trim down the facet, the overgrowth part, then at least reach the laminar portion, and from there, you can eventually go ahead and do a little bit of a foraminotomy. Then you can continue docking deeper. Basically you have to do an over-the-top decompression initially. Then you can probably seat your tubular retractor in a proper position. The narrow canal is very difficult initially, so you have to get used to doing it before you really take those narrow canals for decompression through the tube. So at times I feel that if it is too narrow, I'll just tell the patient that it is not possible. Let me do it and open it. That is what I have done at times. But then over time, obviously one gets that expertise and then you are able to do it. But it is very tricky. And
the next talk is ready. Can we?
The same side is again also difficult because there is hardly any space underneath your own facet, under the facet on your side. The opposite
Next
side
talk is ready
easier.
and loaded.
Thank you, Doctor. We'll go on to the next speaker, and that is I call upon Dr. Ali Guven for his talk on full endoscopic decompression of spinal stenosis. Over to you, sir.
Today I'm going to talk about the full endoscopic decompression of spinal stenosis, indications, and approach selection. Before starting my presentation, this is my disclosure. I'm working with the RivoSpine company as a clinical manager, and I'm responsible for the trainings and the education program of RivoSpine. As we know, the reasons of the symptoms in the degenerative spinal stenosis caused by the mechanical compression, vascular problems, or the inflammatory changes. Bony structures, discal pathologies, capsular or ligamentary hypertrophies can cause a spinal stenosis. Indications for the surgery: neurogenic claudicatio, radicular symptoms, which you can treat only with decompression, and also back pain due to instability, deformity that you cannot treat only with decompression. You have to add a fusion in these cases. Decompression can improve the neurogenic claudicatio and also the radicular symptoms, but at the same time, decompression can cause problems like scarring, tearing, instability, and the pain after the surgery. To avoid or to reduce these problems, people are looking for solutions. When we look at the current developments, we see that the full endoscopic techniques are the least invasive techniques to reduce the traumatization and also improving the vision and the light conditions during the operations. There are two types of stenosis, central stenosis and lateral stenosis, like recess stenosis or foraminal stenosis in the lateral sides of the spine. To decompress the central part of the spinal canal, there's no question we have to select the interlaminar approach. And to decompress the foramen, we choose extraforaminal transforaminal approach, and also to decompress the recess. Some surgeons prefer to do the transforaminal approach, but in my opinion, you cannot achieve a sufficient decompression with a transforaminal approach in the recess. That's why we prefer interlaminar approach to the recess decompression. A reason for this, to reach the middle portion of the facet joint or to resect the middle portion of the facet joint, you have to approach as lateral as possible. In this case, you will have some difficulties like resecting the osteophytes anteriorly will be problem for you, and also you cannot resect all the pathologic flavum which compress the nerve structures posteriorly, and it's impossible to resect all the bony structures, compress the nerve structures like the cranial part of the caudal lamina. We're at the left side of the patient right now, which means that the 3 o'clock is the caudal pedicle, and here in the 12 o'clock is the facet joint, and the 6 o'clock is the disc space. Usually the protected burrs and the deflectable burrs are very useful tools to do the bone resection with the transforaminal approach. As you see here, we do every kind of resection under our visual control. Once you did the decompression with the bone, then you can resect the flavum laterally to the nerve structures, and also you can remove all the disc herniations or the pathologies anteriorly, just located anterior to the nerve root like this. But still, this approach is limited approach to resect, to do the decompression posteriorly to the neural structures. That's why in our daily practice, we prefer to do interlaminar approach to decompress the recess. And then here you see, now we are at the right side of the patient after regular entry to the level with the interlaminar technique. Then we clean all the soft tissues around the facet joint. First of all, we would like to see the tip of the descending facet, and as you see here, we found the tip of the descending facet, and at the same time you see the ascending facet, and we detach the superficial layers of the flavum ligament from the descending facet first. After detaching the flavum ligament from the facet joint, then we start resecting of the middle portion of the descending facet. Our target in the cranial side, as you see in the right side, the apex of the ascending facet. This will be enough for the decompression of the recess. And again, we use the protected burr to resect the medial portion of the descending facet first, and after that, finding the apex of the ascending facet, we can continue resecting the medial portion of the ascending facet. Once you reach the apex, then you can turn to the caudal side. Before to do that, it's better to clean the soft tissues or the superficial tissues to see the bony borders clearly. Then we start resecting the medial portion of the ascending facet under our visual control. Also in the caudal side, our target to reach is the middle of the lower pedicle. This is the reason, that part actually, the reason why we choose the interlaminar approach, because with the transforaminal approach, it's not easy to reach or impossible to reach that part. To reach that part with the transform, then maybe you need to do the total facetectomy. Then we cannot talk about the minimally invasive surgery in this case. Then also with the recess stenosis, most of the times the flavum ligament is a part of the pathology. That's why it's very easy to resect as much as possible flavum with the interlaminar approach. Still, with the transform, it will be really more difficult. Okay, and then also with the central stenosis, you can use the bigger systems. These are available on the markets from different companies, but the steps will be the same. First of all, finding the descending facet and resecting the medial portion of the descending facet, reach the apex of the ascending facet, then resect the medial portion of the ascending facet. Once you finish the decompression in your side, then over the top you can go to the contralateral side. As you see here, there are some eccentric burrs are available on the market that you can resect between the bone and the neural structure safely. And as I said, once you finished with your side over the top of the dura, you can continue to do contralateral side. Usually the resecting the contralateral side is much easier than your ipsilateral side. Then you can decompress the contralateral side like this. Even this is a central stenosis or bilateral recess stenosis. The steps are the same. The only different, maybe nowadays, we prefer to do less resection on the recess, both sides with the central decompression. Usually decompressing only the central part is enough. You don't need to aggressively to go to the recess in these kind of cases. And thank you for your attention.
Great. Thank you very much, Dr. Ali. I have one question. If you had a, Dr. Ali, you're there?
Yeah, I'm here.
Yeah, hi. So in calcified ligamentum flavum, do you, or with regard to adhesions, which could be there in revision cases, do you come across certain challenges? Do you change your plan? Do you go tubular instead of?
You mean the revision cases after open surgery or just the calcified flavum, you mean?
Calcified flavum. First
Yeah,
question.
yeah, the calcified flavum is not a problem for us because you can use your Carson Ronger. They are sharp enough to cut them. And also, always this question is coming to us, what you do with the adhesions. Usually with the endoscope, we try to do the bony resection first. And then we keep the flavum intact until we finish the bony work in our ipsilateral side. Then we prefer to open the flavum ligament from the midline. And then always in the midline, you have more spaces between the dura and the flavum ligament. And usually with the irrigation system, under the irrigation system of the full endoscopic techniques, the adhesions are not problem. Once you open a hole on the flavum, then immediately the irrigations goes between the flavum and the dura. Then you have, every time you have enough space to resect the flavum safely.
So usually in tubular endoscopes, when you decompress, you can use the cotton patties and keep the dura away. You don't find the need for anything of that sort because of the sleeve.
No, no, I don't. I don't need.
Protects the dura, right?
Yeah, the useful instruments with the full endoscopic technique is the scissors types. Usually the cutting part of the scissors are back of the front part, and then every time the front is pushing a little bit the structures away to you, and then the cutting part is coming back, and this is very safe. Usually I use the Carson Ronger in my side, in the ipsilateral side, but I'm really careful using the Carson Ronger in the contralateral side, that you can take the dura there with the Carson. That's why every time I try to dissect the flavum from the bone, and then with the scissors, I cut the flavum on the contralateral recess.
All right. Thank you very much, Dr. Ali. Thank you very much. For want of time, I think we'll have to go to the closing remarks. Dr. Sandeep Sonone, are you there? For the closing remark. Anyway, any comments, Dr. Rakesh, on your final comments, Dr. Rakesh?
Not listen to the voice, but excellent video presentation, Dr. Govind. Endoscopy is a long learning curve. It's an attractive technique. Thank you.
Thank you very much. I think we'll close this session. Thank you.
Thank you. Thank you all panelists and moderator. Thank you very much.
Thank you.
Thank you, moderators. Thank you all panelists. Exciting discussion on lumbar canal stenosis. We'll be moving on to the next session.
Thank you.
Very good afternoon, Dr. Satyan Mehta.
Good afternoon.
This session is a case discussion session with, exclusively with involving expert panels and young Turks. This is basically degenerative spondylosis, fusion versus non-fusion.
So I'll start my screen sharing. You'll have to stop that. Yes. Dr. Shetty, you're here.
Yeah, I'm there. Thank you. Good afternoon.
Good afternoon, sir. So you and Dr. Badu are the only seniors here now.
That's fine.
Okay.
No, there are a lot of other people there.
Yeah. I'm not going to ask you any questions. All to the young Turks.
Yeah, sure.
Can you see my screen?
Not yet.
Sir, we are not able to see your screen still.
Yep. How about now?
Yes.
Okay. So we are not going to discuss cases like these. This 65-year-old female who came with back pain and lower limb radiculopathy, unresponsive to conservative treatment. Now, so this is quite a straightforward case of instability where most people would go ahead and fuse these patients. We are going to discuss cases like this one. I want to go straight to Dr. Yadu. Dr. Yadu, you're here.
Yes, sir.
This patient is a 66-year-old female. I keep getting only female patients who are in their 60s. She has got back pain with a lot of low limb radiculopathy. She's not getting relief with analgesics. These are her views. This is her actual view. What do you feel now? What do you think you want to do with this patient?
Sir, she has complaints only on limb, if I'm right.
She's got some back pain, but predominantly it is lower limb radicular pain, right more than left.
Okay. MRI at L4-5 with some decent change with flaccid fluid sign, but at L5 there is a small facet cyst on the right side.
Over here.
Okay. Any X-rays, dynamic flexion?
Okay, great. So you always want to get an X-ray done for these patients. What are you looking for on the X-ray?
First and foremost thing, signs of degenerative diseases, any reduced disc height, vacuum phenomenon, instability, osteophytes, mainly to see for any dynamic instability and vacuum sign.
Okay, great. Are you seeing anything here?
No, only L4-5 I feel, but it's okay, sir. No evidence of any instability or something. What?
Great. So what would you want to do in this patient?
So this patient mainly has back pain with radiculopathy on the left side. Right more than left.
Yeah. What you want to see the axial again?
Any foraminal cuts, if there's any because mild flame hypertrophy is there, canal okay, and even the lateral disease except at the L4-5.
So you don't want to operate on this patient?
No, sir. We'll give a trial of conservative management for her.
Conservative treatment is done, but you would still think about maybe non-operative?
Yeah, sir. Because X-ray, there's no, only at 4-5 have a doubt, but whatever it's been, there's no dynamic instability on the X-ray, films.
Dr. Sandeep, Dr. Kesarwani, you're here?
Yes, sir. I'm here, sir.
Yeah. Anything different that you're thinking about in this patient?
Sir, if all the conservative methods have failed, I'll go for blocks. I'm not very convinced about operating this patient still.
Okay. Why do you think she has pain?
There is, as per this radiology, there is in X-ray, dynamic X-ray, there is grade 1 listhesis at L4-5, and there is very little bit of stenosis in the lateral recess at L4-5, mainly on the right side.
Okay.
So, if her neurology is normal and only the pain is there, then
Can you
I'll
see
try.
this here?
Yeah, I'm seeing that, sir.
What do you think that is?
It looks like a flavum cyst rather than facetal cyst to me. So probably this might be one of the reason for her pain. So I'll try first with the root block. If root block is satisfactory, it gives good relief.
It's not, yeah.
And if it's not giving, let's say if she has temporary relief in the pain for a few days or weeks, then probably if the patient, after discussing with the patient, I might go for the surgery.
What surgery?
This patient can be very well managed with transforaminal decompression or with tubular decompression, lateral recess decompression.
Okay, so are you worried about any instability occurring to this patient post-operatively later on if you just do a decompression now?
So transforaminal decompression is less likely to produce any further instability in this patient because he is degenerative grade 1 only. Yes, I am going to explain to the patient regarding future. If she is going to develop further instability, she might require another surgery. But just grade 1 instability with facetal cyst with very minimal stenosis where not a lot of bone work is going to be done, I think this only decompression is sufficient for her.
Okay. So is Dr. Raju Surangi around?
Hello.
Yeah, hi, Raju.
Hello, sir. Hello.
Anything different from what Sandeep or Yadu have said?
No, sir. The blocks can be tried in this case, according to me at least.
Okay.
Because
And if it doesn't work, surgical. We're talking surgery.
Surgery, then decompression can be tried, sir.
Plain decompression. What type of decompression would you want?
Over the top.
Over the top decompression. Going in from the left side and then decompressing more on the right. Okay.
But 2 or 3. Sorry. Okay, sir.
Yeah. Ajoy sir, your comment.
This is the first thing we need to confirm exactly what is causing the patient's symptom. If like a cyst is present in the foramen at L4-5, if that is the one which is symptomatic, then the symptom will be more of a L4 rather than a L5, number one. Number two, you need to have other different cuts to be sure that there is a cyst. Just based on a one axial cut, it's very difficult to define. If there is a cyst, a CT guided of that cyst would be an easy option, which a good interventional radiologist will be able to perform that. It's definitely not a facetal cyst. It doesn't seem to be in continuity with the facet. Therefore, you just have to be sure that her problem is coming, the radiculopathy on the right side is coming basically from the particular area, either the cyst or from the facetal hypertrophy, which you can see at L4-5 on the right side, which is probably causing a lateral recess stenosis. Therefore, if you are able to diagnose if it's from the cyst, a cyst will give you a relief. If not, if there is no relief with the block, then as mentioned, you may have to think of decompression of the lateral recess.
Sir, I have been listening since morning and they're talking about all the facet hypertrophy, which will cause further progression in the future. And, if there is facet effusion, which will cause progression in the future. And these patients, they will not come to me, they will badmouth me and they will go to somebody else and get operated there for a fusion. Shouldn't I think about doing a primary fusion now only, sir?
No, Satyan, that's the important point. But we have to understand when you're doing a primary fusion, there is evidence to suggest that at least about 15 to 20% of them, which is a progression.
Can you repeat that, sir?
The above side. Therefore, there is nothing like a prophylactic surgery. It's not a one time. You fuse it, it's over. Therefore, I would feel if I am the patient, I would prefer to have a decompression rather than a fusion in this scenario. If you look at the orientation of the facet, the facetal effusion is only on one side. It is not a significant 0.5 or more. It's only on the one side. I would prefer to have a decompression alone. Depending on the technique where Sandeep said, you are capable of doing endoscopic, it's always good. If not, a tubular or even a open, preserving the midline should be adequate.
Great, great. So the points that you would take care, you've already mentioned. Anything about counseling in this patient, sir? Important points.
The first thing before I venture in, always nowadays in elderly patients, you evaluate the osteoporosis, treat it well. I mean, I find surprisingly, even though they have a neurogenic component, your appropriate treatment of osteoporosis sometimes relieves their symptoms. In the sense, there will be microfractures which you may not appreciate, or some weakening of the bone which will worsen the symptoms. Therefore, that's also appropriate to be looked at. You have to counsel that your aim is basically to improve the radiculopathy, which is on the right side. The patient can have persistent pain, which could be improved with appropriate treatment. If you look at the musculature, there is extremely significant white signal on the paraspinal musculature, indicating that the tone of the musculature is less. Good exercise. All those things are necessary.
Great, great. So there's multiple points that you need to take care. You need to counsel these patients. Very well said, sir. Also, very important points which you said, that we need to preserve the musculature, preserve the facet joints when we are doing this surgery, so that you don't cause any iatrogenic instability. Before I go ahead, Dr. Abhay Kumar, if you're around, Abhay sir, anything that if you want to add over here?
Satyan, thanks for asking. I entirely agree with Dr. Ajay who said.
Everybody agrees with him, sir. Tell me something different.
Yeah, so something different is, if the patient doesn't get benefit here with an injection or conservative treatment, I would just do a unilateral right-sided with a tubular decompression, microscopic decompression of the foramen and the lateral recess, and excise the cyst, whatever is seen. Yeah, so only this unilateral, not at all think of fusion at all in this patient. And I counsel the patient as well, telling that I am just going to do a decompression. Your problem is only on the right side. You have a right-sided radiculopathy, and decompression of the node should be fine. So taking already, Dr. Raja has mentioned about all the muscles are already weak. Doing an open procedure again in this, you're causing more damage to those muscles. Unilateral right-sided tubular decompression of the L4 and L5 nerve root on that side would suffice in this patient, if the patient needs surgery, and if the patient has not benefited with conservative and the injections.
For the interest of time, I'll go ahead. So this was a good discussion on this patient, where we are talking about plain decompression, micro decompression. And again, in this patient, we'll go to the next case. Now, this patient actually was referred to me at a later stage. I'll get Dr. Akash in now. This patient was 66-year-old guy who he actually went to a general orthopedic surgeon who occasionally does spine surgeries with the bilateral lower limb claudication. These are his pictures. Dr. Akash, are you around? And can you tell me what you're seeing here?
Yes, I am there. Sir, hello.
Yeah, go ahead, please.
Yes, so there is a decreased disc height at L5S1 as well as L4-L5, but more in L5S1. There is a foraminal stenosis at an L4-L5. The disc is also causing a foraminal stenosis. So the bilateral radicular pain can be explained by that. And I'll need to see some axial cuts as well to see.
Yep, there you are.
Yes, on L3, L4. So the myelogram shows a compression at around, I think, L4, L5.
Yeah.
And slightly at L5S1. In the axial cuts L3, L4, there is a facetal edema on the left side as well as a foraminal stenosis just above it. Yeah. Similarly, in L4, L5, there is bilateral facetal edema with facetal hypertrophy causing foraminal stenosis. L2, L3 looks.
So what do you want to do in this patient and why?
So I'd like to get radiographs of flexion extension first.
Okay.
And
so unfortunately, that was not done for this patient.
Yes, sir.
Okay. Based on the information that you have,
yes,
what are you thinking about now?
So
this patient clinically has got L5 radicular symptoms,
yes,
and it corresponds to the L4-5 stenosis which you are seeing here.
Yes, sir.
Okay.
So bilateral, sir.
Yes.
Yes.
Considering the facet orientation now, what is your thinking? Would you like to just do a plain decompression, or would you want to fuse this patient?
So I would attempt towards fusion in this case, sir.
Attempt a fusion at
yes,
4-5 level?
So primary fusion is instead of decompressing and letting it.
Okay. Dr. Sandeep, anything different, or you would do a plain decompression here?
Sir, if the adequate conservative management has been done, because the patient's neurology is normal, this patient has severe stenosis with facetal hypertrophy and facetal fluid. If adequate this conservative management has failed and patient is still having it, then I'll go for fusion in this patient. No decompression only.
Of 4-5 level.
4-5 fusion.
Okay. Why do you want to fuse this patient, and why did you not want to fuse the previous patient? What is different here?
So in this patient, there is severe stenosis. There is hardly any space in the canal due to this severe stenosis. The facets are very hypertrophied. So only decompression, if I am going to do, I am supposed to resect lot of bones for adequate decompression, and there is high chance of producing instability in this patient. So in my hand, if I am supposed to do this surgery, I'll do fusion. That will be more justice to the patient from my side.
Okay. Dr. Kanwar, sir, are you around?
I am. Thank you.
Yeah. Thank you, sir. Can you tell me if you agree with the young Turks, anything that you want to add here?
No, unfortunately, I don't. I mean, this is an elderly guy. His main problem seems to be more neurogenic claudication and leg symptoms. He's got no slip. The disc height at 4-5 is not too bad. He's certainly got significant facetal changes, but his main problem is canal stenosis, and I would treat his canal stenosis. I would not fuse him. He's got significant changes at 5-1 already. So if you're going to fuse 4-5, at some point you may be obliged to fuse 5-1. So I would do a minimally invasive tubular decompression. You'll be able to get good access to both sides.
4-5.
You can undercut his facet joints quite well. At this stage, I'll caution the patient that he may end up needing a fusion in the future, but as a primary operation, I do a decompression only.
Great. Dr. Ajay Shetty, sir, I'm very confused. On one hand, the hall in charge wants me to complete this session. On the other hand, we know what we want to do.
But I agree. Basically, you have to understand as your hair grows clearing. I mean, hair start becoming whiter. You realize that it's better to have follow-up rather than having a major problem.
Okay.
Although we are presuming that it cause painful, much less the problem you have with a patient who they come back with a case. In this particular case, the sagittal facet is basically at L3-4, but at the L4-5, more of a central stenosis, you can get away with a sparing decompression with whatever technique you are capable of.
In interest of time, I'll just go ahead and say this patient actually was operated by somebody else and a 4-5 fusion was performed. Now this patient, hall in charge, can you mute yourself, please? So this patient then came with severe back pain, severe lower limb radicular pain. And hall in charge, can you please mute yourself? And this were his post-op MRI pictures. Dr. Abhay, what are you thinking of now? What has happened? Dr. Abhay, are you around?
Can you hear me, Satyan?
Yes.
Yeah. So basically, I'll go back to the history again. After the fusion, whether his symptoms had got better, and
He
then
got better only for a couple of weeks.
Only for a couple of weeks. Okay, that's
Yeah,
something
and then
interesting. Yeah. So basically, what the new scan shows is that the problem has there's a new set of problem has happened at the upper level. So in the previous, I have not seen the axial here. In the previous scans, which had shown me pre-operative scans, there was no much canal stenosis and there was no disc bulge at L3-4 level.
No, it wasn't bad.
Yeah, it wasn't so bad. But this scan, which is done, how much is the time duration between these scans?
Only a month.
Only a month. Okay. So obviously there has been a problem with the upper level as well. So now, again, if he has has a back pain and a claudication as well, is it?
Yeah, he's got mainly claudication, and he was actually just diagnosed as diabetic radiculopathy and shooed off from the OPD. So then he came to us and we saw this.
Yeah, it looks like there was a good adequate decompression has been done at L4-5. That's what I could see, the given images, and the rest things are okay. There is a problem at the upper level now. So the L3-4 level is a culprit, and again there has been a disc bulge, plus there is a foraminal stenosis at both the sides. So if the problem is just the claudication pain now, I would just, in case if he needs treatment, if there's not got benefit, again a conservative treatment, I would just quite bad. So I would just try for a decompression here again and try the best. In even the initial, as I didn't mention, even the initial scan also, I would have planning to do just a decompression rather than the fusion.
Just decompression.
Yes. So now there's a problem at the upper level. I would, because he's an elderly gentleman, I would, and since he just has a claudication, I would just do a decompression again.
I'll show you the X-rays also. This is the X-ray.
Yes, X-ray. So there is some instability at that level as well, L3-4 level. Now it's a little bit
I'll get Dr. Kanwar in. Dr. Kanwar, what do you think?
Yeah, unfortunately, this is one of the things that we're worried about. Firstly, when they did 4-5, I don't see any interbody device, and it's now a flat 4-5 disc, which is increasing the instability at 3-4. So I would have, like the previous speaker, preferred to have done purely a decompression at 3-4, but considering the previous coronal orientation at 3-4 and now the instability, it's a question of extending now the decompression and fusion to 3-4 and adding it to 4-5, and whether you need to improve anything at 4-5 to stop progressive adjacent level problems. So, now, what I think may have been a fairly simple problem is becoming more complex, where you may have to undo the screws and rods at 4-5, maybe put in an interbody device from the side and do 3-4 to improve the lordosis, correct the slip, and then fuse from 3 to 5.
So we are going to now complete this session. Dr. Kanwar, as you're going, can you tell us why this has happened and what are the points to prevent this kind of scenario?
I think it's because the lordosis at 4-5 wasn't corrected initially. So you've got a flat 4-5, you've got increased stress load on joints that are already coronal. I think that would have less likely occurred if in the first place it was purely a decompression rather than a decompression fusion. If you're going to do a fusion, then you need to pay attention to the lumbar lordosis when you're doing the 4-5. And I think if that was corrected initially, you may have avoided the stress load at the adjacent level at 3-4.
Right. So I'll just conclude in the interest of time. A few mistakes which were done here was that they did not get dynamic X-rays before planning out the surgery. Also, this was an open procedure where they have damaged the facet joint probably, which is why this has gone on to getting an iatrogenic instability. You've got to make sure that you preserve your facet joint and capsule during dissection instrumentation as well. especially in even in your MIS procedures. So for grade 1 listhesis, we can do either fusions or you can just decompress them alone. It is said in literature that you get better long-term pain relief if you are fusing these patients with a lower chance of reoperation. But however, you have a higher surgical morbidity, which would be lesser in decompression alone. The rates of reoperation have been said to be almost 30% if you do only decompressions. But you've got to, temper these with individual patient basis. You can't just apply a blanket, procedure for all of these. Every patient has to be independently evaluated. So thank you very much. I thank all the young Turks, Dr. Yadu, Dr. Sandeep, Dr. Raju, Dr. Akash for being on in this session. And I thank our seniors, Dr. Joy Shetty, Dr. Abhay Kumar, and Dr. Badu for helping us, Dr. Kaur for helping us during this session. Thank you, sir. Over to you, all in charge.
Thank you, Sachin, sir. Thank you, my senior teachers and young Turks. We had an exciting session and discussion on degenerative spondylolisthesis. We'll be moving on to the next session. That is again a case presentation. I would like to invite Dr. Ranjit Unnikrishnan, sir, and the expert panel, Dr. Rajkumar Deshpande, Dr. Yu Lang, Dr. Kurno, Dr. Amit Jala, Dr. Arun Bodh.
Thank you very much, Yadu. Can you see me? Can I share the screen?
Yes, sir. We can see. You can.
Okay. Good evening. So good afternoon, and very sorry that we'll have to rush through the sessions because we are extremely late as per the schedule. So I invite all the expert panel, Dr. Deshpande, Dr. Zala, Dr. Arun Banot, Professor Liang, and Professor Kotani. And along with us, we have the young smart Turks, Dr. Sambhav Shah from Mumbai, Dr. Akash from Mumbai, Dr. Srinivas Prabhu from Fortis Mumbai, and again, Dr. Vel Murugan from SRF Chennai. We'll straight away go to the case. This is a 78-year-old male who came with back and leg pain for a lot of years and was recently disabled by his significant leg pain and weakness of dorsiflexus of the left side with difficulty in walking and significant rest pain. These were his x-rays, which is shows what we would expect at 78, osteoporotic bones with lateral listhesis, degenerative scoliosis with lumbar kyphosis. He had his fair share of non-surgical treatment with medication, physical therapy, and injections, massages, and he had all those burn therapies and all that, but still had persistent pain. And with this, he came, and this was his MRI, sagittal and significant, the relevant parasagittal cuts, which shows central as well as foraminal stenosis. And this was a supine AP MRI, which clearly shows the lateral listhesis. And the L4-5 parasagittal image, which shows the tight foraminal stenosis. And again, relevant axial images at L23, L34, and L45 levels. With this, I would ask our expert panel. Let me have Professor Liang. Do we have Professor Liang? Do we have Professor Liang? Can we have Dr. Kotani? Professor Kotani, what would be your solution for this for this problem?
Yeah, thank you. It's in this case, patient main complaint is leg pain. So it's better to do the decompression only, but L3-4 is so degenerated, and without he doesn't have low back pain, but deformity is so severe, and trunk shift is so severe, and I think it's hard to do that. And the cause of the symptom is a lateral slip of 4-5, L4, causing a central stenosis at L4-5 level, causing a bilateral L5 radiculopathy with the weakness. So I think it's hard to do the limited diffusion or decompression. So I recommend the patient to the patient long fusion from T10 to S2 with multiple ORI from the right side, including ORI 5.1 and percutaneous second stage fixation.
So, Professor Kotani, you would advise a minimally invasive surgery only with percutaneous posterior fixation, right? You will not go for a direct canal decompression.
I don't do the I don't do the direct decompression.
Excellent.
No
That's
need.
a very good point. With this, let me ask Dr. Sambhav Shah. Can we have Dr. Sambhav Shah? Dr. Sambhav? Okay, he's not there. Can I have Dr. Srinivas Prabhu? Dr. Srinivas Prabhu, could you unmute yourself and put on your video, please? So, as a young Turk, what do you agree with what Professor Kotani has said? What is your solution to this problem?
Sir, based on this particular X-ray and his primary complaint, which is not back pain, the deformity we can clearly see, and he's primarily complaining of leg pain and dorsiflexor weakness. That is what I got from the history. So, at this age, I don't think we are primarily trying to correct the deformity. We are trying to correct the lateral slip.
Yeah. So how do you plan to correct the lateral slip? As you rightly said, L45, Professor Kotani also mentioned that L45 lateral recess is causing the problem. So you have to correct it there. So how do you plan to correct it without correcting the deformity?
Sir, frankly, I do not have much experience with OLIF. So if this was my case, I would go for a long fusion from the posterior side, but I would do a direct canal decompression along with that.
Okay. Another point of view, Professor Banot, in this situation, would you like to do any minimal invasive focal decompression for this patient for his leg pain?
Does he have pain only in the left side, or it is bilateral leg pain?
He has got bilateral leg pain, weakness on the left side.
So yes, the clinical picture is very inviting and one cannot think of doing anything less than long segment fixation for such a grotesque deformity. But in my practice, I always ask the patient that what is it that has brought you to the clinic? See, the deformity has not happened overnight. He's been living with this for several years before he comes to you.
True.
So if I ask this question that, is it okay if I bring you back to 2 months before which you were, and would you be comfortable? If the patient says, yes, I'll be comfortable with that stage if you can bring me to that level. So we can think of choosing a minimally invasive intervention. But for that, I'll first try to do a block and see my assessment of the level is correct or not, because he has multiple level issues. So the most likely level
you are thinking in terms of treating focally, not treating the entire deformity like Professor Kotani suggested.
Yes, I would definitely be inclined, but taking the patient and the attendants into confidence that this may not work fully, and if they're okay, I will attempt it. Otherwise, if they say no, give us one solution, then with the higher risk at that age, we will definitely go in for it.
Yes, thank you very much. Yeah, Professor Barod, got the point. Do I have Vail Murugan, the young Turk from SRMC Chennai? Do we have Vail Murugan? Dr. Vail? Okay, Dr. Vail is not to be seen. So we think that we can go ahead. Dr. Prabhu was saying that he will do a direct canal decompression. Professor Kotani will do a long segment fixation with indirect decompression. And do we have Professor Zala, Dr. Amit Zala? Our
Hall,
yeah, he's in Hall A. Okay, no problem. Okay, Yadu, you are another young Turk. Yadu, what is your Dr. Yadu? What is your solution for this problem, Dr. Yadu? Dr. Yadu? Okay, I guess. Dr. Yadu, are you there? Fine. So let me ask Dr. Banot. Dr. Banot, since you advised that you'll be suggesting a focal decompression alone in this patient, what are the, you would use the endoscope or the tube with the microscope?
I would be able to do the full endoscopic technique if it is a 1 level or maximum at 2 levels.
Okay, so you would use endoscope.
That's
right. So you are not concerned about the So the lateral listhesis is very much because of the rotary deformity at that level.
Absolutely.
So which essentially when you go and decompress, you'll have to knock off a lot of facet in this situation.
So that is where the role of endoscopy versus microscopy comes. If we think like a microscope, you have to decompress a lot of facet first to reach the lower level, which is the pathologic level. But with your full endoscope, you can actually go under the facet and just drill that part which is compressing.
Thank you very much. Yeah, Professor Kotani. Professor Kotani, in your decision-making algorithm, where I want to go and do a direct canal decompression in a similar situation?
I couldn't hear. I couldn't
My
hear.
question was, in your decision-making in these cases, when would you decide to go and do a direct canal decompression other than doing an indirect decompression?
Okay. When we do the direct decompression, situation is calcification of a ligamental flavum exists.
Okay.
And the indirect decompression by ORIF or XRIF is impossible. I go to the posterior side and doing a TRIF.
Okay. Okay. So those
And,
are. So
when
you have calcified flavum, you will go in for a direct canal decompression, right?
Yeah, direct, yes.
Thank you. Dr. Akshay, another young Turk from Dr. Akshay, are you there? Could you unmute yourself? Okay, again.
So Dr. Akash.
Okay, Dr. Akash. Sorry, Akash. Sorry for misspelling.
Yes.
So Akash, what is your solution for this?
So I would like to agree with Professor Kotani.
Okay.
We have been doing at our institute multi-level OLIFs, and we have had some good results.
Okay.
Not
So
that this bad a deformity, but
when you do them, do you stage them? Like, do you do the front, make them walk, see if they get better, then do the back? How do you do? Or you do one go everything?
The stage surgeries mostly, because it's a long surgery. It's better for the patient, better for the surgeon, better for everyone actually. But before that, I would like to add that I would like to give an osteoporotic treatment to the patient before I commit him to any surgery.
With a 78 years old weakness, significant weakness present, you would want to wait to treat the osteoporosis or go ahead?
So I think even if I implant it with such bone, it will come out in a few months. Okay. So the weakness is most probably not going to improve. I can improve his pain and his posture.
Okay, Dr. Banot, what is your...
So you added one more favorable point for considering a minimally invasive intervention here, that the patient is coming with severe worsening of pain and weakness. And if the patient is osteoporotic, you can do your minimally invasive decompression first to relieve the patient's symptoms and still plan him for a deformity correction at a later stage after building up the bone quality. So that is again one more role of the minimally invasive decompression in such situations.
That's a good point. So you would like to stage the minimally invasive surgery.
You can.
With respect to a decision.
That's and the patient can choose whether he is comfortable with the previous quality of life or he still wants to get better than he was.
Thank you very much, Dr. Banot. So with the want of time, let us go to another similar case, and then let us take what the evidence is from the expert panel. So these are the things which we read out. Do we need root decompression alone? Do we need canal clearance? Do we need deformity correction? Do we need a fusion? Or should we think about PJK at 78 years of age? It's another question. So another patient, she was a 56-year-old lady who had a prior lumbar laminectomy done 34 years ago. 34 years ago, she came with significant back and leg pain. She had both her knees replaced around 6 years ago. Now she got significant back and leg pain, had taken multiple root blocks, epidural injections, etc. Back pain VAS was almost 7 out of 10. Leg pain VAS was again 8 out of 10. She wanted some kind of relief for her pain that she could go at. She's only 56, 57 when she came. These were all her disabilities. Was getting kind of chair bound because of the back pain, not the leg pain, chair bound because of the back pain. And these were her MRI then. You could see post-operative changes at L4-5 and central and foraminal stenosis at these levels with full facets. L3-4 and L45, seeing post-operative changes. So at this level, let me ask Dr. Akash. Dr. Akash, what would you want to do in this patient? You want to go for a long segment fusion, short segment fusion? You want to go for a decompression alone? What will be your take on this? Dr. Akash? Okay, I think he's stuck. Dr. Srinivas.
Oh, sure. Can you hear my voice now?
Do you hear Dr. Srinivas?
No, Dr. Sambhav Shah here.
Oh yeah, Sambhav, you're good. You're back. Okay, Sambhav, what is? Could you see the
Tell
case?
me whether she has more of leg pain or back pain.
She has back and leg pain. Both are equally severe.
In the situation, I would definitely first, speak to the patient regarding what are we expecting. Even though I would not promise the patient anything regarding the back pain anyways, so I would definitely first start to explain the patient regarding her leg pain, where I would try and be as minimal as possible, just treat those
So
two
she's
levels.
very clear. She wants her back and leg pain both to go because she is disabled. She says that my rest pain is more because of the back, and my claudican pain is because of the leg. So whatever you do, she wants to get rid of both.
Even if we are trying to consider the back pain and we go for a long fusion, although still we can't promise her that her back pain is going to go anyways. Yes, it might improve, but she's not going to be expected to have zero back pain, considering a lot of factors, including osteoporosis.
So what would you advise her? What is your solution?
So, I would first try and vend the patient more towards try and make her understand whether if it's a leg pain, treat the osteoporosis if it's not treated before. If it's leg pain, I just see even the full facets or mild lateral.
She's 56, not really osteoporotic as such.
Do we have a so see, in that case, if she is looking for a back pain to get relieved along with leg pain, then yes, then my first option to her would be I would explain her regarding OLIF as well, L34, L45. See how it works, make her stand, see if she has any leg pain any further, and then go from the back and treat her with percutaneous fixation.
Okay, so you will advise a short segment fusion. Professor
Short
Kotani.
Yes.
Kotani, what will be your solution for this problem?
She's 52 years old. Basically, I don't do the long fusion. So first, I would do is a multiple disc block at the 2, 3 to 4, 5, 3 levels disc blocks. Maybe this patient back pain is coming from L3 lateral sleep, but I do the multiple disc blocks and make sure the back pain relieves a lot. And then when we make sure that this back pain relief, I do the short segment fusion from L2 to L5 using OLIF and the percutaneous fixation to L2 to L5.
Okay, thank you, Dr. Kotani. Dr. Banot, what is your take on this?
Same. In this particular patient, the patient is relatively young and she has significant amount of disability arising both out of back pain and leg pain. So in this situation, it would not be prudent to consider a minimally invasive focused decompression. It would be better to go in and do a short segment fixation for OLIF and percutaneous fixation.
Oh, so your solution is that. Dr. Srinivas, do we have you?
Yes, sir. I'm here.
Yeah. Doctor, oh, good. Can you please put on a camera? Another young from Mumbai. So what is your solution for this, Dr. Srinivas?
Sir, I'll also prefer a short segment fusion in this patient, complaining of low backache as well as leg pain. Since you earlier said that she's looking for a solution for her back pain as well, patient expectations were cure my pain and I'll live with the back pain, which we cannot fairly expect her to do at 56 years of age. I think we have to give a chance and go for a fusion, which may relieve her partially, if not completely.
Okay, thank you. Dr. Akash. Dr. Akash, what would be your solution for this problem?
Short segment fusion, sir, as everybody.
So I think we are having quite a lot of unanimous opinion in this. A young or a middle-aged female with a lot of back pain. All the specialists, the young Turks and the expert panel want to go ahead and do a fusion. That's very good. So let us see what, for want of time, let us just see what are the evidence which tells this, So, there's a very famous paper from the Lenki school, which looked at decompression alone versus decompression with limited fusion for lumbar scoli in elderly, which very clearly said that decompression and limited fusion of the decompressed segment was very, very effective when they have less than 30 degree of degenerative scoliosis in that age group. In age less than 65, 65 is supposed to be a cutoff age in these people in which that they're supposed to have long-lasting results, and this was a long-term study. So, Professor Kotani, do you agree to this? Do you agree to this, or do you do decompression alone in this age group? And if yes, what are your technical tips when you do this surgery?
It depends. It depends the case. When deformity is fused deformity, sometimes they compress at the multiple segment. But in this case, instability is present at the 2.5 and 3.4, so the decompression alone is not indicated. The limited fusion is the best. But when I do the limited fusion from L2 to L5, I talk to the patient about the later occurrence of the DJK or PJK. So the maybe 15 years or 20 years later, we are going to fix for the long segment. So.
Okay, that's a good point. So I was going to ask you the question, when would you take the L5S1 in those conditions? What is your deciding factor? When would you want to go to S1?
Let me talk to the previous case. Do you remember the previous case?
Yes.
There's disc wedging at the L5S1, and the left side lower extremity pain is dominant. So last case has another option of the L2 to L5 fusion for 71 years patient. There's another selection, I think,
so
when I talk to the patient.
Okay.
But there is a significant risk in this case for the DJK or no recovery of the left side leg symptoms in the first case. So we have to be very careful.
Okay. So Dr. Sambhav Shah,
yeah.
When you decide to do a decompression alone in this subset of patients with less than 30 degree of deformity and less than 65 years of age as per the literature backup, what are the things you would decide surgically, or what tips you would take care when you decompress, when you use endoscope or the tube, that you don't add to the instability?
See, basically, I do endoscopic and tube both. So I myself have a criteria where I know which, like for an example, if a patient has right-sided leg pain because of significant foraminal stenosis and where the foramen is completely down, if that's the apex level, etc., then I would not go transforaminally in that. Number one. Number two, if I know that I'm going to, then if from the back, if I'm going to remove a lot of facet again, then again, decompression becomes a thought for me whether I want to just do that or even just go for a short segment fusion. But per se, if I'm just decompressing a patient, number one, the patient's symptoms, what levels are involved, where is the pathology? Is it lateral recess? Is it central? Or is it a foraminal? And this is, I'm purely talking about patients more with leg pain, where I'm going to be considering a short decompression with minimally invasive.
Okay, yeah, Dr. Shambhav. Thank you very much. I got the point. It's very clear. So you would look into axial MRI for great detail. And apologies, we'll have to wind up because Dr. Deshpande has come on screen. So we're really late in time. So let me wind up with the current evidence. So this is the only thing which you have to make care that, as we all discussed, the young Turks as well as the masters gave up their opinion that when it has to be an a la carte approach. There's no one size fits all. You have the clear subsets where you would do decompress alone, less than 30 degrees, 65 years of age, where you would do decompression with short segment fusion, and where you would do a large, long segment correction where you got lateral listhesis, large amount of the Cobb angle. So just to sum, we did exactly what the Professor Yoshita and Dr. Banot and Sambhav mentioned. The first patient we went ahead, did a long segment fusion D10 to S1. Those days, this was nearly 7 years ago. We are not trained in NoLIF and it was not available then. So I have a 10-year follow-up on this patient, living well, still alive. And this was it. And the second patient, we went ahead as the expert panel and the young Turk suggested, did a multi-staged surgery, did an OLIF first at 3 levels, made her walk. She reported complete back pain relief and went ahead and did a posterior fixation. Thank you very much. And sorry to have to run through this. Thanks, Misab, and thanks, Professor Deshpande and team. Hand over to the hall in charge. Thank you very much.
Thank you, Ranjit sir. Thank you to our senior teachers, and thank you, NTUX, for the exciting discussion on the topic of degenerative scoliosis, what to do when a case is indicated. Thank you. We'll be moving on to the next session. So we'll have lunch symposium. Now there will be 2 talks. One will be foraminal full endoscopic spine surgery, possibilities and limitations. Second will be an cadaver demonstration, is full endoscopic spinal stenosis demonstration, live demonstration on cadaver from Prima Vista, Germany. So can we have Dr. Arun Banod?
Arun Banod, sir, if you're there, I'll start.
Yes, yes. Start, please. I'm there.
Done, sir. I'm starting your video, sir.
Good afternoon, everyone. My name is Arun Bhanot, and I'll be talking about the possibilities and limitations of the transforaminal endoscopic surgery in the context of various spinal pathologies. Transforaminal endoscopic surgery, as the name implies, that we access the spinal canal through the intervertebral foramen, which is a natural opening of the spinal canal. And as we are going through a natural opening, so there is no associated collateral damage. Some centers do it under awake state or local anesthesia, and others do it under general anesthesia as well. Earlier, it was considered that transforaminal surgery was suitable mainly for contained herniations and small herniations, and large herniation, disc extrusions, migrated or sequestered herniations, or calcified herniations were considered unfavorable indications for transforaminal technique. But with the advent of advanced tools and gaining of experience, these pathologies have also come under the suitable indications for the transforaminal surgery, and we'll witness few examples in the coming few slides. Recurrent herniations are also good indications because you bypass the posterior scar tissue of the previous surgery, as is the indication of infective spondylodiscitis and sometimes foraminal stenosis causing impingement of the exiting nerve root. So all these can be managed very nicely with the transforaminal technique. These are the tools that we use for the transforaminal surgery. We use a beveled working channel here as shown in the middle picture. The endoscope is a working channel endoscope, and this is how the endoscope goes through the tube, the working channel, and the instruments also go in a collinear fashion. Now, a few examples of the successful application of this technique. This is the simplest of the lot, L4-5 paracentral herniation. Here it is a central to left side paracentral herniation causing left radiculopathy. After positioning the cannula, the endoscope has been introduced. This is the orientation. 12 o'clock is dorsal, 6 o'clock is ventral. We visualize the fibers of the posterior longitudinal ligament, which are shrunken with this bipolar forceps and then cut using the endoscopic cutter, and we visualize the disc fragment, which is removed with the endoscopic forceps. As we remove, we see a little bit of bleeding, which is coagulated, and after the hemostasis, we can visualize the very nicely decompressed L5 nerve root. This is the postoperative MRI showing nice decompression. Down migrated herniations are relatively difficult to treat with the transforaminal technique, but some of the down migrated herniations can be treated successfully, like this one, the L4-5 disc herniation. Here, the tip of the herniation goes right up to the inferior border of the pedicle but does not cross it. So in such cases, by positioning the needle and the working cannula craniocaudally and keeping the tip of the beveled cannula close to the epidural space, we can do a successful surgery even for the down migrated herniation, and this is the postoperative MRI. Large central herniations are otherwise very difficult to treat with all techniques, and there is a high chance of a residual disc. But when we do the transforaminal technique, I feel this is one of the best indications. By positioning the cannula across the midline, and in the lateral view you can see the cannula is still partly open into the epidural space, we can stay very close to the largest mass of the hernia and then can successfully treat even such large herniation. This is the postoperative MRI endorsing this fact. As we approach the disc through the transforaminal approach, the extraforaminal herniation lies in our path. So this is also another beautiful indication for a successful decompression of the extraforaminal herniation. Upmigrated herniations can also be treated. Now in this case we see a L3-4 upmigrated herniation lying within the axilla of the L3 root. Here we can see the herniation is going up, but just below the L3 pedicle and lying besides the exiting root, but in the space between the traversing and exiting root. Here we position the cannula in the epidural space like a floating cannula technique, and now after the cannula has been placed, we can visualize that we are close to the epidural space. We shrink the PLL fibers and we palpate along the exiting root here, and the herniated fragment lies there in the axilla, which is opened up with this right angled hook, and once the fragment is visualized, we start removing it with the endoscopic forceps. Again do a coagulation, and this was an old lady, so we expect multi-fragmented herniation, and as per expectation we find another couple of fragments which are removed, and then we check for the adequacy of decompression again. And this is the freely pulsatile nerve root with the overlying fat, and one can visualize the traversing nerve root. Earlier we saw the exiting root. This is the postoperative MRI showing a nicely decompressed state. Infective spondylodiscitis is another good indication for endoscopic decompression. We also get opportunity to decompress, get a good sample for gram staining and culture, and we can also do a lavage. So by doing the transforaminal technique, one can avoid doing a laminectomy and further avoid adding to the instability that has already been caused by the infective process. This is a case of the L5 left side radiculopathy arising out of this large osteophyte in the L5S1 extraforaminal zone. So in this case, we dock the cannula onto the lateral surface of the facet and drill the lateral surface of the facet first, and as we reach the intertransverse membrane, we resect a part of the intertransverse membrane to expose the exiting nerve root. The fat overlying the exiting nerve root is removed to visualize the exiting nerve root. In this case, this is the L5 exiting nerve root, and this is the osteophyte which is causing the pressure. So once we identify the osteophyte, it is drilled to thin it out, and one can use this bendable drill as well to turn it away and protect the neural elements. And once the osteophyte is thinned out, we remove it with the Carrison. Now we check for the adequacy of decompression by palpating the full length of the exiting nerve root, and this shows good decompression. This is the postoperative CT scan showing nicely decompressed state. Now these were all possibilities of various types, but there are still some challenges for transforaminal technique, and one of the biggest one is the L5S1 disc, where the iliac crest is high and the L5S1 disc lies deep inside the pelvis. So this kind of trajectory will encounter the exiting nerve root and may cause damage or discomfort to the patient while doing the surgery. Though some people have advocated iliac transforaminal approach to overcome this shortcoming, but I personally feel that L5S1, where the iliac crest is high, interlaminar full endoscopy is a much easier and simpler procedure, and I prefer to use that instead of the transiliac one. Now coming to the calcified herniations, especially at L5S1, it is not suitable to do a transforaminal surgery, though endoscopic drills are available, but it would be preferable to use the interlaminar technique in such cases. Highly down-migrated herniations are also not good indications. By highly down-migrated, we mean that the tip of the hernia fragment goes beyond the inferior border of the inferior pedicle. In this case, L4-5 herniation goes way beyond the inferior border of the L5 pedicule. Now, I attempted a transforaminal surgery in this case, but one can visualize that there is a residual disc. So, in such situations, it is better to use the interlaminar technique than the transforaminal. So, to conclude, as they say, to each his own, but in experienced and trained hands, many type of disc herniations which were unsuitable earlier can now be treated with the transforaminal technique along with the foraminal stenosis as well. Thank you.
Thank you, Dr. Any questions? So if there are no if there are no questions, we'll be moving on to next talk. The next talk will be on full endoscopic spinal stenosis, cadaveric demonstration from Dr. Ali Kuan. Sir, you are there? Dr. Ali Kuan?
Yeah, I'm here.
Yeah, can you start your video?
Again, please, there's a lot of noise.
Sir, we'll start your video, sir. With
Yeah,
your
okay.
permission, we'll start your video. Okay.
Yeah, sure.
Ladies and gentlemen, it's a great pleasure to have you here today in the RevoSpine wet lab, where Dr. Yarukoglu, our clinical manager, is going to demonstrate live to you on a cadaver full endoscopic lateral decompression with our vertebrous stenosis system. Let me quickly show you components of that system. One of the most important parts of that system is our endoscope. It's a little bit larger than our standard endoscope, as the working channel diameter was increased a little bit. It's very important to have the optimal ratio between the outer diameter of the working sleeve and the working channel. It's optimized for fast resection of bone, while the outer diameter stays as small as possible in order to fit the requirements of a tight space inside the spinal canal. The other tools that we have are here, the 5.5 millimeter Carrison rongeurs optimized for fast bone resection, as well as our sterile 5.5 millimeter burr system. In the toolbox, we have further some rongeurs as well as a dilator, which also is a little bit larger than our standard systems. Let's not forget our two very important tools, the electrodes. This is the stenosis electrode. It's optimized for fast coagulation and cutting of soft tissues on large areas of lamina, while our tip control electrode is optimized to reach points around the corner of a bone while not needing to rotate your wrist. So just by rotating the handle with your fingertips, you can reach around the corner. Let me introduce to you one last tool. This is our endoscope adapter, which is made for keeping the distance between the endoscope and the working sleeve, and for optimal and fast setting of the distance of the optics to the tip of the working sleeve. But let's not waste any more time. Let's jump straight into it. Dr. Yarukoglu, please.
Yeah. Okay, welcome from my side to our webcast. I'm at the right side of the cadaver, which means that the right side is the head and the left side is the caudal side of the cadaver. Now we start with the straight AP view, and I'm going to mark the interlaminar window as medial as possible as usual. Okay, this is the point, the entry point that I found. And the next step, I do the incision on the skin. And always I prefer to go through the fascia with the scalpel. Otherwise, it's not easy to go with the dilator. Then I introduce the dilator directly. I don't use any needle or something like that here. And then I feel the bone in the ground. Okay, I just put the dilator on the bone. Where is it? Doesn't matter. Just put it on the bone, facet joint, lower lamina, or something like that. The next step, I have to check how deep I am with the dilator. Now I'm switching to the lateral C-arm position. Maybe just a little bit more. Okay, that's okay. Just a little bit more further. Okay, as you see, I'm outside of the spinal canal. Then this is good. Now I will go with the sleeve, and I use the sleeve and the handle, the attachment in this position. Always, I know the opening of the sleeve according to the attachment. Then I introduce my sleeve. The opening of the sleeve is looking through the medial aspect. Then the approach is done. The next step is with the endoscope. Okay, now Ronjo. Now for the orientation, 3 o'clock is the cranial side, and the 9 o'clock is caudal side, 12 o'clock is medial side, and 6 o'clock is the lateral side, the facet joint. The first step, I would like to prepare the soft tissues to see the bony structures. Then what I do, I feel the bone in the ground and I clean all the tissues around the bone, and I try to find the tip of the descending facet first. I'm going to explain it later, details of this. I can feel and I can see something in the ground. I can feel the bone. Well, this is the boring part of the surgery, but we have to spend the time here. After starting with the bony resection, if you don't remove all these tissues, it's not good to your visualization. Yeah. Bipolar. Okay, I follow the bone. I can feel the bone, and I try to find the medial and the caudal border. Yeah, can I have the scissor? I use my sleeve as a retractor here to retract the tissues also. Bonjour, please. Could you fix the table? Okay, now I'm searching the caudal tip of the descending facet, which is likely here. Scissor? Again, the 3 o'clock is the cranial side, and 9 o'clock is the caudal side, and 12 o'clock is medial, and the 6 o'clock is the lateral side. The picture is almost the same with the micro, but in any case, I can change the direction of the microscope inside. Then I can feel the descending facet, and I prefer to clean all these tissues around the facet joint and the junction to the upper lamina, because my aim is to start drilling the descending facet from the tip of the caudal tip of the descending facet. Kersen, the smaller one. Yes, this one. And then drill the medial portion of the descending facet until I reach the apex of the ascending facet. I prefer to clean all this. I can feel the caudal lamina.
भैया वहां ले जा, वहां अर्जेंट हो जाता है, जानता ले जा
tissues.
आगे समझ।
Okay. Okay, again, this is the tip of the descending facet. I can feel the ascending facet here, and this is the junction to the upper lamina. And the interlaminar window is really small here, that we are going to enlarge it.
मैं कर लूंगा, तुम लेके जाओ, बताना फिर।
Okay. Caudal tip. The caudal tip and the medial part of the caudal tip of the descending facet. There's the bone here. This is the caudal lamina. If I rotate my endoscope to the cranial side, then immediately I can see the joint here. And this is the gap between the superficial layer of the flavum ligament and the deep layer of the flavum ligament. Now I would like to explain on the model to have a better overview. I prepared this part and this part and all this part, the soft tissue. And I found the caudal tip of the descending facet, and I'm going to start drilling the medial portion of the descending facet and a little bit from the cranial lamina. And the target point of the drilling of descending facet is to reach the apex of the ascending facet. Then, when I reach the apex of the ascending facet, I'm going to drill the medial portion of the ascending facet and the cranial part of the lower lamina. Now I'm going to use the protected drill and use it like that. For your orientation, this is the normal view. This is the view directly like the microscope, but I would prefer to rotate my endoscope. This is the advantage of full endoscopic systems, that I can see what I'm doing. And I start drilling. Now I drill the medial portion of the descending facet and also the junction to the cranial lamina. As I said, our target point in the upper part is the apex of the ascending facet. We can check our direction also. Now it's really through the apex. We are very close to the apex, as you see in the C-arm. There, could you show the C-arm also? I checked once. Now we see the upper lamina and the junction of facet joint to the lamina. As you see here, if you start from the caudal tip, junction between the descending and ascending facet, it's really, really fast to reach the cranial side of the recess with the less resection here. Again, the anatomy is better right now. Maybe just to give you an orientation, I can explain once more. Roger, please.
दिमाग पे ना अंदर तक चोट लगी है, ऐसे हिल गया दिमाग। ठीक है, तो समय लगता है, ऐसे 6 महीने दे दो, आराम मिलेगा। ठीक है, दवाई क्या चल रही है अभी बता दो मुझे।
Now I can see the ascending facet, Roger. Can see, yeah. Okay, this is the ascending facet. As you see here, we already removed the medial portion of the descending facet. We couldn't reach the apex of the ascending facet yet. And this is the upper lamina. We need to drill all this part also. Can I have the drill? Yeah, thank you very much. And we have to advance our drilling here. If you stay on the ascending facet, it's really safe not to estimate something. Yeah. Okay, now let me check with the C arm if we reach the apex or not. I guess the apex is somewhere here. Yeah, I can feel the apex here. Already you see we reached the apex. This is the apex of the ascending facet. I think cranial side is enough, but I would like to resect from the lower part of the lamina a little bit. Okay, I think in the cranial side it's enough. Now we already, can I have it? We already reached the, can you change it with the diamond one? Okay, already we reached the apex of the ascending facet. I think this is enough for the decompression of the cranial side of the recess. And of course, we can drill a little bit from the caudal cranial lamina here, or we can cut it with the Kerrison rongeur that I prefer to use the drill here. Maybe change the drill once more, sorry about it. Yeah, back to do. Then I would like to drill the lamina a little bit. Okay. Caudal part of the upper lamina. Now, I'm really close to the insertion of the flavum to the upper lamina. I can feel that here, but I would like to keep it intact. Okay, now we switch to the diamond burr to drill the medial portion of the Okay, sorry. To prefer diamond, sorry, the bipolar. And now I would like to drill the medial portion of the descending facet, which is here. We already reached the apex, and I'm going to drill all that part. This is the reason why we prefer interlaminar approach to decompress the recess, because here, I will show you later, the pedicle is here, and if you do it with the transforaminal approach, my opinion is impossible to decompress that part of the recess. Yeah, to reach that part of the recess with the transforaminal approach, I think you have to do the total facetectomy. Then we are talking about the minimal invasive surgery. Okay, the next step, I start the drilling from the apex of the ascending facet like that with the diamond burr. Every time I can rotate my endoscope to see better what I am doing. Now I'm drilling the medial portion of the ascending facet with the diamond drill. And in this stage, I would like to keep the flavum intact as possible as before finishing the bony work. I don't want to open it. It's a good protection for me. Now I'm drilling the lower lamina, the crown part of the lower lamina. And limit for us in the caudal side is the middle of the lower pedicle. Maybe we can check once with the C-arm if we reach there. Okay, I think we are on the in the middle of the lower pedicle, and this is enough decompression for us. Yeah, okay. Now I can continue. Now I'm looking to the caudal side. Every time I can change the direction of the endoscope to see better. Here you can see. Okay, I think we are done with the bony work. Now the next step is opening the flavum. But before opening the flavum, I would like to clean the soft tissues a little bit. Roger, please. And give you again the orientation. Once more, the drill. Just a second. This is the lower lamina, the crown part of the lower lamina. I would like to make it as thin as possible before opening the flavum, and then the rest I can cut it with the kerosene ronger. Okay. Now the Caesar, smaller Caesar. Now in this case, in the stenosis, in the in the interlaminar approach, you can start medial to lateral in the middle of the window. But in this case, if for the stenosis case, I prefer to do the flavectomy. Then what I do, usually I start from the medial part and I just try to open from the medial and the caudal part. And you see the midline here, directly this is the midline. Then I would like to open it because, as you know, for the stenosis case, usually the flavum is the part of pathology. Then once I open it here, okay, you see the epidural fat tissue. Once I open it, then I can go to the cranial side from the midline. You can follow it. And cut it to the kerosene resort. Can I have the smaller one? Still, this is the flavum. I try to reach the ascending facet. You can take the flavum, I mean, in one piece, but you also, as you see here, you can resect it piece by piece with the Caesar and the kerosene. Okay, the rest I would like to do it with the kerosene. Smaller one, can I have it? This is the cranial side of the lower lamina, which every time I prefer to decompress it. Kerosene Roger. Okay, as you see, in the lower part, you see the root and the dura. As you see here, already we reached the apex of the ascending facet. Maybe once I can show you where we are in the recess. Could you show the X-ray, please? Here already, we reached the superior part of the recess. And by this way, and if I rotate my endoscope, already I decompress the caudal side of the recess, which I can see the pedicle here, and already one X-ray. You see, I think we need to go a little bit more. And in this case, the smaller burr. Of course, we are already done, but I just want to show you one thing. It's a little bit dangerous, but this is possible also with this drill. It's a little bit, it's protected, but it's smaller than the other protected one that you can drill that part also, the caudal side, I mean. You need experience to do that. I don't recommend at the beginning to use these kind of things inside the spinal canal. Please, can you give me the kerosene? The smaller one, please. Now I'm looking at the root. I'm following the root, and I think this is enough for decompression. Let's check one X-ray and see where we are. Yeah, already we are in the middle of the lower. Yeah. Okay. This is the demonstration of ipsilateral recess. Of course, you can clean a little bit more these tissues. But my opinion, this is enough for decompress the traversing nerve root. Always the discussion, shall we do it, is it possible or do it with a transforaminal approach? Can I have the bipolar? My opinion, no, because you cannot reach, okay, it's possible to reach the cranial side of the recess with the transforaminal approach, but you see, this space ends here at the caudal side, and the pedicle is here. And to decompress that side from posterior part to the root, to posterior decompression to the root, it is impossible to do it with a transforaminal approach unless you resect all the facet joint. This is the technique to do the faster and the sufficient full endoscopic recess resection.
Thank you, Dr. Ali Gawan, for excellent demonstration, step-by-step demonstration of full endoscopic spinal stenosis decompression. Any questions from the house?
No. Can I ask one question?
Yes, please.
Normally for stenosis, how much of fluid you use? Whether you use a pump or gravitational force you use?
Sorry, I didn't get the question. Could you repeat it again?
Germany, normally how much of saline you use for stenosis? And number two, whether you use pump or just gravitational force?
Yeah, how much saline for the regular stenosis? For us, the operating time is around 40 minutes or 40 minutes. Then I think 5 liter or 6 liter saline is enough. Every time I use the pump with the flow control pump, not the arthro pumps, I use the flow control pumps.
How much of pressure you keep?
With the flow control pumps, we don't set up the pressures. Yeah, the flow control pumps has a special spine mode, which regulates the spinal pressure inside the spinal canal. Then we just set up the flow rate, which around, usually we use a 60%, but if you want a little bit more flow, you can increase the flow rate, but we don't set up the pressure. But if you use this, if you use the arthro pump, I cannot say a certain pressure is safe. The only the most important thing is your instruments, your system, it has to be open. If you use a closed system like a round sleeve with a round optic, then you will be in danger in any pressure. This is the most important thing, not the pressure. I think the system is much important.
Do you have seen over years any difference of pressure, BP of the patient, and then your flow?
Again, interrupted. No. Again?
According to the blood pressure of the patient on the table.
Blood pressure of the usually the anesthetist likes to have it around 100, 120 or something like that, but they don't let it increase there.
Okay.
But we don't deal a lot with the blood pressure. Yeah, it's routine operation for the anesthetist. Yeah, we don't care about it too much.
Okay. How do you, last question, how do you identify is there any dural leak in case?
Yeah, dural leak. I can answer this question generally. Now that stenosis with the full endoscopic technique, this is the big advantage because usually you don't dissect the muscles from the bone structures. Yeah, you at the beginning of the operation for the approach, you use a dilator. Then you dilate the muscles. Once you remove the dilator, all the muscles are closing, and this prevents the CSF leakage. Of course, you can put some material like a barriers onto the dura with the full endoscopic technique. It's possible, and also it is possible to suture, but we don't see any advantages to suture it because usually the dural defects with the full endoscopic operations are not more than 2 or 3 millimeter, and then you don't need to suture it. Just put some Drogen Tecasil or something like that and leave it like this. Yeah.
Do you have finally apply any suction after before removing the scope?
No, I don't usually use a suction, but I do at the end of the operation. I just close the irrigation and check around if there is a bleeding or something like that. If I see some bleeding, I stop them really precisely. Especially with the aggressive central stenosis or something aggressive resection, there can be a problem bleeding from the bone structures, and then you can stop these kind of bleedings from the bone with the radiofrequency bipolar, and also you can use your diamond burr to stop these kind of bleedings. The most important thing is to check at the end of the operation with closing the irrigation.
Thank you very much, Dr. Ali, and that was
My
a very
pleasure.
interesting and an exciting session. And thank you for the live demonstration as well on the cadaveric thing, though it was a deferred live kind of a thing. We thank Wolf RivoSpine for conducting this lunch symposium successfully, and we thank the speakers, Dr. Arun Bano, Dr. Ali Guven, and Dr. Pramod and Dr. Sukumar, who took part in the discussions, and they were kind enough because we were running out of time to forego their lectures. Thank you very much for that. And so as we know, we are running a little bit late and we need to go to the next session. So we'll finish or we'll conclude the lunch symposium here as of now, and we'll go on to the next session, that is a didactic lecture session. And I would like to hand over the mic to Dr. Ayush Sharma, who is the moderator for the session. And this is on an MIS rare and challenging session. Dr. Ayush, over to you. And the mic is all yours.
Yeah. So welcome to another session, which is rare, and rare could be challenging. But a panel of experts with us will help us understand how to cross over these challenging case scenarios. So we have 4 lectures lined up. Along with us, panelists Dr. Satin Mehta, Dr. Anand Nayak, and Dr. Ramesh Chandra. We welcome you all. And let's start with the first topic from Dr. Matthew, which is on the sacroiliac fusion, the indication and outcome. We will start with the video. Then we can have the discussion.
Yes, sir. I'm playing it.
Go ahead and start.
I'd like to thank the Indian Orthopaedic Association for the opportunity to talk. This particular talk is on percutaneous sacroiliac joint fusion. As you're aware, recently published literature reports that sacroiliac joint dysfunction can occur in as much as 15 to 30% of patients presenting with low back pain. Additionally, up to 75% of people who've had lumbar fusion can develop degeneration in the sacroiliac joint within 5 years, and there's amply supporting data for that. When we consider this joint, it is the largest axial joint in the body. Synovially inferior 25%, and it's held together by very strong ligaments, especially posteriorly. Posterior sacroiliac ligament runs from the posterior line down onto the back of the sacral lamina. It's reinforced by the sacrospinous ligament as well as the sacrotuberous ligament. Anteriorly, it's supported by a very thin capsule. It's important to understand that the L5 ventral ramus and lumbosacral trunk run anterior to the joint and innervate it from the front, and of course the S1 nerve root also runs over the inferior aspect of the sacroiliac joint as it joins the number 5 before passing out the sciatic knot. In regards to the anatomy, there are a lot of muscles around the pelvis, the glute max, the erector spinae, latissimus dorsi, the biceps femoris, psoas piriformis, and other oblique and transverse muscles. So one aspect of conservative management is to perform exercises that enhance those muscles to help support the joint. Once again, the innervation of the joint is by the anteriorly by L5 S1 predominantly, but S2 can give some ventral branches, and posteriorly from the dorsal rami from S1 down to L4. In relation to biomechanics, it's a very strong joint taking the weight from the spine, and there's an equal weight back up through the hip joint. So it's a triplanar shock absorber, and it transmits and dissipates the forces of the upper trunk. It's a very complex motion there, and there's not a lot. It's mainly gliding, rotation, a little bit of translation, and studies that would look at motion to make decisions about pathology are a little unreliable. In relation to the pathophysiology of joint pain, obviously there's many different causes. Idiopathic is the main one that we've found, but you can have infection, which is usually obvious, osteoarthritis, which is often asymptomatic. So you need to correlate the clinical signs and symptoms with the radiographic findings, and with sacroiliac joint pain that can sometimes be a problem. Encephalopathies, traumas, you see inflammatory conditions such as ankylosing spondylosis, metabolic conditions, tumours, iatrogenic, and following pregnancies are very common and can always usually be managed conservatively. With the theories of pain generation, obviously the ligamentous structures are fairly heavily innervated, so we think that they can be involved. Any extraneous compression or anything that creates greater shear forces like a posterior spinal fusion can cause problems. Then the issues of hypo or hypermobility, and you see both, and both can be symptomatic and sometimes both are not. Any sort of adherent joint mechanics will increase the stresses across the SIJ. In relation to the SIJ pain, we see the strain across the joint if the mechanical load is increased, and typically you'll see that with posterior spinal fusion, anterior spinal fusion, and forces can be increased just 1 over 1 and 2 levels by a factor of 100 and 140%. You can see it up as a traditional posterolateral bone grafting technique. If you're taking a subfascial intramural graft path, it's important not to get your osteotome to breach the SIJ because it contributes to pain. And sometimes you just see SIJ pain. Very eloquent study done by out of Gold's offices, basically looking at the lumbar fusion angular motion and the stresses across sacroiliac joint. I'm basically able to show that these flexion, extension, bending, and rotational forces increase exponentially with the larger fusion, and that therefore can create stresses that can create pain. When we look at the SIJ degeneration post-lumbar or lateral sacral fusion, this is a study done by Ha, where he looked at a prospective cohort over 5 years and found and assessed it by CT scan. They found that 75% at 5 years compared to 38% in the control group. So higher in lumbar sacral fusion group than the lumbar fusion group, regardless of the number of levels fused. Other studies looking at how the fusion across multiple segments can increase the incidence of sacroiliac joint pain, and particularly to the sacrum. 3 or more levels certainly influences, and most importantly, if the sagittal balance is not restored, people can transfer into the SIJ. When we look at the pain patterns, SIJ can be pain over the posterior superior spine. It can radiate to the posterior thighs, down to the calves, and sometimes down to the feet. It can also radiate around the front. So often they point directly over that area. About 4% of people maybe in the midline. It can be unilateral, can be bilateral, and it can refer. And the referred pattern basically is a product of the innervation of that joint. When you go and do a physical examination, it's notoriously unreliable, and you have to be seeing this stuff all the time to be able to examine and examine it properly and get what you need. But basically, there's no specific physical examination tests that have been accurately identified to prove that the painful joint is the problem. We need to firstly just exclude other possibilities such as radiculopathy, hip joints, so it's always important to do the thorough physical examination. You get them to point to the pain, if it's tender over there, and then some of the provocative tests, at least 2 of them are positive, then you can get an idea about the possibility of that sacroiliac joint being an issue. Here's a couple of these tests here, the thigh thrust, the favour test, the distraction and compression test, and then Garlinson's test. And I think it's important to have that as part of your armamentarium. And as I said, 2 at least positive, then I'll go on to do a diagnostic block. In terms of imaging, there's really no useful imaging studies. Sometimes you get the home run where you get a SPECT scan that shows up activity. Sometimes an MR you can see degenerative changes, and sometimes on CTs as well. So the SPECT scan is something that is useful. It's very high, it's very specific, but it's not. It's very got a low yield from a sensitivity point of view. In regards to diagnostic injections, this is where we use local anaesthetic. It's probably the best method for definitively diagnosing the source of SIJ pain. So I tend to do it under a little Neuralef, image guided, use local anaesthetic, and then guide it into the joint, verify that it's in the joint by a bit of a dye, and then inject it. We find that if you've got greater than 75% pain relief, it's diagnostic. Less than 50% pain relief, it's not really diagnostic. We'll often do a second or sometimes third injection to increase the diagnostic accuracy, and generally inject around about 2.5 to 5 to anywhere from 2.5 to 3 mils. If you're going to do it under CT guidance, you must, as you can see, verify that the needle's in the joint. When this is done without local anaesthetic, and it can hurt the patient, and as a consequence, you see a lot of these needles are just on the edge of the joint, not in the joint. You can also look at it from not only a diagnostic but a therapeutic point of view, and you can mix with your local anaesthetic some corticosteroids, and that can help. Look, I think when we're dealing with any sort of problem, conservative treatment is always the preferred option from the patient. So I do prescribe physical therapy to supervise. We do arrange for injections periodically in those who profit from it, and you can do that radiofrequency denervation where you focus on the dorsal rami of S1 down to S4. In terms of the surgical treatment, it's been evolution. Obviously, the advent of cone beam tomography with navigation, in other words, the O-arm versus conventional fluoroscopy, has made a big difference to the accuracy and efficiency of spinal instrumentation. So we have these amazing advances in radiographic technology. Then, of course, we looked at minimising what we do to the patient. So comparing open and minimally invasive sacroiliac joint fusions, and it showed that we were able to get very similar results without increasing the morbidity. So there was this trend into minimally invasive surgery, and like everything, it takes time to penetrate within the surgical field, and then the technology matures. And so we've gone through a pretty good evolution now where there's good evidence on randomised clinical trials about the efficacy of minimally invasive sacroiliac joint fusion. And what I've observed is that open procedures, they're associated with larger incisions, a little bit more comorbidity, mainly because of the soft tissue dissection before the bone exposure. But when you do it open and you use ILAD bolts and pedicle screws, you can really get down into the joint and then certainly get a good solid fusion, such as comorbidities, blood loss, soft tissue issues. Obviously, with the advent of minimally invasive spine surgery, percutaneous iliac screw fixation, when performed accurately, that fortunately good, and studies have been shown that significant reductions in people can improve their quality of life can exist. I found that minimally invasive SIJ fusion is becoming the technique over the age. And because of these stereotactic guidance systems, we're able to do these things through minimally invasive. This is my surgical setup. We have an O-arm, we have navigation systems, and so basically we put the patient on a padded radiolipid Jackson table so that the O-arm can be. I make sure I do all the prepping of the patients, make sure you have a spot prep, and that the area is both crests are. We put the reference arc on the non-instrument. I usually only do one side. I found about 75% of people, if they have bilateral symptoms, I do the worst, and 75% of people of those don't require a contralateral fixation. It seems like just tightening the pelvis, the symptoms. The array must be seen by the navigation system, and then we bring in and do an operative. That alarm image is then sent to the cell, and then we basically can navigate. And I use two threaded cages from Medtronic with a combination of local BMP or sometimes other elements. The surgical technique, as you can see here, we can replace. We've got our guidance system, and then we can map it through the navigation system, and then insert our. I then run an alarm afterwards to verify the position of the system, and it just shows how accurate. So this picture on the left is the technique I use. We've got minimal dissection. We just come on a post to put our iliac spine, basically drill across and ream it. The cage is about 12 millimeter. So if you ream to 10, you can get some bone graft and page, or use any other product knife. You can get 2 or 3 of these in. I don't think one's enough. I think you need 2 at least, and if you can get 3 in. I don't have any problem with the direct lateral approach. Pose a few more issues. One is the accuracy of it. 2, the damage and the superior thyroid artery is very close there, and have heard has been injured in them. In terms of the MIS lateral approaches, obviously they have a shorter operating time, less wound. The disadvantage is, as I said, the direct debridement or grafting point, and you can see screw loose ends, screw melting. And so I think these robotic options will really increase that. In terms of the evidence for open versus MIS, this is a study that was of 63 patients, roughly in 2 groups, and they found a higher blood loss, higher osmosis function at the end of the year. So I think if we can do something where we can use the comorbidity, yet still get the same outcome, then that's once again a good study done by David Polly here, looking at the randomized trial, these triangular lateral-based inserts, and they looked at the 12-month outcomes and showed that there was significant reduction in people's pain and improvement, and these were statistically significantly and clinically more so. And as we look at that, we've seen some systematic reviews where they looked at 12 different cohorts over 400 and were able to show MIS fusion leads to consistent, rapid reductions in people's pain and improvement. So this is how I approach it, and I use, you choose a device with, obviously we're very fortunate in Australia, we've got the alarm and navigation, and we're able to do this through minimally invasive. You always got to be cognizant of post-operative complications. I think if you're aware of them, you can minimise it by, following the proper process. As you can see, it's not a trivial operation. You can get a complication rate that's fairly substantial. So I think the added advantage of in verifying the placement is good. Here's an example of a patient who presented to me. I do a EOS assessment, and as you can, she had a degenerative back, and I performed an angiogram. And as you can see, post-operatively, she sat back on herself for changing her shape of her surroundings. And this increased the stresses across her sacroiliac joint, and I'll perform a navigator sacroiliac joint fusion. I was able to verify it immediately, and then at 6 months post, I validated fusion by CT. So this woman had a reduction in her arm. Obviously, we've got the robot and some MSS robotic guided sacroiliac, and so that's a nice technology whereby the incisions are even. Once again, you've got to get a fusion, and that's important, so you must think about what we do. So in summary, SIJ is a more common problem. I think we need to have a strict diagnostic protocol to use. We can try extensive non-operative treatment, and if people fail it, then the diagnosis can be made by MDs. The role of surgery should be very tested. We need to make sure they don't have other reasons for pain, and we must educate about modest improvements in their pain and disability following SIJ. It's not unusual to have 50 to 70% improvement. It is unusual. It's important to make sure the patient. So it appears as though sacroiliac joint fusion through MIS has an acceptable safety profile, but you still have to get that fusion for that. I'd like to thank you for your time and ask you to present to the society, and I'm thrilled to do so.
So that was from Dr. Matthew. So we don't have him online. So a quick question, Dr. Anand, what is your thought on SI joint fusions when it comes to our Indian scenario? Your experience, just a quick thought.
So if we sit and diagnose about the cause of pain and all, the SIJ pain is like a tip of an iceberg. If you sit down and diagnose, try to so if you diagnose, you will see that there will be a lot of patients who are having that. Matthew and me, we both work together, and we do a lot of anterior surgeries and all. Even after ALIF, the incidence is around 1%, and we see a lot of these patients at around 3 to 4 years mark, having the back pain and all. So we do the diagnostic blocks and all. We started this MIS sacroiliac joint fusion in 2013, and we started navigating them. Now, if you look at the presentation, there are two different types of screws which are being used. Some are cylindrical and some are triangular. So the cylindrical ones, we experience a problem of loosening. Despite using coated screws or graft, whatever is available. But the triangular ones, they are much better, or maybe the cylinder with a cage so that the bone can integrate faster.
Okay, thank you for the overview. So let's move on to the next talk from Dr. Sudhir from Medanta. So again, we have an interesting topic. It's about tackling anterior vertebral body pathologies with the tubes. So can we have his video, please?
Last two frontiers left to tackle lesions with minimally invasive surgery are deformity and lesions which are ventral to the cord involving the corpus. The areas which can be there are ventral to the cord but behind the body, like some tumors and cysts, and certain vertebral body pathologies which are anterior to the cord, like tumor, traumas, and tuberculosis. Sharing an experience of cervical lesions which are between the body and the cord, we use a minimally invasive approach through a syringe port and doing an oblique corpectomy. After doing the corpectomy, we go for a lesion which is like this. We will go on to open the dura. And once we open the dura, this is the coagulation of dura. What you can see is being done. So we'll open the dura. Because we are just next to the tumor, we will dissect of the structures along the arachnoid and separate them and gradually dissect the tumor off the arachnoid, and then gradually build on the arachnoid on the side and the tumor plane so that we can remove this tumor in totality. Also, in certain cases of CV junction, where you have lesions or tumors which are ventral to the cord and cord here, and the tumor which is from here to here, these lesions can be addressed from a port from the sides. And you can see we have gone from one side and removed whole of this tumor and given a lot of space to the cord which was causing edema into the brainstem also. Also for lesions in the cervical thoracic craniovertebral junctions, like a degenerative cyst and a bony element which was there, we could go from the sides with a port like this, and we could address this pathology. This is the video of that case where you can see that we have done the bone work, gradually made more space for ourselves, done some drilling, and gradually reached an area where we can see the part of the cord which is here and the C2 nerve root which is here. Gradually building this space, and you can see the C2 nerve root getting more well defined. And then taking out the cyst, which you can see now, the cyst which is coming out, and the dura is so far off, and that is the area of the dura, and gradually developing a plane so that we can remove this cyst to totality. we also get, this is a double lesion, a tumor, and degenerative ossification of the ligament here. And this, we use tube as a nose. Nose is our tube, and we go through the nose and take this out. And this is the post-op. There's a Fogati here, and this is the corridor which we have used to tackle such a complicated disease. Thoracic spine is challenging, and we can go from the sides in a tailored approach. The amount of bone work we do depends on the pathology. And this is a case where there's an infective lesion here, and there was a pus, and there was a degeneration there. So what we did was we went through the scope, and after going through the port, we also took a 30-degree endoscope. So it gave us a vision which was more than 180. So we could see on the opposite side also, and we could do certain more maneuvers like drilling, taking out of this fragment to total level. So you can see we could dissect it off, take out that fragment, push it down, and finally remove it also. And we could also put a cage in this case. Now, certain body diseases are there in which there may be tumor, there may be osteoporotic collapse, there may be tuberculosis, where we go from the sides, tailoring according to what we require to do. And in this case, we have gone through this corridor into the bone. There is a fragment which is going inside, you can see here, and taking out this fragment through this thing. Certain interesting rare cases like herniation of the cord, which is your cord gets struck to the part of the vertebral body, there's a dural defect and the cord is going out. In this case, what we have done, we have gone through the port on the sides. This is the trajectory. We have gone here and identified the defect. Use a navigation helps us. So what we did is we have gone through the port, done the bony work. And then once we are, we try to go between the pedicle and the corpus. And once we have reached that area, we start seeing part of the dural tube. Sorry, my mistake. So we start seeing a part of the dural tube. And this is the dural tube you are seeing. Now what we are doing is we are working in front of the dural tube and doing the drilling of the corpus in front of the dura. And this is gradually we are defining where we are supposed to get the arachnoid tear. And you can see this bulge of arachnoid which is there. This is where there was a dural defect and the cord was adherent here. So gently you define it. And then you use artificial dura to place it here so that you can do a good job at this place. And subsequently we close it. Also, an interesting in lumbar disease at T12, you will also take out the rib and then go through the pedicle inside. And at the below levels, what you will do is you will go gradually inside, go on drilling, doing discectomy above and below. And then you will take out the bone fragment which is in front through this corridor. And even putting a cage inside is possible with this corridor. Now lumbar spine, this is a metabolically active lesion present here. And in this we took an approach like this. But after removing this tumor, we got a certain spurt of urine which was coming out. So we called the urologist, they couldn't close it. So using our minimally invasive techniques, we only put a stitch and we're able to repair the ureter. And thanking you for all the attention.
Thank you, Dr. Sudhir, for excellent talk. And Dr. Zaveri has a question. Please go ahead, sir.
Sudhir, that was a fabulous talk and some fabulous work that you are doing. Can you enlighten me that in the thoracic cord, when you are anterior or anterolateral to the cord, if there is a dural tear, how do you manage that?
So the video which I showed, I managed it exactly like that. This video which I showed, there was a defect of the dura which was congenitally present. So what we go anterior to the surface, anterior to the surface of the dura where the body is there. Just anteriorly we drill, leaving the posterior part of a thin bone left inside. Then we gently break away that bone down, and then we put a duraform followed by a surgicel. Duraform has to be a small size, and the the surgicel has to be a larger size. We can also put a glue, but in most of the cases we don't use a glue at that place.
This is overlaid, not inlaid, right? You're not laying it below the dura.
In this case, I had to put an inlay because this was a herniation of the cord. But otherwise, I will just do an overlay and get away with it.
So it would be very easy to get lost in this case. Do you always use some sort of a navigation or AI support for all these cases? And do you recommend that they should always be used, or can it be done without AI or navigation? Because we saw quite a few navigation being used in these cases.
Minimally invasive surgery I've been doing for 18 years, and I was doing everything with a C-arm. Past 4 years, I'm doing everything under navigation. So you can do everything with C-arm, no problems.
So thank you so much. So for the interest of time, let's invite the next speaker, Vishal Kundani, the Mumbai blaster, who will be talking on application of tubular retractors in cervical spine pathology. Over you. Please play the video, Vishal's video, please.
Thank you, Ayush. Here it is.
Give me a minute, sir. I'm playing.
Welcome to MISAP Surgical Symposium. Warm greetings from Mumbai. Cervical spine surgery is often performed for various reasons, be it decompression surgery in patients with radiculopathy or myelopathy, or it can be in the form of instrumentation in high cervical spine for odontoid fracture C1-0 fixation, or it can be in the form of lateral mass fixation. Sometimes tumor excision and biopsy is also the primary aim of surgery. And these can be performed by various ways. We all know that cervical spine surgery is either anteriorly done or posteriorly in the form of ACDF, ACCF, or laminectomy, laminoplasty, and lateral mass fixation, or high cervical spine surgery. And all these can be achieved by one of these techniques. They have stood the test of time, all these surgeries. Then why do we need MIS? We need MIS because there are problems of conventional spine surgery, and you need to get convinced that there are certain problems which you have been facing so far in life, and MIS is an answer to it. What are those problems which MIS can really solve? We all know that fusion is not the primary goal in patients with radiculopathy. However, it is to be done whenever you are doing a radiculopathy to get good results, and that is why fusion is probably an addition to it, which results into problems like neck pain, sometimes visceral issues, dysphagia, dysphonia, and sometimes recurrent laryngeal palsy in short term. In long run, ASD can be caused. In posterior spine surgery, when you do a posterior muscle dissection surgery for laminectomy, laminoplasty, neck pain is known to be one of the residual causes of problems in these patients. It has been very well proven in various forms of literature. And these problems do happen purely because of exposure, because of access-related problems, including large incisions, muscle retraction, prolonged retraction of the muscles, and high infection rates can also be adding to the morbidity of these patients. In high cranial surgeries or craniovertebral junction surgeries, spontaneous OC fusion, wiring-related issues, C2-3 facet arthritis is also known in literature very, very well. So why do we need MIS? We all know that these problems, which we sometimes tend to just forego, they do exist. And this is the time has come where we should fight it out and try to solve these problems or do our surgeries with same amount of efficacy, same amount of target surgery. However, by means where the access-related morbidity comes down without hampering the results. And this is what the basic principles of MIS is, which in lumbar spine, we have seen the advantages. We all know the advantages of MIS surgery in lumbar spine, and they can now be easily extendable to cervical spine. And I'm going to show you some examples where MIS surgery has proven its worth and given the test of time, and also has shown efficacious results without actually creating the problems of conventional MIS surgery. We all know the advantage of MIS, and these are exactly the advantages that will be applicable in all cervical spine surgeries also, where the incision size comes down, the blood loss is less, the infection rates are less, it is more forgiving because the dural leaks really don't give any more trouble anymore, the pain is less, the painkiller requirement is less, the rehab time is less, and patient recovery to normal is also very, very fast. And these are the advantages which you cannot hold back from your patients in cervical spine surgery as well. So why do we need MIS in cervical spine? It is established. There are advantages which you cannot forego. It is the future, and it does work. Where does it work? It works in patients with cervical radiculopathy. You can do a tubular oblique corpectomy or corpectomy, adding discectomy to it. Like in this particular patient, we did a tubular discectomy for a laterally placed disc. They are going laterally without disturbing the whole corpus there, just by burring it out. And this is where the MIS technique works very, very wonderfully. And you don't really have to add fusion to these patients. So fusion is not the primary goal of it. You can do this not only anteriorly but also posteriorly. Posterior cervical microforaminotomy for laterally placed large discs creating radiculopathy is very well established procedure, and this can easily avoid any fusion. You can see the pre and post of MRI, wonderful decompression is already done, and this is something that we all must try to target and have less morbidity, less requirement of fusion, less chances of ASD in all these patients. Cervical PIVD, where there is a lateral, not only foraminal stenosis, but also a disc and osteophyte complex. Again, posterior microforaminotomy comes very handy. See the size of incision. These patients can actually walk home the very next day. These are wonderful surgeries, can be performed under tubular MIS technique, or even endoscopes can be used in these patients. Cervical tumor excisions, not only are they very handy with the use of tumor because the dural sac is not to be touched, not to be seen, and you can really excise the whole tumor by very precise placement of your tube over them. Like in this particular patient, you can exactly see the C7 osteoma excised from the lamina, and this is completely gone there. And this is something where tubular MIS surgeries come very handy. This is one case where no amount of open surgery would have actually helped. We use navigation in this particular technique, where a C1 lateral mass osteoma, a complete tumor excision required, where the tumor lies bang behind the vertebral artery, and we went in with the help of MIS tubular techniques and see the size of incision, and when we were able to excise the complete tumor from the C1 lateral mass there. Again, you really don't need to use it. The moment you plan to do an open surgery in these patients, you will actually have to fusion. The segmental or a OC fusion would have been required otherwise, which we were able to avoid purely because of the advantage of MIS. And so it does works. This is one case report from one of our pioneers in tubular spine surgery, Arvind, who did a C2 tumor from the lamina, and he was able to excise it, and wonderfully depicted in his case study. Again, showing the advantage of MIS surgery in cervical. In patients with fracture dislocations, we have been able to do this. In patients with transarticular screw, we have been using minimal invasive techniques, using percutaneous implants there, and the exposure is only limited to see the pars. This is some examples in a child where MIS transarticular screw was done for a patient with C1, C2 dislocation. Now, facet dislocations like these, which actually require a facet resection, and then you have to turn the patient to anterior surgery. This is one such case example where facet resection, which was required to reduce the fracture dislocation, was done under tubular technique. We just docked up a tube on the facet, just excised this small piece of in a locked facet, and we were able to get good reduction and turn the patient, did a ACDF in this patient. Again, imagine doing an open surgery, you would have to actually dissect the whole muscle area to get only reduction in there. This is something that we all must try to apply in patients with facet dislocation. A minimal invasive technique to reduce the fracture and a small ACDF surgery would really help these patients. This is not limited to only subaxial spine. In craniovertebral junction also, we have been doing with the help of tubular techniques, using odontoid fracture fixation with the help of tube and minimal invasive exposures there. And these are just some case examples there. Adding navigation has not only given wings to MIS in spine surgery, but has also helped us to ascertain the completeness of the surgical principles there. Like in this particular patient, we were not only able to excise the tumor intraoperatively, but immediately postoperatively with the help of navigation, we were able to see exact location of the tumor and the completeness of excision. Another case scenario where we just showed you with the help of now navigated drill burrs, we can not only localize the tumors, excise them completely, but also check immediately whether the completeness of the surgery is ascertained or not. And this is purely available because we have been able to establish 3D navigation in our surgeries with MIS techniques also. In patients with high riding vertebral artery, just presence of our guide navigation helps us to get the same MIS trajectory in these patients safely with absolute precision there. And just some more case examples where navigation and MIS combined gives us wings to fly in such syndromic cases, even getting the same advantage of MIS. So We all know that MIS, it does works, it has advantages. And remember, MIS is here to stay. It is the future of cervical spine surgery as well. And it is not new. There are papers loaded with it, which involves not only in cervical spine, subaxial cervical spine, but also in craniovertebral junction. Whether it be decompression, you can really achieve a good amount of decompression using tubular retractor, be it for cervical disc, be it for myelopathies. Even endoscopic techniques are available now to do wide decompressions, even in patients with discectomy and myelopathies, as we have been seeing our endoscopic colleagues as well. Be it in decompression or be it instrumentation, where placement of lateral mass and medical screws are also available now with the help of MIS techniques. So we all know that it is going to stay here. However, we also must acknowledge the fact that cervical spine surgery with MIS is still in infantile stages because the indications are limited. We cannot really expose everything to MIS. However, it is still amenable. Though the learning curve is still steep and resources intensive, however, still it is possible. And unless you start doing the simpler cases with MIS, you cannot imagine doing complex cases in future with MIS technique. Yes, it requires special tools, but the learning with these tools is very, very important. And I'm sure these courses and symposiums are going to get you acquainted. I've just shown you some indications where cervical spine, we have been using MIS technique to do. So to summarize, cervical spine surgery with minimal invasive spine surgery is the future. It is needed not only because I have to be in the race, but also because the benefits of MIS surgery in cervical spine are plenty, which you cannot neglect, and it is only going to grow bigger. Don't just wait and watch. Try to adapt minimal invasive spine surgery in simpler cases, cervical spine. Start with ACDF, start with cervical foraminotomies, and probably that's how you'll probably grow. Though it is infantile, but it is extremely growing fast, and I'm sure despite the steep learning curve, we all can achieve the advantage of MIS in cervical spine surgery. Thank you so much.
Excellent cases, Vishal. Any questions we have for Vishal from any of the panelists?
Thank you.
Vishal, yeah, so really great cases, but you know, these cases require some amount of learning curve. So what stage do you recommend people to take something like this? What has been your experience and learning curve? Because, you know, someone can get influenced looking at you and start doing this, but we know MIS is not simply just about doing cases, but about selecting cases and being in the right zone to do these cases.
I think very interesting question, Ayush. Not only is selecting cases, but I would portray something that Dr. Gautam Zaveri, who's here on the platform, he also speaks this very often, that it is not only the use of tubes or special portals which makes a surgery minimal invasive. The minimal invasive word means reducing the invasion away from conventional spine surgeries, which can easily be not using a Ryle's tube, not requiring a catheter, or reducing the amount of muscle retraction. And then, as you rightly mentioned, the learning curve has a ladder to follow. So anyone who has done 50 discs should go on to do a tubular LCS. Somebody who's been doing 25 LCS should do one T-lift. Somebody who's done 20 T-lift should do a thoracic or a thoracolumbar MIS fixation. And that's how the first cervical microforaminectomy should be chosen if you're doing a tubular. And the simplest way is, I recommend is that when you're doing your first cervical microforaminectomy, might as well just do a midline incision, midline exposure, though limited, and then get your tube docked right in front of your vision, because it is not only the use of tubes, but also playing with your radiology. I mean, getting the tube docked at the right place in the right angulation also makes a big difference. And that is why this is the ladder that we have followed so far. And I'm sure we all can really achieve and reduce the invasion in toto, rather than only depending totally on the tube. Start using microscopes in the simplest most cases, start using tubes in the lumbar spine, start using for the most simplest cases, and even in cervical spine, start trying to use all these combination of things in the simplest cases, and gradually you'll be able to climb the ladder up like any of all of our seniors have done so far.
Thank you, Vishal. Thank you. You're joining from your car, so we really appreciate.
I'm sorry for this.
Yeah, and let's move to the next speaker, the man of the moment, Dr. Umesh Shrikanta from Bangalore. Can we have his talk, please?
Hi, my name is Umesh, and in this video, I'm going to talk about utilizing minimal invasive techniques for treating primary spinal tumors, intradural, extradural, as well as extraspinal in nature. Let me start off by telling that microsurgical excision of spinal tumors is well tolerated with good outcomes, even by an open technique. And we have been traditionally taught to do a laminectomy often beyond the boundaries of the tumor and resect the tumor completely. And this primary objective has been perfectly fulfilled by an open surgery. But what happens is a concomitant or a unwanted muscle damage that happens due to, especially when there is a long segment laminectomy or long segment exposure in such cases. And this is what we aim to prevent by doing a minimal access techniques, and the efficacy of minimally invasive techniques have been proven beyond doubt as of now. So we started off our journey with small tumors like this, or single segment lesions, and which we can, put in a tube, do a decent hemilaminectomy, as well as, open the dura, remove the tumor either with internal decompression or an en bloc complete resection, identify the nerve root going in and going out, and reset the nerve root or preserve it depending upon the need of the hour, and then remove the tumor. So this is these were one of the earlier cases, and the dural closure can be achieved by intermittent tack sutures and all. So this was the post-operative MRI, and there is very little muscle damage that we can see in such cases. Of course, we then progressed to doing similar tumors in the thoracic region, and as you can see again, the muscle injury is significantly less. And then comes the more complex cases like, this, for example, this is an anteriorly situated meningioma, which is a calcified component and at the level of D4, that is the narrowest part of the spinal canal, all points favoring towards a difficulty in excision of these kind of tumors. Of course, these can be done. So this is the dural opening after the hemilaminectomy. And, we made a lateral cut in the dura, and we can progressively do internal decompression, remove the dentate ligament so that the spinal cord can be slightly retracted to the other side, and then go anteriorly under the spinal cord, and then remove all these calcified components, as you can see there, and also see the attachments over there. So that is one big calcified component that is coming out, and then we can virtually remove the tumor completely and coagulate the dural attachment of the tumor. And this is the post-operative case. So coming to slightly bigger tumors, and then these can also be resected using a tubular retractor, a 22 millimeter tube, which can be angulated towards the position of the tumor as required, gaining a single axis. And this is one of the, intraoperative images. So I'll just skip through because ultimately this is just a large tumor, which we have just angulated the tube into various directions, and we removed it, tracing the margins of the tumor from all the directions, and complete tumor excision can be achieved. So this is the post-operative MRI, which is showing complete tumor excision. And as you compare with the pre-operative MRI, the only difference you'll be able to make out is the slight difference in the thickness of the psoas muscle. And if you carefully observe the paraspinal musculature, hardly there is any change between the ipsilateral as well as the side where the surgery was not performed. So the complete preservation of paraspinal muscles can be achieved. Even bony tumors like this is a case of osteoblastoma, can also be resected using a tubular retractor. So in fact, the excision can also be monitored sequentially of the CV junction. So in this particular case, even large tumors arising at the CV junction can also be resected by placing a tube over the C2 lamina and then angulating the tube upwards between the C1 and C2. So that is the posterior atlantoaxial membrane that was resected, and then the tumor can be progressively resected, again changing the direction of the tube. So that is the area where the nerve root has been cut off. And once we remove the tube, the muscles fall into place. Again, the post-operative MRI, similar to that case, was showing only a small CSF collection, whereas the paraspinal muscular attachments, the attachments of the C2, as well as the suboccipital muscles, everything can be preserved without harming them. Of course, then come the slightly, not so big tumors, but which require a slightly lateral thinking. For example, this is a junctional tumor, which is straddling the thoracolumbar junction, as well as straddling the facet joint medially and laterally. And in these cases, in order to resect these tumors, we need to either resect the facet joint and stabilize that segment because it's in the D12L1 region. Otherwise, this is what we planned, in the sense like we put a tube first with one incision into the intraspinal area, resected the tumor up to the level of the foramen, and then coming from the far lateral area, extraforaminal approach, and resected the remaining part of the tumor. So this is the intraspinal approach, and this is how the tube has been positioned. And that is the tumor that is being resected. For us, it was a completely extradural tumor. So the extradural portion, the intraspinal portion, has been completely resected. It is just cut off at the level of the foramen. And then we position the tube into the far lateral area, extraforaminal approach, and we come from there, and the entire tumor can be resected from there as well. And this is the post-operative MRI at 1 year, which just shows an intact facet joint, just a small hemilaminectomy defect. Again, the paraspinal musculatures are very much intact. However, similar dumbbell-shaped tumors that are there in the cervical region, we do not have to go extensively and resect the facet joint, because we know that the cervical facets are wide apart as compared to the dorsolumbar junction, and the facets are more narrower anteroposteriorly and more broader mediolaterally. And that is why we can look actually under the facet, and then angulating the tube under the facet, we can look under the facet and resect the tumor that is going into the extraforaminal area more anteriorly towards the vertebral foramen and all. So this is again a small video. This is the intraspinal portion that is being resected. This is the dural sleeve that is being opened. Once the dural sleeve is opened, the intradural portion of the tumor is being dissected from the spinal cord. You know, the vascular pedicle is being identified. The vascular pedicle can be coagulated and cut, and the intraspinal portion of the tumor can be completely resected. Then the tube is angulated laterally under the facet joint, so we can, you know, decompress the tumor internally as well as remove the tumor from the extraforaminal portion as well. So as we are removing more and more tumor, as you can see there, that is the vertebral artery that is there. That at the anterior margin of the tumor. So then the root sleeve is reconstructed, and the gap that is there left behind where the tumor was coming out, and that can be layered with a dural substitute, and that closure can be achieved. This entire tumor can be removed with an incision that is less than 2.5 centimeters. And this is again a similar example, multi-segmental, multi-compartmental tumor that is extending both intraspinally all the way from the lower border of C3 till C5, as well as going anteriorly. A similar approach, a single incision, again, we can actually resect the tumor completely by wanding the tube both superiorly, inferiorly, as well as going laterally onto the, as was discussed earlier. I just skipped this because of want of time for the tumor. So similarly, a large-sized paraspinal extension can also be planned via a double incision technique. So this is an intraspinal portion at the level of C3, as well as an extraspinal portion that is going all the way down till C4, 5. And these things can also be removed by making two separate incisions, a paraspinal approach, a second incision on the posterior border of sternocleidomastoid, around 7 to 8 centimeters lateral to the midline. And these tumors can also be completely resected. Again, if required, again, this is a dorsal tumor which is extending both intraspinally as well as extraspinally all the way to the level of the pleura there. And, you know, with the near total facetal destruction that we can see there. So in these cases also, we can actually remove the tumor by wanding the tube, as we have discussed earlier, and then we can, through the same 22 millimeter tube, we can put in 2 screws to stabilize and achieve a unilateral stabilization. So this is our experience as of now. I'm not going into the details due to want of time, and there are several concerns and cautions as we are talking about in minimal access spinal tumor resection. So there is a limited visual field. We are not visualizing the margins of the tumor or the borders of the tumor initially. And we have to be accustomed very well to the parallel working channel, especially thoracic level and cervical level tumor manipulation. We have to be very careful. Any upward or inward pressure as the contralateral lamina is intact. Any pressure on the tumor can get transmitted to the spinal cord and cause a pinching effect. So just to summarize, minimal access resection is feasible for the majority of extramedullary tumors. It is safe and effective, and there are several proven benefits of minimal access technique. Thank you.
Thank you, Dr. Umesh. Great talk, great case selections, and excellent documentation. Do we have any questions from anyone, any of the panelists? Like again, excellent cases. So how do you select these cases? Is there a limitation to what you can do with the tubes? The second part of it is, did you ever plan a case with the tubes and later on you do something, you have to convert it to an open case?
Yeah. Only in one case where we thought predominantly intramedullary component, and that was actually very early, during my, when we were doing tumor cases. So that time we were not so confident. So that is one case where we have converted it into an open case. We open. But apart from that, nowadays, what I feel is that majority of these extramedullary tumors, by either a double incision technique or by using, by changing the angulation of the tube, you'll be able to access most of the tumors. And as I have showed examples, even one example that I have not shown is a longitudinally longer segment tumor, where we can put tackle the upper part of the one incision, then again tackle the lower part of the tumor with the second incision, ultimately ensure that both the complete tumor excision is ensured. Of course, the time that is one disadvantage as far as I feel that the time slightly what taken.
Your voice was breaking in between, but another thing, if someone is starting to use tubes for tumor resection, what are the cases you will recommend for the initial case selection, how to go about it before you venture into some complicated cases?
Now, as I told, it is better to select a simple single segment around 1 to 2 centimeter, intradural extramedullary tumor, preferably a schwannoma, with a very well defined margins. And that is something. But before we venture into this, I think there is something else that we need to be comfortable with, that is dural closure. So only when we are comfortable with the dural closure is when we can attempt to do an intradural pathology with the tube. But otherwise, yes, extradural tumors or extradural tumors, extraspinal tumors, even small extraforaminal schwannomas that we can sometimes, if you are lucky enough to find them, if it comes across, these are something that can be approached with a tube very well.
So thank you so much. And if we don't have any questions from anyone of the panelists, we can move on to the next session because we have just finished on the time slot. So can we go to the next session if we don't have anything from any of the panelists?
Yes, Dr. Ayush, I think we should move on to the next session again, due to want of time. Thank you very much, Dr. Ayush, for moderating this session. And I thank all the speakers as well as the panelists for their time and their contribution towards the, towards this particular session. Thank you very much.
Thank you. I think next session moderator, Dr. Ajay Krishna.
Yeah, sorry.
Good afternoon, Dr. Ajay Krishna. So you're there?
Yes, Dr. Ajay. Can you hear us? So the next session is going to be on complications and management. And Dr. Ajay is the one who is going to be moderating the session. Dr. Ajay, are you around? Are you online? So I think he's not online. So I would like to welcome the panelist, Dr. Alok Ranjan.
Here.
Yes, yeah. Ajay, I would like to hand over this session to you. It's a session on complications and management. Over to you, Ajay.
Yeah, so much so has been talked about, and it has been so good here now. Now we need to go into handle certain complication and salvages which you may encounter, especially during the initial series of cases you have. So let's handle a few complications and their management. I would ask Ayush to come and guide us to salvage options after misplacement of percutaneous screws. Ayush.
We are playing Ayush sir's video.
Yeah, and the panelists Alok Ranjan, Subir Javeri, Lakesh Rohana, and Karnakaran. They are welcome.
So today I will be talking on salvage option in cases of misplaced percutaneous pedicle screw. So misplaced percutaneous screw is more common than we think. It could be as high as 12% with the C-arm, and it could be as high as 7% even with a 3D navigation. What is the best salvage option? The best salvage option is to get it right. Get the guide wire right. If your guide wire is right, your screw will be perfect. There's no doubt about that. So, most important thing to understand, even before you start placing your percutaneous pedicle screw, is to get this owl's eye view. What it means that the nose of the owl should be perfectly balanced between his two eyes. And this owl's eye view is specific for each and every level. So you need to turn the CR, you tilt your table to get that perfect view. One of the challenges of gifting this perfect AP before you start your putting your Jamshedis is scoliosis. How to go about it? One other trick we use is we put a cage first. And once you put the cage, it can really derotate the spine. And from here, from this, you can come to this, and then it becomes a cakewalk. And not so much so that we can even do this in a single position lateral. Another challenge could be a high grade listhesis because especially here, the L5 pedicles are very short and they could be dysmorphic. Again, the trick is even before you start putting your screws to get the disc height back, once you get the height back, it becomes a very, very easy screw compared to if you have started at this position. Another important aspect is to understand the 3D anatomy in each and every level. So if you see here, this is from D10 to L2. And if you see, as I'm going up, the direction of my Jamshedi is really changing. So the convergence is less. So understand the level and the anatomy of that level will really help you put a perfect screw and one perfect guide wire. And once you have a perfect guide wire, that is the end of the game. What if you suspect that you have misplaced a guide wire? So if you see this guide wire appears to be more convergent, do you really need to remove it? So this is the small trick which we use. What we do is while tapping, once I have reached the medial border of this pedicle, I'll take a lateral shoot. And as you can see here, as it has already crossed the pedicle here, so this is definitely a good guide wire. What if you realize that there's a mismatch when you already put a screw? So either you can remove it, or if you have neuromonitoring, this is one of the studies which say you can use the trigger EMG at 10 milliampere to check if the screws are still good, and this will help you decide whether to remove that screw or not to remove that screw. What are my salvage tricks? This is what I do if I feel I have misplaced the guide wire or the pedicle screw. I use the Jamshedi, the Lanky. I use the curve of the Lanky to get a completely new trajectory. And for sure, in each and every screw, there are more than one trajectory which you can use. As you can see here, I had a medial breach, so I directed the Lanky laterally, and I got a completely new trajectory. So use a new trajectory while you're placing a salvage screw. This is another good salvage option. So in selected cases, if I think I misplaced my guide wire screw, I use this guide wire less screw, which is a Viper Prime from Synthes. And what it does, it allows me the full strength of the screw because the guide wire is inside that screw. So you can really change the trajectory and really get a new trajectory altogether in single shot. And then if you're salvaging your screw, you need to put a longer screw, try to put a larger diameter screw. The other option is to do a cement augmentation, HA augmentation. And in spite of all that, if you feel that still you cannot salvage it, either skip it or use the technology. If you have a O-arm, if you have a robotic C-arm, now there is enough evidence to suggest that these navigated screws can be a good salvage, and their accuracy can be as high as 99% if you plan the trajectory right. So thank you. These are my salvage options when it comes to putting these percutaneous screws.
Good one, Ayush. Can we have a few questions from the panelists?
Yeah, Ayush, it's a good presentation. So what happens that intraoperative at times you may not realize, but post-operative patient may wake up with a either a foot drop or pain, and you get a CT, you realize that it is misplaced, then what would be the strategy? The real challenge will be detection post-operatively, where you know, rods is fixed. Now you have to go in and then what is the strategy?
About it.
Hello. Yeah.
Something like that.
Yeah.
There's no other option but to change the trajectory, change it, get a new screw in and remove the screw. But with the MIS, I feel, because you have to put your guide wire first, so you can really see if the screw, if the guide wires are good. There's no doubt unless you have really messed up putting that, really change the trajectory. It's very, very difficult.
मेडिकल सेंटर से पेशेंट आया, टीबी का है, नॉन टीबी का, 3 months को एटीटी चल रही, रीसेंट ऑनसेट पैरापेरेसिस. एक बार जरा ओपीडी में आकर उसको देख लो, वो एडमिट करना है, कल या परसों करना.
Can we have him muted? Yeah. So that's what I was saying. If you have something like that, you really need to remove that screw and change it. But I think the best option, as I told, is to make it called intraoperatively, especially with MIS. Yeah. Yeah, please go ahead.
Yeah, that's right.
So Rakesh, I had that opportunity that I'd fixed the patient, and then the patient was doing well. And then after a few days, the patient started coming with pain again. And that at that time, I actually re-imaged the patient after about 3 or 4 weeks of the primary MIS lift. And then what had happened at that, the pedicle, the screw actually had was a little bit more medial than what I had expected. A piece of bone had perhaps broken off, but had not dislodged initially. And after the weight bearing had begun, that piece had dislodged and started causing pain to the patient. So I had to revise that screw. I had to go in, remove my rod, remove both the screws, redirect the screw and put a new rod. I mean the same rod again. So I did have that experience, unfortunately, but that can happen.
Can we move on to the next presentation? Ranjit sir?
More on the panelists?
Yeah, very much here. My video is already there.
Yeah, Ranjit. So that is the next of yours. So,
83-year-old who had a premier fall sustained
having the IIT filtered, having a bullseye of the pedicle is the best way to confirm whether it is infectious or not. And that can be made always a standard to make it 100% sure. Though we have OAM and we take
and MRI
in
of the spine was done,
so we have
along
the
with the
gadget, that's
repeat
why we
X-ray,
take it.
which showed that left side and the MRI showed extensive osteoporosis with an unstable fracture at the L1 level. We decided to go ahead with percutaneous vertebroplasty along with percutaneous pedicle screw fixation. Once we inserted the screw and then got in the rod, as we tightened the rod, we could see that the screw had gradually pulled out. What do we do now? With this, let us discuss screw pull out in MIS. Now what? Screw pull out should not lead you to pull out your scrubs, because that will worsen the situation, lose your temper, people around you get pulled out and lead to an unhappy outcome. So what do you do in these situations? Do you stop the surgery? Do you remove the screws? Go ahead with a standalone vertebroplasty alone? Or do you convert it to an open procedure? Or do you use open cement screws? Or other option could be percutaneous cement screws. Now, how to get out of this situation? Number one is to avoid it. You should anticipate it. We should know that in osteoporotic patients, when we go ahead and treat the deformity or treat the fractures, we have to primarily build the bone. Today it's accepted to have at least 3 months of teriparatide to improve the bone density. We should avoid attempting large deformity corrections or large sagittal plane corrections in these osteoporotic bones. Try to use multiple anchor points to spread out your forces. Use fenestrated screws in the situation that they pull out. You can put them back in. Inject bone cement. Today we have them percutaneous systems available, even indigenously made. Use large diameter screws. You should try and contour the rod more so that you don't have to pull the screw to the rod. You may have to remove the rod to do all this in an MIS situation. Pay attention to the bone mineral content on your DEXA scan. They're divided into 3 grades by Associate et al. So in which grade 3 is the one, 0.3 to 0.4 gram centimeter square is the one which you try and avoid using pedicle screws alone. Always try to use them with some kind of augmentation, cement or bands. Along with that, the traditional techniques of increasing bone purchase by using a more medial trajectory, a cortical purchase, using conical or tapered screws with a larger diameter content in the pedicle, using improving the fit by using augmentation methods with PMMA or CPC. By and large, PMMA is the most popular ones. This particular patient, we tried to salvage the situation by using PMMA fenestration into the fenestrated screws, and we could bail out ourselves, thankfully, for this particular patient because we had it ready. Initially, this was a live surgery. Everything goes wrong in a live surgery. So second condition is anticipate this pullout in case of semi-rigid deformities. If in cases where like you do a degen scoli where you try to do an anterior release by using an A-leaf or O-leaf, try not to use large lordotic cages. Today we know that an O-leaf or an A-leaf seldom does a large part of correction by itself. It has to be augmented by your posterior procedures like a Pontes or a posterior column osteotomy and releases. Try and spread out multiple anchors. Use large diameter screws. Try and contour the rod more. Try to bank on your releases more than your instruments to get your correction. And at times you may have to resort to open procedure if this fails. A similar patient where we had a degen listhesis post-laminectomy. We went ahead, did a 3-level O-leaf, and as was a practice then for us, we try and made her walk to see that if the leg symptoms disappeared, her leg symptoms totally disappeared. So we planned a stage 2 posterior percutaneous alone correction with not attempting any releases. Went ahead, put in the pedicle screws, and as I started correcting, my screw pulled out from here. Now what? In this particular patient, we took out the rod, contoured it more, put in a thicker screw, and try to salvage the situation. So the take-home message from this short presentation is that plan the surgery, because we know failing to plan is planning to fail. We all will face it someday in our life. Keep bailout options ready in the OR. You have to acquaint yourself with the implants and instruments very well before surgery. You might have to get used to various combinations across different manufacturers to bail out situations. You have to have extended options like dominoes, ilia connectors, cables, etc. ready in a situation that you have to convert your surgery to an open posterior correction. Thank you for your patient listening.
Any questions, panelists? So I would put a question across to Ranjit. Ranjit, if you are doing an MI, once to put more incision.
Ajay, I cannot hear you. Is it my network or your network?
He is. I also can't hear him.
Yeah, so it's your end. Yeah, Ajay, are you there?
Yeah, I'm there. Am I audible?
Yeah, tell me. Yeah.
Now, yes.
For a single level fixation, if you are losing the screw hold, would you still continue with your MIS way of doing, or you will try to make it a little bit more open, make it Wilsey, and put a more planned bigger screw, a better trajectory?
So, Ajay,
You will still go
depends
to
on-
achieve the reduction or not?
Yeah, generally in a one-level procedure, if it is say you're doing a chili for something, I would have done a good release. Very unlikely in a non-osteoporotic patient that my screw will pull out. In a non-osteoporotic patient, if the screw pulls out, I'll definitely go more lateral and take a more medial entry and take it. I'll triangulate more and try to get a purchase. Osteoporotic bone, I will not do anything. If it is pulling out, I'll stop there, put it back, put cement and complete it. In osteoporotic bone, I don't change track, etc., because it will still pull out. Did I answer your question,
Yeah, right.
Ajay?
Yeah, right. So we move on. The next talk is intraoperative inadvertent dural tear management options with tubular retractor. Dr. Umesh. Thank you, Ranjit.
We are playing Umesh sir's video.
My name is Umesh, and in this video, I'm going to be talking about how to manage dural tears when it happens while operating with a tube in MIS procedures. So as we know, incidence of dural tear is higher in revision cases, and sometimes even with appropriate techniques, it can happen, in certain cases where the risk factors are high, either due to an older age group or a chronic compression where the dura is thin, in ossified ligamentum flavum, in synovial cysts, and etc. Managing these cases appropriately is very important because this can lead to post-operative complications like CSF leak, post-operative wound CSF leak. It can lead to wound dehiscence. It can lead to surgical site infections, meningitis, internal complications even when the wound, external wound appears all right, like pseudomenimbus seal or a nerve root entrapment can happen, which can result in a higher incidence of Feldbach syndrome in these cases as compared to what we see in a case where there is no CSF leak. So a simpler way to classify these dural tears is to classify them based on their location. The easily accessible, the posterior ones are called type A tears. The lateral located ones in the lateral recess or those around the nerve root sleeve are called type B. And the ones that are located ventrally, which are difficult to access, are called type C tears. Now, there are several techniques that are available when we are doing an open surgery for repairing these dural tears. Direct suturing, of course, is the best. Watertight closure is, of course, the best. But many times it may not be possible. In such cases, we have to use adjuncts like even place minor tack sutures and use adjunct synthetic or tissue in order to augment our primary repair. Now, let us assess how much of this is actually possible with the tube. Watertight closure may not be actually possible in many cases while operating through the tube. Because running stitches cannot be put. Intermittent stitches, definitely. Tack sutures can always be put with an MIS tubular retractor, even with an 18mm tube, as we are going to show some examples. And these are preferable for dorsal dural tears. Tissue adjuncts, synthetic adjuncts, on all these cases, these techniques can also be used in the tube as effectively as we do in an open surgery, as we are going to see some examples. Of course, this can be done only if we have some special instruments and special techniques that are there. Most of the times we need a bayoneted needle holder, a straight tip as well as a curved tip, which will help us to actually see the needle. When we are operating at the depth of the tube, the needle will come forward and it will help us to take the stitch where our hand is not going to come in the way of this. A curved bayoneted needle holder, a knot pusher, a suture cutter, which is a bayoneted knife, and as well as a suture, we often use a 60 Prolene or a silk with 10mm, 3/8 circle needle. So coming to certain examples, so this is a case where, there is a thick ossified ligamentum flavum. Of course, while dissecting the ligamentum flavum from the dura, there were dural tears at multiple levels. So, and as we are going to see, so this is one of the lower dorsally easily accessible dural tears where we are putting intermittent tack sutures and we are closing that dural tear. So as we have seen, so it's important to see that the nerve doesn't get caught or the epineurium doesn't get caught in the thread, and we have to take appropriate precautions. Sometimes even we can push a small piece of abgel or a gel foam inside or a small piece of fat to push the nerve down so that we can take sutures. So this is another tear that has happened in the contralateral area, that is after the over the top decompression, and where suture cannot be done, and there we have just put in a dural substitute. Of course, in all these cases, it's important not to compromise on the primary objective, whatever we are doing. So this is again one more case where there is a small, very, very minor CSF leak from there, and there is a small nerve root prolapse that we can see. But of course, this didn't turn out to be as simple as we had expected in this particular case. So there is a multiple nerve roots, cauda, are lying outside in the epidural space, and the dural defect is not to be identified at all. So the dural defect was actually a very small one. And usually it is recommended in these cases that we open up the dural defect, we enlarge the dural defect so that these nerve roots that have prolapsed outside can be, pushed back inside. But, what we didn't expect was as soon as we opened this, the entire cauda actually came out of the dural sac, probably due to the intrathecal pressure. So in these cases, we can always put the head end down, reduce the intrathecal pressure by reducing the PEEP and, making sure we can gradually and sequentially push these roots one by one into the thecal sac, and then we can put approximated sutures. If it is not watertight, we can always put in a muscle graft, augment this with a fibrin glue. So this is another small example where, there is a simple laterally located dural tear, which we can actually, just put in a dural substitute, cover it, and then tuck it anteriorly, into the dura, and then, wound CSF leak shouldn't be an issue in these cases. So coming to the basics of management, accidental durotomy in MIS, is pretty much the principles of management are similar as what we do in an open procedure. When it's around the nerve root sleeve, we don't have to put a suture because that itself can cause a constricting ring around the nerve root and cause compressive effects. And in this case, only a dural substitute or a patch can be put and augmented with a fibrin glue if possible. Ventral dural tears, of course, no intervention is required most of the time. CSF leak is not a problem. In a dorsal tear, we have to identify whether it is suturable or non-suturable. If it is suturable, primary repair is the best. And if it is not watertight, many of the times in MIS, it is better to augment with a dural substitute muscle fascia or a graft. So just to summarize, dural tear avoidance is still the best, and we need to be familiar with the microsurgical techniques for dural repair. And when we are operating through the tube using special instruments and microsurgical techniques, it is possible to repair most dural tears similar to open techniques. The idea is to prevent internal pseudomeningeal seal or a nerve root entrapment, and wound CSF leak is almost never a problem in all these cases. Thank you.
Thank you, Umesh. We will go to the next talk by Pramod, and we'll take the questions together for both of the topics. Management of dural tear during endoscopic procedure. Pramod, welcome.
My talk is on management of dural tears occurring during endoscopic spine surgery. Let me start with a case example. L4-5 right-sided upmigrated foraminal disc. Transforaminal approach was performed, and see what happened. During the initial dissection, the forceps caught and pulled some nerve rootlets. The more I tried to free the forceps from the rootlets, the more they got pulled. And I had really had a very hard time in separating the forceps from the nerve roots and detaching the nerve roots. Some nerve root was cut with a cutter. The surgery continued later on. Luckily for me, the patient did not develop any motor or sensory deficit post-operatively. So management of dural tear intraoperatively during endoscopy can really be a big nightmare for a surgeon. Even though dural tears are rare in endoscopic spine surgery, they do occur. Their incidence is between 1.7 to 4.3%, which is much less as compared to open surgeries. And the common causes are long-standing lumbar disc herniations, which are calcified during the decompression of the contralateral side in lumbar canal stenosis, revision surgeries, and a synovial cyst resection where the incidence is highest. The reason for low incidence of this dural tear is because of the presence of irrigation fluid channel. Endoscopy always offers a trifold benefit of magnification, illumination, and a clear field of vision due to the presence of irrigation fluid, which washes out all the blood clots and the debris and maintains a very clear field of vision. Another reason is microscope offers a bird's eye view where the surgeon's eye is placed at a distance from the pathology. Whereas in an endoscope, the surgeon's eye is always placed at the tip of the endoscope, which is very close to the actual pathology. And this offers remarkable benefits, especially in deep-seated areas like thoracic disc herniations. The mobility of the endoscope is superior as compared to the microscope. So contralateral decompression in lumbar canal stenosis is much better with the endoscope as compared to the microscope. The symptoms of dural tear in endoscopic surgery can be very unconventional. Many of the times the dural tear cannot be recognized during surgery due to the presence of irrigation fluid. Unlike in open surgeries where we have got CSF leak, wound dehiscence, headache, vomiting, nausea, etc. In endoscopy, the dural tears usually present with intractable radicular pain, which can be dermatomal or non-dermatomal, causing electric shock-like sensations. The pain is aggravated on movement or standing, and if there is a nerve root herniation through the tear, the patient may have significant neurological deficits. Dural tears are more common during the initial part of the learning curve, and the main causes are improper surgical technique, wrong choice of technique, improper handling of the instruments, and lack of experience. This is a case of one of my colleagues who has recently started performing endoscopic spine surgeries. L45 extruded disc herniation transformal approach, good post-operative MRI pictures. But see what has happened. The patient developed a monoparesis in the left leg with the power of grade 2/5 from hip onwards down to the leg, and the sensations were decreased. So if you look at the intraoperative video, there was a big dural tear with herniation of the nerve roots, and the surgeon has failed to recognize this dural tear, and there was mishandling of the nerve roots with the instrument probe. So if you look back again at the post-operative MRI picture, you can see CSF leak, and there is an unintentional damage to the superior articular process. So the surgeon must get familiar with the anatomy and also learn proper handling of the instruments. So whenever we are using sharp instruments like the drill or Garrison punch, we always use it under very high magnification. The tip of the instrument has to be seen at all times, and whenever we are drilling, see that the drill is moved sideways to avoid damage to the underlying vital structures. Similarly, when we are using the Garrison plate, the foot plate of the Garrison should always be visualized so that it doesn't catch the dural sac. So these are the tips: cutting and drilling always under high magnification. Place the drill in a position before it is actually started. Sideways movement of the drill is advisable, not vertical, and the tip of the instrument should always be visible. And intermittent drilling is advisable as it allows some time for the muddy field to settle down. And don't use sharp instruments whenever the visual field is poor. Majority of the dural tears are very small, and they usually can be neglected intraoperatively, and we can continue performing the entire decompression. If you look at the post-operative MRI pictures in such patients, you may see a small pseudomeningocele inside. And these are the patients which are usually conserved without any need for patching or repair. Sometimes the dural tear are moderate in size, and usually in such cases, I complete the decompression in the other areas first, and then lastly come to the area which is affected. And after the decompression is completed, I perform a Valsalva maneuver. If there is no nerve root herniation through the dural tear, usually it can be managed by conservative treatment, either with a dural patch or a abgel which is placed on top. Sometimes we have a large dural defect with multiple root herniations. These are the patients where you have to stop endoscopic surgery immediately and convert the patient into open surgery. Take home message: dural tears can occur in endoscopic surgeries even though they are rare. Small tears are usually difficult to recognize intraoperatively due to the presence of irrigation fluid. So a high index of suspicion is needed if the patient has got complaints post-operatively. Majority of the dural tears can be conserved without the need to convert to open surgery. Surgical repair is needed only when there is herniation of the rootlets or entrapment of the nerve root, or there is a presence of large defect. Thank you.
Thank you. It was quite comprehensive. Now we can have some questions for dural tears and repair. Yes, Subir bhai.
Yeah. So question to Umesh: during repair, is he around? He's not around.
Yes, I am around.
Well, we don't see you.
Umesh, I'm in another screen, yeah.
During repair of these dural tears, someone had showed use of those Liga clips. Have you had any experience? And so Alok is nodding his head like he has used it multiple times. But first, let us hear it from Umesh. Then Alok, you can answer my question.
Well, these are very, very useful clips.
clips, but the only disadvantage what I felt is that it compromises on the fecal sac capacity, and it, because a large amount segment of both sides dura is clipped together, and it reduces the circumference of the entire fecal sac as compared to taking a stitch on the dura. So that was what I felt, and these micro clips are available. Actually, they are pretty good. And if we have access to them, I think they are can form a suitable alternative to taking a suture.
Because I have never tried suturing it. I am always used tissel as and when I need it. But so Liga clips are an option. I think Alok wanted to say something.
So you're muted.
So these micro Liga clips are available, and they are available with the gastro people. They have the laparoscopy. Unfortunately, it will go only at least in 18mm tube. Less than that, that applicator does not enter properly and you can't see it. So the only use of this is when the root is herniation. You want to prevent the herniation, you put this, and it is not a watertight closure. You put the patch which you are saying. But if the root is herniating, then you are in a problem with the patch also. So this is the only thing is to just close the gap. But one more tip I will give you. If you use a bipolar at 6, 7, 8 strength, you can actually catch both ends of the dura and stick it and then put the patch. Very low current bipolar will stick it.
Rakesh.
My question to Umesh. So dural tear occurring at the beginning of case like severe canal stenosis, early dural tear with herniation of roots, that is much more difficult at the end. So would you repair it at that level, or you put a patch and repair after decompression?
No, I always prefer to repair it as soon as possible. There are two reasons for that. So I understand that it may be so more difficult than to repair after your decompression is complete. You have the entire area visualized. You have a decompressed fecal sac. So probably it is easier at the end. But there are two reasons why I would like to do it in the beginning. One is because I should not cause any further damage while trying to decompress more. As it is during the initial part of decompression itself, we have caused a dural tear. And while decompressing further, again, we should not extend the dural tear, or by inadvertently, we should not catch any root that we have not identified and has prolapsed during the meantime, during the decompression, when we are pushing the fecal sac also to a certain extent, either with a patty or anything. The second reason is that if I repair it in the beginning, I have a very, very good indication of how I have repaired it by the end of the decompression. Because if by the end of the decompression, if the fecal sac is round and if it is pulsatile and I am not seeing any amount of CSF coming out of the area that I have repaired, I know that I don't need to do anything further, in the sense like that itself is a good indication. Or at the end of the decompression, also, if you feel that there is a persistent CSF leak, probably you can use some adjunctive method to augment your repair.
Umesh, one question, what is your experience of tear about 1.5 or 2 centimeter without closure, without stitch, just a Duragen apply and then come out? Have any experience like that?
Sir, I think it can be done, but it all depends on whether it is, how much we have. The only risk, we know that the Duragen or any of these dural substitutes that are available, they don't form an immediate watertight closure. So it takes time. And as long as there is any amount of CSF that is oozing out from below, so the Duragen may not heal and it will not form a sticky layer with the Dura as it is supposed to do. So in all these cases, it is better to have as much of less CSF pressure as possible. Of course, there are instances where we are not able to approximate the Dura completely and we have to leave open a small area. In those cases, I prefer to put in a small facial patch or a muzzle patch and then use either fibrin glue or Duragen on top of that.
Morning, I listened to a paper where a tumor excision from the tumor. The surgeon has rubbing and everything, just applied Duragen and then came out. He said nothing happened. It was just...
No, if the Dura is approximating, it's fine. But when there is a rent, when there is an open gap with CSF gushing out, Duragen, sometimes it doesn't heal. Means Duragen, as we know, it doesn't cause an immediate watertight closure. It takes time to form that fibrin layer between the dura and the Duragen.
The trauma cases where the dura is very torn has taught us that quite often in certain bad trauma, you can't close the dura. And that has taught us not every case has a CSF leak. So as long as the roots are not bulging out, I will like to, in those cases where we have these problems, if I have to just put a patch, I'll put a patch. But if I have a chance to put a lumbar drain, I will definitely put a lumbar drain for a couple of days, just so that the pressure reduces. But there are places where you can't put lumbar drain, then you have nothing, you can't do anything about it.
So there are only two things to do. If it is big enough event, then you can probably just contain it. That is the one idea. And secondly, you need to have a closure done which is tight enough to secondarily seal it. Now for endoscopic procedure, I would put a question across to Pramod. If at the start of a procedure, if you have a tear, then whether you would continue with the procedure or you would like to convert it to an MIS or an open procedure. Because this is a underwater procedure.
Yeah, as I told you,
directly going to increase the ICT pressure.
Yeah, as I discussed in my presentation before, that majority of the tears which we find in endoscopy, they are very small, less than like half a centimeter or so. And if there are no herniations of rootlets or the internal arachnoid membrane is not damaged, so I usually prefer to continue with my surgery and keep a watch at that particular tear all the time, see that it's not getting worse or something like that. And if the procedure is completed, then I usually need not worry, because unlike in open surgery where we have the posterior intact track of incision, which maintains some kind of patency between the actual dural tear and the outside. So there is a chance of formation of a track or CSF leak post-operatively. In endoscopy, there is no cutting of muscles. So, once the dilator or the working channel is removed, all the muscles, they just fall in place and they form a very watertight closure per se. So the chance of dural leak through the incision is, I think, is almost negligible in endoscopy as compared to. But unlike if there is a bigger tear, like a centimeter, centimeter or more size tear, in one of the third cases which I had shown, there was a big defect and some rootlets were coming out. So in that case, I think there is no point in continuing with endoscopy. You just stop it, just convert the procedure to open surgery. First repair the tear, whatever it is, so that you don't cause further damage to the rootlets. And then you try to finish the remaining surgery after that. So that's the way I usually deal with it.
One question.
Can I comment?
Okay.
Can I comment?
No.
Yeah, Dr. Professor King. Yeah, please.
In those cases where probably in your earlier stage, not recognized, patient has intractable pain post-op.
Yeah.
Manage it.
So usually that's what I told, that these are not something which are routine cases, but you always need to have this high degree of suspicion in your mind that maybe there is a tear somewhere, and and the patient has got radicular pain which is probably worsened or something, which is not relieved, and you try to manage it conservatively for a couple of days and the pain is not getting relieved. In such cases, I would prefer to go in and do an MRI in those cases. And you might see that maybe there is some, kinking of the, the dural sac nerve root contents towards the anterior side or lateral side, wherever it is. And if that is the case, there is no point in waiting. You just go inside, open up, explore the problem. And if there is a tear inside, you just, relocate or reposition the nerve roots and repair the tear properly.
Can I comment?
Yeah, yes. Professor Kim, your last comment.
Yes, as commented, Dr. Pramod, Dr. Pramod commented very good. In the endoscopic spine surgery, we met so many cases of dural tear because of that. Nowadays, we can perform so many endoscopic decompression surgery. But as Dr. Pramod commented that the dural tear is not major problem in the endoscopic spine surgery, but more important point is that two detecting the dural tear is more important. It means that if we cannot detecting the dural tear during the processes, that sometimes post-operatively it make us some root prolapse and make us some problems. But if we detect and try the patchy, Takoshiri patchy or some blocking point, dural tear is not major issue in the endoscopic spine surgery because, as commented by Dr. Pramod, the more important point is that checking the final point of the dural tear. Because of that, if we suggest some suspicion or some worry about the dural tear, we should, in spite of the not dural tear, we should try some patch or some blocking point there.
Okay. Yeah, I agree.
Yeah, thank you very much. We will just move forward, and I would invite Dr. Mihir Bagpat for his talk, Calcified Disc Detected Intraoperatively, Reconsidering the Options and How to Choose.
I thank the organizers of MSAB 21 for giving me this pertinent topic. Calcified disc can be calcified pulposus. However, what we are worried about during surgery is the calcified annulus. This is seen in morbidly obese. It is seen in elderly patients due to age-related degeneration. It is seen in young adolescent discs due to chronicity of more than 6 months or 12 months of duration. The overall prevalence is about 5 to 6% in adult patients. Calcified annulus on X-rays or on a CT scan can be incomplete or complete with a focal protrusion or extrusion of the soft disc, or it can be a complete ossification of the annulus with cortical definition. The MRI is often not very specific. There is a uniform hypointensity on T1 and T2 weighted images, and you may see only the disc extrusion or sequestration, or more ominously, you may have an intradural disc herniation in these patients. So a CT scan becomes mandatory. Now in this patient, a multi-level stenosis was seen, but as you can obviously see, the more severe L4-5 did not have a calcification, whereas the less significant L2-3 showed a calcified disc on the CT scan. So the CT scan may show a focal protrusion in the foramen, or it may show a unilateral protrusion which is slightly more broad-based, or it may show a uniformly broad-based calcification from one pedicle to the other. In this particular morbidly obese patient, a 34-year-old male had chronic symptoms of claudications for about 12 months and a cauda equina syndrome with leg neurological weakness since 4 weeks. As you can see different discs in different stages of calcification. L3-4 had a broad-based annular calcification. L4-5 was completely ossified, and L5-S1 showed a unilateral focal protrusion. The clinical symptoms with calcified discs have one common feature. That means they have recurrent episodes of chronic axial or leg spasms, and the presenting symptom is claudication or an acute leg spasm or a neurological deficit. The calcified disc, when detected intraoperatively, one has to separate out the soft tissue component from the hard annular calcification. So the protrusion or extrusion can be excised, and if the root becomes mobile, then you can leave the calcification alone. However, if the root remains restricted, then you may have to extend your lateral recess decompression and foraminal decompression, and you may have to restabilize the spine. However, if the root still remains restricted even after a wide decompression, then one has to resort to an adhesiolysis, excision of the calcified annulus, and stabilization, which is a more extensive and precarious procedure. So in this particular patient, we did an L2-3 decompression with posterior lateral fusion, L3-4 discectomy with a fusion, L4-5 again a posterior decompression with a fusion, and L5-S1 again a discectomy with a foraminotomy. So these options have to be kept available on table. Now, this is a 36-year-old male who had a soft tissue protrusion according to us, because we missed to detect the calcification on the X-ray, which is obviously the most common scenario. And when we went intraoperatively, we found that there was a focal protrusion of the disc, a soft tissue protrusion, which was incised like a soft disc herniation. So once the soft tissue component of the disc is removed, the surgery actually begins. The decisions are, is the root adequately mobile, or is an annular portion of the disc compromising the root? So once you have done an adequate foraminal decompression, you can slide the tip of your L punch just beneath the edge of the root without retracting the root too much. This may have to be repeated more than once to slowly separate out the root from the calcified annulus. As you punch back, the calcified annulus separate of the root. One has to be very careful about root injuries in this particular scenario. You can use an osteotome to osteotomize the calcific annulus to gain an entry, slowly distract the disc to separate out the root, firmly hold the root, do not allow the root to get stretched abnormally. Then use the L punch, or you may even use a pneumatic saw, a piezoelectric saw, to complete the discectomy. There are very few articles on calcified discs. And in this particular article, they have shown that doing a wide decompression and stabilization is probably equal to doing a discectomy and stabilization in these patients. You can actually avoid the complications of a discectomy, that is dysesthesia, root injury, and CSF leaks. Thank you.
Thank you very much. We will take two questions, please. Dr. Rajamani.
What is your, for a central calcified disc, what is your long-term follow-up after decompression? Whether the calcification stays back, or you try to remove initially, or you leave it? What is the long-term follow-up?
Central discs, if you decompress them wide, do not have long-term consequences. We have had follow-ups up to 8 years now. And these patients, in fact, the last patient that I showed had a follow-up of 5 years, multi-level calcified discs in various stages. These patients do extremely well if you have decompressed the roots far laterally and stabilized. The central protrusions usually do not cause a problem.
Any reason, in any one of the cases, you found out the reason, something like a parathyroidism or something like that?
Sorry, I didn't get the question.
In any of your cases, could you find out some reason for the calcification, like parathyroidism?
Yeah, so like I said, there are two different scenarios. One is a calcified pulposus. Now, calcified pulposus commonly seen, we have seen cases of uchronosis, we have seen cases of hyperparathyroidisms, in rare cases of some connective tissue disorders. I really do not recollect their names, but these are calcified discs which are very, very obvious on your x-rays. What we really worry about is that the disc that we see soft on the x-ray turns out to be a calcified annulus, and these patients usually do not have a metabolic disorder.
So we move on. Thank you, Mayor. Thank you. The next talk, Dr. Karthik Kailash, persistent pain following lumbar surgery, the evaluation.
One of the major problems following lumbar spine surgery has been a persistent back pain following surgery. So today we look at a few factors and how to evaluate this persistent problem which we have. Now, persistent pain is becoming an increasingly common challenge for spine surgeons owing to expanding indications for spinal surgery. This is a big problem, and a multidisciplinary approach is most appropriate for patients who are unlikely to benefit from formal lumbar fusion surgery. Now, what do we call this problem? Do we call this a failed back syndrome, or do we call this a post-surgical spine syndrome? Many terminologies are being used. The problem of persistent back pain, more than 50% of primary spinal surgeries are successful. 30%, 14%, and 5% of patients experience successful outcome after second, third, fourth surgery. So as we keep going and repeating surgeries, the outcome seems to be poorer, leading to poorer quality of life, and thereby diminishing the trust with the clinician, and counseling and getting the patient together is another problem with all these persistent back pains following surgery. So in evaluating these factors, we could take into three major patient factors, operative factors, and post-operative factors. So we look at patient factors. We have to look at what kind of treatment options were discussed to the patient, the freedom of choice given to the patient, psychosocial health, because this can create other issues, comorbidities like obesity, metabolic diseases, musculoskeletal conditions, substance abuse, etc., can be varying factors to cause persistent back pain even after a very well done surgery. Now, operatively, many factors are there. Inappropriate surgical choice, choosing a wrong type of surgery for the patient. Prior lumbar surgeries, going back and doing a revision may not necessarily yield a satisfactory result which you want. Single-level decompressive laminectomy in the presence of multi-level spinal involvement can also lead to problems. Approach-related problems, whether it's a posterior surgery, whether it's a TLIF, whether it's a lateral lumbar interbody fusion, or whether it's an ALF surgery. Approach-related problems can also lead to persistent back pain, other problems related to it. Errors, wrong level of approach, wrong level of surgery can also be there. And implant-related complications can also lead to persistent low back pain in all these patients who have undergone the so-called successful lumbar spine surgery. So intraoperative errors during lumbar fusion may not only cause ongoing pain in the same pre-op distribution, but can also trigger new pain sources, and these have to be evaluated carefully. Each surgery has the potential to create new segmental instability and generate further pain with misplaced interbody fusion grafts and implants, which may, for example, potentially cause neural impingement and lead to worsening of the outcome for the patient. Typically, for example, a patient undergoing lumbar fusion surgery is at risk of sagittal balance, particularly when more than one level is involved. Furthermore, those with reduced sacral tilt after surgery have been found to exhibit loss of natural lumbar lordosis that result in increase in stress transfer to the sacroiliac joints, and this can lead to an additional back pain for these patients. The postoperative factors could be early or late. The early factors could be procedural complications that are deleterious with an outcome, include hematoma formation, the epidural subdural space, infections, pseudomeningeal neural injuries, and implant-related factors. Late factors could be altered biomechanics in the operated spine, lead to a transition syndrome, change the load distribution with adjacent segment degenerations. And in fact, the study by Baklanov et al. Has shown that transition syndromes are known to happen even 5 years after lumbar fusion surgery. So in evaluating all this, one should be very careful in taking a good history, a physical examination, and proper investigations have to be organized to assess these persistent problems. So in the history, seek for any psychiatric comorbidity, workers' compensation claims, or personal disability claims should be noted, as these could lead to persistent low back pain. Accurate detailed pain history is crucial in delineating the likely source of the patient's pain, and a difference between predominantly axial pain and neuropathic pain, the presence of both, should be very clearly understood and analyzed. Eliminate any red flags in the history, any bowel or bladder disturbance, any new or progressive neurological deficit, signs of possible infection, weight loss, other symptoms may cause indicate underlying undiagnosed malignancy. This has been missed sometimes where patients have been operated for the low back and then found later on that they have a tumor or a metastatic lesion higher level, and this has to be corrected at that point of time. So a thorough documentation of previous treatment should be included during history taking, and similarities in the distribution of prior and current pain are also highly relevant, given that new source of pain may be an indication of unrelated pathologies. Examination should eliminate the presence of any ominous diagnosis, elicit clinical signs of high predictive value, and a detailed neurological examination is a must to understand why or what is the recurrence of the back pain. Investigative modalities can be an X-ray, can be MRI scan or a CT scan, and it's important that the appropriate and appropriate investigation is done to make sure that we have correct treatment. Plain electroradiographs are used in extent of previous surgical intervention, as well as in detecting substantial and clinically significant degenerative changes. Lateral dynamic radiographs have been shown to be superior to MRIs in detecting spondylolisthesis or in sagittal imbalance. MRI remains the gold standard owing to a superior contrast enhancement sensitivity compared to CT. An MRI with the gadolinium is a capacity to distinguish between epidural fibrosis, perineal cartilage, recurrent disc herniations of the pain, while being the best modality for detecting spondylodisthesis. CT scan is used when MRI is contraindicated owing to the presence of metal wear or non-cardiac pacemakers, where in old-fashioned motion sonography may be used. CT may be also useful in identifying facet or pedicle breaches, pseudarthrosis, owing to its fine slice superiority and osseous imaging. So briefly on management, conservative management should always have tried. NSAIDs are useful. Repeat surgery depends on predominantly axial mechanical pain. Consider repeat surgery, disabling problems are there. Removal of implants depending on what is related to. It's also important to consider the presence of significant adjacent segment disease, periprosthetic loosening, osteoporosis requiring appropriate medical management, etc. Neuromodulation can also be tried. And to summarize, some of the causes to keep in mind: wrong level of surgery, inadequate surgery, hematoma, fibrosis, etc., infection, pseudarthrosis, implant-related problems, and psychosocial issues have to be kept in mind when evaluating persistent or recurrent low back pain following lumbar fusion surgery. In conclusion, a multidisciplinary approach is needed. Proper identification of etiology is to be identified, and think many times before repeat surgery is offered to the patient. Thank you very much.
Thank you. Thank you very much for a brief update of the things. 2 questions we can take. We are short of time. So,
Dr. Ajay, I think Dr. Karthik is not online. Sir? Yeah. Okay. Yeah, sure. Sorry, I couldn't. Yeah, please. Any questions for Dr. Karthik? I think we'll allow one question. We are running nearly more than an hour late. So, Ajay, any questions are there on the dashboard? Anything?
Nothing on there. So we'll move forward. Thank you very much for the session.
Thank you very much.
Thank you.
Karthik gave an excellent overview about the entire post-operative pain scenario. So no more questions for him, I guess. Thank you all for having us here on the panel. And Umesh, great show. Thank you very much.
Thank you. Bye-bye.
Thank you very much, sir. Thank you very much for an interesting session. And now we move on to the next session. And this session was actually a brainchild of our Honorary Secretary, Dr. Arvind Kulkarni, who gave us the idea that we should have a quick bits session. So on safe spine surgery, tips and tricks for how to do a safe spine surgery. And as you can see, all these talks are about minimizing certain issues or certain complications that we can commonly encounter while doing any kind of a spine surgery. So Dr. Ankur Nanda is the moderator for this session. So Dr. Ankur, I would like to hand over the session without any further ado.
Thanks, Umesh. So I think we'll quickly go on to the session. So I think it's a very, very important session. And the first talk is on minimizing perioperative pain after spine surgery. And incidentally, I happen to be the speaker. Can I please have my presentation there? While they put up, I'd also like to welcome our panelists, Dr. Vishal, Dr. Rajamani, Dr. Ajit, and Dr. Chandan Mohanty.
Good afternoon, everybody. So I'm going to be speaking on minimizing perioperative pain after spine surgery. Now, it's a little bit of a dry topic for a surgeon, but it's very, very important to dwell into this, because if you've done a fantastic surgery and the patient is writhing with pain post-op, all your effort is going to be a zero. So postoperative pain is a form of acute pain that starts with surgical trauma with an inflammatory reaction and irritation of an afferent neural barrage and ends with tissue healing. Like any other disorder, the pain disorder has an acute and subacute phase, and postoperative pain is something which is part of this phase of the disorder. It happens usually in the first 3 to 4 days post-op, and the type of pain is moderate to severe. Post-op pain is something which is the most frightening aspect of undergoing a surgical procedure for many of these patients, and so it becomes very important to take control of this aspect. The factors to consider for an individualized approach for a patient would be to take care of his medical condition, look at his physical condition, the age of the patient, level of fear or anxiety associated with the post-op pain, personal preferences, and response to an agent may vary from an individual to an individual. If we fail to adequately manage post-op pain, it can lead to severe unpleasant sensory, emotional, and behavioral experiences like depression, helplessness, and anxiety. Not only that, it can also cause autonomic hyperreactivity with increase in heart rate, blood pressure, decrease in gastrointestinal mobility, decreased in your physical mobility, and interfere with your rehab program post-operatively. If you do not manage it, then the acute phase can convert into a chronic pain syndrome, and this is something which you don't want in any of your post-operative patients. Looking at the pathophysiology, we know that the surgical incision incites inflammatory response and leads to activation of prostaglandins, and overstimulation of the peripheral nociceptors leads to primary hyperalgesia, and mostly it's the PGE2 and IL-6 which are responsible for that. On the other hand, the NDMA receptors are responsible for the chronic pain, and the prolonged stimulation of CNS is known as the process is known as the central sensitization. The management of postoperative pain is complex, and the rationale behind is to combine different treatment modalities working at different pain mechanisms to improve analgesia and potentially to reduce side effects. And hence a multimodal approach becomes very, very important for these patients. This is an approach which is being used for last few years. So basically what you're doing is combining the local anesthetics, the anti-inflammatory drugs, the opioids, and trying to achieve the maximum pain relief with minimum side effects. Every hospital needs to have its own multimodal analgesia protocol. This protocol needs to be divided into pre-operative, intraoperative, post-operative, and post-operative sessions, and then appropriate drugs need to be used in consultation with the anesthetist, and this will lead to getting optimal outcomes from your patient. As far as parenteral route is concerned, you can use opioids. Morphine is one of the most popular ones, which is used as an opioid, although the problem of respiratory depression, nausea, and vomiting needs to be taken care of. NSAIDs are again a popular class of drugs which are used for analgesia. They block the inflammatory cascade and hence help in relieving pain and fever. But at the same time, NSAIDs can give some side effects like gastric ulceration, renal toxicity, platelet dysfunction, and one has to be careful in using them. Paracetamol is our good old paracetamol, which is very safe, and when combined with opioid can help in decreasing the opioid consumption substantially. Ketamine again is a wonder drug. It has a good direct analgesic effect. It's an NDMA receptor antagonist and also reduces the postoperative narcotic demand hugely. Steroids can also be used for a postoperative pain relief, but usually in the orthopedic spine surgeries, we tend to use them less in fear of complications of infection. Going from parenteral to central neuroaxial techniques, intrathecal drug administration can be done for pain relief, or an epidural drug administration can be done for pain relief. The agents which you can use are local anesthetics, narcotics, and steroids. And different techniques can be used like a single and double catheter, or you can use the patient-controlled analgesia devices. They are also quite successful. When you're using epidural local anesthetic, one must be careful not to cause motor blockade and use products like ropivacaine or bupivacaine 0.25% for selective sensory blockade. Preemptive analgesia is becoming more and more common now. Drugs like gabapentin and pregabalin are being used preoperatively to have good post-op control of pain. Also, local injections like lignocaine and ropivacaine are being used in the local site preoperatively and postoperatively to reduce pain. One of the things which I wanted to talk was about the TLIP block. Nowadays, this block is getting popular, which is the thoracolumbar interfacial plane block, wherein the target is the dorsal rami of the thoracolumbar nerve, and the block is given between the multifidus and longissimus muscle. It is likely to give good postoperative pain relief, especially in the daycare procedures and minimal invasive spine procedures. With this, I would like to end my presentation. Thank you so much.
Dr. Ankur, We have just now received the talk of Dr. Shajesh Menon. I just need a few seconds to load it. Then you can take the questions.
Sure. Sure. So I think we'll be directly going to the next speaker first. But if there are any questions from the panel or from the experts which are here with us. Okay. So I think we'll quickly call our my good friend Dr. Dhruvin Patel, who will be speaking on minimizing neurological complications after lateral approaches. So can we have Dr. Dhruvin's talk, please? Dhruvin, you are here?
Yeah, I'm here, Ankur.
Yeah, Dhruvin. Hi, how are you?
That's fine. Yeah.
Can we have Dr. Dhruvin's talk, please?
No, sir, it's ready. Just give me a second.
You mean to say Dr. Sajesh's talk is ready?
Yes, sir.
Okay. So we can have this. Then Dr. Sajesh's topic is minimizing infections after spine surgery. Can we have his talk up on the screen, please? Is Dr. Sajesh playing? Yeah, okay.
Good afternoon. Let us discuss how to minimize infection after MIS surgery. As you all know, that cervical site infection are a dreaded complication and it's a nightmare for spinal surgeons, which can worsen the clinical outcome, increase the healthcare cost, and harm the reputation and confidence of the surgeon. However, fortunately, the infection rate reported in MIS is much less, maybe 1/10 of that seems to be with the open spine surgery, and which is the beauty of minimally invasive surgeries. Reasons for reduced infection rate, as you all know, that we use a small surgical corridor, reduction in the exposed surface area, reduction in the dead space. Less muscle retraction means less ischemia, less necrosis, and better wound healing potential. Surgical field guarded by the tubes lead to less exposure to pathogens, and shorter hospital stay and with the MIS and the early mobilization is also contributing to this. However, there are concerns regarding the challenges a surgeon faces during the initial experience of the MIS systems, which means that is the longer operative duration and steep learning curve may amend the infection rate. How to minimize the infection? It is by optimization of the patient. If you maximize the optimization, you can minimize the infection rate. This optimization of the patient can be done preoperatively, intraoperatively, and postoperatively. All the modifiable preoperative related risk factors should be controlled before taking up the patient into the OR, like diabetic mellitus, chronic liver disease, steroid use, smoking, anemia, obesity, low serum albumin, and neuromuscular disorders. Revision surgery is especially more important that infection rate are double with the revision surgery than a fresh patient. Of the infective agents, Staphylococcus aureus is the most commonly encountered microorganism, which contribute about 40 up to 49% of infection rate. The current evidence suggests that routine preoperative Staphylococcus aureus screening with nasal swabs as well as eradication or using mucopyroxene ointment is an important step in preventing infection. This is especially true for a redo procedures or procedures. The preoperative antibiotic shower seems to be an effective way, and University of California Health recommended 3 showers, 2 in the nights before surgery and 1 in the morning of the admission and surgery can go a long way with controlling the infection. And next is the prophylactic intravenous antibiotics. Administration of broad-spectrum antibiotic covering Staphylococcus aureus, such as cefazolin, 30 minutes before the skin incision with redosing every 4 hours during longer surgery seems to be more effective. There is controversy regarding the choice of the antibiotic, but cefazolin seems to be a good alternative. And the recent evidence suggests that skeletal muscle concentration of cefazolin peaks with 30 to 60 minutes after the first IV dose. So initiating a parenteral prophylaxis with a cefazolin within an hour before skin incision is more desirable than a 30-minute injection. Patients who are allergic to penicillin or the cefazolin, clindamycin is a safe alternative. Of course, the theater setting should be is important. One should have a clear over. The laminar airflow system is also helps in reduction of infection. Less personnel and less traffic in the over can also reduce the infection rate. Skin preparation, the two commonly used agents are povidone alcohol and chlorhexidine gluconate alcohol. And studies show that there is significant low viable bacteria after skin infection with a sequential application of both these agents, povidone and chlorhexidine, compared with the application of only one, and it should be a good practice to prevent infection. Surgical gloves is an important source, is an important barrier against infection. Conclusion from a Cochrane review shows that double gloving significantly decreases the glove perforation and resultant infection. And indicator gloves of different color allow early detection of the perforation. And again, they shown that a significant reduction in SSI was noted with the removal of the surgeon's outer pair of gloves prior to handling the instrumentation compared to wearing the same pair of double gloves on the entire time. Image intensifier is an integral part of any MIS surgeries, and it can be a potential source of infection too. The lower portion of the image intensifier is undergoes constant changes in position that can be a source of infection. So a freshly draped the lower portion of CM each time the image intensifier is positioned for a lateral exposure is very desirable to prevent infection rates. Another potential source is a microscope. So microscope draping should be meticulous, and one has to use aseptic precaution while handling the eyepiece, which can help in reduce the contamination. Change the gloves every time after manipulating the optical eyepiece and avoid contact with the portion of the drape above the optical eyepiece should also be observed throughout the procedure. Wound irrigation irrigation is an important step. Many agents are used. The infection rate was significantly lower, and it seems that infection rate was significantly lower with the povidone iodine solution. However, despite this encouraging result, concerns exist regarding the potential negative effect of povidone iodine on tissue at the cellular level. Intra-wound vancomycin powder application is a commonly done procedure now. Routine, there is high-level evidence show that routine application of vancomycin powder, both in adult about 1 gram and a pediatric 0.5 gram, patient undergoing instrumented posterior spinal procedures to decrease the risk of SSIs. Another important factor is intraoperative oxygenation and body temperature regulation during surgery. Based on the current evidence, it would be most reasonable to suggest keeping the FiO2 at 50% and body temperature between 36.5 and 37.5 degrees throughout the spinal procedure for optimum results. So post-operative optimization is also important. Antibiotic impregnated or silver impregnated dressings are useful in preventing superficial skin infection. One should observe meticulous wound care. Close suction and drainage is if indicator should be used. Good glycemic control is essential. Early mobilization and redosing of the antibiotics if indicated can also prevent the post-op infections. So, conclude, observing the correct surgical practice in minimally invasive technique markedly reduce the risk of post-op infection when compared with the open spine surgery. A happy patient means it is a happy surgeon. So, please observe it meticulously to prevent post-operative or prevent or reduce the post-operative infection. Thank you very much.
Thank you, Dr. Sajesh, for the very informative talk. So, Dr. Sajesh, just are there any tips to be for all of us for intraoperative reduction in how we can reduce the infection, like the amount of retraction of the tissue or timing of repeating of antibiotics? Do you have any fixed protocol for that?
See, our protocol is that we start the antibiotic infusion 1 hour prior to the surgery. And every 4 hours, we repeat 1 gram of antibiotics. Usually, Rasolin is the preferred choice. And if patient is allergic, we go for clindamycin or something. And it will be repeated till the end of the surgery. And post-operatively also, we will give 1 dose of antibiotic. That is our protocol observed in our hospital.
And usually the wash which you give, is it a clear saline wash or is it mixed with any particular agent which you prefer?
Initial washing, in between washing and all will be done with the saline only, but the final washing will be done with the diluted betadine or coordinating solution. And after that, we'll put the vancomycin powder also in indicated cases, especially in instrumented cases.
Sure. Are there any other questions for Dr. Sajesh from any of the panelists?
I think Dr. Sajesh summed it up very well. Changing of gloves. A lot of time I see my colleagues handling the eyepiece and then going back and handling their implants or instruments again. So one of the checklists we have is every time we adjust the eyepiece, we change our gloves. We change our gloves before putting any implant inside the person. And if anything is touched below the waist, it is considered an unsterile, is considered a sterile breach. Other thing is a lot of people, the antibiotic has to be, there might be a gap between the antibiotic and the induction. It has, the incision has to be ideally between half an hour to 45 minutes of administration of the particular antibiotic. Surprisingly, the majority of infections we are seeing are because of gram-negative organisms and not Staphylococcus aureus. And one of the most common contaminant found is scrubbing water. It's a fecal contaminant, basically gram-negative organism. So you should have, it's even in small nursing home setups, you should have a sterilizer, like maybe one of the ultraviolet sterilizers for the water that you use for scrubbing, or you should use normal saline to scrub. These are certain things that help in preventing infection.
Sure, I think that's a very important
one thing you can do about the scrubbing part. Yeah, one thing you can do about the scrubbing part, we usually do chlorhexidine. After once you scrub when you dry and you have to dry your hands, then you can take some chlorhexidine to wipe again to make your hand clean. That is the usual practice we do in our institution.
Good. One of the funny point I've seen is these the other end of the Siam. People, trauma surgeons, etc., left, right, and center, they assume it to be, sterile every time they take a lateral. It goes underneath the table. It knocks the table, but still it is presumed to be. I've seen many surgeons do that.
So I think that's a very important point. The underside of the other side of the C-arm is always unsterile, and I think we should try as much as that we don't make the lateral. Once you have come to the lateral, you drape it and you don't take it to the AP unless it's absolutely necessary. Otherwise, the whole draping has to be changed again and again. Also, one thing which I thought was very important was, when you're doing, let's say, surgery and it's long, the retractors and the retraction of the soft tissue also has to be very, very regular. And this is something which a lot of us miss. We don't relax our soft tissues every 45 minutes an hour. And if you keep it retracted for a long time, there's a lot of devascularization, and it's a good home for the organisms. So timely washes, as Dr. Sajesh said, and relaxation of the musculature is very, very important, along with the timing of the antibiotic. I think so. Points well taken. And we can quickly go on to the next talk. This time again, I'm going to invite Dr. Dhruvin. He's speaking on minimizing neurological complications after lateral approaches. Can we have his slides, please?
Can we have the next talk?
Can we have
Shall I
Dr.
start Dr.
Jovit's?
Govin Patel's
Yes,
video?
please. Yeah. Please start his talk.
So my topic today is minimizing neurological complications after lateral approaches. It all starts with positioning. One has to secure the patient adequately with multiple tapes. It's also vitally important to pad the axillary region and the fibular head on the right side. This is how generally I secure my patient in the lateral position. I put one pillow between the knees and two pillows between the ankles and apply the multiple tapes. Also, it is not wise to break the table as like an actually for a D-lift procedure, because that would stretch the psoas muscle as well as it will put the femoral nerve under a stretch. I keep my table straight. It's amazing that we negotiate between the abdominal wall layers between so many multiple nerves which are innervating the abdominal wall muscles. So it is very, very important to remain in the direction of the muscle fibers whenever we negotiate the abdominal wall layers, and not to violate the direction of the abdominal wall fibers. Because no matter how small the nerves are, once you damage it, it will have consequences post-operatively. There are various tricks to navigate the abdominal wall layers. Important thing is basically to split the abdominal wall layers in the direction of its fibers layer by layer, either with a finger or with a scissor. But it is always separating, never using a monopolar cautery. Also, it is important not to coagulate the vessels which are sometimes bleeds from the abdominal wall layers, because many a times they are accompanied by small nerves. So be careful when you use bipolar cautery in the abdominal wall layers. The important nerves which are likely to be encountered in the lateral approaches are the iliohypogastric and the ilioinguinal nerves. Once these nerves traverse along the anterior surface of the quadratus lumborum, they traverse between the internal oblique and the transversus abdominis muscles. So once you split the internal oblique muscles, be very, very careful for these nerves, because if there is inadvertent injury to these nerves in the lateral approaches, post-operatively patient will complain of severe paresthesia or a burning or a tingling along the groin and the anterolateral thigh region. So be very, very careful between these two muscle layers. Also, genitofemoral nerve lies over the belly of the psoas muscle. If there is injury to these nerves during the psoas belly retraction, post-operatively patient will complaining of groin paresthesia and burning. So be very, very careful with all these three nerves. Important thing is to visualize in the retroperitoneal cavity. It is okay to do a finger dissection for a while, but after a while of a finger dissection, put your long detractors or a devers, try to look in the retroperitoneal cavity, identify the psoas belly. This is how generally I do peanut or a swab dissection along the anterior aspect of the psoas belly and the loose areolar tissue between the psoas belly and the iliac vessels. And I try to retract the psoas belly with my swab holder. Identify the genitofemoral nerve over the psoas belly directly. It just lies over the psoas belly. Lift it attached to the fascia of the psoas belly. Do not try to separate the genitofemoral nerve from the psoas belly. Let it get retracted along with the psoas belly. Important thing is to retract the psoas belly adequately. One may use fingers initially to dissect and to retract the psoas belly adequately. Many times the psoas is pretty bulky, and at that time it's difficult to retract it posteriorly. Sometimes we have to erase the anterior third of the psoas which is attached with the disc surface itself. You can use a bipolar cautery or some peanut dissection to erase the psoas muscles from the discal attachment. But be sure that how much you retract your psoas belly, because sometimes the lumbar plexus can get compressed between the transverse process of the vertebra and your retractor. So be careful with your retraction time. Sometimes there is a strong tendon of the psoas muscle and it makes the retraction of the psoas belly a bit difficult. But take your time, use a peanut dissection multiple times, but do retract the psoas belly adequately if you want to prevent any lumbar plexus nerve root injury during this oblique or lateral approaches. Avoid sympathetic chain as far as possible. The sympathetic chain lies between the psoas belly and the aortic vessels. Sometimes it may not be possible to preserve it entirely. If at all it needs to be sacrificed, sacrifice it at a disc level and not at the body level. Patient will have temperature sensation sometimes in the ipsilateral leg, which may persist for a while. But be cognizant of the sympathetic chain as far as possible. Be cognizant of the contralateral foramen also, because although it's an oblique approach, it's essentially when you implant it, it's a direct lateral approaches. because if you are not orthogonal to the plane of the patient or the disc surface, it's easy to target the contralateral foramen and damage the ganglion in the contralateral foramen. So be very, very careful, because when you insert your trial or a cage, you may be oblique, but once you finish it, you should be perpendicular to the patient. And this is very, very important in case of a degenerative scoliosis, especially left convex one, when the bodies are rotated towards your side. And it may be a bit difficult, it may be time consuming to remain orthogonal in that direction, but it's very, very vital. Avoid the psoas hematoma post-operatively also, and be sure that you have a meticulous hemostasis once you close it, because any psoas hematoma, retroperitoneal hematoma, can compress the lumbar plexus nerve roots, which is lying within the substance of the psoas muscle. Also be careful during the closure of the abdominal wall layers. There are small nerves which are within the substance of these layers or along the surface of these layers. So when you bite your sutures, be very, very careful not to entangle any nerves layer by layer. Be very, very meticulous with your closure. Thank you very much.
Thank you, Dhruven, for your talk. So, any questions from Dhruven from any of the panelists? Dr. Rajamani?
Hip knee is bit flux. Probably will relax and then.
Ankur, can I ask?
Yeah, so I think Dr. Rajamani is saying something, and Dr. Rajamani, actually you are not audible.
Am I audible now?
Yeah, you are audible now.
Yeah, keeping the hip and knee flexed, both sides. Usually we keep one flexed and the other contralateral limb a little bit extended to keep the patient stable. But keeping the both hips and knees a little bit flexed 30 degrees probably will help to keep the anterior group of muscles.
Yeah, I think that's very important. Yeah, Dr. Bharat sir.
Yeah, Dhruvin, you know, we usually go from the left side for the olive. Now, if the scoliosis is other way around, any tips?
Bharat sir, you're muted. Unmute yourself.
Bharat sir, you're muted.
Sorry. Dhruvin,
yes,
we usually go from the left side, and that is what the approach is. Now, if the concavity is on the left side, then any tips how to circumvent that? Because it is very difficult.
I agree, sir. It would be very difficult. And on the concave side, when the left side is concave, there will be very huge osteophytes along the concavity. So that might make taking entry operative pretty difficult. But still, I have done a few cases from the left side only. The big good part is that even if it's a single incision, you can target 2, 3, 3, 4, 4, 5. But at the same time, there would be crowding of the muscles. And generally, in that case, I have to knock off the osteophyte with osteotome before I can get entry into the disc space. So whatever cases I've done is only from the left side. I have never approached it from the right side. But yes, left concave would be a bit challenging to operate upon. I agree.
Okay, are there any further questions from anybody? If no, then we would move on to our next speaker. Dr. Shailesh Hargaonkar will be speaking on minimizing cement leaks after vertebroplasty or balloon kyphoplasty. Yeah, you can start the talk, please.
Hello. We'll be talking about the minimizing cement leak in vertebroplasty or kyphoplasty in this MSAB surgical symposium. When we talk about vertebroplasty, it's one important procedure for osteoporotic or metastatic compression fracture for pain relief. And sometimes there can be problems of cement leakage, and we need to understand these factors. Cement leak has been widely published in the literature, and nowadays with the better imaging and better viscosity of cements, the leaks have reduced, but still we have to be concerned about epidural venous leak, epidural space leak, the neuroforaminal leak. Cement towards the disc usually do not cause a clinical consequence. Leak into the paravertebral vein leading to the pulmonary event, also in the basivertebral vein leading to pulmonary embolism. Leak into the intercostal vessels been shown by CT in some reports. This was the landmark paper by Yom et al. In JBJS, which spoke about 3 types of leakages. One is the basivertebral vein and leakage into the pulmonary vasculature and devastating complications like pulmonary embolism, which was the most dreaded a complication of cement leak. And second was the segmental leakage, which is type S, and third was cortical leak, which is type C. And all these leaks are important when we are doing a procedure. Normally the type B and type S are not seen on image intensifier, which are commonly used by orthopedic and spine surgeons. These are the leaks which they have mentioned in their landmark paper. The leaks adds the epidural space into the surrounding area, into the cortical breaches, into the foraminal and neural areas, also in the discal space. These are the most commonly seen cement leakages, and we have to be very, very concerned. A lot of papers have spoke about the worsening of neurology after the epidural cement leakage, and this is a paper of balloon kyphoplasty leading for lower limb neurology, where there was cement into the canal. Cement leakage, is it an underestimated problem? And this is an article in 2005 where there was vertebroplasty as a very commonly done procedure, and it was gaining significant popularity. But nowadays we understand there are surgeon factor and surrounding factors. Everyone talks about how much amount of cement we should use, how much temperature should be there in the operation theater, and the assessment is very, very important. The assessment about timing of the procedure, assessment about the X-ray, the morphology of the fracture, the retropulsion from the MRI scan, the fracture morphology, and the instability pattern. All these things are very, very important when we talk about cement leak in a vertebroplasty. And in this procedure, we understand that the amount of cement injected into the anterior and middle zone of the vertebral body normally gives you a good mechanical stability. At the same time, the thermocoagulation effect, and that is how the pain relief procedure is done. Anatomical location is the key, and normal preferred area is anterior third into the vertebral body. Either you do it by CT scan or by this C-arm. Important about the direction, again, we have to have a proper convergence and angle of inclination according to the vertebral body when we are using, and always make sure you are checking it in AP and lateral when we are using the C-arm. In upper thoracic, normally prefer a smaller pedicle, therefore smaller gauge needle should be used. Volume, does it matter? Nowadays, most of the surgeons prefer 2 to 3 mils or cc of cement for thermocoagulation effect or for the burning of the nerve endings and giving stability also. We don't need to inject a larger volume as it was propagated in earlier times. Also, the viscosity, the high viscosity was considered as a better cement for preventing leaks a decade ago, and there were a lot of papers also about the kyphoplasty and high viscosity cement. This was becoming almost the standard, but nowadays there are papers coming which are talking about even low viscosity cement giving a better vertebral stability and less leakages. The delivery system, again, they are important. If you use a proper delivery system with guarded or hydraulic systems for injecting the cement under the image intensifier, these are very, very important things which really can help us giving a graded and guarded cement injection into the vertebral body, preventing problems of leakages. And even there are papers which have talked about various different techniques like making zones 1 to 5 and injecting 1 mil in each zone. We have our own experience of gel foam embolization in vertebroplasty by injecting the mixture of saline and gel foam around 4 to 7 cc, and we have very good outcomes as we check it into the dye before and after the gel foam, and this technique we have published in JOR. Again, important is to understand the cement, and opacity of the cement is going to tell us how much cement and where exactly we are injecting the cement. We need to understand the working time, the setting time, the dovey and paste-like consistency for injecting the cement. Mind it that most important things are the inadequate cement opacification leading to cement leakage and hurry to inject even before the cement hardens. These are the two things which have led to problems and cement leakage. Thank you very much for patient hearing. Thank you.
Thanks, Shailesh. It's always a pleasure to hear you. Shailesh, any experience between the cement leakage rates, vertebroplasty versus kyphoplasty? Do you think there is any difference, or do you think it's the same for both? You are muted, Shailesh. Just unmute yourself.
Yeah, outcome-wise, there is not much of a difference. See, basically, the concept of vertebroplasty or kyphoplasty, how it works. The most important thing is thermocoagulation. It is not about the amount of cement or, it is basically the nerve endings and the fracture pattern which is causing the instability, and that pain we need to stop. First is that we need to burn that nerve endings. Second is to give some amount of stability to the vertebral body. These two things are important. It's in a very, very subtle population where we restore the sagittal balance. Yes, kyphoplasty has the advantage of slightly better sagittal balance, but not.
Shailesh, sorry to cut you there. Sorry to cut you there. So I'm not talking about the result part of it. I'm talking about the cement leakage rate of it. Do you feel there is any difference?
The literature is biased. It is showing the outcomes are better with kyphoplasty in most of the cases, but there are papers which are talking about the leakage in even kyphoplasty. So I don't think it is significantly different.
Sure. Dr. Rajamani wanted to say something. Sir, you are muted as well, sir. Can you please unmute yourself?
See, the incidence is more in vertebroplasty than kyphoplasty.
Dr. Gautam?
I'm Gautam. Sorry to put in butt in here, but what is important is not leakage. What is important is symptomatic leakage, which is what Shailesh has been trying to emphasize. And the symptomatic leakage rate is absolutely the same between vertebroplasty and kyphoplasty. You may say that because vertebroplasty is a high pressure injection and kyphoplasty is a low pressure injection, the leakage rates are better, lower in the kyphoplasty rate, but symptomatic leakage, as Shailesh mentioned, is not really any different. And in over 20 years of experience with vertebroplasty, and with having done more than about 600-700 cases of vertebroplasty, I can assure you that over these years I've had just one single complication when I was really stupid and had a really serious problem, but that was at the very beginning of my career. After that, we've not had a single problem of leakage, symptomatic leakage.
Yes, sir.
I would like to add up one thing, Ankur, is that a lot of people do vertebroplasty and there are indications. Normally, we prefer to wait for 3 to 6 weeks before we inject in most of the time. But there are people who are doing vertebroplasty even whenever they see the fracture. And I've had conversation with these guys, and there is a lot of leakages. And then when we talk about vertebroplasty versus kyphoplasty, it is the indication is important. When you are doing the procedure is important, and at what stage you are doing it's also important. So I think the literature is biased. It's going to be biased, but it's a comparable result from my practice and the latest.
I think that's the important point which you have brought out when you are doing it and the indication. Just one last question to Shailesh. Shailesh, any tips for the youngsters when you are doing a vertebroplasty, when you see a posterior cortical breach in the vertebra, which may be either because of an osteoporotic fracture or maybe because of a metastatic? Any special tips which you do when to make sure that
I think stop the cement injection the moment you see.
Yeah, I think there is some net issue.
We lost his voice.
Yeah, we should stop when you see something like this. And most important is don't rush for injecting before the paste-like consistency of the cement. Go gradual, go slow. No need to rush in. No need to get excited. Sometimes in that excitement, you are getting good amount of feeling. You keep pressing. And that is where you end up in trouble. So I think check it in AP and lateral. That's important. Don't get excited when you're getting a good feel. Always check it in the C arm.
Another thing you can do is start injecting in the anterior part rather than in the middle and in the posterior part.
Yeah, that's the
rather than middle in these people.
I think both the things, making a paste-like, waiting for the paste-like consistency and the region we are injecting. Also, there's a technique which was popular called the eggshelling technique, wherein you put a little bit of amount of cement, you put your balloon, inflate it, let the cement line the cavity, and then you go ahead and do this real cementing next. So that will also prevent the posterior leakage. Anyway, for the want of time, I think we'll quickly move on to the next topic. And this presentation is by Dr. Rakesh Luhana, and he's going to be speaking on minimizing guide wire related complications in posterior pedicle screw fixation. So can we have Dr. Rakesh's slides on, please?
Good afternoon, everyone. My talk is on minimizing guide wire related complications in percutaneous pedicle screw fixation. So guide wire is an integral part in percutaneous pedicle screw fixation. You place a Jamshedi needle over which K wires or guide wires are placed, and then serial dilator, and then you put a tap over a guide wire, remove the tap and put a screw over guide wire, and at that time guide wire is removed. So at any of this step, complication can occur. So what is the literature about guide wire related complication? So this is a comprehensive literature review of complications associated with guide wire use in spine surgeries involving pedicle screw placement, which summarizes various articles which were published between 1988 to 2017. And it suggests that the risk of complications is between 0.4 to 14.8%. Here, majority of cases are retrospective study, and prospective study usually shows more complications. So yes, there are complications related to guide wire, which includes blood loss, retroperitoneal hematoma, injury to visceral organ, guide wire fracture, CSF leak, postoperative ileus, infection, etc. So what are the causes of complication? Ventral migration of guide wire is the most common complication. If that migrates less than 5 millimeter, sympathetic plexus is at risk. If it is between 5 to 25 millimeter, apart from sympathetic plexus, major vessels at risk, which can lead to aneurysm, pseudoaneurysm, or a retroperitoneal bleed. And if guide wire migrates more than 2.5 centimeter, there is a bowel at risk. Breakage of guide wire is another complication. Most common cause of this complication is inexperience with guide wire use. And very important is there is lack of tactile and at times visual feedback during MIS procedure. What is the impact of complication? Majority of complications are minor. So they impact predominantly on radiation exposure, healthcare resource use, increased operative time, and at times it is frustrating. Increased risk of complications are also noted in osteoporosis, obese, and L5S1 level. So what are the tips to minimize guide wire related complication? So guide wire should be blunt-ended and serrated at the tip. That serrations would give you a tactile feel as well as it will engage in a vertebral body, which prevents back out. Guide wire should be of sufficient length so that you can hold one end while tapping. How do you prevent ventral migration? Don't go too deep with Jamshedi needle. Stop at mid-vertebral body level. And while placing a guide wire through Jamshedi needle, be mindful and check under CM. Here we were preparing for this talk, and in the same case, my guide wire went ventrally. So you have to be mindful. And while tapping over a guide wire and placing screw over guide wire are the steps where the chances of ventral migration are high. You have to be vigilant and check under CM. Like here we went too far in, and that is stressful. Till the patient come out, you examine his bowel, look at vitals. It's very, very stressful. So it can be avoided and should be avoided. So when you're putting a tap over a guide wire, make sure that your assistant or you yourself hold it while tapping and check under CM. Accidental removal of guide wire is frustrating and it takes time to get there again, or you might have to at times make a new hole. So fix it with artery forceps while performing other steps. Prevention of guide wire fracture, avoid multiple usage, be in line of guide wire while putting screw in. You can't change the direction of screw with guide wire in. That is very, very important. So usually guide wire related complications are not that major, but it adds stress, anxiety, frustration, time, radiation exposure. So what are the invention to minimize guide wire related complication? This is a very interesting device which has been designed by a Japanese group. They invented a percutaneous guide wire for percutaneous pedicle screw insertion. It is called S-wire. So here they have made a 9 braided wire which forms a kind of tube in a stainless steel hollow tube. So when you place it, it's like this, but as soon as there is pushing resistance, there is more force, it would open up. The braided wire would open up and it won't pass through anterior vertebral body. So it's very, very interesting device. Another is minimally invasive guide wireless navigated pedicle screw placement. So here they have obsolete guide wire, and they use awl and tap under navigation followed by directly screw under navigation. So summarizing tips, being aware at each step is important. Taking frequent C-arm shoot, holding guide wire while tapping over it or putting a screw over it, and fixing a guide wire when performing other steps, and eventually switching over to guide wireless system would eliminate it. Thank you.
Thank you, Dr. Rakesh, for the nice presentation. Any questions for Dr. Rakesh, Dr. Chandan or Dr. Ajit Naik, if they would like to ask something?
One addition, it's not a question. In fact, sometimes the guide wire gets stuck up while you tape and then untape. Any situations like that, guide wire got stuck into the tap before tapping.
The guide wire gets stuck, so sometimes it gets stuck into the tap, yeah.
Along with the tab, while you remove it, it comes along with the tab sometimes.
Yeah, it does. Vishal, any comments on this? Have you encountered the same problem?
Of guide wire coming out of with the tap, yes, it comes out plenty of time, especially when you're using, like we use an OAM-based navigation. So, and I use a lot of local Indian screws. So Indian guide wires are thicker, and they get definitely tend to get stuck in the Metronic tab that we have as a part of the navigation. So one of the solutions for that this is to see that your tap insides are cleaned every time you have tapped a single screw. So if you're doing a single level fixation, you tap it the first time, take it out, take out all the bone pieces by putting in a guide wire, flushing it with saline, so that the next time this doesn't happen. Other thing is to see that the guide wire and the inside of the tap are compatible in their size. Check it before you put it in rather than after the guide wires have gone in. Third thing is the majority of the guide wire advancements will happen in osteoporotic patient. If the patient is not osteoporotic and if your guide wire is advancing, then it's probably because you're not aligning your tap to the way the wire has gone in. We do a couple of things. So to prevent radiation, so the moment I put in my tap and the tap is touching the bone, and before I start tapping, I get my assistant to put a clamp from where I started. And then I start tapping. So if that distance is not increasing as per the amount I have tapped, then I know my guide wire is migrating forward. That's the time to take a shoot to see that we are not doing going forward. Other thing you should do, majority of them are again going to happen in S1, where you want to go and breach the anterior cortex to get a tricortical hold. So one of the things you should do is use a guide wire, take your tap. I use a lenke, go to the opposite side, bang it open. And then I take a guide wire, make a small bend at the tip. I'll take my Jamshedi. Before I put the Jamshedi again in the hole that has been made, I measure what is the distance of the guide wire when it is going to cross the tip of the Jamshedi, and I mark it. So when I'm there, I know, okay, this is just going to cross the Jamshedi. I would put in a few centimeters in. Because the tip is bent, the moment it comes out of the Jamshedi, it will go to other direction rather than straight into the hole that you have made anteriorly. And this will stabilize. Once you can put in your screw so that this doesn't migrate forward. This was a hard way to learn because I've had the misfortune of two guide wires traveling forward, and both of them were at S1. I remember calling Arvind and Vikas Gupte. This is 10 years back in panic. Arey yaar, aisa ho gaya. So one of the things you should do if a guide wire migrates forward is first change the guide wire. You never know if it has touched a perforated bubble. If you're going to use the same guide wire, there are chances that while taking it out, you have some fecal material or something attached to it, and chances of infection are high. It's better to change the guide wire there. I prefer blunt threaded guide wires so that they don't migrate so easily. Having said it, they can still do. The best idea is to have somebody, your assistant, hold it. If the wire comes out, I mean, yes, it's a 10-minute extra job to put it back again in the same hole. But I would rather have a guide wire walking out than walking in, because if there's anything that can create a life-threatening or a very bad complication, it's a guide wire in an MIS lift.
Sure. So I think
just one point, Anur.
So
just
Umesh
really
is
saying,
waving at me for we are running really late. So I'm really sorry.
One tip
Yes.
I'd like to.
Yes, sir.
One
Please
tip
last
I'd
comment
like
and
to.
then we go ahead.
When the guide wire is stuck up, you hold the guide wire firmly, and either you have one turn forward or backward without allowing the guide wire to rotate, and then you try to remove it, will come off. Usually that happens occasionally, not very common.
Okay, so point well taken. So we quickly move on to the next talk, and the topic is minimizing dural tears during MIS procedures, which is going to be presented by Dr. Bala Molli. Hi, Bala. Can we have his presentation, please?
Hi. I'm Dr. Bala Molli, spine and neurosurgeon from Chennai. I'm going to talk to you about how to minimize the dural leaks in MIS surgery. You need to understand the anatomy, where the ligaments called the Tollard's and the Hoffman's ligaments attach in the midline, which are the commonest causes of a dural tear when you don't notice it. The types are either an intended dural tear where we make an incision, or an inadvertent where it's due to trauma. Lumbar surgery, primary, is much less compared to the revisions. However, in minimally invasive surgery, initial reports were high, but the results are usually between 7 to 9%. And the causative instruments are misuse or improper use or slip of a kerosene ronger, a disc punch, or a high-speed drill, or slipping of an implant. So because your working corridor is so minimized, these damages can happen. The tear is either medial, mediolateral, or very close to the root sleeve. If it is something medial, it can be repaired. Mediolateral can also be repaired, but something in the root sleeve is very difficult to repair. Now, how to avoid these CSF leaks? So first thing is you need to anchor and support your work so that your instruments don't slip. Get to the bone and stay close to the bone. Work in such a way that the slip will move your instrument away from the dura, not on the dura. The surgeon using a burr must use the pedal and avoid the assistant using. Optimize good light and magnification. Probe questionable areas with blunt instruments. Use a patty to protect. The minute you get a dural tear, put a patty so that neural elements don't come out. Beware of neural anatomical variants. Operate from normal towards abnormal areas, and expose the laminectomy margin from lateral to medial. So the principles of CSF leak are is close with patty, to position the patient, inform your anesthetist, and elevate the patient. And if it is in the cervical spine or the lumbar spine, is to put the patient down. To reduce the suction in the sucker. Use cottonoids to increase safety in the sucker. Optimize the access of the defect. Consider a nice microscope. Get all your instruments ready and an assistant. So there's a combination of things that have been used, and it varies from department to department, surgeon to surgeon, and experience from one center to the other. But suturing of a patch or a staple, so will give you the best watertight results during a primary closure. You can use a 5-0 Prolene or a 6-0 Prolene, but you need good micro instruments. When not to suture, if the breach in the dura, the arachnoid is intact, then you don't need to do that. If it is a very small tear and if it's a very tiny, minimally invasive approach that you're using, the muscles will close together and there is no need to do a dural repair. You can use a collagen sealant, collagen or a sealant if necessary. Patches can be used like muscle graft, fat, or any other material can be used. Wound drains are highly debatable. If you look at the various studies, you can see that the drain has been used in some, not used, and some have not used. Bed rest again is debatable. In my practice, I do not give any bed rest unless it's a very unconvincingly closed dural repair and I'm not happy with the skin closure. Antibiotic prophylaxis may be necessary, but I don't use them. Any medication, stool softener, acetosolamide does not have a role. But stool softener as an antiemetic is important to reduce the pressure. When you're using through small tubes, you need to understand where the position of the tear is, access to close, the technique and the alternatives. Make use of hooks. Make sure you have all micro instruments, not pushers. And you can see that when you're during opening and your dura is very close, and if you're not very careful, it's very easy to cause injury to the dura. And there you can see that we try to repair the dural tear successfully. Even giant thoracic disc tumors can be closed very safely. You can sometimes leave them open. Watertight closure is not always necessary. U-clips can be used. There are various complications that can happen from pseudomeningocele. There's a big difference between open and MIS. This is another case of an anterior disc herniation through a defect where you can keep a small patch going around and still repair a CSF leak. So in summary, suturing fibrogen gels can be used. If you're not suturing, a patch with the glue can be used, and lumbar drain. Valsalva maneuvers can be tried to see if there's leak. Watertight closure is very important. No drain, no additional antibiotics, antiemetics, and salt fixtures can be used, no bed rest. Thank you very much.
Thank you, Bala. As usual, very good and crisp presentation. Any questions for Dr. Balamurli?
So I had a comment. It's a very good presentation, Dr. Balamurli. For tears in the dural root sleeve, which are usually the most difficult to suture, what I personally prefer is usually to take a small amount of fat, and I just plug the fat so that 2/3 of the fat is inside the dura and 1/3 is pouching out like a mushroom. So that works well in my hand. I don't even attempt to suture when we have a tear in the dural root sleeve. This plugging of fat and then putting a glue on top usually works well.
Sure, I agree. Root sleeves are very difficult. You can try various things. You can use a fibrin glue or something, but I wouldn't even attempt to close a root sleeve tear.
Agree.
Bala, can you just, for the benefit of the young surgeons, can you just tell us what is the most common site for dural tears when you do a tubular decompressions, and how do you manage them?
Yeah, so when you're doing a simple tubular, either a micro discectomy or a decompression or crossing over, the tear is usually in the mediolateral. So it is just about the root sleeve at the shoulder where you're trying to retract your nerve root in order to go to your disc. Or when you're doing a midline decompression or crossing over, it is more towards the midline. If your dural tear is complete and there is complete CSF pouring out, you have two options. You have either an option of trying to get a stitch, and most people, when using an 18 or a 22 millimeter, between 18 and 22 millimeter port, you're probably not used to closing your dura through such a small defect. So majority of times for a discectomy, I will not do anything because your tear is usually going to be a few millimeters. So I would just leave it. Give a good closure once you take your tube off your fascia. The fascial closure is very, very vital. And then your skin closure again, you could either do and sub as you normally do, or you can put in clips or even more ethylon sutures. So this is a way I would manage a micro discectomy. If the tear is too deep, if you're 3 to 4 millimeters, nerve roots come outside, and you're concerned about it, then I definitely would attempt to close with a 5 or 6 unit, and then you can use TC. I've just found that over the years, using a TC or any other fibroglue has no major difference. The end marketed, most of us use, is more for our satisfaction more than anything. Use the glue or leak and patient. These are the simple techniques. Avoiding dural tear is vital, but if you do get a small tube, do not panic. You can still get your patient next day off and going, and still patient is going to be fine.
Thank you, Bala. Thank you, Bala. So, want of the time, we'll move ahead. I would invite next speaker, another master from Chennai, Dr. Karthik Kailash. Over to you, Dr. Karthik.
Pedicle screw fixation is the norm in spinal surgery these days, and more so with minimally invasive surgery. All the more we have to know how to minimize our errors in putting these pedicle screws. So, pedicle screw problems can be malposition in the facet dilation or pedicle breach or anterior cortex. These are also the more important problem.
Dr. Bhupesh Patel, please mute yourself.
Now, the replacement rates have been recorded between 4 and 25% in our own studies, as well as Dr. Vishal Kumnani's studies recently published in 2020 have shown it to be around about 5%, with lateral breach being more common than the medial breach. Now, the facet violation and breach is very important because it can lead to adjacent segment degeneration, and therefore it's all the more important for us that we have proper placement of our pedicle screws on when we're doing minimally invasive surgery. So how do we avoid it? There are three things: by appropriate X-ray technique and operative technique, and by using newer technologies. Now, when you look at the 2D fluoroscope, you always make sure that you identify the disease level. You want to correct orientation and avoid rotation. And you also want to maximize this so that the errors are minimized in doing our procedure. So make sure the C-arm is seen for position to see one level properly. End plates are parallel, pedicles to be the upper half of the body, and the spinous process equidistant between the pedicles so that there is no rotation seen at all. This is an example of a good AP view where you see the pedicles at the upper half, the end plates are thin and parallel, and there's no rotation. Improper AP view, which you should not use because you can lead to errors. Again, you'll find here the spinous process is equidistant between the pedicles, and when it's moved to one side, you know there's rotation. So either rotate the C-arm across to make sure that the position is again reoriented like the one in the above picture. Then going on to the lateral view, you make sure the same things have been visualized exactly like above on the lateral view. And also more importantly, the pedicles are superimposed so that you don't have two pedicle vision, and therefore you reduce your error margin. An image which shows the top two lateral where you can see thin end plates and the pedicles being superimposed. The third view is the end phase view or the coaxial oblique view, which gives 10-20 degrees oblique view to the AP. This view gives us an image directly into the pedicular canal, which is the largest, the widest view of the pedicle, and this can be used if you're going to do what technique is called down the barrel technique, where you're going end on. Now, once having visualized this, you go on to putting your skin incision 1.5 centimeters lateral to the lateral margin of the pedicle, ensuring that you're not going to have a medial violation at any point of time. Once you land this, then you land on your transverse process. You land on a transverse process and walk your jam shooting needle across to the entry point, which is formed at the junction of the transverse process, the superiorarticular facet, and your pars intra-articularis. At this junction, you will find a small hump over there, and you enter into this at either the 10 o'clock or the 2 o'clock position, depending on the right or the left side you're operating on. And this will ensure that you're on the lateral margin of the pedicle. Once you're there on the lateral margin of the pedicle, in the AP view, then go ahead and ensure that your needle is moved into the pedicular canal, ensuring that it does not violate the medial border of the pedicle. Once you reach the medial border of the pedicle, switch your C-arm into the lateral view to make sure that your needle is still staying at the posterior vertebral body junction and is not gone beyond it. If it's gone beyond it, it indicates that your orientation is not correct and your angulation is not correct, and you have to go back into the AP view and restart all over again without trying to bypass something there. So at the same time, ensure that your needle is placed in the proper position to the end plate, going parallel to the superior end plate. So to reiterate what we are saying, just to take home, make sure that the spinous process is the midline and your lateral entry is very correct. The C-arm is end on the vertebrae. Do not go past the medial pedicular wall, and on the lateral border, make sure that you're on the posterior vertebral body line. The lateral entry point is very important. Ensure that you do not violate that, because if you go down the medial entry point, medializing your screw will be disastrous towards, they can cause neurological impairment. Most importantly, and technique-wise, do not cross the midline, and make sure that you stay on the posterior 2/3 of the vertebral body, and do not cross the anterior 2/3, as you can have an anterior cortical breach otherwise. Now you can also go apart from this, various techniques have been adopted, fluoroscopy, navigation, things. Technology can help further, like CD guided or other things, and these are useful for us to follow. Thank you very much for your patient listening.
or any questions for Dr. Karthik? Arvind, you are muted.
So I've seen that, sometimes when you are using just fluoroscopy, you'll be surprised that some of these very bulky patients, elderly patients, they have asymmetric pedicles. And I've seen patients who just take 4.5, 5.5 screws. You can put a 6.5 in them, but you have to be exactly in the center, so that there is a, circumferential expansion of the pedicle in case there is. So you don't get CT cuts in every of them preoperatively, but at least, you should tell the MRI guys to give you a section at the pedicle level and go through the axial sequences, keeping this also in mind, the pedicle dimensions also in mind.
Okay, thank you. Dr. Zaveri.
Yeah, I had a question actually. Since Karthik is not here, probably Arvind can answer the question. Arvind, there are 2-3 things. One is that do you do any bowel preparation to ensure good imaging intraoperatively? Is it necessary? Number 2 is that sometimes the facet joint is very vertical. So when you start off the facet joint, your needle keeps on slipping down. And it becomes difficult to get an entry into this thing. And third thing is, as difficult as it is to avoid a neurological injury, the other problem is facet joint violation. So all these 3 we needed tips from you.
So I don't do any bowel preparation. So if you know, at SciFi you have this 3D Siam. So whenever there is an obese patient, I choose to do there in case I'm not using navigation, because irrespective of the size of the patient, you will get very good precise images there. So that is the advantage we have. You need to have a very good CM. I don't do bowel preparation. And with regards to the sagittal facets, so now, for almost last 6 to 7 years, I don't take 2 small incisions. I take 1 long incision. So if I can palpate the transverse process and the lateral wall of the superior facet, I usually don't go wrong. The only issue the anatomical restriction which can prevent you from getting medial is if you have a iliac crest which is very close to a sacral entry point, S1 entry point. There it is a big challenge. So you'll have to just figure out a location. The advantage is, S1 you can have various entry points. That advantage is also there. But if it is a iliac crest is very close, it can come in the way of your screw. So you have to be very smart to see that, because after the Jamshidi, the other structures that will go over the guide wire are bulkier. So they shouldn't, skid over the iliac crest. So there you have to be very careful. I don't remember what is the third question you asked me?
Facet joint violation.
Not very often.
So how do you diagnose that the back pain is due to facet joint violation? How do you diagnose in post-operative period if a patient comes with back pain and it is due to facet joint violation? Vishal.
Guru, I think we have. Sorry.
No, Vishal Kundnani, he had raised a hand. Yeah.
So we had a publication on this about superior facet joint violation in MIS cases, and in fact, most of them are asymptomatic, and it is not uncommon. In fact, in one of our study where fluoroscopy guided MIS TLIF was done, 23.4% in a case study of 200 cases, it was found that superior facet joint violation does happens. And that is one thing that we all must be very cognizant about, that in MIS TLIF, which is done fluoroscopically, no matter how good we do a decompression, more often than not, we have a habit of putting up an incision which is biased toward decompression. So the tubular point of incision that we do, we are biased towards decompression, and that is why our entry points or the incisions are usually more medially placed on the side where decompression comes. Whereas on the side where decompression is not done, we generally tend to have more lateral incisions where only the screws are going in. And in our study, we highlighted this point very clearly, that in patients where you're doing MIS TLIF, on the side where you're doing tubular decompression, those are the side where your incision should be slightly longer, and the incision should be placed little lateral to avoid superior facet joint violation. The good part about SFV, superior facet violation, is that 93% of our patients were asymptomatic in whom we had it. Only 7% of them had back pain. Again, it is absolutely impossible to ascertain whether the back pain post-operatively is coming from superior facet joint violation or not. Unfortunately, in our study, we never had any long-term, longitudinal study to see in long run what happens to them, or we never studied the incidence of ASD. But there is enough literature to suggest that if the facet joint violation is more than grade 2, which means more than half your screw tulip is sitting on the facet joint, the chances of you having ASD is as high as 50%. So this is one thing we all must be cognizant about.
Vishal Peshatiwar, do you have a comment or we'll move ahead?
So adjacent level, especially proximal level arthropathy because of tulip encroaching is not going to happen in the first few years. This is going to land up slowly, and majority of them will come with an pain at extension. That's what I mean. The trick, like Arvind said, is to land at the junction where the transverse process joins in and in the center, and to enter either at the 3 o'clock or 9 o'clock position, so that your screw is not superior also, and at the same time does not come close to the inferior margins.
Thank
and
you.
go at lateral.
Okay, we'll move ahead. I am getting call from Umesh. So next speaker is Dr. Gautam Zaveri. Sir, please.
Good morning. About 40% of instrumented spine surgeries within moderate to severely osteoporotic bone are complicated by some form of implant failure. The complications can range from intraoperative cutout of the screw to screw pull-out, cage subsidence, loss of correction, junctional failure, and non-union at follow-up. Today, I have been asked to provide tips for minimizing implant-related complications in the osteoporotic spine. And over the next 5 minutes, I will be providing you with 5 very valuable tips. The first tip is, in patients with moderate to severe osteoporosis, whenever possible, delay spine surgery if start the patient on calcium, vitamin D, and teriparatide. This should be started a minimum of 4 to 6 weeks before the surgery and continued for up to 2 years post. It has been shown by starting teriparatide along with calcium and vitamin D, there is a rapid increase in bone mass with an significant increase in the insertional torque of the pedicle screws. It improves the fusion rate and shortens time to fusion, significantly reducing the pedicle screw loosening and the risk of junctional fractures. The second tip is limit correction of spinal deformity in osteoporotic bone. In the osteoporotic spine, less is often more as far as deformity correction is concerned. In situ fusion is preferable where the risk of instrumentation failure is extremely high. The third and probably extremely vital tip is ensure adequate reconstruction of the anterior column. Adequate restoration of the anterior column restores the weight-bearing mechanics of the spine and reduces the strain on the implants. Anterior column reconstruction can be done using bone cement within the disc or within the vertebral body. One can use intervertebral or intravertebral cages. One can use strut bone grafts. And in some cases, where the gap is significantly higher, one chooses to do vertebral shortening so that the gap between adjacent bones is reduced and there is lesser strain on the implants. The planning of the instrumentation construct in osteoporotic spine is extremely vital. Long constructs must be used with multiple points of fixation. A variety of anchors can be used ranging from pedicle screws and wires, sublaminar wires to hooks and cortical screws. Sublaminar wires and hooks have the additional advantage that they have purchased in the lamina, which is bicortical, and therefore the risk of pullout is far lower. I personally prefer to use pedicle screws coupled with sublaminar wires. The cortical screws, which have a purchase in cortical bone, run from in a mediolateral direction to gain purchase in that bone. Today, a number of designs of the screws have been innovated to improve the pull-out strength of the screws. And therefore, screws with dual threads or conical screws, screws which have expandable tips, hydroxyapatite coated screws, and PMMA augmented screws have been used to improve the pull-out strength. PMMA augmentation can be done either before insertion of the pedicle screw, or the cement can be injected through fenestrations within the screw. Finally, you must remember that in osteoporotic bone, you have only one chance to get it right. Use the CIAM and be very careful to follow all the steps of surgery. Avoid tapping and under tap to prevent loosening of screws. Use larger diameter screws and try and get a purchase in the anterior cortex of the vertebra so as to improve the pull-out strength. Finally, be very careful when doing the final tightening of the screw rod assembly to prevent pedicle cutout. To conclude, to minimize complications of implants within osteoporotic bone, whenever possible, delay elective surgery and start the patient on appropriate anti-osteoporotic medication, limit the amount of deformity correction, provide stable reconstruction of the anterior column, provide multi-segment, multi-modality stabilization to reduce the risk of implant failure, use screws which are augmented with either hydroxyapatite or bone cement, or use expandable screws or some of these newer double-threaded screws to improve the purchase within the trabecular bone. And remember, in osteoporotic bone, you have only one chance to get your instrumentation right. Get it right the first time. Thank you.
Thank you, sir. Wonderful presentation. Any comments or any questions for Dr. Gautam?
Guru, let me start by making a comment. There was one important tip which I missed, and that is the number of times surgeons try to bring their rod is not adequately contoured, and they try to bring the screw or the bone to the rod when applying the rod. That is fraught with danger in osteoporotic bone. Not only can you get an intraoperative pull-out of the screw, but post-operatively also the strain on the screw is much higher and the pull-out rate is higher. Now this is one place where surgeons who try to put screw percutaneously should be extremely careful. I've seen two patients where at the thoracolumbar junction in an elderly patient who already had a little bit of thoracolumbar kyphosis, the rod placed was straight. So what happened was the fixation was perfect. The screws were in perfect place. Everything was done very well. And yet post-operatively the screw pulled out because you had tried to bring the bone to the rod. The bone had already settled down into an acceptable space, and the anterior reconstruction was not done to support this. So one has to be careful about this part when you are doing, especially minimally invasive surgery. You don't tend to contour the rod as well as when you're doing an open surgery. So be careful about that part for sure. The second thing is I see a lot of young surgeons using a lot of bone cement to fix screws. Now, I think we operate about 2 to 3 osteoporotic patients every week. And I can remember the last time I have used cement was probably 15 years ago, where I must have done in the early part of my career. At that time, there were no fenestrated screws. We just put in cement and then we put the screws over that. But if you take care and go stepwise, 90% of the times or more, you will not require to put in additional cement either before or after you have put in the screw. If necessary, you can use sublaminar wires to supplement it, and it works very well.
Thank you, sir. Move ahead. We'll move ahead.
The role of crosslinks, long constructs, definitely.
I don't think crosslinks have anything to do with the pull-out strength of the screw and do not tend to reduce the implant failure specifically in an osteoporotic bone. So no, I do not use crosslinks routinely in osteoporotic bone. In the good old days, I used to use crosslinks if I did a vertebrectomy and reconstructed anteriorly because then there was lack of rotational stability. But in this kind of bone where you are, if it is osteoporotic, you are anyway going to go 3 segments above or below, then I don't see the need for crosslinks in these patients.
Thank you, sir. We'll move ahead. So the next talk will be by my good friend, Dr. Sandeep Sonone. Dr. Sandeep, over to you.
A very good afternoon. And this particular talk, we are going to have a look at some of the essentials for having a good clinico-radiological outcome in lumbar interbody fusion. So as we all know, lumbar fusion surgeries are one of the most commonly fusion surgeries which are done. Initially it was the flip, now we have the transforaminal access for this. And we have moved on from the open procedures to MIS TLIF procedures currently, and the future lies with more minimally access surgeries like the endoscopic therapy. Having said that, as the number of lumbar fusions increase, the number of failures are bound to increase, and this is basically because of an inability to understand the rationale or principles of lumbar fusion. We need to understand the ultimate goal of fusion is elimination of pathologic motion segments and the symptoms which come along with it. And this is achieved by an attempt to form an osseous bridge across the level of fusion. There are 3 basic requirements for this. You need to have a good fixation. The fusion bed should be good. And obviously you need to use a good amount of bone graft. And the 4th factor is biomechanics, which we need to understand. So going into the biomechanics briefly, the area where we put the graft, that is the anterior interbody area, is the anterior and the middle column, which is always under compression. Your interbody graft is basically resisting compressile forces and the shear forces which come along with it. So the end plates have to be really strong, especially in osteoporotic bones, as the end plates are very poor. The interbody spacer has to share the load which falls on it, so it should be an adequate height. And the screws should be of adequate size and length to give immediate stability. Here you can see the screws are totally malplaced and no amount of interbody fusion is going to give you good result because the immediate stability is lost in these cases because of malplacement of screws. So the screws should be perfectly placed.
Dr. Dhruvin,
adequate
size, length and good medial angulation. As far as interbody devices like cages are concerned, we have a lot of options. We are spoiled for choices. However, the cage has to be inserted properly, should be placed properly, having good coverage over the end plate. They should not be eccentrically placed, as you can see in this particular case. So the placement has to be preferably in the center, and they should be of an adequate height. So the concept behind this is that the cage, once you insert it inside, becomes a load-bearing structure. And if it is loose, the whole weight is shifted from the anterior or the middle column to the posterior column over the pedicle screws, and they can give way because of inadequate stability. So the cage has to be of adequate height, should be placed preferably in the middle of the anterior column, as anterior as possible, so that they are under compression and lordosis can be given to enhance stability. So that's how a cage should be placed as anterior as possible, preferably after you grafted the anterior, after you insert a lot of graft anterior to the cage, because that is where the fusion happens maximally. And then you can compress posteriorly. So that places the interbody spaces, cages under compression, restores the segmental lordosis and enhances the stability. As far as fusion bed is concerned, you need to make sure that your access window is quite good. You have to remove all the posterior osteophytes. The disc preparation has to be good. Subtotal disc excision is mandatory to create a good surface area for grafting. And that's how it should look at the end of the subtotal discectomy with good end preparation. Just enough cancellous bone, enough bleeding cancellous bone to give a good fusion bed. As regards grafting, initially we used to use a lot of iliac crest graft, but now most of us use a local autogenous graft combined with allograft. As far as minimally invasive surgeries are concerned, we have the options of the DBMs and the BMPs along with the bone marrow aspirate which goes along with it. However, if you compare the mechanical stability versus the osteogenic potential and the osteoinductive and the osteoconductive properties, then what works best is a combination of local autograft and an iliac crest graft. Now there are multiple ways in which you can harvest the iliac crest graft by minimal access ways, reducing the donor site morbidity and the pain. Combine this with allograft and use it as an interbody spacer. So to summarize, a good interbody fusion will happen if you follow the basic principles of good rigid fixation, meticulous bed preparation, and good amount of bone grafting. Thank you very much.
Thank you, Sandeep. Only one question or a comment. Anyone? If not, Sandeep, you have anything?
Yeah, so I just want to say, because this is a symposium, basically a conference on minimally invasive fixation. Just a short message to the young guys who are doing it, that it's very important that before we actually venture into minimally invasive surgery, it's important to have the basic principles with you. Make sure that you have enough experience in open procedures before you actually go into the minimally invasive techniques.
Okay, thank you. So we'll move ahead. The next talk will be by Dr. Alok Ranjan. Over to you, sir.
Increased dose of radiation is a invariable fact in minimally invasive spine surgery. From this slide, we can see that as we go for more and more minimally invasive surgery, the fluoroscopic time increases, hence the radiation dose also increases. The increased radiation dose is a real danger. Studies suggest that cataract, malignancy have been found to be more in that group of people who are exposed to radiation. Most of the brain tumors such as GBM and meningioma in cohort studies of intervention radiologists and cardiologists have been found to be on the left side, and that is the side of the brain which is also exposed during intervention procedure. There are two types of radiation injury. One is deterministic, which is a dose dependent, direct tissue injury such as arrhythmia, alopecia, cataract. They come in short term and immediate. And there is something called stochastic, which is not exactly dose dependent. It causes genetic damage. It causes dendritic damage and can result in solid tumors. Studies have been done to see radiation exposure to the spine surgeon during fluoroscopic assisted pedicle screw insertion, and as expected, if the beam source ipsilateral hand gets more radiation, in obese patient there's a more radiation to the hand. Radiation level significantly decreases as the distance from the beam source and surface, body surface increases. The greatest level of radiation were noted on the side where the primary radiographic beam entered the cadaver. It has been found that for a safe limit, 453 minutes should be the estimated total amount of radiation dose to a fully protected surgeon over a year. So what is the most important factor that determines the radiation dose to staff? It is the scatter radiation. Now, if we use high kbp to get better films, obviously there will be more scatter. And obviously in obese patient, high kbp is used to get a better film and there's more scatter radiation. There are three cardinal rules of external radiation protection. less time, less exposure, greater distance, less exposure, and more shielding, less exposure. In this slide, we can see the beam source is the area where there's more scatter radiation and the surgeon should be away from that. So the first one is what is right. In an angled imaging, the observer should stand on the image intensifier side of the C-arm wherever possible and step back from the patient as much as possible if you are not required. Then comes this slide where again position A is correct because as you notice that the surgeon is staying the other side of source beam and hence thus scatter radiation. Obviously radiation can be minimized if we use fluoroscopy very intelligently, and if we get a true AP film, most of the dorsal and lumbar spine, we can plan multiple entry site at the same time with one picture. Obviously requires intelligent use of fluoroscopy. However, in deformed spine, this is a problem. In an advanced type of fluoroscopic machine, there are imaging techniques like digital hotspot and pulse fluoroscopy, which decreases the dose of radiation without decreasing the quality too much. In summary, exposure time should be reduced. Doubling the distance reduces the radiation exposure by a factor of 4. Shielding is very important. Radiation emitting source should be the surgeon should stay away from that side. True AP film will do in most of the cases. Obviously, robotic navigation assistance is very important. Surgeon's control over C-arm makes a better flow, and wherever possible, we must try to get fluoroscopic modification for pulse fluoroscopy and digital hotspot. C-arm has a less radiation than X-ray, whereas O-arm has more radiation, and at that time, it is advisable that the surgeon and the other staff stay outside the theater when the O-arm being used. Navigation obviously means less radiation, but works best with a straight spine. As the deformities increase, there will be more and more X-rays needed for a proper navigation. Hence, one has to be very careful of that. Navigation is not something which is always reliable, as this X-ray shows same position on the left side as shown in navigation and on the right side shown in X-ray, and there is a discrepancy. Robotic mount is very important. It reduces radiation by 62.5%. However, it's very, very costly. Thank you.
Thank you, sir. Any questions for Dr. Alok? So I have a question. How many of us we use the radiation protective gloves and eye shields?
As far as I know, no surgeon uses it.
There is one hand which is raised. That's always there. Vishal, you are using. Anand. Yeah. Okay, any other questions? Okay, if there are no questions, we'll move to the next talk. That's by Dr. Arvind Kulkarni. Dr. Arvind Kulkarni, over to you.
Dear friends, it's said that the difference in good and bad surgery is how well you treat the soft tissues. We always heard this particular phrase, respect the tissue will respect you. We've seen our senior surgeons operating, doing open surgery. The planes are absolutely clear and clean. When it comes to minimal access surgery, whether you use the tube or the endoscope, the crux lies in creating a portal in the middle of muscles. So this is prone to traumatize soft tissues because it could be because of blunt impact of the dilators, or it could be while landing and navigating in the superficial planes, or because of the anatomy itself of the spine, which is uneven because there are hills and valleys and not a flat surface. The soft tissue protection starts right from the word go. When we localize, precise localization is the key. For example, in this particular case, if the tube had landed at L3-4, you could have imagined how much of soft tissue swiping and sweeping had to be done to get the tube in the right place, and this would contribute to soft tissue trauma. Again, before incision, it's very important that you soften the paraspinal muscles with the diluted sunsocaine so that the impact of bleeding, the impact of resistance to dilators is less. It also provides preemptive analgesia. Also, cut the fascia and don't bang the dilators in without cutting the fascia, because that again can contribute to a significant soft tissue trauma, because the other dilators will not go on top of one another. And if you're doing multi-level decompression, it's important to incise the fascia above and below so that the tube can be tilted easily. So in case you land superficially with the tube, don't panic, don't cut the soft tissues, don't cut the muscles. Make another incision at the level of the landing in the same line as the skin and the facial incision, and put your dilators once more. This you can keep doing twice, thrice, 4 times till you reach bone. So this way you can prevent soft tissue trauma, which we call multiple docking technique. This is usually seen when you are doing a MIS TLIF. For example, it is very easy to do a TLIF without any soft tissue injury if you land on the right side. But if you have to go on a side which is a hypertrophied facet like this, you will end up quite high, and this is prone to significant soft tissue trauma. So what we do here is we land on the facet, we drill the facet till we reach the plane of the lamina. Then the surface becomes flat, and you thrust the tube lower down so that there's no soft tissue trauma involved. So science does not have a moral dimension. It is like a knife. If you give it to a surgeon or a murderer, each will use it differently. Again, one important part of minimal access decompression is winding, where you tilt the tube in different directions to accomplish your decompression. This causes significant muscle creep when you're using a expandable retractor, which has generally has weak blades. So it is not a good instrument to use when you're using winding, because the gap between the retracting blades encourages creep. Again, the attachments of these particular expandable retractor is quite bulky, and it doesn't actually allow significant winding. On the other hand, a fixed tube prevents creep. It is stronger. It can be lucidly winded in any direction, and definitely in my experience, I've seen that this prevents soft tissue creep. Again, when it comes to discectomy decompression procedure, increase your experience such that you start using smaller diameter tubes, because smaller diameter tubes land directly into the valley, the area of interest, and this way you can minimize your soft tissue trauma. Again, percutaneous pedicle screws, instead of using multiple small holes, use a slightly longer incision so that you can finger palpate the entry point and then put in your Jamshedis. When you're before you put the screws, when you're tapping the screws, make sure that you use sleeves so that the tap doesn't destroy the soft tissues on the way. Small incisions, poor techniques can lead to compartment syndrome, infection, etc., as highlighted in this particular paper. Again, it's very important, to be right in terms of putting a pedicle screw in the right place in the right time. Otherwise, you'll keep get lost in the soft tissue, and that adds to soft tissue trauma. In that way, in that connection, it is advisable to use navigation, robotics, etc. So the take-home message is respect the tissue will respect you. The main motto of MIS is minimizing tissue trauma. That you should always bear in mind. I'm sure my other colleagues have many more tips to share, and in terms of minimizing tissue trauma when you accomplish goals using minimal access. Thank you very much.
Thank you, Arvind. As usual, a great presentation. So any questions to Dr. Arvind?
No, please.
If not, I have one question. Arvind, how do you prevent the backing of the tube, which actually causes a lot of creeping of muscle?
I didn't get you.
So how do you prevent basically tube back migration?
Use a longer tube than required. So if your dilator shows 6, use a 7 centimeter long tube. That will prevent it from coming out. If you use a shorter tube, it keeps coming out. And you should be conscious of this fact that it might, come out. So you need to reorganize every time it tries to come out.
Thank you. I can see Umesh. So I thank all the speakers for great presentation and great interaction. And I thank the organizers also. Over to you, Umesh, for the next session.
Thank you, Guru. I think you are projecting my face as some red signal that you see at the
I have
the
the red
moment you see
cursor.
my face, you're telling, I see Umer's face, let's stop. All right, that's definitely not what I intended. Unfortunately, I'm feeling bad that, the time is not sufficient for the enthusiasm that this faculty group has. And once again, thank you very much, everyone, for this excellent session. It was, as I told, it was our honorary secretary's brainchild to have this session, quick bits, tips and tricks for a safe spine surgery. And definitely it has turned out to be very, very useful, especially for everybody who looks at minimizing the complications and to perform a safer surgery. Without any further ado, I would like to go on to the next session. Now, again, due to want of time, Hall A, somehow we have made a little bit progress, but in Hall B, we are significantly late. We are significantly still short of time. So I would like to cut down or request the next moderators of the case discussions to cut down their discussion time to 15 minutes maximum. We will remind them at the end of their time. And I would like to hand over the session now to Dr. Rakesh Lohana, who is going to do the first bit of case discussion. And that is going to be on difficult disc prolapse, endoscopy versus tubular. Dr. Rakesh, request you to again stick to time to bring out only relevant points that you were intended to make at the beginning of the session, and try to be try to save some time in this session as much as possible. Thank you.
Sure,
Dr. Rakesh, over to you.
Umesh. Yeah, sure, Umesh. Thank you for this wonderful opportunity. So I welcome all panelists as well as young Turks. Somebody will have to stop screen sharing, then I can share my screen. Okay. Okay. So the purpose of this session is discussing few cases where I thought that there are some lessons to learn and there is some difficulty. So we begin with first case, a 35-year-old male with acute right leg pain and left leg weakness. And this was his MRI, which was showing L1, L2 superiorly migrated disc herniation. And these are axial cuts.
We cannot see the images.
Rakesh, the images are not seen.
We cannot see the images.
Okay.
Maybe share off and share again. Share out and share again.
Can you see now?
No. You may have to close it again totally and share. Open your PPT and then share again.
Rakesh, first open your slides, keep it ready, and then share.
Yeah, I kept it ready. Yeah. Now you can see?
Yeah.
Yes.
Yes.
Start from the first.
Okay. So this is 35-year-old gentleman presented with acute onset right leg pain and left leg weakness and difficulty in walking. So this was his MRI, which showed L1, L2 superiorly migrated disc herniation. And this is actual view. Again, we got contrast as well, which confirmed that it was a disc and nothing else. So at L1, L2, higher level cord compression, what difficulties you would feel and what suggestions you would have. We'll ask from panelists. Dr. Kim, June Kim is there.
June Kim or HS Kim? Who call you?
Whomsoever. Dr. H.S. Kim is there?
Yeah.
Yes.
Can I suggest my proposal for treatment of this patient?
Yes.
Yes. This case is a very good indication of the transfemoral endoscopic lumbodiscectomy. Because of that, this case is L1, 2, and highly superior migrated cases. Because of that, if we try the open surgery or some retraction from the posterior or intramina, there is some higher chance of the cord injury or nerve damage. Because of that, we should try the remove this pathology if possible, not retract the nervous structures. Because of that, transfemoral approach is the best option. But unfortunately, L1-2 level is very high level, and there have some tips of the transfemoral approach. For example, there have in the upper level, especially L1 to L2, 3 have a so huge, large foramen and dura expanded so lateral area. Because of that, if we ducking so deeply, there is some make some chance of the dura tear or nerve damage. Because of that, making the firstly keep the distance from the midline to the skin insertion point approximately 6 to 8 centimeters. Because of that, there have some another structures of the kidney or some another visceral organ, maybe chance of damage. Because of that, 6 or 8 centimeters is sufficient, and making some steep angle to the target point of approximately 45 degrees. Why? There is very close approach, and foramen is wide. Because of that, if we some ducking to their foramen, some steeply, there is some chance of nerve damage, dural tear, or some cord damage is lessening. And anyway, in these cases, if we try keep this recommendation, this is the best option of the transfemoral approach, in my opinion.
Okay, Subir bhai, what you would suggest? Tubular, what are the tips and tricks, and what are difficulties expected?
Yeah, I already mentioned B.
So in my opinion, this is a significantly high level lumbar placed disc prolapse. Even with a proximal migration, it is causing displacement of the dura. I would want to avoid further displacement, and I would not want to retract the dural sleeve at all. So I would probably plan for a primary tubular TLIF in the MIS TLIF in this case, rather than try and fiddle around with just a tube and try to retract the dura to get my disc. So it would be a straightforward MIS TLIF as far as I am concerned.
Okay, Dr. Malhotra. Dr. Anant Malhotra is there?
Yeah, I think I completely agree with Dr. Subir Zaveri. This is a high level disc, and transfemoral, the problem would be that the migrated disc would be difficult to take out. So it would be better if we go do a conventional MI TLIF approach for this.
See, but the disc is very well preserved. It's just you have to do just fragmentectomy. So, Dr. Arvind Kulkarni.
Yeah, I have done such at these levels. It's not difficult. The only difference is you need to do a wider laminotomy. I mean, in the sense you do a ipsi contra, you widen the lamina, and create enough space, and gentle retraction is okay here, and you can pull out the fragment. You put your nerve hook and pull it out through the wide laminotomy you create without actually harming the facet.
Yeah, right. So that's what we did. We did a MIS laminotomy, widen laminotomy, go on opposite side, and ipsilaterally go with a blunt hook, take out the nerve root, and then take out the disc, fragment tail of the disc, and then fish it out without retracting the root, and that's what we did. Yes.
So if it's an
next case.
acute disc, yes, it can be done, but if it's a long-standing, probably it might be difficult.
Yes, right, agree.
No,
this was an acute disc.
You go through all the axial sections. At one point, you'll find that the tail is just waiting to come out. At that point, you catch hold of it with the pituitary and comes out.
And it is coming quite laterally. It's coming quite laterally, so that's easy to fish out. It's not that difficult, and it's pretty soft. It's quite hyperintense on T2. So moving on to next case is a 72-year-old gentleman with a long-standing history of claudication with recent acute right leg pain. So MRI, because of want of time, I will just show you relevant images. Is just 4-5 stenosis and right extraforaminal disc herniation. So he has got a L4-5 stenosis and right the same level, right sided extraforaminal disc. And clinically also, he came with a long-standing history of claudication with recent worsening in right leg pain. Dr. John Kim, how would you treat this?
Yeah, in this case, we have to resolve the bilateral lateral stenosis and foraminal and extraforaminal disconnection together. So if we go through two separated surgical route, paraspinal, right side paraspinal approach for the extraforaminal disc and interlaminar approach for the bilateral lateral stenosis. In this is with two surgical approach, right side past joint violation will be the problem for the post-operative instability. So we can resolve the intraspinal stenosis and primary and extraprominal disconnection with one surgical approach. We can do the left side interlaminar approach for the bilateral stenosis decompression and contralateral foraminotomy for the foraminal disconnection removal and extraforaminal disconnection together is one surgical left side interlaminar approach.
Right. Yeah. And Dr. Mahesha is there? Dr. Mahesha?
Yeah.
Yeah. So how would you treat this case?
Yeah, I agree with Dr. Kim. So the extraforaminal fragment is targeted with a transforaminal route, and for central stenosis, I will do a stenoscopic decompression.
Okay. And Dr. Malhotra, how would you treat this case? Subir bhai?
Well, so this definitely requires a two-pronged attack. We can try and have a single paraspinal incision, which is slightly more lateral than the usual. Try and angulate the tube a little bit more medially to get the central stenosis with over the top decompression. And once you are done with that, remove the tube completely and then redock it again onto the lateral aspect of the facet, and then go slightly proximally towards the foramen to do the decompression. So it does require a single, it can be done through a single incision, all from the right side, and you can do a bilateral decompression and a foraminal disc as well.
Right. So that's what
little
we
difficult,
did.
but yes, it is doable.
Yeah. So that's what we did. Placed the incision around 3 centimeter lateral to midline, went first to the extraforaminal component, then again docked it medially, and then did a bilateral decompression from right.
Yeah. Perfect.
So move on to third case. Is a 46-year-old gentleman with a basically cauda equina syndrome for last 4 weeks, getting worse, and there is past history of lumbar spine surgery in 2000. So it's basically a cauda equina syndrome in a revision case, past open laminectomy, and now it's a cauda equina. So how would we tackle this case? L5S1 level, cauda equina, revision.
Can you show the X-ray for this patient?
Unfortunately, we don't have X-ray. Yeah, there was no instability, but from iliac crest perspective,
Yeah.
Sorry.
For iliac crest.
Yeah. Sorry, I didn't get it. So how do you treat, like whether iliac crest is low or high? How would you change your approach, and what would be your perspective, Dr. Kim?
Yeah, actually, in the cauda equina syndrome, I already mentioned that some transforaminal approach is the best because there is not a completely not restricted nervous structures, because that not additional injury to the cauda equina or some other neural damages. Because of that, the transforaminal approach will be the best. But only problem is that how much iliac crest or how much Freeman, there have some obstacles. But today's doctors give us some lecture of transiliac approach. Yes, there is also can possible, and also There have several techniques to approach from the transforaminal area. Because of that, if this patient have a coda equina syndrome, I will choose the transforaminal approach rather than the intraminal approach.
Okay. Any of the young turns, Dr. Mukul Kaushal?
Sir, in this
Dr.
case, I would like to see the axial cuts also, sir. Can you show the axial cuts?
Yeah, sure.
So, sir, I can appreciate that it's a central disc with the midline scar can be appreciated. So, I would
Yes,
like
yes.
to do an revision interlaminar approach via Distendo technique or a UB technique. My docking would be on the facet. I would confirm it on my radiographs when I dock my tube, and I will like to clear a part of my medial facet and work lateral to the scar. I would not like to work inside the scar, and then I would want to identify the pedicle. And from that pedicle, I know that the disc is just above and medial to the pedicle. And through that, with angled disc forceps, I would like to retrieve this disc without much retraction of the neurostructure, sir.
Okay. So, okay. Dr. Amit Chug, how would you approach? Amit Chug is there? And Utkarsh Agrawal? Not there. Vaibhav Goel?
Yes, sir. Am I audible?
Yes, yes, yes.
Yes. So, sir, I would like to go for by the transforaminal approach, considering the iliac crest. If I can go supra-iliac, I'll go first from the one side where the symptoms are more, and if required, then from the other side also.
Okay. So, Dr. Mahesha, in transforaminal approach with a previous laminectomy and coda equina, what are your problems or what are your difficulties? Will be any scar tissue will be problem for transforaminal or no?
Transforaminal, it is very easy. You don't expect scar tissue anterior to the dura. So it is very easier to do. Only thing is the facet or iliac crest may come in the way. If the iliac crest is high, I will go through transiliac approach, because to access the central part, it is very easy with the transiliac approach. Because the crest is high, your cannula and the scope will angulate down and you will not get central part. Whereas in transiliac approach, you can target even to the other side. So it is very easy. So I don't know, because we don't have the X-ray, we don't know the crest part.
Okay.
And this will definitely require some undercutting of the facet to access the dorsal part of the.
Dr. Rakesh, Anand this side.
Yes.
Can I chip in?
Yes, sure. Yes.
Actually, I'm quite comfortable with the Distendus. I agree with what Mukul said, that this is a reasonably good case for the Distendus technique, by interlaminar technique. You can go through and use, basically what he said is absolutely right. In recurrent case, you start laterally so that you avoid the scar tissue. And then perhaps you might need to drill a little bit, because there's a placental enlargement out here. So once you do that, you will be on the lateral part of the dura, and then you can work along. Transforaminal going transiliac is, I think, might be, I don't know whether it is an overkill or not for the technique, but this disc is like it's too anteriorly displaced for a transforaminal approach.
And Subir, what about tube with this case? This case is for tube.
So definitely, I think Destando and the tubular dilator work in the same principle, that you can dock on the posterolateral aspect, shave off the medial aspect of the facet. Then once you have a normal dura, then you can work your way and detach the fibrosed area from the bone and then go ventrally. Now, at times at L5S1, one has to understand the limitation of the transforaminal system. And I think instead of trying and attempting an iliac crest bony window, it perhaps is better to, concede defeat at that point. That, okay, this cannot be done, it's fine. Let the other guys handle it. Right?
So,
I don't agree. There is no limitation of transforaminal approach. In such cases, we have done many cases of transiliac approach.
Right. So
There is no
transiliac.
So
let's not get into that. But I think
so basically, it is amenable to
if it is a debate, then it's
system you are
be a
comfortable
debate.
with. Yeah. So basically, this case is amenable to the system you are more comfortable with, I guess. Whenever there is a revision case or a coda equina, maybe the thing that is best in your hand, that may be the suitable approach. I think that would be the take home
मुझे
message.
सर केस को छोड़ेगा नहीं.
Let's get on to the scientific aspects.
So next case.
So what was that?
This is
What
I
did
did
you do?
MIS. I did MIS alpha S1 tubular discectomy.
How many can I just ask? How many would think of doing a primary TLF in a recurrent disc like this? Would anyone think about it?
I would not, unless there is significant instability, significant end plate
ask
changes in
Alok.
clinical
Alok
back
is
pain.
there.
Yes.
If there is no
Alok,
back
sir,
pain,
was-
then I will not do it.
Yeah.
So
If there's no back pain, forget what. Obviously, there's no instability on X-ray. But if the patient complains of significant back pain, then I may consider. Otherwise, I will not consider a fixation in this case. TLF.
Sorry, sir, I didn't ask you. You told me you have no, you won't be there, so I didn't.
No problem.
sitting in a dark background.
I'm listening to you, Rakesh. Don't worry. In between, I'm going out and coming back.
Hyderabad sunset has already fallen. Put
I
on
was
a
taking
light,
some
man.
bird photographs, man. I was taking some bird photographs.
Okay.
Put on some light. We can't even see your face.
Okay. So, chalo, one last case. This was an interesting case. This 51-year-old gentleman with a short duration of right leg pain and limping while walking. Right knee extension was grade 4. So proximal L3-4 clinical localization. And there was MRI which showed right L3-4 far lateral kind of disc herniation or some soft tissue lesion. We are not sure. We got contrast done. Contrast also confuses. There was central hypodensity and surrounding enhancement. So most likely to be a disc, but small possibility of some other lesion as well. So how do you approach this kind of case? Dr. H.S. Kim?
Yes. Yeah, actually, this case is the best indication of transforaminal approach. This is very easy. Today morning also give us some lecture of the transforaminal approach for the foraminal lateral cases. Maybe these cases will have a higher pain during the working channel insertion. Because of that, we can use the floating technique. Floating technique meaning that there's some docking, not foramen around the facet joint area. Firstly, remove the rupture disc and then insert the working channel. Then we can, this case is, I think that maybe it not over than 30 minutes.
Okay. And Dr. Jun Kim?
Yeah. In my opinion, best option is transforaminal with plot technique, as mentioned, Dr. Kim, Harrison Kim. However, we can do the extraforaminal disconnection, extraforaminal disconnection with UV surgery simply.
So there is a possibility is mentioned that it may be some lesion as well. So would you keep that in mind, or would you treat as an extraforaminal disc only? Like, would you think it may be something else as well, or it is just a disc?
Would it be a schwannoma?
Yeah.
Listen, it has a target sign. It has a target sign. Most likely it is.
Is there any possibility other than disconnection or other
Yeah, there is a small possibility,
possible?
because there is a bright enhancement, central dark area. There is, you can see that probably the disc, you don't see any annular tear or, so there is a small possibility. But the dictum usually is, if it looks like a disc, usually it is disc, but you can, get cheated at times. Umesh?
Disconnection with vascularization can have the enhancement, but however, we can exclude the absolute. So in this case, I recommend the Wills approach to microscopic surgery to biopsy, for the biopsy and safe surgery. In this case, another pathological tumor could not be excluded cases. Yeah.
Dr. Umesh?
Yes, Dr. Rakesh, I sincerely request you to make some closing comments. I know it's a very interesting topic. We have a very good panel of surgeons over there.
Okay. So I thought of disc, any extraforaminal disc, so went in with a endoscopic approach, but I went into the disc, tried to go outside, but couldn't find anything, struggled for 2 hours, then converted into MISS. And then what I found that there was some soft beaded lesion along the root, and it turned out to be a metastasis. And then we got a PET-CT, which showed that primary lung cancer with metastasis.
Some different learning from this case.
Yeah, so maybe in atypical cases, tube may score or endoscope, unless you may be very extraordinary at endoscopes, or maybe choose what you are good at. So we'll close this session. Any comments from panelists before we close?
Excellent case collection, Rakesh. Thank you for stimulating our brains. And I agree with Dr. Mahesh that this would be more amenable to an endoscope rather than a tube. But well, you had a different experience, so no offense, but each one is best. Whatever tube he works with or instrument he works with, he is best with it, right?
Yeah, thank you, Misab, and thank you, panelists, for joining us. Dr. Umesh.
Thank you, Rakesh. And extremely sorry that we couldn't give more time for the discussion of this interesting topic. And we move on to the next one. Dr. Nikhil is here to moderate the next topic, that is lumbar canal stenosis without listhesis. And in these cases, what are the points that you need to consider to see whether a decompression alone is sufficient or whether a fusion is required? So, Dr. Nikhil, I would request you again, just like we had discussed, to limit your discussion time to 15 minutes, please.
Okay, yeah, sure. So because of want of time, so I think all the panelists are here. Puneet, Bharat Dave sir, Sudhir. Anyway, I'll just start with the screen share. I think, Rakesh, can you just... yeah. Someone has to. Puneet, Bharat Dave sir, Sudhir. Anyway, I'll just start with the screen share. I think, Rakesh, can you just... Rakesh has to exit, I think, the screen share.
No, sir, we have exited the screen share. You have to share your screen.
Yeah, 1 second. I just... Okay.
You're able to see your screen.
Yeah, okay, fine. So I think Bharat Dave sir I've seen, and Puneet and all are there. So today's debate discussion cases will be only for lumbar canal stenosis by decompression fusion. Going to the cases. So this is a case of a 47-year-old male, bilateral leg pain, claudication, walking just 3 minutes. He also has back pain on long standing, normal neurology, is a chronic smoker, chain smoker actually, but has no comorbidities except hypertension. These are his MRI pictures. The X-rays were done, but there was no instability. That is 100% sure. So he had basically the stenosis at L3-4 and the 4-5. The 4-5 was the most severe. And so the points to consider, the disc height was good, has back pain, work involves traveling usually on bike or car. He's a chronic smoker, he won't stop. So what should be the plan? So can I ask, is Jayesh here? Or Sanjeev, I think is in the other this thing. Anyone else?
Oh, yeah. Hello, sir. Hello, sir. It's Jayesh here.
Ah, Jayesh, hi. Yeah. So have you seen the cases? Do you want to see the MRI films again?
I have seen it, sir. But
yeah. So what would be your plan? I mean, you are starting with your career and getting a patient who is 47-year-old, has more of a leg pain, claudication distance of 3 minutes, but has also back pain on long standing and comes with this MRI pictures. He needs to get a surgery done. He doesn't want any conservative management.
So definitely he's a active worker. He has to travel a lot. Along with that, he has a back pain at 2 levels. Stenosis is there. More of L4-5 and along with the lateral stenosis at L3-4. Both are the symptomatic level. So in my case, I will consider a fusion in this case, because as compared to his daily activities and along with the back pain component, so I will offer him a fusion along with the decompression.
Because of the back pain?
No, because of his daily active load of a means activity level, basically because of his daily traveling, bike traveling. So I just don't want him to get into another level of recurrence. So only for that I will consider a fusion over here along with the decompression at both the levels, sir.
So you would do a MIS TLIF at both the levels, you're saying?
Yes, sir, at both the levels.
But he doesn't have any instability. I mean, the X-rays are not put up, but I'll tell you, there is no instability. There is no listhesis, not even grade 1, and no angular instability. We would still consider do an MIS TLIF at 2 levels.
Yes, sir, definitely, because even though there is not of much of the instability as per your history from the X-rays, but there is a diffuse stenosis at L4-5, for which more of a bilateral discectomy and a bilateral facectomy, bilateral modern facet. Hello, sir, am I audible? Hello?
Yeah, you're audible, Jayesh.
So bilateral discectomy, even though the heights are well preserved in this case, in both the levels, but he will require a wide decompression from pedicle to pedicle level. So definitely I will consider the stabilization in this case, sir.
Okay, so so we have got a point from the young person saying you do bilateral decompression and MIS TLIF. So what about Dr. Sudhir? Is he here? Or Puneet? Who is here? I think
Nikhil, Dr. Lee has logged on. Dr. Singh Lee from South Korea.
I'm here.
Yeah.
I'm here.
Oh, yeah. Dr. Lee.
Yes.
From India, yeah.
Yes.
Yeah. So
nice
basically, this patient, just to go through the case, it's a 47-year-old male. He has both leg pain. He has back pain on long standing, normal neurology. He's a chronic smoker.
Yes. His problem is only the stenosis of the spinal canal. Is that right?
Yeah. Right.
Yes. So, it's the problem is to decompress effectively in a 2 level. So, I don't need the further fusion surgery. I prefer to using the small surgery for 2 level decompression for the spinal canal to make it wide.
Right.
So I don't agree with the fusion surgery.
So you feel a decompression surgery would be adequate for him?
Yes, absolutely.
And what kind of decompression would you do? I mean, would you be tubular, endoscopic, or through a distendu?
Yes, I prefer to using the tubular retractor matrix. So the uniportal decompression of the bilaterally, right?
Right. So, I mean, what particular aspect would you think would favor doing decompression more in this case? Because he's having no instability, or because he's having more of a stenotic symptoms of claudication?
Yes. So I think it's we have 2 reasons for the fusion surgery. Just the first one is that make it stable, right? And second one is to wide decompression classically. But recently, so we just haven't the very powerful tools for decompress in a spinal canal with a small
Can I speak? Yeah. So sorry. Yeah.
Okay. Yeah. So that I think it's to decompress the spinal canal. So far, so we don't need the fusion surgery. So except the fusion surgery, so we can decompress effectively in the spinal canal.
So you're saying effective decompression can be achieved with the tube. You don't need to do complete fusion surgery effectively with this.
No, I don't think so. Yeah.
Yeah. Bharat Dave, sir. So the senior present here.
Yeah, sir. I think I would do the tubular decompression. Maybe conventional complete laminectomy would be of help with the bone scalpel, rather, the one that undercuts the the under the facet, that may be helpful as well. So that will give me the adequate decompression. But I would also add the facet joint ablation, because patient has got significant back pain. It seems to me the pain generator seems to be the facet joint for the back pain. So probably I would also consider that. So adequate decompression, and most important thing, do not miss the level. And if you do miss the level, venous congestion and neurological deficit, which I have seen on occasions, particularly for the MSS surgeons.
Right. So I just saw Anand shaking his head. So I think he was totally having a different viewpoint. Yeah, Anand. We have the anterior surgeon. Anand, you're on mute. Can you unmute?
Yeah. So I just heard the facet joint blocks and all. I would prefer to do a facet joint block before taking the patient to OT.
Why?
I need to identify the pain generator. It's a. You said that. Sorry, I joined late, but it's mainly.
I'll tell you, this patient's main complaint
axial
was
back pain, right?
Yeah. So the patient's main complaint was that he's not able to walk more than 3 minutes. He has pain on long standing, but as such, his job is
L4-5 can be decompressed by n number of techniques. There are so many available. I'm worried about L3-4 as well. So you need to identify whether L3-4 is a back pain generator or not. Do the discogram there. L4-5, facets are hypertrophied. They may be a pain generator, but I'm not very sure that it's ideal.
The discs look pretty good, healthy. I mean, you don't feel like a black disc or anything. You still feel it could be a pain generator.
You can see white disc, but even then there will be some kind of internal disc disruption. Look at the exiting area and the amount of stenosis over there.
Nikhil, may I?
Yeah, Vishal.
So Nikhil, I think there are three things that we are missing here. One, this is not a straightforward pure degenerative lumbar canal stenosis. There is a developmental bony canal narrowing also, considering the length of the pedicles, considering the kissing facets there. That is number one. We all must understand this, that these are cases where there is bony narrowing, which is also contributing to neurological symptoms other than only ligamentum flavum hypertrophy or discogenic component to it. So bony widening of the canal is absolutely a must. So it is not something that we can neglect that here. Number one. Number two, my feeling is that even if this patient has back pain, is back pain the only criteria to offer fusion to these patients? Isn't it that many of our patients, back pain does get better by pure decompression only? Why just because of presence of back pain we add fusion to these patients? In fact, there are plenty of literature available that pure decompression not only takes care of leg symptoms, but also takes care of discogenic back pain also. Number two. And number 3 point, to me, why can't we just do plain decompression in this patient, even if this patient has some residual back pain left behind? Is our fusion by all practical means going to make his back pain even half of what we are thinking of it? So with these 3 points, I have my own reservations whether I would really offer this patient any kind of fusion. Developmental canal, pure decompression, and I feel my decompression will surely take care of at least 50% of back pain. And even if it doesn't, I don't think my fusion will take care of 50% of back pain.
Yeah, so I agree with you, Vishal, and this thing, and with Bharat Daveskar. So basically, and Dr. Lee. So I saw you have a lot of stenosis because of flavum hypertrophy and the bony hypertrophy. So I did a 2-level tubular decompression from the left side, did over the top, and it's been 4 to 5 years. He still hasn't come back to with any major complaints. So I think, in the cases where you have hypertrophy and all, I think a decompression can be a good option, like Dr. Lee said, and you can do thorough decompression. I agree, Vishal. So going on to the next case. Yeah. So this is a 60-year-old female. She has both leg pain, walking distance of 5 minutes, no back pain, pain on extension, no deficit. She's a housewife who stays with her husband who is disabled. So she's the only working person for him. They don't have a full-time maid. And I just this is the X-ray standing. The flexion extension, and these are the MRI pictures. O5, 3-4 are the most stenotic levels. 5S1 is not that much. And if you can see the MR Milo. So now, has anyone from the younger people come? I think Jayesh, you are here only. So I think you have to this thing. So Jayesh, what would be your this thing? So the dilemma is that she's having multi-level problems, degenerative scoliosis. There is a facetal orientation problem. So what would be in your opinion a good option to do? Where she's the only working person, her husband is disabled, and she doesn't have any back pain.
And sir, walking distance is
5 minutes, 4 to 5 minutes.
You got her BMD scan done?
Pardon?
The BMD scan?
I hadn't done it before surgery. I did it after, but it was pretty normal. It was around -2 to -2.2. It wasn't an osteoporosis, it was osteopenic.
Nikhil, we are running out of time. Can you just make this a little quicker? This
yeah. So I think we just wind up with this. Yeah, sure. Yeah.
So can we go to MRI, please?
Yeah.
So more of a claudicating pain she's complaining of, and along with that, she's having a degenerative scoliosis along with the on the X-rays too.
Yeah.
What would you offer her? So decompression alone for this patient.
Only decompression.
It's also a learning curve.
And before 4-5 stenosis. So can we go to X-rays?
And the big problem now with this, and some liquids, so it is a big process.
Yeah.
So only decompression in this patient because there doesn't seem to be much of an instability.
Tubular or endoscopic or through a disc undo?
Sir, tubular. That's fine.
Tubular.
Yes, sir.
3445.
3445.
Okay. Dr. Lee?
Yes. So I agree with them. So I think it's the patient is come to the hospital for the complaining the leg pain only, not the back pain, or that the pain come from the deformity. So I think it's we just decompress only the two levels of the severe the level. So I agree with him. So that the decompressing 3, 4, and 4, 5.
All right. Bharat Dave sir, you have any points you want to share looking at the experience of long term?
Yeah. I think I have my reservation about only decompression because the facet joint arthritis is significant, and probably I would like to find the pain generator as well by giving the local block. Most probably it is a 4-5 and the 3-4 both are at the culprit. That is going to be facet joint arthritis, and probably just doing decompression may not work. So we really need to prime the patient that if the decompression doesn't work, then we may have to, go ahead with the second surgery. So that may give patient by some few years because the degeneration is going to progress, and the load will again, give rise to further compression and further back pain and neurological issues as well.
So you would prefer to wait for some more time and the degeneration to progress and then go for a fusion?
Yeah, well, if we'll discuss with the patient, and probably I would go for fusion straight away if patient is not ready for the second surgery, because the first surgery may work for in a year or two, and patient will come back with the same pain because facet arthritis is significant at both the level.
Right, but even if she comes say once in a year complaining of pain, which is very mild and lasts for a week, is then that acceptable?
I agree. All the points taken. So that is why we will discuss with the patient. And let us share with the patient. I agree with what you are saying. So I don't say that I will straight away go with the fusion surgery, but I will certainly tell the patient what you want, and then share and then explain them at a length, and then it will be shared decision with the patient.
Right. So we have Ketan here. Ketan, you do uniportal this thing. You think this can be tackled through an endoscopic decompression?
It is quite possible. So if we decide to go just for decompression, then it is possible. We may have to use two different approaches for the same. Just not extending the same incision and then going over to the other level, but two separate approaches. Maybe for L4-5, I would like to go from the right side, and for L3-4 from the left side. But yes, if only decompression, it is possible by a biportal endoscopic approach.
And you can get a thorough decompression with this. Okay. And do you also do any facet blocks also with that, or you would just leave it with decompression?
I would go within surgery first, and if at all there is any residual thing, I might consider it, but not as a primary mode of treatment in this patient.
Okay. So anyway, I think Umesh is Yeah. I see like Guru saw. So anyway, we did a 2-level decompression. It's been about 4-5 years. She calls me just once in, say, 1 or 2 years. She has just called me with some minimal thigh pain, has now not having any recurrent symptoms. So as of now, we're keeping track of it. But this is one case which I would really like to follow for a long time and see. So yeah, so I think because of want of time, we haven't been able to do the majority of the cases that we had lined up. But thank you, Umesh, and thank you to the panelists and the young people who were there. So I think I'll hand it over back to you, Umesh.
Thank you very much, Nikhil, for this exciting session. I'm sure there was a lot more to discuss, but unfortunately, we are short of time, and somewhere we have to call it, a day, or probably in this case, we have to call it a session. So I thank you. I thank all the panelists, and I thank all the young Turks who were there. Thank you, Dr. Lee, also for joining, and it was very nice to see you. So we move on to 2 exciting debates from henceforth. So we all know that we have discussed over the last 2 days about different ways of managing lumbar disc prolapses as well as lumbar interbody fusions, whether it is an endoscopic technique, whether it is a biportal technique, whether it is a Destendo technique, whether it is a tubular retractor technique. So now comes the time for us to debate and find out which one of these, in case if one is better than the other, and if so, which one is better than the other. So I would like to hand over the session to none other than the master moderator, Dr. Vishal Kundanani. So Vishal, you are going to be the moderator for the next session on the future, if there is a future gold standard for treating lumbar disc prolapse. Vishal, over to you.
But you have given me 50 minutes to hold this session, and I'm sure you will not stop me unless the 50 minutes are genuinely over, because we genuinely have a star panelist with us. We have Dr. Gautam Zaveri, Dr. Arvind Jaiswal as well. However, our speakers today, Dr. Rajkumar Deshpande, Dr. Jinsak Bey, Dr. Ali Govind, Dr. Pramod Lokhande, Mohinder Kaushal, Ketan Deshpande, they truly represent what the master blasters would do in disc today and tomorrow. We have guys from all walks of the world who deal with these discs in different manners totally. And they always say only 2 lines. Either it is my way or it is highway. There is no middle way. So let's, without taking much ado and without taking much time, may I call upon the first my way technique by Dr. Alok Ranjan, who's going to tell us about tubular retractor is the way today, tomorrow, and future gold standard for treating lumbar disc prolapse. And Alok, before you vouch on the tubular, remember immediately following you is none other than Dr. Kim and Dr. Rohidas and another Dr. Kim, who are going to kill your debate portion by saying you that you are not the best way to deal with lumbar disc prolapse. Over to you, Dr. Alok, and let us welcome all the other panelists around here. Dr. Alok Ranjan, over to you. Sir, you unmute, please.
Can we run Dr. Alok Ranjan's talk, please, quickly?
Yes, sir, I'm putting up his talk.
Are we going to talk of emotions or are we going to talk of logic? Because Rohit Das gets very emotional about these things. Can you hear me?
Yes, we can hear you, sir, very clearly.
I said Rohit Das gets very emotional about it. And I don't like to disturb him emotionally. He doesn't sleep after that. So
that's the best way. Attack is the best way, Dr. Alok. I can see you are already attacking your opponents here.
He's a good friend of mine. I don't want him to, kind of.
So what is the gold standard for treating lumbar disc disease? Is it tubular retractor because it is a versatile system? The concept of minimally invasive spine surgery depends on precise target localization with fluoroscopy, is an off-midline approach with preservation of midline structure and ligament, is a muscle splitting, and there's a minimum tissue damage. However, the optimum surgical goal has to be achieved. Paraspinal muscle has a huge importance, especially multifidus, and in this technique of endoportal discectomy, one dilates a space between the muscle without destroying it, as it is done in microdiscectomy. Objectively, inflammatory and tissue injury markers have been studied as compared to open surgery and even in microdiscectomy, and universally we have found that in minimally invasive spine surgery, less of those markers suggest less of tissue damage. Now, lumbar disc disease is not one entity. It has a wide spectrum of soft disc prolapse, migrated disc prolapse, hard disc, lateral recess stenosis, associated lumbar canal stenosis, far lateral disc prolapse, early degenerative listhesis, and associated facetal hypertrophy. Placement of endoportal is well known using a guidance under fluoroscopy with sequential dilator, and the port is placed at the right position. Placement is very, very important for a good job without destroying the facet. For this example of L5S1 disc prolapse, we can see with the imaging that the extruded disc has been removed. In the E, we can see both dural sac and traversing nerve root, and there's a post-op scan which shows removal of the offending fragment. In early days of tubular discectomy, it was endoscopic assisted. As we can see from the imaging did not show very clear view. However, surgery could be done, and first 5-6 years the surgery was done with that. However, due to lack of stereoscopic vision, there used to be more dural injury. Hence, one shifted to the microscope, which we can be seen on the right side, and obviously the advantage of microscope is immense. Now, this is the only minimally invasive disc procedure where there have been several randomized control trials comparing it with microdiscectomy and open discectomy. And practically in every randomized control trial, we have found that the short-term parameters are better in minimally invasive spine surgery. Long-term parameters, there is no vast difference in most of the studies. Now, significant number of lumbar disc prolapse are associated with lumbar canal stenosis. In a randomized clinical trial, 1 to 2 level stenosis, it was found that unilateral laminectomy versus bilateral decompression, open lumbar laminectomy, the parameters of early mobilizations, faster discharge, better pain control, and better VAS as expected were obviously with minimally invasive spine surgery. Missed laminectomy not only has short-term parameters which are better, statistically significant, but biomechanical study confirmed that unilateral approach to treat lumbar stenosis produced significantly less biomechanical instability. One of the problems with tubular retractor with microscope has been quoted that the visualization of angle is not possible, which actually is not correct. By tilting the port, one can visualize anything. Now we have done the decompression of the ipsilateral side. We are drilling under the lamina, under the spinous process. We can see the contralateral side. This is the disc on the opposite, this side. So wide decompression can be done. Contralateral ligamentum flavum can be easily reached by tilting the tube. So that is not an issue at all. What about far lateral disc prolapse? The far lateral disc prolapse at L5S1, sometime because of the high iliac crest, you cannot do any other procedure where there's no such limitation with tubular retractor system. By adopting certain landmarks, one can easily reach and remove the disc with the same small scar and no muscle injury. 18-year-old boy with severe pain in the legs, multi-level MED. Now, 18-year-old boy, what choice we have with this kind of things? We tried multi-level disc MED in this case, L34, L45, and L5S1 on the right side. And you can see the pre-op film and see the post-op film that there's a very good decompression. Not only for lumbar spine, case of C7 disc prolapse, we can see it on our right side, exactly the similar approach, and we can remove the disc without any problem. Minimally, microendodiscectomy has been compared with PLIT, and it was a randomized clinical trial, follow-up of 2 years, and it was found that PLIT was only better for foraminal disc prolapse. For all other, MED had no problems. PLIT was, as expected, was inferior result for central disc. In conclusion, tubular retractor system is the present gold standard for lumbar disc surgery. It can take care of associated lumbar canal stenosis. Several randomized controlled trials over the years have proven it. Not ideal for foraminal disc prolapse. I do agree, especially hard disc. It works for both intraspinal and extraspinal as well at all locations for every conceivable associated pathology.
Thank you, Dr. Alok, for being in time and very lucidly coming up with your points. You have already shown your my way. Now let me take you to the highway. Tell me only two reasons why would you not learn and choose Dr. Deshtandu's technique or Dr. Kim's technique? Dr. Alok Ranjan, quickly answer two reasons. Why is your technique better than Dr. Deshtandu's technique and Dr. Kim's technique?
I think I'm an average surgeon and I would like to be very good in one technique. I don't want to adopt multiple, techniques, and I'm not very, very good in all those. So it's just that I have refined myself for that purpose. And I try to overcome all the limitations through one area where I like to be a very good surgeon. That is as simple a reason as possible.
That is one reason. What is the second reason that you don't want to learn Deshtandu's technique? Is he not ready to?
Deshtandu is nothing but another tube. Another tube. There's a tube technique. Deshtandu is a tube technique.
Alok.
And one thing I want to tell you that Deshtandu. Just 1 second, Rohidas. 1 second. I will like you to tell you one thing, that no randomized controlled trial in Deshtandu has been done with Deshtandu. They all quote the tubular retractor system, tubular dilator system. Not a single randomized controlled trial has been done with Deshtandu technique.
Right. I think we'll take up your point when Dr. Rohidas's turn comes. Dr. Rohidas, I'll get back to you. Let me just invite Dr.
Vishal, give time for me to speak. Okay, let everyone speak, then give time me to speak. Okay. Continue.
Yes, sir, your turn will come. We are
it's okay.
in a very organized and systematic fashion.
Continue.
Let me call upon Dr. H.S. Kim for his full endoscopic technique. Yes, Dr. H.S. Kim, can we have the talk of Dr. H.S. Kim, and we'll soon get back to Dr. Rohidas. His turn is next immediately after this, and we'll hear from him about his two ways and two techniques. Dr. Kim, over to you.
Yeah.
Tell us about my way and the future of disc surgery in your hands.
Yeah, thank you so much. Interesting. Can you show my slide? By recording video slide, can you show?
Tech team, can we have Dr. H.S. Kim's slides and video, please?
Yeah, can we have H.S. Kim's slide, please?
While we start, Dr. Kim, can you tell us about your two reasons why you don't want to take up the tubular surgery in your practice?
Actually, the endoscopic spine surgery, a full endoscopic spine surgery is the real minimized option of the spine surgery, meaning that firstly, there is a real preservation of the all structures. Maybe there is a first lesion, and the second things maybe in with the increasing second things that with the development of the surgical scale, the more deepest point and the more detailed point can managed by the endoscopically, and then give the more higher chance of return to normal life. That is the second things.
Thank you, Dr. Kim.
Play my slide now?
Yes, we are just waiting for the slides to come over.
Okay, I will play my slide.
Yes, there we are.
Okay. Okay. Thank you, Chairman. Good afternoon, ladies and gentlemen. I'm Hyun Sung-kim from Gangnam Nanuri Hospital, South Korea. First of all, it is my pleasure to give a lecture at the MSS Surgical Symposium. This time, my lecture is debate for future gold standard for treating lumbar disc prolapse, full endoscopic technique of transforaminal and intraminal. Small, effective. Less is more.
Advances in medicine and science continue to increase the life expectancy of humans. The increase in life expectancy has resulted in a rapid increase in spinal diseases, and lumbar disc prolapse is also increasing rapidly. However, humans want a happier life, and they want to maintain a normal life. To this end, efficient treatment of spinal disease is required, and the preservation of spinal functional segments play a very important roles. First, let's look at two interesting cases of lumbar disc prolapse. This patient is a male patient in his 20s with a very severe disc prolapse who came to the hospital with excruciating pain. Which of the following surgical treatment will be selected for this patient? This patient is a 32-year-old female patient with very severe disc prolapse. Which of the following surgical treatment will be selected for this patient? Full endoscopic lumbar discectomy was initiated with a transforaminal approach, and in the early stages, it was aimed at the treatment of minimized option with limited indications. However, advances in surgical technology have made it possible to expand indications for lumbar disc prolapse. Due to the advancement of surgical technology and the development of surgical instruments, a full endoscopic approach has become possible for almost all lumbar disc prolapses. However, due to the difference in surgical grade, it is difficult to apply a full endoscopic approach to lumbar disc prolapse in general, but it is believed that this problem can be sufficiently overcome through training and education. The development of the full endoscopic approach for lumbar disc prolapse has finally developed into a technique that can completely preserve the functional segment. The structural preservation intraluminal approach played a very important role in obtaining effective treatment through a full endoscopic approach for all lumbar disc prolapses. Here are some cases. These are the cases of lumbar disc prolapse that can be applied through a full endoscopic approach. First, it is highly inferior migration disc. And through many studies, it is now possible to solve the highly inferior migrated prolapse through a full endoscopic approach without any particular difficulties. The high canal compromise of the neurologic pending state is also effectively treated. Proximal to superior migrated prolapse can also be treated effectively. Bilateral disc prolapse can also be treated effectively. And also, effective treatment is possible even in recurrent disc prolapse. It can be treated stably even in high-level lumbar disc prolapse. And it can be effectively treated in four-corner lumbar disc prolapse. Even intradural problems can be stably treated through a full endoscopic approach. In L5S1, lesions can be effectively resolved through a structural preservation intraluminal approach. Even the case of L5S1 foraminal to superior migrated disc prolapse can be effectively resolved through a contralateral intralaminar approach. Therefore, the purpose of full endoscopic approach to lumbar disc prolapse can now be called a return to normal life with the preservation of a functional segment. And a recent study reported more than 95% satisfactory result for all lumbar disc prolapses through full endoscopic approach. In conclusion, according to Dr. Chen's report, it was reported that the full endoscopic approach had lower complications than the existing open surgery. And through this, Dr. Jin-Sung Kim said that the full endoscopic approach has become the gold standard for lumbar disc prolapse. Lastly, this patient is a male patient in his 20s who came to the hospital with symptoms such as low back pain that occurred after a recent traffic accident. Until then, there was no specific symptoms. So, did this patient have no specific problem with the lumbar spine before?
Hello.
This patient is a 32-year-old female patient who recently visited the hospital with symptoms such as low back pain that occurred after walking excessively. And there were no specific symptoms until then. If so, did this patient have no specific problems with the lumbar spine before?
These two cases saw the initial presentation.
Thank you so much.
Thank you, Dr. Kim, for bringing out the highway on my way, where you showed one of the most difficult and the challenging cases, how you can tackle them. And 95% satisfaction rate in not only difficult, but very difficult disc herniation. I think that is very commendable. Now, one quick question before I can request the tech team to please get up Dr. Rohidas's talk there. Dr. Kim, while I put my question to you is, what are the two problems in your early learning curve that you faced with this endoscopy and you continue to face the same problems even today?
Yes, I already mentioned that in my presentation.
Tech team, can we have the next talk online, please? Yeah, Dr. Kim.
What?
Yeah, question, Dr. Kim. Yes. Two problems that you used to face and today also you face the same problems in endoscopic surgery.
Can I give the answer?
Yes,
We
please.
have the next talk ready.
Yes, Dr. Kim.
Okay. There is a endoscopic spine surgery still have no training course and the educational course. There is a most big problem in the learning curve. Maybe I think that maybe in the future, after organization of the education and training course, the endoscopic spine surgery is not a steep learning curve. Okay.
Right. Thank you, Dr. Kim. So we move on from PLED back to the midline, where Dr. Rohidas, the pioneer of Destandu technique, he's going to tell us about his way, why his way is the future gold standard in management of lumbar disc prolapse. Dr. Rohidas, over to you.
This is a different topic, Destandu's technique, extended applications. This is not the topic. 4 slides, we'll just try to know Destandu's technique. Hello.
Stop the video. This is not the video.
This was the yesterday's topic.
So, Dr. Rohidas, do you have those slides with you? Do you want to share now?
Yes. Just ask Prashant because I have uploaded both.
Yeah, just a minute. I think
Just
there has
a
been a
minute.
confusion. So we'll just exchange the videos.
No worries. So while that video comes up, Dr. Rohidas, we would like to hear your comments on why have you not changed your views on Destandu technique, and is there, why would you not want to take a full endoscopy or PLED in your practice?
Listen, in my talk at the end of the things, I have discussed this full endoscopy, pure endoscopy, assisted endoscopy. These are all vague terms. There is no proof for that. The basic is we started with laparoscopy in 1983. When we used laparoscope, we never told that it is a laparoscope assisted surgery. It is a laparoscope which gives good vision and triangulation is there. So all this full endoscopy, pure endoscopy, these are the marketing gimmicks. I'm crystal clear in that. Second thing, we started with the full endoscopy with a foraminal, and now we have changed to an interlaminar with a 16 millimeter sheath. So incision, there is nothing in between the incisions. So don't fool the youngsters by the size of the incision in millimeters. Fixed tubes and mobile tubes. Now in fixed tubes, we have multiple tubes. Everyone has to answer why they want to have a multiple tubes, because they want to have exposed area at the operating site. When the patient is obese, like in Europeans and Americans, they have to have an X tube to have a more exposure at the site of the pathology. 10 millimeter diameter tube with a 120 kg patient, you cannot go on the opposite side with a nice microscope also. Third is now Kim has talked about the functional surgery. In lumbar, we talk about functional surgery, but in cervical, when there is a small disc, we try to fix them. So these are double standards. And with Distendu, in case of Indian patients, in case of an Indian scenario, where the patients are poor, not in Korea, where the patient, everybody is insured, we have to think of a system which is less economical. Frequent charges of the instrument should not be there. And we have to think in case where we will be able to use the same system for all the pathologies.
Thank you, Dr. Distendu. Dr. Rohidas, you have already mentioned the benefits of Distendu technique. It is economical, it is reproducible, it is mobile, and it can give you access to the other side, even in the
And
most
it is
sick
the
and
only
obese
system.
patients.
Now, there is always skepticism that with microscope there is a 3D vision, but Distendu is the only system where you can use 3D endoscope, and
Right.
it is like a mobile microscope.
Right.
You don't
I
have
think
to
this fight is
defocus.
going to get more interesting. We have a good panel discussion coming up when we have the young Turks like Dr. Shomayu, Dr. Ali Govind, Jion, and almost everyone here is going to share their views on all the technique that they are using. Is the video ready, Umesh? Umesh?
Everybody,
Yeah, we are.
everybody has seen the yesterday's case, which I
Wait a
demonstrated live.
minute. We will play Dr. Rohidas's video now.
Yes, yes.
Coming.
Yes.
Srinivas Rohidas, is it the same thing you wanted?
Yes.
Thank you so much. Continue, please.
And use technique, endoscopic spine surgery. And this is for the youngsters. They have to decide what is the best technique for them in minimally invasive spine surgery for future. Basically, application of keyhole surgery or MSS does require latest technology initially, but it also requires willingness to understand the concept. If patient understands that concept, then it's a brand. Basic thing is we have to minimize the collateral damage of the tissue, re-evaluate the current thinking. There should be generous use of the endoscope, and always remember keyhole or MSS refers to a concept. It's not the size of the incision, which is MSS. About Distendu technique, these are the basic instruments. This is the outer tube. This is the inner tube. Inner tube has 4 channels. This is the channel for the suction. This is the channel for the endoscope. This is the channel for the working instrument. And this is the channel for the nerve root retractor. The basic principle is just like a laparoscopic surgery. The instrument and the endoscope are at an angle of 12 degrees. They reach the target area. So there is no intermingling of the instruments. These are the basic instruments: 2 Kerrison punches, nerve hook, disc forceps, a trocar to rupture the annulus, inner tube, and the outer tube. This is an angle in between the working instrument and the endoscope, which is 12 degrees, and we use 0 degree endoscope. This is how we mobilize the system. It's a mobile system. You can move around each and every direction, cranial, caudal, medial, lateral. You can zoom in also with the help of the outer tube and inner tube. So Distendu technique, named after Dr. Distendu, who is a French neurosurgeon. He has used this system since 1993. It's an air-based endoscopy and mobile system. These are the basic things. This is the only system which can be used for all pathologies like lumbar discectomy, lumbar canal stenosis, cervical anterior and posterior approaches, thoracic disc and intradural SOA. So all pathologies except intramedullary tumors, it can be used. It is the cheapest system available, which can be used with the routine instruments, and the anatomy is not foreign to the surgeon at all. It is the same anatomy which we use for microscopic technique or open technique. This is the only system which can be used with 3D endoscope. And in future, it can be used with the 4K endoscope. Now, this is one of the example. Now, this is an intradural tumor. Dura is open. Same exposure. We can use instruments. This is the nerve, rudimentary nerve root which is cut. Intradural neurofibroma. But this is not possible with the wet endoscopy. Routine closure of the duratomy. We use anasto clips. We can use 4-0 Vicryl also with a pediatric needle holder. So if there is an initial tear, it can be easily tackled with this technique. One of the complications in MISS is the dural puncture, dural tear, or dural laceration. With this mobile system and dry system, we can easily close dural tears. Everything is under vision. So watertight closure. So this technique can be used for all pathologies. Now this Distendu technique, we have to have a critical comparison to choose the techniques for the beginners. First is the skin incision. Second, whether local anesthesia or general anesthesia for the technique. Cost of the instruments, endoscope size, degree of the endoscope and mobility of the endoscope. Endoscopic exposure at the site of the pathology. Whether it's a wet or dry technique, what are the advantages and disadvantages? Whether it is a true or pure endoscopy, what they call it as, or endoscopic assisted. Whether the technique is versatile. What about the learning curve of the technique and complication avoidance with the modification of the technique? So we'll try to discuss one by one. Now the skin incision. Does the size of the skin incision millimeters matters in the final outcome? We have to just think of this. One should not consider the incision size while choosing the technique one wants to choose. When it is a small incision, we have to use delicate instruments, smaller endoscopes. There is a limited vision and less mobility. This is the comparison with the interlaminar incision and the lateral approach incision. So don't compare the incision in millimeters. What the surgeon does at the site of the pathology for that particular case is very important. And in spine, each and every case is a different thing. When you use an endospine duo, this incision can be around 15 millimeters. Second, whether local anesthesia or GA. We try to prefer local anesthesia for easy mobility, but with a good GA by an anesthetist, patient can be mobilized early, and we mobilize our patients after 2 to 3 hours without catheter. But general anesthesia gives you good muscle relaxation, and that helps you in minimizing the operating time. Cost of the instruments is really important for the youngsters. Distendu technique, very few instruments, routine instruments, so the cost of the instruments is quite considerable. Recurrent cost of the instruments, if the instruments are delicate, that one has to take into consideration. Smaller incisions, smaller delicate instruments, breakage is expected. Endoscope size, whether it's a 0 degree, angled one. In Distendu, we use 4 mm diameter, 0 degree scope, which is 18 centimeter length. It's a universal endoscope. We can call this as a routine endoscope. When this can be used as an angled endoscope with the angle in between the endoscope and the instrument, which is 12 degrees, which is just like when we operate with two hands, the angle between the tips of the two instruments is 12 degrees to 15 degrees. This is the mobility of the endospine. You can move around each and every direction with a good vision without changing the anatomy because of the angled endoscope. In 45-degree or 30-degree endoscopes, we have to assume in that angle the deformed anatomy. But in distant use technique with 0-degree, it is the same as what we look at with the microscope or with the open technique. Another important thing is the exposure at the site of the pathology. This is really important to give very good results. Smaller the incision, smaller endoscope, limited exposure. For wider exposure, now the newer techniques, they use wider sheath and they have come up to around 15 millimeter to 17 millimeter sheath. And the distant incision with the smaller endospine duo is something around 15 millimeters. So the incision doesn't matter. What you have the exposure at the site of the pathology is important. If the exposure is adequate, then tackling of the pathology is better in cases of canal stenosis, cervical anterior, cervical posterior, and space occupying lesions. Now, wet and dry technique. Distant to technique is a dry technique. In wet, it is necessary. The fluid is necessary for good vision with the smaller endoscope to create pressures so as to get hemostasis. It helps in muscle retraction. It creates a cavity. In wet, there are limitations to treat dural tear, and we have to need to convert it into open. In dry, the muscle retraction is really important. We have to separate the muscle nicely with minimal trauma to the muscle, and with the outer tube, we have to nicely retract it so that it does not intrude into the tube. In wet technique, dural tear is really difficult to manage because of the continuous fluid pressure. We have to need it to convert it into open, and there are problems related to the fluid overload when there is a dural tear. In dry technique, it is quite easy as compared as like when we close the dura in open technique. Another point is the true or pure endoscopic assisted. True or pure endoscopic or endoscopic assisted. There is no exact evidence to accept this terminology. Laparoscopy never termed as an endoscopic assisted laparoscopy. When the endoscope and instruments are parallel to each other, it is termed as a pure, but it doesn't mean that, because when the endoscope and instruments go parallel to each other, we have to use an angled endoscope to see the tip of the instrument. We cannot use a 0-degree endoscope. Endoscopic assisted, we get a wider exposure and mobility. Another important thing is the versatility of the technique. With distant use technique, we can treat lumbar disc, lumbar canal stenosis, multiple level canal stenosis, posterior cervical, anterior cervical decompression and discectomy, thoracic disc and stenosis, intradural extramedullary tumors with the same set of instruments. Maybe in cervical, we have to use 2 mm or 1 mm Carrison punch. The outer tube or inner tube is the same. Now, learning curve in the distant use technique is same as compared to the other technique. But because of the routine pathology, what we see in the routine cases, open cases of microscopic, the understanding of the anatomy is quite easy. The orthospinal surgeons, because of the arthroscopy and their knowledge of triangulation, it becomes quite easy for them to learn this technique. For neurospinal surgeons, because of the microscopic fixed vision, they take little longer time to adjust to the mobility, the mobile vision of the endospine. Cadaver courses and hands-on is quite really important to learn the technique. Now, modification and complication avoidance. Distant use technique is the only technique which can be used with the 3D endoscope. In future, it can be used with the 4K endoscope. It can be used for fixation. Good amount of decompression, and with the outer tube, it can be used for the fixation. It can be used for the tumors, intradural extramedullary tumors. It can be used with 0-degree and 30-degree scope, but 0-degree vision is quite good as compared to the 30-degree. The smaller size of the system make the incision smaller in thin build patient. It is called as an endospine duo, and the incision is something around 15 millimeters. Now, this is the future. This is with the 4K. You can see this with the ICG. This is the carotid. This is the carotid artery. You can see the carotid in different color. Now this is the carotid. These are the vessels at the base of the skull. These are the vessels. With the anterior cervical to locate the vertebral artery. So the philosophical conclusion, but it's a reality for the real gold standard. Our final but unreachable goal is 100%. No technique can reach to 100% success, but our reachable goal is everyday learning, training, and improvement in the technology. Thank you.
Thank you, Dr. Rohidas. I am sure this reachable goal will soon be accomplished by various techniques that we are discussing here. May we have the tech team to get the talk on UB by Dr. Kim coming up next. We have already seen a tubular way of dealing with it. We have already seen PALD. We just heard Dr. Rohidas speaking about the Stando mobile system. And the last but not the least, the more accomplished way of dealing with all disc pathologies, interlaminar posterior UB. Dr. Kim, over to you.
I am Jiyoung Kim in Spine Center, UC Memorial Hospital, South Korea. It's a great honor to present at the MSSAB Surgical Symposium. The topic is UB is simple and cost-effective for treating lumbar disc herniation. UB surgery is performed through two separate portals, viewing portal for the saline input and endoscope, walking portal for the saline output and surgical instrument. During the uniportal endoscopic surgery, saline input, output, and instrument are passing within one endoscopic system. Fixed 6 mm walking diameter has limited the use of various size and shape of instrument. However, UV system has a separate walking portals, can be changed in the size and location. Hence, various sizes and shape of the surgical instrument can be used in any direction. This pre-use of instrument must be a powerful benefit of the UV system. UV procedures are performed under familiar and magnified surgical view. We can use the existing equipment for microscopic spine surgery and arthroscopic spine surgery. Furthermore, the drill is compatible with the shaver. Therefore, we don't need to spend money to buy new equipment to start simple lumbar surgery. This article shows the cost effectiveness of endoscopic discectomy compared to microdiscectomy. Furthermore, there are also compared cost effectiveness among the three endoscopic surgical groups, transperineal, interlaminar, and biportal endoscopic discectomy. UV surgical group show the values between the TLD and microscopic surgery, operation time, hospital day, and clinical output, reoperation rate, and readmission rate. Three endoscopic groups show the similar cost of surgical instrument. Primary hospital cost and overall cost were between the TLD and the microscopic surgery. As a result, endoscopic discectomy is more cost-effective compared to the microdiscectomy. There is no difference among the three surgical groups. This article describes the learning curve of the UV surgery for lumbar decompression laminectomy. The surgeon was proficient in open and microscopic lumbar decompression for spinal stenosis, but didn't have any experience with endoscopic surgery. After 30 cases, the slope of the cumulated number of failures decreased. Then 58 cases, surgeons have reached adequate performance. UV pressures are required substantial learning curve period, but did not have a steep learning curve. It may be due to the simple and easy accessibility. This case showed the bilateral inferior migrated lumbar disc herniation was treated by UV surgery. Bilateral discectomy was performed with conventional surgical instrument, visual deposit, and calcium punches. Recently, UV equipment has been developed remarkably from the optimize fine UV scope to the endoscopic drill and curved instrument. We can perform the discectomy with two-hand technique by using the scope cannula self-retractors. Another assistant is not necessary for the root retraction. Walking cannula make the good saline up. There was better size of and shape of the curved punches and curette and acetone. Many equipment has been developed, but we don't need to have all of them for lumbar discectomy. But the scope self-retractor and walking cannula is essential. Efficient two-hand technique is possible with scope self-retractor and good saline approach prevent surgical neural damage by decreasing the hydrostatic pressure in the walking space, especially at the cervical and thoracic cord level. The interlaminar contractor approach to can remove the intraspinal and pyramidal and extraproximal HMPN with one surgical direction while preserving the passage joint. The entire length of the existing nerve root until the fouled area was successfully decompressed. Advanced UV techniques save the cost by escaping the high-cost fusion operation. Cervical posterior decompression surgery could be performed successfully with the advanced UV technique. The patient has saved the cost by escaping the high-cost laminoplasty or two-level HDF. Thoracic OLF was also successfully removed by advancing UV technique and passage joint surrounding posterior muscle and ligament structures were preserved. As a result, the patient has saved the cost by escaping the high cost of posterior instrumentation and decreasing the hospital day. Thank you for your attention.
Thank you, Dr. Kim. I think in the interest of time, I'll just run through one quick question through our expert panel. Let me start with Dr. Shomayu Datta. Dr. Shomayu is a young Turk and he's a consultant spine surgeon at the Park Clinic in Kolkata.
Hi, sir.
What happened?
Hello?
Yeah.
Vishal, you're frozen.
I think Vishal's phone must have actually gone down. So
Please tell me one more time. My system was just down. Before. Please.
Okay. So I think there is a connection problem with Vishal. So I was not sure what he's going to ask. So since Vishal is not there, I'll take the liberty of asking Dr. Rohidas. You are responding to quick response, less than 30 seconds, because we are running really short of time.
This is just like an Arnav show.
I know. So what we should do is
youngsters are not going to learn by this.
I know, but this is unfortunately what has happened. All the talks are beyond time. We had given 6 minutes.
My advice to youngsters is try to go to the basics of each and every technique. Learn the basics and decide for your patients. An Indian should not think of a Korean patient. Indian patient at your place. What is best for you and try to learn it and master it.
Yeah.
Don't try to learn multiple techniques. It is of no use at all.
Okay. So with that, I will take the liberty of addressing for Vishal, and I will make this session close because we have another session coming up, which is equally important. Before that, I thank all the speakers, including Vishal Kundani, Jinset Bey, Ali Guven, Pramod Lokhande, Mohinder Kaushal, Ketan.
Alok wants to speak.
As expert panelists. Yes, please. And I also thank John Kim, Dr. Rohidas, Dr. Hinson Kim, and Dr. Alok Ranjan. And we'll close with one comment from Alok. Then the next session will start. Dr. Alok.
Thank you.
Thank you.
You
Unmute him. You have to unmute.
Alok, you have to unmute.
I thought that the topic was a gold standard, which means it is not about a great surgeon like Rohit Das. It is about average surgeon doing the surgery and reproduce it. And the second thing about the scientific evidence. You understand?
My patients are my scientific evidence, Alok. Don't worry about that.
This
Always
session closed.
don't cry for a scientific evidence.
I think with the interest of time, I request both of you to have a private chat.
Youngsters should think of their patients, not for the scientific evidence.
I agree. So with
patient doesn't ask for scientific evidence. In court, your patients is better or not. It is the important thing.
Dr. Rohidas and Dr. Alok Ranjan to have a discussion separately. Vishal, in your absence, have make the session closed. Thank you for your interactions, and I will go and ask Ranjit to start the next session, please. Thank you so much, all of you.
Thank you, Dr. Raja. Thank you, Dr. Umesh. Thank you, panelists, Dr. Kim, Dr. Alok, and Dr. Rohidas. Thank you so much.
Ranjit, it's all yours.
Thank you very much, sir. So shall we go ahead and can you allow me to share the screen? So with this session, start with the session on scientific evidence for interbody fusion. So with this, let me just start. So we know that we heard a lot of things about decompression, fusion, no fusion, which technique. So we all are very familiar with this picture from literature. When you choose an interbody, whether is it an A leaf or is it an O leaf or is it an X leaf or a T leaf, with this, let us have the classic standard technique, the young man dashing spine surgeon from Mumbai, Dr. Mihir Bapat, or is it the side kick or the side approach man from Ahmedabad? I don't mean the side kick, I'm the master blaster from Ahmedabad, Dr. Amit Zala, or is it the front man from Delhi, Dr. Anand Naik, or is it our tube guy from Maharashtra, from Satara? Is it Dr. Girish Datta? Let's see who's going to take the lead. With this, I will let us know who's going to get the crown as the king technique. And let me invite first Dr. Mihir Bapat to give his talk on for MIS TLIF as the standard technique of choice for interbody fusion. Dr. Mihir Bapat, please. Do we have Dr. Mihir Bapat's presentation?
I thank the organizers of MSS for giving me this opportunity. MI-TLIF is a versatile technique, and we do a hybrid version of MI-TLIF, which probably suits a lot of indications. So this is a typical example of a single level stenosis. All of us would agree that MIS-TLIF is now the gold standard for this procedure. However, in our technique, we do not use the tubular retractor. We use a simple micro endoscopic retractor and use a paramedian approach after having passed the percutaneous screws through a separate channel. And this approach uses a microscopic fenestration technique to complete the MIS-TLIF. So we have tried to extrapolate this particular approach to a variety of indications, as I'm about to tell you. Now, the most important thing in this approach was, will we be able to complete an over-the-top decompression of the contralateral side? Now, this is the way to do a contralateral side decompression. The undersurface of the spinous process is burred and the ligamentum flavum is excised. The contralateral root can be easily decompressed, and even a contralateral discectomy can be done through this approach using a simple paramedian microscopic fenestration. The other thing that sort of baffles a minimally invasive TLIF is if there is an adjacent segment disease, how do you tackle it? Now, this is an example of a 2-level percutaneous screw with a laminectomy done, This was done about 6 years back, and the patient had an adjacent segment at alpha S1. So we have managed to sort of remove the implants through using the same pinholes and extending the implant to the lower level and fixing the rod in place. So it is possible to capture the rod even without the towers, and it is possible to extend it to the adjacent segment. In cases of multi-level stenosis, what we have found out is that the combination of microendoscopic, a microfenestration approach done on the contralateral side. Now, in this case, we could do a 4-level surgery through 3 centimeter paramedian incisions using over-the-top decompression at all levels. So we have used this technique to correct degenerative scoliosis up to the level of L1 and L2. High-grade listhesis is another bane for MIS TLIF. And here you can see that high-grade listhesis can be reduced using a microscopic fenestration approach, and the whole dilemma of whether the exiting route can be adequately decompressed or not, that can be adequately demonstrated as in this video. So we have probably been able to tackle most of the indications of lumbar spine surgeries using the microfenestration approach. In this particular case, the patient had presented with a discitis, and using separate fenestration screws keeps the screws protected in a separate muscular compartment, and the microfenestration approach is used to debride the disc. This, in our experience of more than 20 cases now, we have found out that the implants need not be really bothered about anymore because they are less likely to get infected. The disc space, as it is separate from your implant, can be easily tackled, and it behaves more like a soft tissue surgery if you do not use a cage. So you can easily debride and treat these patients with IV antibiotics, and the whole dilemma of whether the implant may form a biofilm is easily negated. So as you can see, there are a variety of approaches that you can do using fenestration screws and microfenestration approaches. And really, it is one technique that suits almost all the indications in the lumbar spine. And I think these approaches can be extended to most of the dilemmas that baffle surgeons across the world. Thank you.
Thank you very much, Dr. Mihir. So let me ask, we have the master panel, Professor Ji-Sung Kim from Korea, Dr. Jeon Kim, as well as our young Turks, Dr. Deepak Bangle, Dr. Murli Krishna, Dr. Akshay, and Dr. Sai. So let me ask Dr. Murli Krishna. Let us have the young Turk first. Dr. Murli, in your practice, what do you believe? Is it is MIS the gold standard, or is it anything else which is going to be the gold standard for interbody fusion? Dr. Murli.
Yeah, good evening, everyone. I'm well experienced with MIS TLIF. I don't have much experience with oblique direct lateral interbody fusion. So I always prefer MIS TLIF for any degenerative spine diseases.
Okay. So let us ask Professor Ji-Sung Kim. Welcome, Dr. Kim. So Dr. Kim, you are versatile with MIS TLIF, OLIF, and all sort of fusion. So today, in your take, when do you exactly choose an MIS TLIF as compared to an OLIF or an ALIF, Dr. Kim? Dr. Ji-Sung Kim.
Thank you for asking me, Ranjis. So recently, I have changed my surgical strategy a little bit compared to I used to be. When I, for example, when I see the spondyle recesses, regardless the canal compromise status, I love to approach the lateral retroperitoneal approach first, because compared to the MIS TLIF, so we can make the better restoration and the less subsidence and high fusion rate and high faster velocity of the fusion, and we can minimize the complication. So in the case of if there's no problem anatomical hindrance such as the Oldic corridor and the variant of the vessels, I love to the retroperitoneal lateral interbody fusion like Olive or sometimes axillary procedures.
Thank you, Professor Kim. It's very kind of you. Thank you for staying back. I know it's very late for you. Thank you very much, Professor Kim. It's a very good value. So you will always choose first choice for anything for you is it's an OLIF or a anti-psoas procedure. And then if you cannot do like the contraindications you mentioned, you will go for an MITLF. Thank you very much. So let me ask Dr. Sai Jyot. Dr. Sai Jyot, are you there, Sai? Dr. Sai, another young Turk? No. So we have Dr. Deepa Bangle. Dr. Deepa Bangle, what is your take on it? In your practice today, when do you choose MIS TLIF as compared to? I know that you are in a setup where you do a lot of OLIFs. So when do you choose MIS TLIF over an OLIF?
If the patient have a severe severe facetal arthropathy with foraminal stenosis, with neurogenic claudication symptoms, with canal stenosis, we definitely prefer the TLIF over the OLIF.
Okay, severe canal stenosis where you have got high grade listhesis. Thank you very much. So with this, let us have the next master blaster to deliver his talk, and that is next one is Dr. Amit Zala. Let us see what is his take on the lateral approach. Can we have Dr. Amit Zala's presentation? He needs no introduction for anybody.
Everybody. At the outset, I would like to tell that I am already the winner because my previous speaker, Mihir, was talking on TLIF, and the organizer have already said that it's a convenient approach. That means it's never a perfect approach. My next speaker, Anand, is going to speak on ALIF, which is a dark horse. That means it's also not a perfect. And the last speaker, Girish Datar, is going to speak on EndoLIF, and you know that it's not for today. So the only best approach as on today are the lateral approaches for the interbody fusion. But nevertheless, to complete the debate, let me say that TLIF, that same boot suits all. I don't think it's perfect. You can never have a one surgery for all the problems. And we are all spine surgeons and not gynecologists who have only hysterectomy for all gynec problems. The spinal fusion has got so many different aspects. And the other thing is, it's a smaller boot for everyone. Why? You know that the cages of the TLIF are much smaller compared to the cages of the lateral approaches, and therefore it has a high chance of subsidence, and it can never give a good sagittal balance what the lateral approaches can give. It's a destructive approach because you are destroying the walls of the spinal canal to enter into the disc space. So you have a bony resection, more muscle damage, and because you are entering the spinal canal, you have chances of neural and dural injuries. And these patients definitely have more back pain. And the revisions are difficult because of the epidural fibrosis. Coming to the ALIF, though it can give a good large size cage, you can do a good discectomy, you can get a good lordosis as you want to get it, and you can get a good fusion. And over and above that, you have that macho feeling of done a very great surgery. But mind you, that you have to go between the bifurcation of the aorta, and these bifurcation of the aorta behaves like two horns of a bull. And what you are doing is putting your head inside these two horns. And what happens if you fight the bull, sometimes you are caught in a very odd positions and you can damage one of the horns, or you can damage one of the vessels, and then you are in a difficult situation as is depicted here. And therefore, it's a difficult approach, and the salvage is also very, very difficult. Coming to the endoliph, endoliph behaves like this jaguar. The endoscopists, they are like jaguars, and they would try to put their head anywhere they can do a good decompressions, but they should not put their head in the fusions. They have a long way to go. Present stage, they are struggling just putting the cage inside. There's no way to get a good segmental lordosis, difficult to decompress the central canal, and difficult when there is a disc height which is lost and there are no long-term results. So they should not put their head inside anywhere, otherwise they would be in trouble. The best approach is the lateral fusions. You get a perfect balance. You get a good indirect decompression by putting a large size cage. You get a good sagittal balance and you get a less chance of subsidence. You can get a good fusion because of good clearance of the disc and better grafting. And you can do all the MIS way. You can get a good clinical outcome with minimal back pain to the patients. Giving some of the examples, this is first situation. A patient is having a spondylolysis and is unstable at L4-5. There is no need to enter the spinal canal here. It's only unstable spine and needs only stabilization, and lateral approaches are perfect for such conditions and not damaging the contents of the spinal canal. Now, somebody would say that this is one of the easiest approach. Coming to this case, you can see that it's a severe canal stenosis, whether you can do the same lateral approaches, and definitely yes. And you can see that we just did a lateral approach or an OLIF approach, and you can see how much canal clearance or indirect decompression can give you a good canal clearance. And more or less, it can achieve a good sagittal and segmental lordosis. Situation 3, in an adult deformity, I think this is one of the best indications for lateral approaches. This is a doctor, old age, with a chronic low back pain, with a very high PILL mismatch of 25. And you can see that we just did all CMIS, which was a staged operation, and can get a good, very good sagittal balance and a multi-level lateral fusions at 3 levels. You can get a very perfect lateral balance. Not only the lateral or sagittal balance that I got, but we also got a good coronal balance. This is another case where you have a very high SVA, a lot of positive balance in an adult deformity. And just by doing lateral approaches, we could get a good correction of the sagittal balance. And in this last case, a double level spondylolysis with lysis, which was operated in 2011, presented to us in 2018 for an adjacent segment disease. The lateral approaches are best, just putting a cage at L23 and L34. And you can see this is a 2-year follow-up. You can get a very good canal clearance, and that's a fusion. So we got a good decompression, we got a good fusion, and a good balance. I can just go on and on for these lateral approaches and different cases, but I would shut my case here. And in summary, I would say that the lateral fusion are the best approaches for me as on today. Clinically, the patient should have claudication, no rest pain, and SLR negative. The patient should have instability above L4-5. You can do it at multiple levels, which is much more easier compared to multi-level TILIFs. Do it in adult deformity for a good sagittal balance. For an adjacent segment, one of the best indications. So I think one of the best and the balanced approach as on today are the lateral approaches. And I would close my case here. Thank you very much.
Thank you, Dr. Amit Zala. Excellent as always. With this, let me invite our master panelist, Professor Arvind Jaiswal. Sir, can you please unmute yourself, sir? Can you please give your opinion, sir? You've seen it all, how we have gone from all the way open to the small incision to endoscope. What is your take on the situation, sir? In your experience today, which do you think is the winner? Is it the TLIF, the OLIF, or the ALIF, or the endoscopic fusion, sir?
As I see it, as it was in the open surgery era, right? You started with the addressing your diseases and pathologies from the back to start with, simple stenosis and disc problems. And then things moved up anteriorly, and there was a spurt in anterior surgery because we all thought the pathology was mostly anterior. So anterior came on, and then everybody went back to posterior, right? And this, as I see for future, right, the massive advantage of anterior as well as posterior approaches, decompression, stenosis, and foraminal stenosis, facetal hypertrophy needs to be addressed posteriorly. Whereas, as has been said and proposed, the better restoration of lordosis, multiple level involvements, anterior and lateral approaches. I mean, anterior approaches, as Amit rightly said, revision is a big issue in the anterior approach. So lateral approaches for multi-level is where the future would be. But the posterior surgeries and for localized decompression, posterior surgery will have a role as it is. And with better endoscopic techniques coming in, posterior approaches would become. And as I see in multiple levels, both combination of lateral approaches and posterior approaches is where the future would be.
So for a single level L4-5 grade 2 listhesis with back and leg pain, what would be your choice of fusion?
As of now, posterior, MIS TLIF.
Thank you, sir. Thank you very much. Let me invite our young Turk, Dr. Akshay. Dr. Akshay Hari from Bangalore. Akshay, you've seen it all. You've been with the team which does front, back, side, left and right. So what is your take on this today? For a single level grade 2 L4-5 spondylolisthesis, what is your choice of fusion procedure? Dr. Akshay.
I think if there's a good enough anatomical corridor to perform an OLIF, and if there is no stenosis or facetal hypertrophy, I think I would go for an OLIF. If it is a straightforward single level grade 2 listhesis.
Okay, so you prefer a OLIF over a MIS TLIF for a single level listhesis. Thank you very much, Dr. Akshay. With this, let me invite our next master, the master who has probably the largest number of ALIFs in India. I don't know if in South Asia. Dr. Anand Naik from Delhi. ALIF, the dark horse in the waiting. Can I have Dr. Anand Naik's talk, please?
Yeah, my talk is not pre-recorded, so I will share my screen.
Please.
Yeah. Can you see
yes,
the
screen? Oh, yes, Anand. We can see your desktop.
Yeah, so I'll play my presentation.
Yeah, please.
So you said ALIF, dark horse in waiting. It's not waiting. It's not in waiting. It's already waiting. Come on, all approaches and try to catch up with me. Let's discuss why ALIF. Because it allows complete removal of disc and pain generator, not possible by any other technique, not possible by posterior endoscopy, OLIF, not possible. Best end plate preparation by the anterior approach, and the largest grasp placement without manipulation of any nerves can be done by anterior approach. OLIF and XLIF, okay, they are slightly lagging behind. Best sagittal coronal and coronal balance without damaging any of the posterior stabilizing structures can be done. In OLIF, you need to put the posterior screws as well. So like Jhala sir said, I'm not talking about the good. I am talking about the excellent, not best, not good, excellent results. So what I am achieving biomechanically by doing an ALIF, I'm achieving a stability of the spine. I'm achieving a fusion of the spine and stability because there is less rotation and very minimal AP translation. It prevents the graft kick out. It always keeps the graft between the bone. And there are compressive forces, and because of the cantilever action, you can get a better fusion. And combined with BMP, you get a faster fusion. You don't have to wait for a year. Maybe probably 4 to 6 months is the time with BMP you can achieve a fusion. It's an indirect decompression. I'm not touching any of the nerves. So very less chances of having any scar in the neural foramen and very high chances of nerve repair. Whereas in the OLIF, you need to put those lousy posterior MIS screws again, maybe in another added procedure, change the patient to a different position. So lousy approach, I would say. I can achieve the excellent sagittal and coronal balance with ALIF, no doubt about that. So patient selection is always the criteria. There are some drawbacks about OLIF and some about ALIF. OLIF not possible for L5S1. L5S1 OLIF is almost like an ALIF. There is not much of a difference. ALIF not possible at L1, 2. L2, 3, yes, you can attempt depending on your orientation about the anatomy. So we do all these imaging studies, EMGs, and all different types of blocks and things. So instead of indication, I will simply talk about the contraindications because there are so few and it's easy to remember. Atherosclerosis is a challenge. You have to be very careful whenever you are doing an anterior approach. Bottom 3 levels easily can be done, but you have to be very careful if there is calcium deposition in the vessel. If there is any prior vascular reconstructive surgery or any prior abdominal or retroperitoneal surgery, then probably you have to be a bit careful, or maybe you tend to avoid. Same thing goes with the OLIF as well. OLIF is a left-sided approach, but if there is any prior retroperitoneal surgery, I still have a right-sided XLIF. So XLIF is slightly better than OLIF compared to this kind of indication. If there is any history of severe pelvic inflammatory disease, any retroperitoneal fibrosis, yes, it's a contraindication for any anterior approach, be it ALIF, be it OLIF, or be it any XLIFs and all. So approach, retroperitoneal and transperitoneal, it's different. It's not a typical vascular or a general surgery procedure, and they are basically designed to assist on the spine, and you can monitor and protect the entire vessels throughout. Like Jala sir has said, there are two horns he showed as a picture, but these horns are inverted, and an inverted horn will never hurt you. You can go between them, between L5, S1, protect your vessels. You can go very easily over there. At L4, 5, you just have to move the vessels across. So approach per se is not difficult at all, and it's not time consuming. Hardly takes 5 to 10 minutes to reach there. Very minimal amount of blood loss. There's certainly a lot of advantages to the patient and to the surgeon, but most importantly, less OR time, less blood loss, excellent sagittal and coronal correction. I can treat standalone discogenic axial back pain with anterior technique, but not with any other techniques. So there are so many spurious arguments against anterior lumbar interbody fusion in India, but by the end of this talk, it will be clear to everyone. These are our experience: 359 cases, single level 144, 189 two level, and very few 3 level. And you can see that all parameters, the leg pain on VAS, back pain, ODI, and RMDQ and ODI, they all went down, and they were significantly maintained over there, and they were all clinically significant improvement, and they were all statistically significant as well. Results nearly 100% fusion rates at 1 year mark, maybe earlier. One patient did not have fusion because I used a DBM. Subsidence rate is less than 1%. Even if there was a subsidence, the indirect decompression was so excellent that the patient never had any problem. Had 4 IVC injuries. So most of these complications, it depends on the number of surgeries and the access, whether you have an access surgeon or not available. And over a period of when you do more cases and all, you are acquainted with the anatomy, and you can manage them. Only 4 patients had skin abscess, stitch line abscess, which were controlled with prolonged antibiotics. At 3 years, the only drawback in ALIF, I would accept that 8 patients had sacroiliac joint issues at 3 years. And in all of them, the lordosis was not properly corrected. So I will conclude that ALIF is the excellent, probably the best approach to achieve sagittal and coronal balance. It will not hurt you. They are faster. You will get super awesome, excellent fusion rates. The technology is so advanced that ALIF is more enjoyable surgery. Within an hour, you finish off a single level surgery. Within 2 hours, you finish off 2 level surgeries. So thanks.
Thank you very much, Dr. Anand. That's been excellent. So, I mean, it's got amazing 100% fusion rates.
Yeah.
So, what do you use in all your cases of ALIFs?
I use BMP in all my cases.
Okay. So, you never use autobone at all?
No, because there are donor side morbidities. And if I'm using a bone graft or any synthetic material or anything, then I need to put the posterior percutaneous screws. That defies the purpose of doing a minimal destruction surgeries. For,
So that
for example,
transfer
like you need to stabilize from behind, because if the case subsides, it's a race between fusion and the subsidence. If the case subsides, there are so many dangerous structures in the front, so you have to be a bit worried about that.
Thank you very much, Dr. Anand. So Dr. Mihir Bapat. So you also have fair amount of experience in A-lifts and T-lifts. So in your view, so today, what is the indication for an A-lift in your practice today?
Can I make a very sarcastic comment on this? Dr. Arvind Jaiswal said that we used to do a lot of anteriors, and we have really gone through all the anterior gamut. They have two problems. One is mera sabse bada. That means my cage is the biggest, and that is why I get more lordosis, which is absolutely a myth. You can get that by a TILIF very, very easily. Second is that it is impossible to explain a patient why an IVC got cut, why the ureter got cut, why there was a bowel perforation, why you required an anterior surgery. No, let me finish, Anand. The problems of anterior surgery are exclusive. They are absolutely exclusive, and you often require a person to dissect the vessels for you. You have to be very bold to do this all by yourself. You require people, you require assistance. I have seen this even in the UK. Lots of complications happening with ELIF. They have been doing this for years. So it's a good approach. You get good fusions. I agree. But this whole concept of jacking up the disc, that extra bit, is not the valid excuse of doing an ELIF. That is all I've got to say.
So there are n number of papers which are published, and most of them are level 1 or levels 2 studies, and they have said that you achieve the proper balance and all. It's not about the size of the disc, it's about the restoration of the lordosis, how we are going to restore that. Not possible from TLIF at all, because in anterior we are sacrificing ALL. And coming to the vascular part and all, yes, initial few cases you will definitely have some kind of injuries, but will you take a patient to an operating table without telling all the complications? I always discuss all these complications with my patient. I always tell them there is a possibility this can happen, and if it happens, then we can manage that. So without telling,
yes,
you can't cut a sorry figure after the surgery that, oh, your IVCs got cut, your ureter is injured. No, never do that.
Yeah, Dr. Anand, yeah, that's understood. With your training experience, you are able to handle those injuries probably for an averagely trained spine surgeon from India who has not had your kind of experience in handling vascular injuries. Probably difficult. That's what Dr. Bapat was mentioning.
Yeah. So the thing is that training, and probably maybe very few surgeons have started doing ALIFs at L5S.
So let me ask the opinion of Dr. Ji-Sung Kim. Professor Kim, in your practice today, where do you find the role for ALIF as a choices procedure for lumbar fusion?
Thank you for asking me again. I love to the LLIP or so. So in my recent practice, when I choose the method of inner body fusion among the MIS T-lip, O-lip, and L-lip, so I find the choice recently. The L-lip usually could be considered first of the spondylodiscitis and the high-grade spondylolisthesis and the multi-level degenerative spine needs multi-level fusion involving the L5S1 especially. So by the based on the concept of restoration of the lumbar lordosis, L-lip is the best one, right? So I think the L-lip could be one kind of sort of the salvage procedures in the case of the fusion failure. In that situation, L-lip gonna be the best one. But recently, I also have operated my patient in patient having the single level disease. Easy case of I mean the vessel anatomy of vessel. I I have done the only 5S1 as well. But the more fundamental concept, the LLIP is the king of the strong and powerful innovative option in the case of especially the L5S1 level.
Okay, thank you very much. Thank you very much, Professor Kim. So let me ask Dr. Amit Zala. Professor Zala, in your practice, is there a role for A-lift surgery for interbody fusion? Dr. Amit Zala?
Yeah, so I absolutely agree with all the points what Dr. Anand has said. The only issue is that for a single level L5S1, anterior LF is okay. But if there is L3, 4, 4, 5 and 5S1, to mobilize all the vessel and do 3-level ALIF, it's not a good idea. If I can do a MIS OLIF, that means I can access 3, 4, 4, 5 and 5S1 through an OLIF approach. I think then that is the best combination that everyone can have it. And I'm just waiting for it to come in India so that we can have that as one of the procedures. And the other point I want to make is, Anand, what is the salvage option? I think what Dr. Kim told was that you can use ALIF as a salvage option. So what is the salvage if you have a 3-level OLIF and then you have to go again at L3, 4, 4, 5 and 5S1 if you have done a multi-level. So that's more dangerous compared to just doing the laterals and then anterior.
Yeah, there are, I can use the anterior approach total for 4 times, 2 times for the right side and 2 times for the left side. If it is a first time approach, it's very easy. But if it is a salvage, if I went in from the left side, or maybe the olive is done from the left side, I can still use the right sided approach. But if both the sides are exhausted, then stent the ureter and you can do the salvage.
Okay, Dr. Anand, thank you very much. So with this, we are really run out of time. Let us have the last talk by Dr. Datta. Dr. Datta is not available, so we might not take any questions on that. Before we sum up, endofusion limited by today's technology, tomorrow's winner. Is it really a winner? Can we have Dr. Datta's video, please?
Hello, everyone. So the fusion in the lumbar spine is primarily done for stabilization and reconstruction of the anterior column of the spinal motion segment. The choice of the procedures that we have today are conventional procedures, which are conventional open procedures, mini open procedures or micro procedures, endoscopic assisted and endoscopic procedures. Now, the available options that we have today are open conventional surgeries, which give you an incision of about 10 to 12 centimeters. Need to have stripping of the paraspinal musculature, primarily the longissimus and the multifidus, to gain access to the pathology. The second option that is available is more tubular systems, which have an incision of about 18 to 20 millimeters. Again, some amount of stripping of the muscles to reach the pathology for decompression as well as for stabilization. The third kind of systems that are available are smaller systems. That means the skin incision is smaller, say about 12 to 15 millimeters. But then again, you tend to tent underneath the incision. And the last system now which we are using is the endoscopic system, which is about an 8 to 10 millimeter system with no tenting and far more superior visibility, since the camera on the endoscope is located at the tip of the endoscope, which gives you a far superior vision and an access to the pathology as well as for inserting your interbody cage. The choice of the procedure is determined by the comfort of the surgeon with a particular kind of a procedure and the type of pathology. The other determinant that is necessary is the level of the pathology. So if you primarily see posterior lumbar interbody fusion and transforaminal lumbar interbody fusion, these two procedures can be very comfortably done at all the levels, including the dorsolumbar junctions. The feasibility is also based on its ability of a procedure to perform direct decompression. Procedure which can perform direct decompression and fusions are posterior lumbar interbody fusion and transforaminal lumbar interbody fusion. Now, a feasibility is also based on the ability to use an endoscope so that we have minimum to no access trauma. So this is possible only with posterior lumbar interbody fusion and transforaminal lumbar body fusion for decompression of the neurological structures and for preparation of the end plates. Now, endoscopic interbody fusions can be performed with two different routes. One is transforaminal route and second is interlaminar route. Now, if you see cadaveric dissections of the Camden's triangle, which has been done and which is available in the literature, you can see that at the medial border of the pedicle, the size of the triangle is about 18 millimeters. Now, if you see the interlaminar axis to the Camden's triangle, so when you are doing an interlaminar interbody fusion, the axis is primarily interlaminar. Here in this area, we are able to access the Camden's triangle more medially. So we can by and large enlarge the Camden's triangle by retracting this traversing route more medially so that the Camden's triangle is enlarged. The part of the Camden's triangle which is covered medially is going to be the inferior articular process. So if we are able to take off part of the inferior articular process, we can have more room in the medial part of the Camden's triangle for inserting our interbody cage. So this is going to be the cage placement. So cages. So different kinds of cages are available. So the one of the standard things that is going to be is this height, the foot plate is going to be 10 millimeters broad. This is pretty standard. Then you may have anything ranging from 23 to 26, 27 millimeters, depending upon the size of the vertebral body. The height is going to be the height of the interbody cage. So you may have different cages with different heights, which are more static cages like this, and you can have something which can expand, like you put in an 8 millimeter height cage inside, and then you may be able to expand about 3 to 4 millimeters, which will be about 12 to 13 millimeters in height. So expandable interbody cages are available. One is a straight, which is available. Second is a kind of a dome, which is available. And third is a lordotic cage, which is usually a 6-degree lordotic cage, which can be utilized and which can be used through the endoscopic approach. Various instruments which are necessary for preparation for decompression, standard instruments like burrs and Kerrison rounders, osteotomes may be required, which is part of the decompressive surgery, which we do it for stenosis. But for fusion per se, you may require some instruments which are primarily for preparation of the end plate, because you need to prepare the end plate by and large complete, near to complete. And then you need some instruments for retracting the neurological structures that you may require a sleeve, or you may require a special kind of a retractor. And third thing is you may require instruments for introducing the cage inside and to expand it if you are using an expandable interbody cage. With ETLF, we are able to perform a direct decompression of the extraforaminal, foraminal, and lateral recess completely. So if you have a pathology which is unilateral and with unilateral symptoms and with instability where you think fusion procedure may be useful, so you may opt to do a endoscopic transforaminal lumbar interbody fusion through the transforaminal route. In posterior lumbar interbody fusion, direct decompression of the lateral recess and lateral, central, and contralateral recess can be performed. So you can do a bilateral decompression with a single approach. A single incision of about 10 millimeters is used. Some sort of regional anesthesia can be performed. It can be performed like epidural or spinal. So normally it is done under epidural anesthesia, where decompression and fusion is done as a single stage procedure. Reasonably priced implant and direct visualization of decompression, and it can also be performed as a daycare procedure. Thanks a lot for a patient listening.
Thank you very much, Dr. Datar. So for want of time, let us conclude. It's been an excellent session with Master Blasters giving their point of view. So before we thank our young Turks, Dr. Deepak Bangle, Dr. Akshay Hari, Dr. Murli Krishna, as well as our master presenters, Dr. Amit Zala, Dr. Anand Naik, Dr. Mihir Bapat and Dr. Girish Datar, let me invite one comment each from our two of our experts, Professor Arvind Jaiswal. So how do you sum up this session, sir? What would be your advice for the younger generation as well as current spine surgeon practice? What should be the first choice for a single level degen fusion at L45 or 5S1? Professor Jaiswal, please.
For the younger generation, I mean, one has to be well conversant with if you're doing MIS surgery first with MIS TLIF, and then you go up the ladder as such, right? And one has to get very familiar with the lateral approaches. With the anterior approach, there is still a question mark, and Anand has his own viewpoint on that. We will not go into that. But yes, the future is TLIF with endoscopic TLIF and endoscopic EPLIF. With multiple level and deformity surgery with stenosis, the lateral approaches and a combination of posterior fixation is what is going to be the standard later in few years from now onwards. So you have to be familiar with mixing MIS TLIF as well as the lateral approaches.
Thank you, sir. Thank you very much. Professor Kim, Dr. Jisun Kim from Korea, thank you very much once again for attending this session and staying up late. So what would be your advice for the younger generation? How do we learn the OLIF or the anterior approach, or how to shorten our learning curve in these procedures? Professor Kim, please.
Yeah, it's truly important for the novice or the younger generation for spine surgery. So when I started the OLIF in Korea 2013, so already 8 years back, so nobody taught me about how to avoid a complication of OLIF surgery. So that's why I had the sort of the complications following the OLIF surgery. But according to the mistake and making the complication, I can circulate my opinion. How can we avoid the complication, approach-related complication? How can I maximize the fusion rate, or how can I get the better restoration involving the upper level and the lumbosacral level as well? Anyway, it's not easy to talk it with one sentence. How can I make it for younger generation? But I'd like to make it. I can talk about the strong advantage of OLIF surgery. Please follow the master surgeons in India, Amit Challar and other friends. And I'm sure you're gonna be one of the best OLIF surgeons for this in the case of degenerative spine. Thank you very much.
Thank you very much, Professor Kim. Thank you for staying back, and thanks very much. With this, thank you all. Let me hand over the proceedings to Dr. Umesh Srikanta and Professor Rajkumar Deshpande. It's been amazing. So the session, the wait has been done. Hats off. Let's really pray that the team from Bangalore always does it as ever excellently as possible. Over to you, Dr. Umesh and Professor Deshpande.
Thank you, Dr. Ranjit. I knew that you were going to make some comment at the end of the session. And rightly so, as you said, this has been a fitting finale for a day-long and an exhaustive day, should I say, of an academic event, right from 8 o'clock in the morning all the way now. It is 8:45, and so it's more than 12 hours, and the energy that our faculty have shown and the participation that we have got from overseas faculty, Professor Jisun Kim and Professor Hyun-Sing Kim, and we really appreciate it. It is really midnight there in South Korea, and you have been there for your sessions. Apologize for being late again, but there are some things that we as organizers cannot control, and the amount of discussions that were happening in each session was really really abundant, and we literally had to stop them, midway in many of the sessions. So once again, we thank you very much, Ranjit. Thank you very much for conducting this session, and we thank all the panelists and all the faculty for their excellent contributions, for their dedication, as well as their thorough support and supporting us throughout the inception of this event planning stage as well as its execution stage. Dr. Rajkumar sir.
So it's my personal thanks to Professor Jaiswal. Sir, I am really honored. I am very, very glad that I could participate. And I'm simply amazed that even at this late hour, you're up, you're discussing, you're giving gyan. I am simply thrilled to be a part of the team that has been, nurtured by you. Thank you so much. My personal thanks. And my thanks to Dr. Amit Jala, the president-elect, Dr. Arvind Kulkarni. Oh my God, these guys are wonderful. I'm very, very happy that you're there till the last. And not but the least, my great friend Alok. I don't know how I can say my thanks to you. Thank you so much. My former president, Dr. Roy Das, he was participating in a very big way, and I had to sort of cut in short of that. I apologize for that. Thank you, everybody. My personal thanks to Luke. Luke, thank you so much for staying back.
Thank you. Thank you so much.
Thank you again. We'll meet again personally sometime.
Yeah,
Dr.
sure.
Honsan Kim, thank you once again for your participation. And from all the people in Bangalore, I thank you all. Have a great Sunday. And Anand, keep your spirits and your flag flying high. Thank you so much. Good night and take care.
I think we can have a thumbs up for the Bangalore team, that what they have done is a fantastic job.
A standing ovation.
A standing ovation, and it's a duo. It's a duo.
And to the entire team and to the team at Avyaya, along with Dr. Umesh Srikanta, Dr. Rajkumar Deshpande, Dr. Akshay Hari, Dr. Murli Krishna, and Dr. Yedu. Thank you very much. Let's hope that you do it every year like this. And Umesh and Deshpande can do it excellent. Thank you, sir.
Thank you. And we're signing off.
Thank you so much.
Take care. Take care. Take care. Bye. Good night. Good night.
So IT team, stop the Zoom meeting and stop the live stream.